Hey, future nurses, this course is the fastest, smartest way to pass the NCLEX on your first try. If you're serious about passing, this 10-hour crash course is your one-stop solution. More than 70 questions in every NCLEX exam come directly from the topics covered in this video. We created this course after analyzing feedback from 5,000 registered nurses who successfully passed the NCLEX in the last 5 years. We've handpicked 100-plus high-yield topics that are repeatedly tested, and we're giving them to you for free. After every topic, you'll find real NCLEX-style questions from previous exams to test your knowledge instantly. This 10-hour crash course will save you over 500 hours of study time. But here's the challenge you need to watch the full 10 hours to get the maximum benefit. Miss even a few minutes, and you might miss a question on your actual exam. Every NCLEX candidate must watch this before the exam. It's the fastest way to brush up on key concepts without wasting time on unnecessary topics. We've designed this course using animations because studies show that visual learning helps retain information longer. This is your final power revision. Let's get started. Before we move ahead, let me take a quick moment to tell you something that could completely change your NCLEX journey. If you're serious about passing the NCLEX in just 1 week or even within a month, then the smartest move you can make right now is to enroll in our complete online NCLEX crash course. This isn't just another course, it's a shortcut, a clear step-by-step roadmap that has already helped over 100,000 nursing students pass the NCLEX with confidence. And here's the most incredible part. Not a single student who completed this course has failed. Yes, that's a 100% passing rate. We built this course based entirely on the feedback and insights of thousands of nurses who've successfully cleared the NCLEX in the last 5 years. That means we've removed all the fluff and focused only on what truly matters for your exam. Here's exactly what you'll get when you enroll. You'll get 100 hours of animated crash course content designed for rapid revision, 500 hours of comprehensive recorded lectures covering all the high-yield topics, and access to 10,000 real NCLEX questions to sharpen your test-taking skills. You'll also get 500 next-gen case-based questions to strengthen your clinical judgment, along with 15 full-length practice tests that simulate the real NCLEX experience. And of course, you'll receive our complete NCLEX ebook and PDF notes, plus 1 full year of access, so you can study at your pace on your schedule. And yes, we're currently offering a 70% discount for a very short period. Once the offer ends, it's gone. Thousands of students are enrolling in our online NCLEX course every month and passing the exam, but if you don't enroll now, you risk being left behind. Spots are filling fast and only a few seats are left. Visit our website to enroll now. Link is given in description box. Let's continue the video.
This lecture is about cardiac drug, calcium channel blockers, ECG rhythm, chest tube, congenital heart diseases, infectious disease, transmission-based precautions, and doses calculation. You just have to know some basics about these heart drugs. Somewhere in the margin of this lecture, I want you to write the following. Calcium channel blockers are like Valium for your heart. It's easy for you to remember what they do. What does Valium do for your body and for you in general? What's the difference? It calms you down. So what do you think calcium channel blockers do to the heart? They calm it down. So if you get a question about a calcium channel blocker, think, oh, that's going to calm my heart down. That would be just like giving my heart some Valium. Now, did I say it was Valium? No, it's not Valium. It has nothing to do with Valium. But it's like Valium for your heart. So if your heart is tachycardic, could it stand a little relaxing? Yes. So what class of drug could you give? Calcium channel blocker. If you're in shock, does your heart need to relax when you're in shock? No. So would you give a calcium channel blocker? No. If your heart was in a heart block, would you give a calcium channel blocker? No. If your heart was having a tachyarrhythmia, would you give a calcium channel blocker? If you had a heart attack and you wanted to rest your heart, what would you give? A calcium channel blocker? So, calcium channel blocker is given when you want to rest your heart. When your heart needs stimulation, please don't give a calcium channel blocker. So in this way, it is like Valium for your heart. So how do we say that really fancy? The way we say that fancy is the following. A. Calcium channel blockers are negative inotropic, chronotropic, and dromotropic. When you see the fancy words negative inotropic, negative chronotropic, and negative dromotropic, don't freak out. All that's saying is that it's like Valium for your heart. So negative inotropes, negative chronotropes, and negative dromotropes. Relax. your heart. They calm it down. Now, the chart below shows you the difference between the positive inotrope, chronotrope, and chromotropes, and the negative inotrope, chronotrope, dromotropes. What do positive chronotrope, positive inotrope, and positive dromotrope do? They strengthen and speed up stimulation, so they are called cardiac stimulants. Negative chronotrope, negative inotrope, and negative dromotropes are cardiac depressants. They are negative because they weaken, slow down, and depress the heart. B. When would we want to do that? What do they treat? Well, they treat small AAA and big AAA. The first small A stands for antihypertensives. They relax your heart and blood vessels. If you relax your heart and blood vessels, your blood pressure goes down. If your blood pressure was high, would you take Valium for your heart or a stimulant for your heart? Valium. That would mean you'd use a calcium channel blocker. The second and third small a stand for anti-agenal. They are anti-agena drugs. It's going to relax your heart, so it uses less oxygen by decreasing oxygen demand. It treats angina by decreasing oxygen demand because it relaxes the heart. What's the worst thing in the world for a person with angina? What's the worst thing that can happen to their heart? It speeds up. Big AAA. Anti-atrial arrhythmia. So what does it treat? Will it treat ventricular tachycardia? No. Why? Because that's ventricular. And this only treats atrial. Will it treat atrial flutter? Yes. Premature atrial contractions? Yes. Paroxysmal atrial tachycardia? Yes. Atrial bigeminy? Yes. Ventricular bigeminy? No. Atrial fibrillation? Yes. Premature ventricular contractions? No. So, all you have to know is to know if it starts with the letter A. If it's an A, it's yes. And if it's a V, it's no. But there's a trick about this one. Supraventricular tachycardia, SVT. Would calcium channel blockers treat SVT? Yes or no? I'm going to say yes, but why? What does supra mean, and what's above the ventricles? Atrial. So supraventricular is the only ventricular which is actually saying atrial. It treats a small AAA and big AAA. What are the side effects? H and H. The letter H is your friend here. Headache and hypertension. Why hypertension? Because it relaxes the heart and the blood vessels. Why the headache? Because you get vasodilation in the brain, and that gives you a migraine. By the way, headache is a great thing to check on. Select all that apply. What do you have with low sodium? Headache. What do you have with high glucose? Headache. What do you have with high blood pressure? A headache. What do you have with low blood pressure? A headache. What do you have with low glucose? Headache. What do you have with high sodium? Headache. Okay. Names of calcium channel blockers. Anything ending in dipine, alomdipine, nifedipine, the dipines. I always say you're dipping in the calcium channel, not pine. So why not pine? Why would you want to memorize anything ending in pine? Because there are loads of drugs that end in pine. It has to be a dipine. Dipine is your calcium channel blocker ending. And then there are two others you have to know by name. Verapamil and cardizem. Those are your calcium channel blockers. Which of those is a continuous IV drip that can be given? Cardizem. So when you give a calcium channel blocker, what vital signs do you need to measure before you get it? Blood pressure. What's the side effects? Hypertension. What are your parameters? What are your guidelines? Measure the blood pressure And if the systolic is under 100, then you hold the calcium channel blocker. You have to monitor the blood pressure continuously or fairly quickly intermittently while they're on a cardizem drip. If it was 98/52 millimeter of Hg, what would you do with the drip? Slow it down. Measure it again so you titrate. By titrate, I mean changing the IV rate to keep the blood pressure up and the systolic over 100 millimeter of Hg. They would say, if somebody's on a cardizem drip, which of the following would you report to the RN? It's a systolic blood pressure falling below 100 millimeter of Hg.
Before we move ahead, let me take a quick moment to tell you something that could completely change your NCLEX journey. If you're serious about passing the NCLEX in just 1 week or even within a month, then the smartest move you can make right now is to enroll in our complete online NCLEX crash course. This isn't just another course, it's a shortcut, a clear step-by-step roadmap that has already helped over 100,000 nursing students pass the NCLEX with confidence. And here's the most incredible part. Not a single student who completed this course has failed. Yes, that's a 100% passing rate. We built this course based entirely on the feedback and insights of thousands of nurses who've successfully cleared the NCLEX in the last 5 years. That means we've removed all the fluff and focused only on what truly matters for your exam. Here's exactly what you'll get when you enroll. You'll get 100 hours of animated crash course content designed for rapid revision, 500 hours of comprehensive recorded lectures covering all the high-yield topics, and access to 10,000 real NCLEX questions to sharpen your test-taking skills. You'll also get 500 next-gen case-based questions to strengthen your clinical judgment, along with 15 full-length practice tests that simulate the real NCLEX experience. And of course, you'll receive our complete NCLEX ebook and PDF notes, plus 1 full year of access, so you can study at your pace on your schedule. And yes, we're currently offering a 70% discount for a very short period. Once the offer ends, it's gone. Thousands of students are enrolling in our online NCLEX course every month and passing the exam, but if you don't enroll now, you risk being left behind. Spots are filling fast and only a few seats are left. Visit our website to enroll now. Link is given in description box. Let's continue the video.
Cardiac arrhythmias. Knowing how to interpret rhythm strips. There are 4 rhythm strip tracings that you must know by sight. The first one is normal sinus rhythm. How do you know it is normal sinus rhythm? There's a P wave, a QRS, and a T wave for every single complex. There's a P wave before every QRS, and every QRS is followed by a T wave. And what else tells you it is a normal sinus rhythm? The peaks of the P waves are equally distant from each other. That tells you you are not dealing with something called a sinus arrhythmia. So it is a normal sinus rhythm, because there's a P for every QRS, and the QRS complexes are evenly spaced. When you see that it is a normal sinus rhythm, it doesn't really matter if they go up or down. You could have a P wave going up and the QRS is going down, and that's okay. That's still normal science. The second one is VFib, ventricular fibrillation. It is a chaotic squiggly line. The third one looks like a 1960 wallpaper border. That's VTAC. Ventricular tachycardia. It's got these sharp peaks and jacks. Is there a pattern? Yeah. Is there a pattern with ventricular fibrillation? No. There's no pattern with VFib, but there is a pattern with VTAC. And the last one is called asystole. Whenever the question says QRS depolarization, it's talking about ventricular. You can always narrow it down to one of 2 that would say the word ventricular. You can rule out anything that says atrium. And if you see QRS, you can rule out anything that says atrial and go with what's ventricular. However, number 2, if it says P wave, that will refer to something atrial, and you can rule out anything ventricular unless they say a lack of a P wave. Well, I mean, that's not really talking about it. The 6 rhythms most tested on NCLEX. Number 1. They will use the phrase, a lack of QRSs. There are no QRSs. That's called asystole. That's a flat line. Number 2. As to be a form of what? Atrial. Why does it have to be atrial? Because of the P wave. When you see sawtooth, you always pick flutter. Flutter is always described as sawtooth. Number 3. If you notice that they have the same adjective, the word chaotic. Chaotic is always the word used to describe fibrillation. Number 4. Ventricular fibrillation. How did you know it was ventricular? How did you know it's fibrillation? Chaos. Number 5. Some form of what? Atrial or ventricular? Ventricular. How do you know it's ventricular? QRS. When it says bizarre, bizarre always applies to tachycardia. Bizarre is the word they use for tachycardia. Chaos is the word they use for fibrillation. So if you put 2 and 2 together, what is number 5? Ventricular tachycardia. Now, what about a periodic wave bizarre, QRS, as a PVC? Why is it ventricular, and why is it wide and bizarre? This is like one snapshot of tachycardia. It's just one piece of tachycardia. So is it possible that you could call a salvo of PVCs? You know 1,000 of them, a group of them in a row of salvo. What else could you call it? A short run of the attack, because it's the same idea. Do physicians care about people having PVCs? Generally speaking, no. How high a priority is a client with a PVC if you had to prioritize 4 clients, and one of them has PVC? Low, moderate, or high? Low. Under 3 circumstances, you could elevate that person to moderate, not high priority, just moderate priority. 1. If there are more than 6 PVCs in a minute. 2. More than 6 PVCs in a row. Or 3. If the PVC falls on the T wave of the previous beat. That's called the R on T phenomenon. If one of these happens, you elevate the priority of your PVC client to moderate. PVCs never reach high priority. The most the PVC client can reach is moderate. After a heart attack, even if they're having PVCs, is that good or bad? It's actually good because it means they're reperfusing. So it doesn't raise their priority. It actually lowers it because they're doing great. Lethal arrhythmias. How high a priority are these? These are high priorities. There are 2 of them that are super high priorities. They're lethal, meaning they will kill you in 8 minutes or less. The first one is asystole. If you are alastolic, you have 8 minutes or that brain is gone. VFib is the other lethal one. What do asystole and VFib have in common? No cardiac output. If you've got no cardiac output, you do not have brain perfusion, and if you don't have brain perfusion, you're dead in 8 minutes. So if they give you 4 patients, and one of the patients has asystole or VFib, how high do you prioritize that patient? They're probably number 1. One of these arrhythmias is potentially life-threatening. It is not life-threatening, it is only potentially life-threatening. But that still makes it a fairly high priority, and that is ventricular tachycardia. So therefore, what is the difference between VTAC and the asystole VFibs? VTAC has a cardiac output. If there's no pulse, there's no cardiac output. It's just as bad as what was there before. Treatment. The first 2 are PVCs and VTAC. They are both ventricular. For ventricular, use lidocaine. You know that lidocaine is not used in a lot of squads now in the bigger cities because they're using aminodarone. But boards is going to talk more about lidocaine after April 1st. So it would be aminodarone. Supraventricular arrhythmias. What's the synonym for supraventricular arrhythmias? Atrial arrhythmias. For treatment of atrial arrhythmias, use the ABCDs. Atrial starts with the letter A. So remember the ABCDs of atrial treatment. So for ventricular, use lidocaine. For atrial, use the ABCDs. A stands for adenocard. This is the one you have to push in less than 8 seconds. So is it a fast or slow IV push? Fast. No, it's super fast. You've got 8 seconds. They call it slamming. Have you ever heard that you've got to slam this drug? You've got to push it in 8 seconds, and then the other nurse pushes 20 milliliters of flush right after it? So you've got to use a big vein. The problem with this, though, is when you slam it fast, what could they go into? A systole for about 30 seconds, but they'll come out of it. B stands for beta blockers. What do all beta blockers end in? LOL, carvedilol, bredilol, and propranolol are all beta blockers. This is the best named class of drugs in the universe. Every drug that is a LOL is a beta blocker. Beta blockers are negative inotropic, negative chronotropic, and negative dromotropic. So they're like Valium for your heart. So they'll treat AA and AAA, right? Anti-atrial arrhythmia. So what will beta blockers have as side effects? Headache and hypotension. But don't make a big difference between calcium channel blockers and beta blockers. Calcium channel blockers are better for people with asthma because beta blockers bronchoconstrict. So people that have other diseases like COPD probably should be on a calcium channel, although a beta does all the same things and has all the same side effects. So what's the C? Calcium channel blockers. Beta blockers and calcium channel blockers are like Valium for your heart. They're negative inotropic, negative chronotropic, and negative dromotropic. They treat the little AAA and big AAA, and they have the side effects of H and H, both of them. The D stands for digitalis, digoxin, and lanoxin. You have to know these names because they will only give you one name for this drug. They'll say lanoxin. You're supposed to know that's digitalis. Here's the overview of ABCD to treat atrial arrhythmias. A. Adenocard. B. Beta blocker. C. Calcium channel blocker. And D. Digitalis. What do you use for VFib? It rhymes, right? For VFib, you defib. What do you use for systoles? Epinephrine and atropine. In that order. What's the first one you give? Epinephrine. Then, if that doesn't work, you give atropine. Now, the way I remember this is to look at the word asystole, the first letter A, which stands for atropine, the last letter E, which stands for epinephrine, but give it in reverse. So meaning, in asystole, give epinephrine first.
Before we move ahead, let me take a quick moment to tell you something that could completely change your NCLEX journey. If you're serious about passing the NCLEX in just 1 week or even within a month, then the smartest move you can make right now is to enroll in our complete online NCLEX crash course. This isn't just another course, it's a shortcut, a clear step-by-step roadmap that has already helped over 100,000 nursing students pass the NCLEX with confidence. And here's the most incredible part. Not a single student who completed this course has failed. Yes, that's a 100% passing rate. We built this course based entirely on the feedback and insights of thousands of nurses who've successfully cleared the NCLEX in the last 5 years. That means we've removed all the fluff and focused only on what truly matters for your exam. Here's exactly what you'll get when you enroll. You'll get 100 hours of animated crash course content designed for rapid revision, 500 hours of comprehensive recorded lectures covering all the high-yield topics, and access to 10,000 real NCLEX questions to sharpen your test-taking skills. You'll also get 500 next-gen case-based questions to strengthen your clinical judgment, along with 15 full-length practice tests that simulate the real NCLEX experience. And of course, you'll receive our complete NCLEX ebook and PDF notes, plus 1 full year of access, so you can study at your pace, on your schedule. And yes, we're currently offering a 70% discount for a very short period. Once the offer ends, it's gone. Thousands of students are enrolling in our online NCLEX course every month and passing the exam, but if you don't enroll now, you risk being left behind. Spots are filling fast and only a few seats are left. Visit our website to enroll now. Link is given in description box. Let's continue the video.
Chest tubes. The purpose of a chest tube is to re-establish negative pressure in the pleural space. So the pleural space is a place where negative is good, because we don't tend to think of negative as bad, but negative is good for your pleural space. Negative makes things stick together. So the purpose of a chest tube is to reestablish negative pressure in the pleural space, so that the lungs expand when the chest wall moves. This is why you need that tube in there. When you get a test tube question, look at the reason for which it was placed. Number 1. In a pneumothorax, the chest tube removes air. Pneumo means air. So in a pneumothorax, positive pressure is created by air. So I've got to put a chest tube in to remove the air so I can reestablish the negative pressure. But in a hemothorax, the chest tube removes blood, right? Because what causes the positive pressure? Blood. And I have to remove it to reestablish the negative pressure. In a pneumohemothorax, what's in the pleural space? Air and blood. And I must remove both air and blood to reestablish the negative pressure in the pleural space. So, if you have a question that says, you have a patient with hemo, with chest tubes in, for a hemothorax, what would you report to the nurse or the doctor? 1. The chest tube is not bubbling. 2. The chest tube drained 800 milliliters in the first 10 hours. 3. The chest tube is not draining. Or 4. The chest tube is intermittently bubbling. What does a hemo chest tube put in for a hemothorax? What's it supposed to drain? So which one of these says it's not doing what it's supposed to do? Number 3. So which one would you report to the nurse or the physician? Number 3, because it's not doing what it's supposed to do. Now, what if this said pneumothorax? For pneumothorax, what would you report to the physician? Well, you could have 2 of them. What would they be? 1 or 2. It needs to bubble. It's not doing what it's supposed to do. What's wrong with number 2 then? It's doing something it's not supposed to do in that case, and that would be hard. But the point is that you see how it is definitely not number 3. With a change from hemo to pneumo, what was the right answer is no longer an option for the right answer. So if you're going to get just 2 questions correct, what must you pay particular attention to in this disease, for which it was placed? And that will tell you what you should expect. The other thing you have to pay attention to is the location of the tubes. And the 2 locations are apical and basilar. Apical means the test tube's way up high. And if you put a chest tube way up high, air will be removed because air rises. So apical removes air. Basilars are at the bottom of the lungs, so they will remove blood because blood is subject to gravity. So apical removes air and basilar removes blood. A for A, B for B. Apical starts with A, and that removes air, which starts with A. And basilar starts with B, and it should remove blood. So if they say that your apical chest tube is draining 300 milliliters per hour, do you think that is good or bad? Bad. Your basilar is draining 200 milliliters per hour, and it needs to come out. Your apical tube is not bubbling? Bad. Your apical tube is bubbling? Good. Your basilar tube is not bubbling? Fine. Your basilar tube is bubbling? Bad. Now, this brings up the next 3 questions. Number 1, how many chest tubes and where would you place them for unilateral pneumohemothorax? 2, you'd use an apical for the pneumo and a basilar for the hemo. Question 2, how many chest tubes and where for a bilateral pneumo? 2, they would be both apical. So you'd use an apical on the right and an apical on the left. Number 3, how many chest tubes and where would you place them for post-op chest surgery? 2, an apical and a basilar on the side of the surgery, because you are to assume that chest surgery or trauma is unilateral unless otherwise specified. Now here's a trick question about the chest tube. How many test tubes would you need and where would you place them for a post-op right pneumonectomy? None. Pneumonectomy means the removal of the lung. There is no lung. There's no pleural space. There's nothing. So if there's no pleural space, why do you want to re-establish pressure in something that does not exist? So you do not use test tubes for pneumonectomies. You use them for wedge resections and lobectomies. Now let's talk about troubleshooting. What do you do if you knock over one of those close-range drainage devices? I mean, you didn't break it, you just knocked it over. You set it back up and have the patient take some deep breaths. It's not a medical emergency. You don't need to alert the physician. And what do you do if the water seal drainage breaks? Now that's a totally different thing now, because now positive pressure can get into the pleural space. Clamp it. That's the first thing you do, so nothing gets in. You need to cut it away from the broken device because it's not good anymore. So cut it all away. Take that tube underwater. It's better to be underwater because air can't go in, but stuff can come out. But if it's clamped, nothing can go in or out, and you want stuff to come out, but you don't want stuff to go in. So clamping is only a stopgap measure. It doesn't solve the problem. Now, what can we do to solve the problem? Sticking the tube underwater to seal it. And what is the order for this whole procedure? It's alphabetical. Clamp, cut, submerge, unclamp. That's the order. So if they said to you, what is the first thing you're going to do when the water seal breaks? You clamp the tube. When they say first, they're talking about what order. So what is the best thing to do when the water seal breaks? The answer is submerge it underwater. Clamping is not the best answer for water seal breaks because it's just a temporary fix. Clamping is the first action you will take in this case, but it's not the best for this problem. So in a water seal break, if they ask for first action, the answer will be clamping. But if they ask for only the best action from these 4 actions, in case of a water seal break, the answer will be submerge the tube underwater. So first action, clamping. Best action, submerge the tube underwater. Now, what do you do if the chest tube gets pulled out? The first thing you do is take a gloved hand and cover the hole. The best thing to do is cover it with Vaseline gauze. The real problem here will be solved by covering the hole by Vaseline gauze. Now, we will discuss about bubbling. Bubbling in chest tube drainage systems. On these, ask yourself 2 questions. Where is the bubbling? And when is the bubbling? Because sometimes bubbling is good, and sometimes it's bad, depending on when and where. Intermittent bubbling in the water seal is good. If bubbling is continuous in a water seal, it's bad. There's a leak. You do not want continuous bubbling in the water seal, which means there's a leak in the system. Intermittent bubbling in the suction control chamber is bad. The suction is not high enough in that case. You're only getting intermittent bubbling in the suction control because your suction is too low. You've got to go to the dial at the wall, and you've got to turn it up until it bubbles. Continuous bubbling in the suction control chamber is good. So, 2 scenarios are good, and 2 scenarios are bad. The 2 chambers are opposite. What's good in one is bad in the other. If something is sealed, there shouldn't be continuous bubbling. If continuous bubbling is in a water seal chamber, it means it's leaking, so that's bad. Intermittent bubbling in the water seal is good, but in the suction control, intermittent bubbling is bad. Rules for clamping tubes. Number 1. You're not allowed to clamp chest tubes for longer than 15 seconds without a doctor's order. So if you break the water seal, you've got 15 seconds to get that thing off and underwater. Number 2, use rubber tip double clamps to avoid puncturing the tube.
Before we move ahead, let me take a quick moment to tell you something that could completely change your NCLEX journey. If you're serious about passing the NCLEX in just 1 week or even within a month, then the smartest move you can make right now is to enroll in our complete online NCLEX crash course. This isn't just another course, it's a shortcut, a clear step-by-step roadmap that has already helped over 100,000 nursing students pass the NCLEX with confidence. And here's the most incredible part. Not a single student who completed this course has failed. Yes, that's a 100% passing rate. We We built this course based entirely on the feedback and insights of thousands of nurses who've successfully cleared the NCLEX in the last 5 years. That means we've removed all the fluff and focused only on what truly matters for your exam. Here's exactly what you'll get when you enroll. You'll get 100 hours of animated crash course content designed for rapid revision, 500 hours of comprehensive recorded lectures covering all the high-yield topics, and access to 10,000 real NCLEX questions to sharpen your test-taking skills. You'll also get 500 next-gen case-based questions to strengthen your clinical judgment, along with 15 full-length practice tests that simulate the real NCLEX experience. And of course, you'll receive our complete NCLEX ebook and PDF notes, plus 1 full year of access, so you can study at your pace on your schedule. And yes, we're currently offering a 70% discount for a very short period. Once the offer ends, it's gone. Thousands of students are enrolling in our online NCLEX course every month and passing the exam, but if you don't enroll now, you risk being left behind. Spots are filling fast and only a few seats are left. Visit our website to enroll now. Link is given in description box. Let's continue the video.
Congenital heart defects. Every congenital heart defect is either trouble or not trouble. It's either all bad or all good. Nothing in between. I want you to memorize one word, and only one word. And that word is trouble. Now, you notice it has 7 letters. Write the word trouble, but capitalize the consonants. Keep the vowels small and lowercase. Capital T, capital R, small o, small u, capital B, capital L, small e. You don't make the diagnosis. The radiologist does. Your role in congenital heart defect is teaching the patients the implications. If it's trouble, teach them how it's going to be a lot of trouble. But if it's not trouble, pick the answer that says this is not trouble. They always want to know, does the defect shunt blood right to left or left to right? Because R comes before L in the word trouble. So a trouble defect shunts blood from the right to left. No trouble defects shunt blood left to right, because that's not the way trouble is spelled, because it's not trouble. The other thing they want to know is if the kid is cyanotic or acyanotic. Cyanotic means blue. The letter B in trouble can help us remember that. Right to left shunts are blue. So left to right means not blue, which is pink, or acyanotic. Now, there are 40 congenital heart defects. Some of them are trouble, and some of them are not trouble. It just so happens, by total sheer coincidence, that all congenital heart defects which start with the letter T are trouble. If it does not start with the letter T, it's not trouble. For example, a patient with ventricular septal defect. Ventricular is not trouble because it starts with a V. That's not a T, so it's not trouble. It shuts blood from the left to the right. The child is acyanotic. Tetralogy of Fallot starts with a T, and that means it's trouble. It shunts blood right to left. It's cyanotic. Patent ductus arteriosus starts with the letter P. It's not a T, so it's not trouble. It shunts blood from left to right, so the child is acyanotic. Patent foraminovalle, PFO, starts with the letter P, so that's not T, and it's not trouble. It shunts blood from the left to right, so the child is acyanotic. Truncus arteriosus starts with the letter T, and that means it is trouble, shunting of blood from right to left. The child is cyanotic. Transposition of the great vessel. It starts with the letter T, so it is trouble, shunting blood from the right to the left. The child will be cyanotic. Tricuspid atresia. It starts with the letter T, so it's trouble. Shunting of blood will be from the right to the left. The child will be cyanotic. Atrial septal defects. It starts with the letter A. It's not T, so it's not trouble. It shunts blood from the left to right. The child is acyanotic. Totally anomalous pulmonary vasculature. TAPV. It starts with the letter T, so it's trouble. Shunting of blood will be from the right to left. And the child, cyanotic. All congenital heart defects for kids will have 2 things, whether trouble or not trouble. Number 1, they'll all have a murmur. They all have murmurs because they are shunting the blood, either something from the left to the right or from the right to the left. You will hear a murmur. Number 2, They all have an echocardiogram done. Even your no trouble kids will have an echocardiogram done. The last thing about congenital heart defects is that you need to know the 4 defects of the tetralogy of Fallot. The best way I know is the saying, varied pictures of a ranch. Capitalize the first and last letters of each word. You've got V, D, P, S, O, A, R, H. You can also memorize this by the sentence, Valentine's Day, pick someone out a red heart. But if you choose this method, then please do capitalize the first letter of all the words. Then make a group of each of the 2 capitals, like this, VD, PS, OA, and RH. Those are the initials of the 4 defects. So varied becomes VD. VD stands for ventricular defect. PS stands for pulmonary stenosis. OA stands for overriding aorta. And RH stands for right hypertension. For all congenital heart diseases, you have to remember 2 words: trouble and VDPSOARH.
Before we move ahead, let me take a quick moment to tell you something that could completely change your NCLEX journey. If you're serious about passing the NCLEX in just 1 week or even within a month, then the smartest move you can make right now is to enroll in our complete online NCLEX crash course. This isn't just another course, it's a shortcut, a clear step-by-step roadmap that has already helped over 100,000 nursing students pass the NCLEX with confidence. And here's the most incredible part. Not a single student who completed this course has failed. Yes, that's a 100% passing rate. We built this course based entirely on the feedback and insights of thousands of nurses who've successfully cleared the NCLEX in the last 5 years. That means we've removed all the fluff and focused only on what truly matters for your exam. Here's exactly what you'll get when you enroll. You'll get 100 hours of animated crash course content designed for rapid revision, 500 hours of comprehensive recorded lectures covering all the high-yield topics, and access to 10,000 real NCLEX questions to sharpen your test-taking skills. You'll also get 500 next-gen case-based questions to strengthen your clinical judgment, along with 15 full-length practice tests that simulate the real NCLEX experience. And of course, you'll receive our complete NCLEX ebook and PDF notes, plus 1 full year of access, so you can study at your pace, on your schedule. And yes, we're currently offering a 70% discount for a very short period. Once the offer ends, it's gone. Thousands of students are enrolling in our online NCLEX course every month and passing the exam, but if you don't enroll now, you risk being left behind. Spots are filling fast and only a few seats are left. Visit our website to enroll now. Link is given in description box. Let's continue the video.
Infectious disease and transmission-based precautions. There are 4 transmission-based precautions: standard universal, contact, droplet, and airborne. Contact isolation is for anything enteric, which means what? It can be caught from the intestine, fecal, oral. So that would be C. diff. Clostridium difficile. Hepatitis A would be there. That's enteric. That's intestinal. Any of those cholera. Dysentery, you know, those ones where the bugs and diarrhea and you don't wash your hands and then you touch somebody and then they eat their food. People get confused about hepatitis A and hepatitis B and which one is which. I always say hepatitis A. The A stands for anus. I mean, it doesn't, but for hepatitis A, think hepatitis anus, which tells you it's fecal oral. Hepatitis B is hepatitis blood, so it's by the blood. Another one used for contact is staph infections, staph and RSV, respiratory syncytial virus. The interesting thing about RSV is that it's transmitted by droplets, but it's on the precautions for contact because little kids catch it from touching other things that other kids touch and put in their mouth. Staph, RSV, and herpes are contact isolation. So what's involved in contact isolation? I'm going to give you all the latest, newest things because some things have changed in contact. They are now saying a private room is preferred. So therefore, while it's not required, it is preferred. Therefore, you would say yes to the private room. However, these kids can be put in the same room as long as you cohort. So if you've got 2 RSV kids, you can put them in the same room. Yes, but otherwise, an RSV needs to be in their own room. However, an RSV kid with a suspected RSV kid cannot be put in the same room. They have to be cultured and positive before you can put them in the same room. Cohorting is done on the basis of culture, not on the basis of symptoms. Droplet is for bugs that travel 3 feet on large particles due to sneezing and coughing. Therefore, meningitis, all meningitis and H-flu, Haemophilus influenza B, are more likely to cause epiglottis. So a private room is preferred, but not required. It's preferred, so on boards, you would select private room. It's preferred unless you are cohorting based on culture. If it is meningitis, they all have lumbar punctures, because that's where meningitis is cultured. Airborne is for measles, mumps, rubella, tuberculosis, and varicella chickenpox. Now, the private room is required unless you're a cohort. A special mask filter is only for tuberculosis patients. Disposable supplies and dedicated equipment are probably a good thing, but it's not an essential, as in the other two. So you could let that one slide. You could, because it's airborne, not droplet or contact. And negative airflow, yes. Now, the interesting thing about tuberculosis is the method by which it is spread. It spreads by droplet, but it's on the airborne precautions. RSV and TB are both droplets, one contact, the other is airborne, but they're both transmitted via droplet. The other thing that I want you to know is personal protective equipment, PPE. And they want you to know what order you put it on and what order you take it off. You always take it off in alphabetical order. Gloves, followed by goggles, followed by a gown, followed by a mask. Putting off is alphabetical. Putting on is the reverse alphabetical for the G's, but mask comes second. So gown, mask, goggles, gloves. The first two are what we call dosage calculation. It's when what the doctor orders isn't what's on the bottle. There's no conversion involved. It's just a simple desired over half times available. Or, if you're like me, just set up a ratio proportion. The next one is the IV drip rates. And these are mostly for the RNs. You're going to have to know these. LPNs, you may not have to know these, but that's the design. Your formula to memorize: volume times drop factor over time in minutes. Remember, mini drip is 60 drops per milliliter. Mini or micro is 60. Macro is 10 or 20 or 15 or 12. But boards will say it's 10, which is really stupid because all manufacturers are different. Micro and mini are always 60. 60 drops per milliliter, that's your drop factor. The next two are pediatric dose questions, where you're using the child's weight in pounds. They will give you these. It's 2.2 pounds per kilogram. They will always give you the kilogram weight. They always give you pounds and ask for kilograms. So you're going to be dividing pounds by 2.2. You will always be dividing by 2.2. You will never be multiplying by it. So take the weight, divide by 2.2, then do your math and pay attention to whether they're asking the total amount per day for the amount to be given or just at one time.
Before we move ahead, let me take a quick moment to tell you something that could completely change your NCLEX journey. If you're serious about passing the NCLEX in just 1 week or even within a month, then the smartest move you can make right now is to enroll in our complete online NCLEX crash course. This isn't just another course, it's a shortcut, a clear step-by-step roadmap that has already helped over 100,000 nursing students pass the NCLEX with confidence. And here's the most incredible part. Not a single student who completed this course has failed. Yes, that's a 100% passing rate. We built this course based entirely on the feedback and insights of thousands of nurses who've successfully cleared the NCLEX in the last 5 years. That means we've removed all the fluff and focused only on what truly matters for your exam. Here's exactly what you'll get when you enroll. You'll get 100 hours of animated crash course content designed for rapid revision, 500 hours of comprehensive recorded lectures covering all the high-yield topics, and access to 10,000 real NCLEX questions to sharpen your test-taking skills. You'll also get 500 next-gen case-based questions to strengthen your clinical judgment, along with 15 full-length full-length practice tests that simulate the real NCLEX experience. And of course, you'll receive our complete NCLEX ebook and PDF notes, plus 1 full year of access, so you can study at your pace, on your schedule. And yes, we're currently offering a 70% discount for a very short period. Once the offer ends, it's gone. Thousands of students are enrolling in our online NCLEX course every month and passing the exam, but if you don't enroll now, you risk being left behind. Spots are filling fast and only a few seats are left. Visit our website to enroll now. Link is given in description box. Let's continue the video.
First lecture is about acid and base imbalances and ventilator settings. First, we will read acid-base balance here. If they give you lab values, you have to convert it to words. Step 1 is to memorize these lab values. First, like pH, carbon dioxide, and bicarbonate, you should know what the normal values are. Then step 2 is looking at the pH value. First, and see if it is acidosis or alkalosis. Normal pH value is 7.35 to 7.45. If it is less than 7.34, it's acidosis. If it is higher than 7.45, it is alkalosis. And then, step 3, you should use the rule of B's. The rule of B's is when the pH and the bicarb are both in the same direction. It's metabolic. BBB. And on the other hand, if pH and the CO2 are in opposite directions, it's respiratory. Does that make sense? So, again, this diagram shows it in a little simpler way. You first look at the pH value and identify if it's acidosis or alkalosis based on the pH value. Then you compare the trend of pH with bicarb and look to see if both are in the same direction. If they are, then it's metabolic. If not, you look at the trend of pH and compare it with the carbon dioxide. If they are in opposite direction, it's respiratory. Here at the bottom shows the memory trick for acid-base imbalances rule of B's. That tells you when pH and bicarb are both in the same direction, it's metabolic. And remember the acronym ROME. Respiratory is opposite and metabolic is equal. So, let's look at how this rule would work by solving some of the example questions here. First, we have to know the normal values. What's the normal pH value? It's 7.35 to 7.45. Normal bicarbonate level is 22 to 26. Also, you could remember it as 2 plus 2 plus 2 is equal to 6. Again, 22 and 26 for bicarb based on the normal values that we memorized. Let's look at our examples. First example, the pH is 7.3, which is lower than the normal range of 7.35 to 7.45. So it's acidosis. And now you look at bicarb and see where it sits. Bicarb's normal range is 22 to 26. Remember, the 22 to 26 and the bicarb of 20 is lower than the normal range, so pH and bicarb are both in the same direction of down. So it's metabolic. So the first example is metabolic acidosis. Let's look at the second example. The pH is 7.58, which is higher than the normal range of 7.35 to 7.45, so it's alkalosis. And now you look at bicarb and see where it sits. Bicarb's normal range is 22 to 26. Again, the 22 to 26 is the bicarb, and the bicarb of 32 is higher than the normal range. pH and bicarb both in the same direction of up, so it's metabolic. The second example is metabolic alkalosis. Boards don't question you about mixed and complicated imbalances, like compensated, uncompensated, and fully compensated stuff usually. But for your information, I'm going to briefly cover the differences between fully, partially, and uncompensated imbalances. If pH is normal and there is either acidosis or alkalosis, it's a fully compensated imbalance. If one of either CO2 or bicarb is normal, it's an uncompensated imbalance. And if all these values, pH, CO2, and bicarb, are all abnormal, meaning if they are all out of the normal range, it's a partially compensated imbalance. All right, that's it about the ABG interpretation. Let's talk about signs and symptoms of acid and base imbalances. The type of question the board likes to ask about usually is in a select all that apply SATA format. What they like to do is that they will throw out a lot of signs and symptoms of disease and disorder and let you select everything that is related to that disease or disorder. In this type of question, it is important to know the trend because you can't remember all of them, but you should know the trend of those cohesive characteristics, and you should be able to pick and choose the correct sentences. So what they will do is, for example, they will tell you that a patient has respiratory acidosis, metabolic alkalosis, or something like that. And they'll say what you would see in the situation, and select all that apply. And you get a whole list of options. You have to check, and check. But the thing is, how will you memorize all the lists for each disease and disorder? It's nearly impossible. For example, if I learned 10 signs and symptoms of hypercalcemia and then 10 signs and symptoms of hypocalcemia, and when I took the test, guess what would happen? I've memorized how I would remember the lists word for word, and I could reproduce the list, but I forgot which one was which. So the point is, this board does not test your knowledge of lists. What the board tests is your knowledge of principles, not lists. But how will they test it? Boards will not test your knowledge of lists. They will test your knowledge of principles by having you generate lists. So it's better to know the general pathophysiology and trend than memorizing every single list word for word. Because on the board, they will rephrase them. For example, in general, what does pain medicine do? In general, what do pain opiate medications do? Do they sedate your central nervous system? Okay, now they will ask a question like your patient is on morphine, which is an opioid analgesic. What are the following things that you would expect to see if they got too much of that? Now, are you thinking, oh my God, I don't remember the list? But it's not about memorizing the signs and symptoms of morphine overdose. It's to see if you know that opiate analgesics as a depressive agent and picking all the symptoms that correlate to depressive characteristics. Okay, back to the acid-base imbalances. You are applying the same principle here. We should be able to generate the list ourselves. But first, you should remember, as pH goes up, so does my patient. What does that mean? As the pH goes up, the patient goes up. As pH goes down, so does the patient. So the patient goes down as well. What it means is that when the pH goes up, every system in your body gets more irritable. But when your pH goes down, systems in your body shut down, and things go down as well again. When your patient goes down, you shut down. When your patient is up, everything gets hyper-excitable. It's pure chemistry. Basically, the catalyzing chemical reactions. But remember, this is all except for potassium. So what does that mean? If you have alkalosis, it means your pH value is higher than the normal range, bigger than 7.45. As pH goes up, so does the patient. But potassium goes down. The signs and symptoms that you will see in alkalosis are hyper-irritated body status and hypokalemia. So how would heart rate go to tachycardia? How about respiratory rate? It will be tachypnea. Blood pressure, it will be hypertension. CNS-wise, hyperirritable, which can make you seizure. Muscle-wise, what about your bowels? Diarrhea and borborygmy, which is increased bowel sounds. What about reflex hyperreflexia? So +3 and +4. But remember, your potassium is opposite to pH. So high pH means low potassium. So hypokalemia. Okay, and if your patient is hyperirritable, your patient is at risk for seizure and aspiration in the worst case scenario. So as a nurse, you want to make sure there is suction available at the bedside as a safety check. Does that make sense? So, here we generated all these lists based on what we know about the relationship between pH and the physiological status again. As pH goes up, so does your patient, but for potassium. And with this sentence, you can generate all these lists without even memorizing them word for word. And you can assume that there is risk for seizure and that the nurse should ensure there is suction available for the worst case scenario. Don't limit yourself when they start asking these things. You should be like, wait a minute, I know about this. I can get there okay. Now, what about acidosis? It's the same analogy. Just remember this sentence here. When pH is low, everything is low except potassium. So if you have acidosis, it means your pH value is lower than the normal range, smaller than 7.35. As pH goes down, so does the patient, but potassium is high. So the signs and symptoms that you will see in acidosis are hypoactive body status, hyperglycemia, bradycardia, hypotension, bradypnea, lethargic and obtunded flaccid, and hypoactive bowel sounds. What about reflexes? Hyperreflexia, so 0 and +1, because normal reflex is +2. But remember, your potassium is opposite to pH, so low pH means high potassium. So it's hyperkalemia. Okay, and if your patient is hypoirritable, the patient is at risk for respiratory arrest in the worst case scenario. As a nurse, you want to make sure there is an ambu bag or intubation and ventilation available at the bedside. Remember, if things are hyper and the hyper patient can seizure, things will go down and the patient will go down and can end up in a coma or in respiratory arrest. Seizure is when things are up and coma is when things are down. They go the same as the pH. Again, here, we generated all these lists again based on what we know about the relationship between pH and the physiological status. You should be able to get to all this list by thinking about the general principle of pH-related symptoms. And a quick memory trick here, when one of the lists is cosmal respiration, which is deep and labored breathing pattern. Now, let's look at this example. What are the signs and symptoms of respiratory acidosis? Select all that apply. So what did we say for signs and symptoms of acid and base imbalances? You should look at the trend of pH. Does pH go up? Or does it go down? It's acidosis, so pH is less than 7.35. The pH is down again. Where the pH goes, so does the patient, except for potassium, so acidosis is lower pH, so the patient goes down. Let's look at the list here. Reflexes patient goes down, so hyporeflexia. Therefore, +1 or 0 reflex. How about their bowel? Patient goes down, so hypoactive bowel sounds. What about their urine? Patient goes down, so hypoactive urine output, meaning urinary retention. What about the heart rhythm? The patient goes down, so heart rate will also go down. Therefore, heart block can happen, and bradycardia can happen as well. What about potassium? The patient goes down, but remember potassium is the opposite, so potassium is going to go up. Therefore, hyperkalemia, not hypokalemia, okay? Now let's look at the causes of acid and base imbalances. It's different from signs and symptoms of acid and base imbalances. They may look similar, but you have to know the differences, and you should be able to pick the correct choice for select all that apply questions. First, be sure to look and see if the question is asking about the signs and symptoms or causes of the acid and base imbalances. The first thing to look at when it comes to the causes of acid or base imbalances is when it is respiratory. It means things are related to the lungs. When it says respiratory acidosis or respiratory alkalosis, you should say, oh, it's the lungs that's causing this imbalance. And then you should ask yourself, are they overventilating or underventilating? If it's underventilating, meaning things go down, therefore the patient goes down, when pH goes down. So, in other words, pH is less than 7.35, which means acidosis. Does that make sense? So, when it's underventilating, things go under. So pH is under the normal range. So, acidosis. If they are overventilating, then things go over, and the pH goes over the normal range, which means alkalosis. Let's look at some examples and see what kind of acid and base imbalances are present in each example. First, when you are in labor, what would you have for acid and base imbalance? You're thinking about the physiological process here. If the mother is in labor, they are having a hard time breathing because of pain, and all of that which will make her hyperventilate. Overventilate breathing means the lungs, which means respiratory imbalance, and overventilating means a higher pH value, so alkalosis. So they have respiratory alkalosis. Let's look at the second example. What about a drowning person? When they are drowning, how would their breathing look like? They can't breathe in a drowning situation, so they are hypoventilating, like underventilating. This means their pH would also go down, so it's acidosis. And it's also related to breathing, like lungs, so it's a respiratory problem. So they have respiratory acidosis. Okay, what about a patient with a PCA? The PCA pump has analgesics, like pain medication in there, and that makes things go down because they are CNS depressants. So that will lead to point to go down, and their respiratory would be underventilating, meaning the pH will go down as well. So respiratory acidosis presents in this condition. What if it's not related to lungs? It's going to be metabolic imbalances then. So how do you know if they are alkalosis or acidosis? You just need to memorize one thing. If the patient has been vomiting or been suctioning, meaning their acid is in their GI tract, it is being taken out of their body, meaning their acidity in the body goes down, meaning they became alkalosis. And because there is no lungs or respiratory things involved here, it is metabolic. In such cases, like emesis, or vomit, or suction, you should pick metabolic alkalosis. But for everything else that is not related to the lungs, you pick metabolic acidosis. For NCLEX, when you don't know what imbalance it is, and it's not related to the lungs, and it's not vomit or suction, your default answer should be metabolic acidosis. Now, what about this person who has acute renal failure? What acid-base disorder does she have? Metabolic acidosis?
Before we move ahead, let me take a quick moment to tell you something that could completely change your NCLEX journey. If you're serious about passing the NCLEX in just 1 week or even within a month, then the smartest move you can make right now is to enroll in our complete online NCLEX crash course. This isn't just another course, it's a shortcut, a clear step-by-step roadmap that has already helped over 100,000 nursing students pass the NCLEX with confidence. And here's the most incredible part. Not a single student who completed this course has failed. Yes, that's a 100% passing rate. We built this course based entirely on the feedback and insights of thousands of nurses who've successfully cleared the NCLEX in the last 5 years. That means we've removed all the fluff and focused only on what truly matters for your exam. Here's exactly what you'll get when you enroll. You'll get 100 hours of animated crash course content designed for rapid revision, 500 hours of comprehensive recorded lectures covering all the high-yield topics, and access to 10,000 real NCLEX questions to sharpen your test-taking skills. You'll also get 500 next-gen case-based questions to strengthen your clinical judgment, along with 15 full-length practice tests that simulate the real NCLEX experience. And of course, you'll receive our complete NCLEX ebook and PDF notes, plus 1 full year of access so you can study at your pace on your schedule. And yes, we're currently offering a 70% discount for a very short period. Once the offer ends, it's gone. Thousands of students are enrolling in our online NCLEX course every month and passing the exam, but if you don't enroll now, you risk being left behind. Spots are filling fast and only a few seats are left. Visit our website to enroll now. Link is given in description box. Let's continue the video.
Let's talk about ventilators now. A ventilator is a machine that is designed to move breathable air in and out of the lungs to help patients who are physically unable to breathe or breathe sufficiently. And there are 2 alarms that you can hear from the ventilators when you work on the ICU. So there are 2 types of ventilator alarms: high pressure and low pressure alarms. First is the high pressure alarm. When does a high pressure alarm go off? High pressure alarms are triggered by increased resistance to airflow, so resistance that is due to any obstruction that makes the alarm to beep at a high-pitched sound. For example, when the tubing of the ventilator is kinked, it creates obstruction to the airway and creates the resistance there and leads to the high pressure alarm. When the water in the dependent tube is condensed, the tube is obstructed with water and creates resistance here again, and creates the high pressure alarm. When the patient has mucus plugs, the airway is obstructed, and that leads to resistance for airway flow and creates the high pressure alarm sound as well. So, what should you do in each situation? When the tube is kinked, you simply unkink it. When the water is condensed in the dependent tube, you simply just empty the water. When the patient has mucus plugs, make the patient to turn and cough and take a deep breath, or suction them to get rid of the plugs that were causing the resistance and obstruction. When all of these are suspected, what is the correct order for you to take? Stop the high pressure alarm, then first unkink the tube and empty the water, and then turn the patient and lastly do the suction. What about the low pressure alarm? Its cause is the opposite of the high pressure alarm. The low pressure alarm is triggered by decreased resistance to airflow, so when things are disconnected, you lose the resistance, and that creates the low pressure alarm. So in such situations, you should look for a disconnection. There are 2 things that can be disconnected. First is the main tube, and the second is the oxygen sensor tube. When either of these are disconnected, and you hear the low pressure alarm sound, just simply reconnect them to regain the proper resistance to airflow. The ventilator has to be set to the patient with the appropriate settings. For having too much ventilation or too little ventilation can lead to acid-base imbalances again. So when the ventilator setting is too high, the patient will be overventilated, meaning they are going to have respiratory imbalance. And because the patient goes up with the overventilation, the pH will go up as well, meaning alkalosis. So this patient will be panting with respiratory alkalosis. What if the ventilator setting is too low? The patient will be underventilated, meaning they are going to have respiratory imbalance again. but because the patient goes down with the underventilation, the pH will go down as well, meaning they will become acidotic. So this patient will end up retaining carbon dioxide due to respiratory acidosis. Let's go over this question here as a recap for acid-base imbalances and the ventilator system. So the question is, the physician wants the inpatient off the ventilator at 6 in the morning, and the ABG result says that the patient has respiratory acidosis. What would you do next as a nurse? Okay, so weaning off the ventilator means the patient can ventilate themselves without the vent support in order to see if the patient is ready for weaning or not. You should look at the acid-base gases lab result. The result said that the patient has respiratory acidosis, meaning the lungs are ventilating but pH is low, so the patient is underventilating. That means that the patient is not ready for weaning off the ventilator just yet. So what should you do as the nurse? You should notify the doctor that the patient is not ready to be weaned off the ventilator. Based on the ABG lab result, the patient will be ready to be weaned off when they are over-ventilating, which will be shown as respiratory alkalosis on the ABG result. I hope this video helped you with studying for your NCLEX. If you found the video helpful, please give it a thumbs up and don't forget to subscribe to the channel so that you don't miss any important nursing lectures.
Before we move ahead, let me take a quick moment to tell you something that could completely change your NCLEX journey. If you're serious about passing the NCLEX in just 1 week or even within a month, then the smartest move you can make right now is to enroll in our complete online NCLEX crash course. This isn't just another course, it's a shortcut, a clear step-by-step roadmap that has already helped over 100,000 nursing students pass the NCLEX with competence. And here's the most incredible part. Not a single student who completed this course has failed. Yes, that's a 100% passing rate. We built this course based entirely on the feedback and insights of thousands of nurses who've successfully cleared the NCLEX in the last 5 years. That means we've removed all the fluff and focused only on what truly matters for your exam. Here's exactly what you'll get when you enroll. You'll get 100 hours of animated crash course content designed for rapid revision, 500 hours of comprehensive recorded lectures covering all the high-yield topics, and access to 10,000 real NCLEX questions to sharpen your test-taking skills. You'll also get 500 next-gen case-based questions to strengthen your clinical judgment, along with 15 full-length practice tests that simulate the real NCLEX experience. And of course, you'll receive our complete NCLEX ebook and PDF notes, plus 1 full year of access, so you can study at your pace, on your schedule. And yes, we're currently offering a 70% discount for a very short period. Once the offer ends, it's gone. Thousands of students are enrolling in our online NCLEX course every month and passing the exam, but if you don't enroll now, you risk being left behind. Spots are filling fast and only a few seats are left. Visit our website to enroll now. Link is given in description box. Let's continue the video. Before we move ahead, let me take a quick moment to tell you something that could completely change your NCLEX journey. If you're serious about passing the NCLEX in just 1 week or even within a month, then the smartest move you can make right now is to enroll in our complete online NCLEX crash course. This isn't just another course, it's a shortcut, a clear step-by-step roadmap that has already helped over 100,000 nursing students pass the NCLEX with competence. And here's the most incredible part. Not a single student who completed this course has failed. Yes, that's a 100% passing rate. We built this course based entirely on the feedback and insights of thousands of nurses who've successfully cleared the NCLEX in the last 5 years. That means we've removed all the fluff and focused only on what truly matters for your exam. Here's exactly what you'll get when you enroll. You'll get 100 hours of animated crash course content designed for rapid revision, 500 hours of comprehensive recorded lectures covering all the high-yield topics, and access to 10,000 real NCLEX questions to sharpen your test-taking skills. You'll also get 500 next-gen case-based questions to strengthen your clinical judgment, along with 15 full-length practice tests that simulate the real NCLEX experience. And of course, you'll receive our complete NCLEX ebook and PDF notes, plus 1 full year of access, so you can study at your pace, on your schedule. And yes, we're currently offering a 70% discount for a very short period. Once the offer ends, it's gone. Thousands of students are enrolling in our online NCLEX course every month and passing the exam, but if you don't enroll now, you risk being left behind. Spots are filling fast and only a few seats are left. Visit our website to enroll now. Link is given in description box. Let's continue the video.
Let's discuss a most important topic, Diabetes. Diabetes is a disorder related to glucose metabolism. In simpler terms, people with diabetes have difficulty processing glucose. This can be due to a lack of insulin or because cells have become resistant to insulin. Since glucose is a primary fuel source for our body, those with diabetes face challenges. Their bodies cannot effectively use this essential fuel, and as a result, cells can die, making the disease severe. Diabetes insipidus versus diabetes mellitus. It's crucial not to confuse diabetes mellitus with diabetes insipidus. They are not the same. Diabetes insipidus. It results in increased thirst, polydipsia, and increased urine production, polyuria, leading to dehydration. This is due to a lack of the hormone ADH. So when thinking of diabetes insipidus, remember these symptoms: polyuria, polydipsia, and dehydration. They resemble symptoms of diabetes mellitus, which also includes polyuria and polydipsia. However, with diabetes insipidus, it's only about the fluid imbalance, not the glucose. Therefore, if asked about urine output in diabetes insipidus, it's high. SIADH. Syndrome of inappropriate antidiuretic hormone. This is the opposite of diabetes insipidus. Instead of remembering every detail about SIADH and diabetes insipidus, consider this. We know diabetes mellitus leads to polyuria and polydipsia. Hence, diabetes insipidus also has polyuria and polydipsia. On the other hand, SIADH is the opposite, leading to reduced urine output, oliguria, and a lack of thirst due to water retention. Consequently, while those with diabetes insipidus and diabetes mellitus lose water and weight, those with SIADH gain weight due to water retention. Urine output and blood glucose relationships. A person with a urine output of 200 milliliters per hour over 3 hours and normal blood glucose might have diabetes symptoms. If another person has the same urine output but a glucose level of 280, if someone excretes 10 cc's of urine in 3 hours with normal blood glucose, it suggests SIADH. Diabetes conditions show similar urine outputs, while SIADH exhibits the opposite urine output pattern. Relationship between urine volume and specific gravity. It's inverse. Lower urine output leads to higher specific gravity, and vice versa. SIADH would have high specific gravity due to reduced urine output. Diabetes insipidus would have a high urine output, implying a low specific gravity. Nursing diagnoses. Fluid volume deficit. This indicates higher urine output associated with DM and DI. Fluid volume excess. Think about which condition would result in an accumulation of fluid. That is SIADH. Diabetes mellitus overview. Type 1 diabetes. Other names are insulin-dependent diabetes mellitus, IDDM, juvenile onset, or ketosis-prone diabetes mellitus. Type 2 diabetes. Other names are non-insulin dependent diabetes mellitus, NIDDM, non-ketosis prone, or adult onset diabetes mellitus. Symptoms of diabetes. The 3 P's to remember: polyuria, excessive urination; polydipsia, excessive thirst; polyphagia. Technically, it means increased swallowing. However, in the context of diabetes, it refers to an increased appetite. Treatment of type 1 diabetes. The 3 main treatments are: diet. This is less rigid now. Patients are generally allowed to eat what they want with some guidance. Insulin, the most crucial treatment for type 1 diabetes. And exercise, an essential component for managing diabetes. Now, we will be discussing diabetes management, focusing on dietary interventions. It's essential to understand the nuances between type 1 and type 2 diabetes, especially in terms of dietary adjustments. Firstly, individuals with type 1 diabetes, they count their carbs and adjust their insulin doses accordingly based on their blood sugar level checked by glucose meters. We've evolved in our approach. Previously, we significantly restricted their diets. However, nowadays, while we advise against consuming a lot of refined carbohydrates, like pure sugars, they can still consume these, but they must adjust their insulin doses accordingly. On the other hand, type 2 diabetes is different. If untreated, type 2 diabetes leads to DOA. Here, DOA stands for diet, oral hypoglycemics, and activity. Alright, let's delve deeper into the dietary component, primarily focusing on type 2 diabetes. The most important aspect of a diabetic diet for type 2 patients is calorie restriction. That's why we have diets named after calorie counts, like the 1200 calorie or the 800 calorie ADA diet. Calorie intake matters. Another significant dietary recommendation is to divide the daily calorie intake into 6 small meals. Why? Because this prevents sudden spikes in blood sugar levels. Think about it. Consuming all your daily calories in just 3 meals could cause massive blood sugar peaks, but splitting them into 6 meals would ensure a more stable blood sugar level. Remember, on your exams and in real-life scenarios, it's crucial to differentiate between first and best actions. While it might be best in the long run to strictly limit calorie intake, the first step, especially for someone consuming a large number of calories daily, might be to teach them meal splitting. Let's dive into function of insulin. Insulin's primary role is to regulate blood glucose levels because it lowers blood glucose. There are multiple types of insulin. Regular insulin. It's recognizable by the bold letter R on its packaging, regardless of its brand name. This is commonly known as short, rapid-acting insulin. It has an onset of 1 hour, peak of 2 hours, and a duration of 4 hours. Regular insulin is clear in appearance. It's also suitable for IV drips. NPH insulin, denoted by the letter N. This is truly an intermediate-acting insulin. Onset of 6 hours. Peak of 8 to 10 hours, and a duration of 12 hours. NPH insulin is cloudy in appearance and is intermediate acting. Due to its suspension nature, it's not suitable for IV drips. Lispro Humalog. This is the world's fastest acting insulin. Onset of 15 minutes, peak of 30 minutes, and a duration of 3 hours. Given its rapid action, it's administered during meals. Glargine Lantus. A long-acting insulin absorbs so slowly that it doesn't essentially peak, posing little to no risk of hypoglycemia. It has a duration of 12 to 24 hours. This is the only insulin that's safe to be given at bedtime. A mnemonic that might help you remember. For regular and NPH, just remember the sequence 1, 2, 4, and 6, 8, 10, 12, respectively. It corresponds to their onset, peak, and duration. Now, focusing on practical aspects, always remember to check the expiration date on insulin vials, and mark the date when you open an insulin vial, as the manufacturer's expiration date becomes void once opened. The new expiration date becomes 30 days post-opening. How to mix and draw insulin using a single syringe. Before drawing up the insulin, inject air equal to the dose of insulin you'll be taking into the vials. First, inject air into the NPH vial, followed by the regular vial. Always draw up the regular, clear insulin first, and then the NPH or cloudy insulin. This sequence ensures that the regular insulin isn't contaminated by the NPH insulin. Decide on your injection site. Common areas include the upper arm, thigh, buttocks, and abdomen. It's essential to rotate your injection sites to prevent lipodystrophy, which is a lump under the skin resulting from the accumulation of extra fat. Always store unopened insulin vials in the refrigerator. Opened vials can be kept at room temperature. Remember, never freeze insulin. Let's think of exercise as an additional shot of insulin. When someone exercises, it's as if they're receiving another dose of insulin. For example, if someone says, "I have gym class this morning," think of it as, "I'm getting an extra shot of insulin this morning." Consequently, if you're more active, you'll need less insulin. However, if you're less active, you'll need more. Take this scenario as an example. If a diabetic student plans to play soccer in the afternoon, what should the school nurse recommend? Given that exercise acts like an additional shot of insulin, the student should have some rapidly metabolizable carbohydrates as a snack before and during the game. Dealing with illness in diabetics. Diabetics can get sick for various reasons, like anybody else. When sick, their glucose levels tend to rise. So, even if they aren't eating, they must take their insulin. Being sick stresses the body, causing a rise in glucose levels. Thus, sick diabetics should continue taking their insulin, take sips of water to avoid dehydration, and stay as active as possible to help lower glucose levels. Complications of diabetes. Hypoglycemia, low blood sugar. Causes: taking too much diabetes medicine, not eating enough food, or doing too much exercise. Signs: they act like they're drunk and in shock, shaky, confused, might be sweaty, and could be irritable. Solution: give them something sugary, like juice or candy. If they're unconscious, they need medical attention immediately. Another complication is diabetic ketoacidosis, DKA. What is it? It's a severe problem where there's too much sugar and acid in the blood. Who gets it? Mostly people with type 1 diabetes. Causes: the main cause can be getting sick, like catching a cold or flu. But not taking enough diabetes medicine, eating too much food, or not exercising enough can contribute. Signs: they are dehydrated, breathe deeply and quickly, have a fruity smell to their breath, and may be very sleepy. Now let's delve into the topic of diabetic ketoacidosis, often abbreviated as DKA. If someone has ketones in their urine, does it necessarily mean that they have diabetic ketoacidosis? No, it doesn't. A person can have ketones present in their urine and still not have diabetic ketoacidosis. However, if you find ketones in the blood, that confirms diabetic ketoacidosis. Thus, it's the presence of ketones in the blood, not the urine, that verifies the diagnosis. Now, when we look into diabetic ketoacidosis, there are three main things that stand out, represented by the 3 Ks. 1. The first K refers to ketones present in the blood. 2. The second K in diabetic ketoacidosis refers to cosmal breathing. What does cosmal breathing mean? It means a deep and rapid breathing pattern. 3. The third K indicates a high level of potassium in the blood. The A in diabetic ketoacidosis stands for 3 conditions that start with an A. Firstly, they are acidotic, a kind of acidosis called metabolic acidosis. Secondly, these patients might have an acetone breath. This means their breath might have a fruity smell. Lastly, they might experience anorexia due to nausea. Anorexia here refers to a lack of appetite, which occurs because the individual feels nauseous. So, if you were to ask me, what are the signs and symptoms of diabetic ketoacidosis? I would describe them as follows. Dehydration. Indications include dry mucous membranes, a weak pulse, dry skin, and headache. When someone is dehydrated, their skin loses elasticity, appearing dry. It also can become hot and flushed, similar to an overheated car engine. Just as a car requires water to prevent overheating, our bodies need water to regulate temperature. Ketones found in urine, but more importantly, in the blood. Acidosis, acetone breath, and anorexia due to nausea. When treating diabetic ketoacidosis, the patient is usually dehydrated with high blood sugar levels. The treatment involves administering intravenous fluids at a rapid rate. Alongside the fluids, regular insulin is introduced. The specific type of intravenous solution used, whether it's normal saline 0.45%, sodium chloride solution with 5% dextrose, or 5% dextrose in water, doesn't typically matter. Now, when we talk about another condition, hyperosmolar hyperglycemic non-ketotic syndrome, or HHNK, or HHNS, or HHNC, it's essential to know that it is primarily associated with type 2 diabetes. HHNK can seem daunting due to its lengthy name, but it's relatively straightforward. At its core, HHNK is fundamentally about dehydration. Long-term complications of diabetes, such as renal failure, gangrene, stasis ulcers, blindness, impotence, heart disease, and brain disease, arise due to 2 primary factors: poor tissue perfusion and peripheral neuropathy. The best lab test that indicates long-term blood glucose control is the hemoglobin A1C test, also known as the glycosylated hemoglobin test. Ideally, the results should be 6% or lower. If it's 8% or higher, it indicates poor control, while a result around 7% suggests borderline control and requires further investigation.
Before we move ahead, let me take a quick moment to tell you something that could completely change your NCLEX journey. If you're serious about passing the NCLEX in just 1 week or even within a month, then the smartest move you can make right now is to enroll in our complete online NCLEX crash course. This isn't just another course, it's a shortcut, a clear step-by-step roadmap that has already helped over 100,000 nursing students pass the NCLEX with confidence. And here's the most incredible part. Not a single student who completed this course has failed. Yes, that's a 100% passing rate. We built this course based entirely on the feedback and insights of thousands of nurses who've successfully cleared the NCLEX in the last 5 years. That means we've removed all the fluff and focused only on what truly matters for your exam. Here's exactly what you'll get when you enroll. You'll get 100 hours of animated crash course content designed for rapid revision, 500 hours of comprehensive recorded lectures covering all the high-yield topics, and access to 10,000 real NCLEX questions to sharpen your test-taking skills. You'll also get 500 next-gen case-based questions to strengthen your clinical judgment, along with 15 full-length practice tests that simulate the real NCLEX experience. And of course, you'll receive our complete NCLEX ebook and PDF notes, plus 1 full year of access, so you can study at your pace on your schedule. And yes, we're currently offering a 70% discount for a very short period. Once the offer ends, it's gone. Thousands of students are enrolling in our online NCLEX course every month and passing the exam, but if you don't enroll now, you risk being left behind. Spots are filling fast and only a few seats are left. Visit our website to enroll now. Link is given in description box. Let's continue the video.
The next topic is blood transfusion. Before we dive deep into this topic, I want to tell you that you will see at least 1 or 2 questions on this in your next exam. So sharpen your focus, because every detail could be that golden nugget that you're looking for. Let's begin the topic. Types of blood components. Packed red blood cells, or PRBCs. PRBCs are used to replenish erythrocytes. A unit typically infuses over a period of 2 to 4 hours. Each unit can increase the hemoglobin level by approximately 1 gram per deciliter and the hematocrit by around 3%. Lab values typically reflect this change 4 to 6 hours post-transfusion. Effectiveness is gauged by the alleviation of anemia symptoms and a rise in erythrocyte, hemoglobin, and hematocrit counts. Leukocyte-depleted units are those with leukocytes, proteins, and plasma have been minimized. Their primary purpose is to enhance the oxygen-carrying capacity of the blood and restore intravascular volume. For individuals with prior allergic transfusion reactions, or those who have had hematopoietic stem cell transplants, washed red blood cells, devoid of plasma platelets and leukocytes, might be recommended. Leukoreduction, achieved through filtration, washing, or freezing, diminishes the WB count in a unit of packed cells. Platelet transfusion. Platelets treat thrombocytopenia and platelet functionality issues. After receiving multiple platelet units, clients may develop alloimmunization to various platelet antigens. Such individuals may benefit more from HLA-matched platelets. While not obligatory, cross-matching is typically performed. Platelet concentrates have minimal RBCs. Platelet unit volumes can differ. Always inspect the bag to determine the component's volume. Platelets should be administered promptly once they arrive from the blood bank, typically within 15 to 30 minutes. The efficacy of the transfusion is judged by the rise in platelet count. Normally, platelet counts are checked 1 hour post-transfusion and again 18 to 24 hours later. An increment of 5,000 to 10,000 millimeter cube is anticipated for each platelet unit transfused. Fresh frozen plasma. Fresh frozen plasma provides clotting factors or volume expansion, but lacks platelets. This plasma is infused within 2 hours of being thawed to maintain the viability of clotting factors. The infusion process lasts about 15 to 30 minutes. Both RH and ABO compatibility are prerequisites for plasma product transfusion. The transfusion's success is evaluated by tracking coagulation tests, especially prothrombin time and partial thromboplastin time, and by checking the resolution of hypovolemia. Cryoprecipitates. Cryoprecipitates are derived from fresh frozen plasma. They can be stored for up to a year, but once thawed, they must be used immediately. A unit is typically administered within 15 to 30 minutes. They are primarily utilized to replenish clotting factors, notably factor VIII and fibrinogen. To determine the transfusion's effectiveness, coagulation coagulation tests and fibrinogen levels are closely monitored. Granulocytes. Granulocytes are suitable for treating sepsis or neutropenic patients with infections resistant to antibiotics. Effectiveness is evaluated by monitoring WBC and differential counts. Document relevant information about the transfusion in the medical record, noting client's tolerance, response, and the transfusion's effectiveness. Types of blood donations. Autologous donations. Clients donate their own blood for scheduled procedures to minimize disease transmission and potential transfusion issues. Not suitable for patients with leukemia or bacteremia. Donations can be made every 3 days provided hemoglobin is safe. Donations should start within 5 weeks of transfusion and cease at least 3 days before the procedure. Blood salvage. Autologous donation involving suctioning blood from enclosed body site. Blood might require washing to remove tissue debris before reinfusion. Designated donor. Recipients choose their compatible donors. It doesn't reduce infection risk, but offers donor identification comfort to recipients. Compatibility. Blood samples from recipients are labeled at bedside with identity verification.
Stancoast.
Recipients' ABO and RH types are determined. An antibody screen is performed to identify other antibodies. Compatibility is assessed through cross-matching. Compatibility is confirmed if no RBC agglutination takes place. People who are AB positive are universal recipients, meaning they can safely receive a blood transfusion from any other blood type. O negative individuals are universal donors, meaning their blood can be given to people of any blood type. RH positive individuals can receive blood from RH negative donors. However, RH negative recipients should avoid RH positive blood. Incompatibility can lead to severe transfusion reactions. Infusion pumps. Suitable for blood products if they function with opaque solutions. Use specific IV tubing for blood products. Dedicated manual pressure cuffs can be used to adjust flow rate, maxing out at 300 mm of Hg. Regular sphygmomanometer cuffs shouldn't be used. They don't provide consistent pressure on the bag. Blood warmers. You might wonder why we need them. Well, they're essential to ensure patients don't experience hypothermia or have any adverse reactions during multiple transfusions. It's vital to only use devices specifically approved for this job. And a little pro tip, never, and I mean never, think of using microwaves or hot water to warm up blood. It's just not safe. Now, since we're on the topic of blood transfusion, there are some key points that you should absolutely remember. Always provide accurate recipient details to the blood bank and keep a good record of it. Remember, only authorized personnel can pick up blood from the blood bank. Let's avoid mistakes. Only transport one blood unit to one patient at a time. Make sure you inform the patient about what's going on. And don't forget to ask about their past transfusion experiences. A fever in the patient? Check in with the healthcare provider before starting the transfusion. Always ensure the patient has given informed consent. And keep an eye on their vital signs and evaluate the renal, circulatory, and respiratory health. Let me share some of the common mistakes and tips to avoid complications. Be careful with quick infusions of cold blood through a central venous catheter. It can trigger cardiac dysrhythmias. Always inspect the blood bag for any issues. Leaks, weird colors, clots, bubbles, everything. Monitor the patient's vitals and lung sounds during the entire process. Be timely. Infuse within the recommended time frame. Like for packed red blood cells, stick to 2 to 4 hours. Always check expiration dates on blood bags. Store blood in the right refrigerators. If not used timely, return it to the blood bank. Medications and blood, they don't mix, so don't combine them. Only normal saline should accompany blood components. And always ensure that the blood type is a match. We don't want any unpleasant surprises. Remember, safety first. Use an 18 or 19 gauge IV needle to ensure smooth flow and to avoid damaging those RBCs. Use specific sets for blood transfusion with Y tubing or straight tubing equipped with filters. If a patient has history of reactions, pre-medication might be needed. Keep an eye out for any signs of transfusion reactions during the procedure, especially in the initial 15 minutes, and document everything. And on that note, let's discuss some complications to be aware of. Circulatory overload. This happens when blood is infused too quickly. Symptoms include coughing, chest pain, headaches, and more. If this happens, slow down the infusion rate and contact the healthcare provider. Septicemia. This is when the transfused blood is contaminated. It can lead to chills, fever, vomiting, and even shock. If you suspect this, immediately alert the healthcare provider and obtain blood cultures and cultures of the blood bag. Iron overload. What is it? This is a delayed issue we notice in patients who've had multiple transfusions. Think of those with conditions like anemia or thrombocytopenia. Symptoms to watch for are episodes of vomiting, diarrhea, a sudden drop in blood pressure, and fluctuations in regular blood readings. What can we do? Administer drugs like deferoxamine, either IV or subcutaneously. Why? This helps in removing excess iron from the body. Keep an eye on urine color. It might show a reddish hue because of iron being expelled. This treatment is stopped once the serum iron levels are back to normal. Hypocalcemia. Let's decode. The citrate in the transfused blood loves calcium, so it binds with it, leading to its ejection from our body. Clinical indicators. Always check the serum calcium levels before and after giving a transfusion. Keep tabs on hypocalcemia signs, overactive reflexes, tingling sensations, muscle spasms. In your action plan, if you see these signs, slow down the transfusion and give your HCP a heads up. Hyperkalemia. What's happening? Old stored blood releases potassium due to cell breakdown. Steps for care. Remember, the older the blood, the more potassium, especially in patients with kidney issues. Fresh blood is preferable. Always cross-check the storage date on the blood bag and keep an eye on potassium levels. Look out for signs: numbness, fatigue, stomach cramps. If in doubt, slow down the transfusion and bring it to your HCP's attention. Citrate toxicity. Citrate is an anticoagulant in blood products, but guess what? It gets processed by the liver. Rapid transfusion can make levels of calcium and magnesium drop, causing citrate toxicity. This is bad news, as it affects the heart and blood's ability to clot. Our patients with liver issues, or very young ones with immature livers, need extra caution.
Before we move ahead, let me take a quick moment to tell you something that could completely change your NCLEX journey. If you're serious about passing the NCLEX in just 1 week or even within a month, then the smartest move you can make right now is to enroll in our complete online NCLEX crash course. This isn't just another course, it's a shortcut, a clear step-by-step roadmap that has already helped over 100,000 nursing students pass the NCLEX with confidence. And here's the most incredible part. Not a single student who completed this course has failed. Yes, that's a 100% passing rate. We built this course based entirely on the feedback and insights of thousands of nurses who've successfully cleared the NCLEX in the last 5 years. That means we've removed all the fluff and focused only on what truly matters for your exam. Here's exactly what you'll get when you enroll. You'll get 100 hours of animated crash course content designed for rapid revision, 500 hours of comprehensive recorded lectures covering all the high-yield topics, and access to 10,000 real NCLEX questions to sharpen your test-taking skills. You'll also get 500 next-gen case-based questions to strengthen your clinical judgment, along with 15 full-length practice tests that simulate the real NCLEX experience. And of course, you'll receive our complete NCLEX ebook and PDF notes, plus 1 full year of access, so you can study at your pace on your schedule. And yes, we're currently offering a 70% discount for a very short period. Once the offer ends, it's gone. Thousands of students are enrolling in our online NCLEX course every month and passing the exam, but if you don't enroll now, you risk being left behind. Spots are filling fast and only a few seats are left. Visit our website to enroll now. Link is given in description box. Let's continue the video.
The next topic is positioning of the patient. Attention, students. This topic is hot for your upcoming exam. Expect at least 2 or 3 questions directly from here. Don't miss a beat. Watch every second of this video with laser focus. Master this, and you'll be 1 step closer to acing that paper. Now, always position your client in a way that ensures both safety and utmost comfort. Also, keep in mind the client's medical history and conditions. If someone just had surgery, certain positions might aggravate their condition or hinder their healing process. Here, we will discuss various positions for specific conditions. Autografts. After a surgery like this, you must keep the site completely still, usually between 3 to 7 days. It is crucial as it allows the grafted skin to stick properly. Face and head burns. In such cases, elevate the head of the bed. It's not just for comfort, but to prevent scary complications like facial or tracheal edema. Burns around the arms or legs. Elevate these limbs higher than the heart. It's like giving them a little pedestal of their own to prevent swelling. Skin graft. Here, you should be gentle. Elevate and immobilize the graft site, ensuring there's no unnecessary movement. And no, they shouldn't be standing on it either. Mastectomy. For clients who've had this surgery, always prop them up at least 30 degrees. Think of it as the queen or king reclining on their throne position, and elevate their affected arm on a pillow. It aids in fluid drainage and gives them some relief. Only turn the client to the back or the side that hasn't been operated on. The affected side needs its beauty rest. Perineal and vaginal procedures. Here's a position straight out of your yoga class. The lithotomy position. It's the best way to ensure access and comfort for the client post-procedure. Hypophysectomy. Imagine you're trying to balance a delicate scale. If someone has undergone a hypophysectomy, which means removal of the pituitary gland, our master control gland, we must make sure there's no added pressure in the head area. Think of this as adjusting the weights on the scale. So we elevate the head of the bed slightly. Why? This reduces the risk of intracranial pressure that might cause complications. Thyroidectomy. The thyroid gland, shaped like a butterfly, sits comfortably at the front of our neck. When it's removed, we need to imagine we're cradling that area with utmost care. So we place the client in a semi-Fowler's to Fowler's position. This angle helps reduce swelling and gives a little comfort to the area where our butterfly-like gland once sat. Think of it like supporting a delicate sculpture. We might use sandbags, pillows, or other stabilizers to ensure the head and neck remain steady. Ever been told not to stretch a new rubber band too hard? Similarly, we don't want to extend the neck too much as it may strain the area where surgery was done. Hemorrhoidectomy. It's all about comfort after this procedure, which deals with the removal of swollen veins in the rectal region. In this case, it's best to lay on the side, which prevents pain and potential bleeding. Gastroesophageal reflux disease, or GERD. Think of a seesaw. With GERD, we want the stomach end lower than the esophagus to avoid food and acid moving upwards. The reverse Trendelenburg's position tilts the body with the head elevated higher than the feet. It's like creating a downhill for the stomach content so it doesn't flow back into the esophagus. Liver biopsy. We gently and carefully assist them onto their right side. Why the right side, you ask? Well, the liver is situated on the right side of the body, tucked neatly under the ribcage. By lying on this side, we're applying some gentle pressure to the wound area, which can help reduce any potential bleeding and offer added support to the puncture site. But wait, we can offer even more comfort. Think of a pillow or folded towel as a miniature soft shield. By placing the shield beneath the puncture site, it provides cushioning and further ensures the area remains stable. Paracentesis. Imagine needing to access fluid in the abdominal area. For this, we'd have our patient either in a semi-Fowler's position or sitting upright. Think of it as allowing for space for the procedure. Once it's done, our priority is comfort, so we help the patient find a relaxing position. Nasogastric tube insertion will prop the client up into a high Fowler's position. Why? Because tilting the head forward magically helps close the windpipe, or trachea, and opens up the esophagus. Imagine trying to slip into a busy street versus an open alleyway. For nasogastric irrigations and feedings, elevate the bed's head to prevent our patient from aspirating or accidentally letting fluids go down the windpipe. Remember to maintain this elevation, especially after feeding, like allowing time for digestion. Rectal enema and irrigations. Place the client in the left Sims position, as it's like letting water flow downstream in a river. This takes advantage of the colon's natural pathway. Sangston Blakemore and Minnesota tubes. They might sound like names of rock bands, but these tubes, though not a fan favorite, sometimes are a necessity if we have to use them. Keeping the head elevated helps both in lung expansion and reducing blood flow in specific areas. Chronic obstructive pulmonary disease, COPD. In severe cases, think of giving the client a pose like they're in deep thought over a desk, sitting. Leaning forward with arms over pillows or a table makes breathing easier and more effective. Laryngectomy. We aim to keep the airway open and reduce swelling. A semi-Fowler's or Fowler's position is like giving a clear tunnel for airflow. Post-bronchoscopy. After examining the main passageways of the lungs, we position the patient in a semi-Fowler's position. This helps in preventing any unwanted particles from going down the wrong way, considering their swallowing might be momentarily impaired. Postural drainage. Imagine you're pouring a drink. You want to ensure the last drop goes into the glass, so you position the bottle such that the remaining liquid is at the very top. Similarly, in postural drainage, the segment of the lung we want to drain needs to be in the highest position. Think of it as tilting the bottle. We sometimes use the Trendelenburg's position. Thoracentesis. Visualize a ketchup packet. To get every drop out, you squeeze from the bottom and position it to one side. Similarly, during thoracentesis, picture someone leaning over a table, trying to get a good view of something on the ground. That's our patient. They sit on the bed's edge, leaning over the bedside table with feet propped up on a stool. Alternatively, they can lay in bed on the unaffected side, sort of propped up like they're watching TV in a relaxed position. In other words, Fowler's position. Abdominal aneurysm resection. Imagine after a big operation. Our pipe needs minimal bending, so we make sure the head of the bed is elevated, but only to 45 degrees. Amputation of the lower extremity. Within the first day, we prop the foot of the bed up. It's like elevating a repaired toy to let the glue set. We use pillows, but ensure not to elevate too much, because we don't want it to bend at awkward angles. Regular stretching as prescribed is essential. Imagine doing yoga twice a day to ensure flexibility. This is to avoid any stiffness setting in. Arterial vascular grafting of an extremity. Imagine a newly planted sapling. The tree is kept straight and undisturbed for a day, ensuring its roots grab hold. Similarly, the affected limb is kept straight. Movements are restricted, like making sure kids don't play near our new tree. Cardiac catheterization. Think of a freshly painted wall. If we assess the wall, or in this case, the femoral vessel, we let it dry or stabilize. It's like when we paint a wall and ensure no one touches it. The patient stays in bed, though they can turn side to side. The limb we worked on is kept straight, and the head is not lifted too high, no more than 30 degrees. It is like ensuring our freshly painted wall isn't smudged. Heart failure and pulmonary edema. Imagine this. Your city is flooded and the waters are rising in the downtown area. What do? Exactly. Move to higher ground. In the same way, when someone is dealing with heart failure or pulmonary edema, we want to position the client upright. Let their legs dangle over the side of the bed. Why? This reduces the flood, or in our case, decreases venous return and eases the lung congestion. And remember, many clients with respiratory and cardiac issues generally benefit from having their head elevated. Peripheral arterial disease. Okay, now let's talk about the arterial highways of our body. Sometimes there's a traffic jam because of swelling. The key here, elevation, but not too high. We don't want to slow down the traffic. So raise the feet, but not above the head. Some clients might need their feet a bit lower to keep blood flowing smoothly. Varicose veins. Think of these as the bumpy, uneven roads in our city. For these, elevating the legs above heart level is the way to go. But just like avoiding potholes, folks should try not to sit or stand for too long. Venous insufficiency and leg ulcers. When the drainage system is clogged, elevating the leg can help clear it out. Cataract surgery. After this operation, imagine propping up the main statue in our city center. Elevate the head of the bed and either lay on the back or the unoperated side. This stops excess fluid from gathering at the operated site. Retinal detachment. This is like a major billboard in our city is hanging off the edge. Sometimes you'll need to completely close off the area, like bed rest and patching both eyes. Autonomic dysreflexia. This one is critical, guys. Imagine a sudden storm hitting our city. Immediately elevate the control tower, or in our case, the head of the bed, to a high Fowler's position. This helps us navigate the storm, ensuring enough air and avoiding a disastrous hypertensive event. Cerebral aneurysm. Imagine your brain as a delicate garden where too much water or pressure could be harmful. To ensure just the right amount of pressure, lie down, but make sure the top part of your bed is tilted 30 to 45 degrees upwards. This delicate angle avoids putting too much pressure on the area of the aneurysm. Cerebral angiography. Keep the arm where the contrast medium was injected straight and still for about 6 to 8 hours. Stroke or brain attack. It's like a storm in the brain, depending on the type. A hemorrhage stroke, you elevate the bed's head to 30 degrees, helping drain out the storm. Ischemic stroke. Keep the bed flat for optimal care. Always keep your head straight and in the middle. Avoid making sharp bends with your hips and neck. It's a bit like ensuring proper drainage after heavy rain. Craniotomy. Imagine your skull as a protective helmet. When a part of this helmet is removed, like during a craniotomy, don't lie down on the operated side. Tilt your bed's head 30 to 45 degrees upwards and keep your head straight and avoid extreme bending. Laminectomy and vertebral surgery. When lying, think of turning your entire body as one solid log. Lumbar puncture. Getting this test is like forming a C with your spine. Lie on your side during the test, curving like the letter C. After the test, Lie on your back for a while.
Before we move ahead, let me take a quick moment to tell you something that could completely change your NCLEX journey. If you're serious about passing the NCLEX in just 1 week or even within a month, then the smartest move you can make right now is to enroll in our complete online NCLEX crash course. This isn't just another course, it's a shortcut, a clear step-by-step roadmap that has already helped over 100,000 nursing students pass the NCLEX with confidence. And here's the most incredible part. Not a single student who completed this course has failed. Yes, that's a 100% passing rate. We built this course based entirely on the feedback and insights of thousands of nurses who've successfully cleared the NCLEX in the last 5 years. That means we've removed all the fluff and focused only on what truly matters for your exam. Here's exactly what you'll get when you enroll. You'll get 100 hours of animated crash course content designed for rapid revision, 500 hours of comprehensive recorded lectures covering all the high-yield topics, and access to 10,000 real NCLEX questions to sharpen your test-taking skills. You'll also get 500 next-gen case-based questions to strengthen your clinical judgment, along with 15 full-length practice tests that simulate the real NCLEX experience. And of course, you'll receive our complete NCLEX ebook and PDF notes, plus 1 full year of access, so you can study at your pace, on your schedule. And yes, we're currently offering a 70% discount for a very short period. Once the offer ends, it's gone. Thousands of students are enrolling in our online NCLEX course every month and passing the exam, but if you don't enroll now, you risk being left behind. Spots are filling fast and only a few seats are left. Visit our website to enroll now. Link is given in description box. Let's continue the video.
Welcome to the next topic, legal aspects of nursing, types of law, contract law. This is about keeping promises between people. Civil law, it's about protecting people's rights and handling issues between individuals. It doesn't involve big threats to society. Criminal law, this deals with actions that could harm society. Crimes are serious offenses against the law, either less serious, called a misdemeanor, or more serious, called a felony. Tort law. A tort is when someone does something wrong that hurts another person. It's not a contract issue, and the injured person can ask for compensation. Tort laws address wrongdoings causing harm, but there are 2 main types: intentional and unintentional. Unintentional torts. Harm or injury caused accidentally or due to negligence, without deliberate intent. Types of unintentional torts: negligence and malpractice. Negligence. Negligence is doing something that a careful person wouldn't do. We compare actions to what's reasonable in a situation. Malpractice. Malpractice is when professionals like nurses make mistakes due to misconduct or not having enough skill. It's like a serious form of negligence for experts. Examples of negligence or malpractice: accidental burns inflicted on a client through the use of a heating pad, objects inadvertently left within a client's body after a surgical procedure, inadequate assessments compromising the quality of patient care, administration errors involving incorrect medications or missed doses. Intentional torts. Intentional tort happens when someone purposefully does something to harm another person or their property. It's when harm is done on purpose, not by accident. Types of intentional torts: assault, threatening someone with physical harm, making them fear and attack. Battery, physically harming someone intentionally, like hitting or punching. False imprisonment, illegally confining or restraining someone against their will. Defamation. Defamation is when someone says or writes something untrue about another person, hurting their reputation. It can be in writing, called libel, or spoken, called slander. Intentional infliction of emotional distress, purposefully causing severe emotional distress to someone. Fraud, deceiving someone intentionally to gain an unfair advantage. Now, understanding treatment for minors. Who is a minor? A minor is someone under a certain age set by the law, usually less than 18 years old. Getting consent. Minors cannot legally agree on their own, so they need permission from a parent or guardian. When consent is needed, in most cases, treatment for a minor needs the patient or guardian's permission, but there are exceptions. Emergencies, certain health issues like substance abuse or infections, when a minor can decide if the minor is independent, emancipated, or when there's a court order. Emancipated minor. An emancipated minor is someone who became independent through marriage, pregnancy, joining the military, or a court order. An emancipated minor can legally give their own consent for treatment. Before moving on to the next topic, let's highlight a key point of utmost importance: Good Samaritan laws. These laws make sure that professionals help in an emergency and give proper care, and they won't get in trouble. It encourages them to assist without worrying about legal problems. HIPAA, the Health Insurance Portability and Accountability Act, describes how personal health information, PHI, may be used and how the client can obtain access to the information. Advance Directive. It is a legal document that extends a person's control over healthcare decisions in the event that the person becomes incapacitated. They are called advance directives because they communicate preferences before incapacitation occurs. Critical pathway. A critical pathway is like a map for taking care of a client. It helps plan and keep track of their progress within a certain time. The next topic is leadership styles. Autocratic leadership. In this type of leadership, the leader takes control and makes decisions. No input is sought from the group, and it's like a strong guiding hand. Democratic or participative leadership. Everyone in the team contributes ideas. The leader supports and guides like a friend, and communication flows more freely. Laissez-faire leadership. Leaders step back and give space. Team members take charge and decide. Minimal guidance is given by the leader. Situational leadership. The style changes based on what's needed. Flexibility to adapt to different situations. Bureaucratic leadership. The leader follows strict rules and procedures. Organizational guidelines are the main focus. The next topic is emergency department triage system. In emergency departments, a commonly used system rates patients in 3 tiers: emergent, urgent, and non-urgent. Emergent, red, priority 1, or highest priority. This top priority goes to patients with life-threatening injuries requiring immediate attention and constant monitoring. These patients have a good chance of survival once stabilized. Examples include trauma victims, severe chest pain, cardiac arrest, limb amputation, acute neurological issues, and chemical eye injuries. Urgent, yellow, priority 2, assigned to patients needing treatment with non-life-threatening complications, but they should be treated within 1 to 2 hours. Continuous evaluation every 30 to 60 minutes is needed. Examples include simple fractures, manageable asthma, fever, hypertension, abdominal pain, and renal stones. Non-urgent, green, priority 3, given to patients with local injuries lacking immediate complications. They can wait several hours for treatment, with evaluation needed every 1 to 2 hours. Examples include minor cuts, sprains, or cold symptoms.
Before we move ahead, let me take a quick moment to tell you something that could completely change your NCLEX journey. If you're serious about passing the NCLEX in just 1 week or even within a month, then the smartest move you can make right now is to enroll in our complete online NCLEX crash course. This isn't just another course, it's a shortcut, a clear step-by-step roadmap that has already helped over 100,000 nursing students pass the NCLEX with competence. And here's the most incredible part. Not a single student who completed this course has failed. Yes, that's a 100% passing rate. We built this course based entirely on the feedback and insights of thousands of nurses who've successfully cleared the NCLEX in the last 5 years. That means we've removed all the fluff and focused only on what truly matters for your exam. Here's exactly what you'll get when you enroll. You'll get 100 hours of animated crash course content designed for rapid revision, 500 hours of comprehensive recorded lectures covering all the high-yield topics, and access to 10,000 real NCLEX questions to sharpen your test-taking skills. You'll also get 500 next-gen case-based questions to strengthen your clinical judgment, along with 15 full-length practice tests that simulate the real NCLEX experience. And of course, you'll receive our complete NCLEX ebook and PDF notes, plus 1 full year of access, so you can study at your pace on your schedule. And yes, we're currently offering a 70% discount for a very short period. Once the offer ends, it's gone. Thousands of students are enrolling in our online NCLEX course every month and passing the exam, but if you don't enroll now, you risk being left behind. Spots are filling fast and only a few seats are left. Visit our website to enroll now. Link is given in description box. Let's continue the video.
The next topic is parenteral nutrition. Before we dive into this topic, expect at least 3 or 4 questions from this topic on your next exam. So keep those eyes peeled and take notes. Alright everyone, let's dive into parenteral nutrition, or PN as it's often called. Think of it as a lifeline for those who can't get nutrients the conventional way. Imagine supplying the body with essential nutrients directly through the veins. That's exactly what parenteral nutrition does. We have two types here, PPN, or partial parenteral nutrition, and TPN, total parenteral nutrition. Which one we choose depends on the specific needs of the patient. Let's break down what's in PN. There are carbohydrates, presented as dextrose, fats that are emulsified, proteins appearing as amino acids, and then we have the vitamins, minerals, electrolytes, and water. What's great about PN? It helps our body conserve its energy resources, ensuring it doesn't start using up our subcutaneous fat or muscle protein. Now, a quick note. PN solutions are hypertonic, meaning they have higher concentrations of substances like glucose and amino acids. Why might someone need parenteral nutrition? It's perfect for individuals whose gastrointestinal tracts are sadly out of commission, so they can't process or absorb nutrients effectively. Think of someone who can eat a bit, but not enough to fulfill their daily nutritional requirements. PN to the rescue. It's also a boon for those recovering from multiple GI surgeries or trauma. For patients grappling with health challenges like AIDS, cancer, severe burn injuries, malnutrition, or undergoing chemotherapy, PN can be a life changer. Remember, the preference is always to try oral nutrition or nasogastric tube feeding before jumping to PN. It's our backup when all else fails. Administering PN. When we're talking about PPN, it's typically given through a large distal vein in the arm using a regular IV catheter, a midline, or sometimes a PICC. Peripherally inserted central catheter. The midline often goes into veins in the upper arm, like the brachial or cephalic veins. On the other hand, TPN is directly channeled into a central vein. PICC works here, but sometimes we might also use the subclavian or jugular veins. A quick nursing tip. If you ever notice that the bag of IV solution is empty and you're waiting for a replacement, start with a 10% dextrose solution at the prescribed rate to keep hypoglycemia at bay. Get the prescribed solution as quickly as possible. Keep in mind that introducing hypertonic solutions into peripheral veins could lead to complications like sclerosis, phlebitis, or swelling. Always monitor for these signs. Diving deeper into PN components. Carbohydrates. The strength of the dextrose solution we use hinges entirely on the patient's nutritional requirements and the delivery route. Alright everyone, keep these points in mind and let's ensure our patients get the best nutritional support possible. Dive in with me as we break down the essentials of administering solutions. Administration basics. Number 1. Whether you're going with a central or peripheral method, always follow the agency's guidelines. It's the golden rule. Number 2, carbohydrates. Think of carbohydrates as your body's main fuel. They typically cater to 60 to 70% of our energy needs, and that's a significant chunk. Number 3, amino acids. Yes, proteins. These concentrations vary. We're talking from 3.5% to a whopping 20%. Remember, lower concentrations are typically used for peripheral veins, while the big guns, the higher concentrations are saved for central veins. And here's a fun fact. 15 to 20% of our energy should ideally come from proteins. Number 4. Fat emulsions, or lipids. Lipids chip in up to 30% of our energy needs. They're not just about calories. They also help prevent fatty acid deficiencies. These solutions can be administered either through a peripheral or central vein. But here's a quick trick. If you're adding it to the main IV set, use a Y connector. Most of these emulsions come from familiar sources, like soybean or safflower oil, but keep an eye out for potential allergies, especially with egg yolk in the mix. Our friends with glucose intolerance or diabetes might get a more significant chunk of their PN from lipids. It's a nifty way to keep those glucose levels in check. Now, always, and I mean always, check the bottle. Any separation, fat globules, or froth, red flag. Send it back to the pharmacy. And remember, these lipid solutions are unique. No additional additives should be mixed in. When it comes to infusion, start slow. Monitor the patient for any adverse reactions. If anything seems off, halt the infusion and get the healthcare provider on the line. Vitamins. PN solutions usually have our vitamin needs covered with a standard multivitamin blend. However, individual vitamins can also be added if necessary. Minerals and trace elements. These come in various preparations and are crucial for keeping our metabolism ticking right. Now, look at this diagram. For those of you who are more visual learners, it gives a fantastic overview of the placement of catheters, both peripherally inserted and central. And here's something super important. Signs and symptoms of a bad reaction to lipids, chest and back pain, chills, fever, nausea. These are things we need to be vigilant about. It's essential knowledge, so make sure you've got these down. Electrolytes. When it comes to PN therapy, not everyone's electrolyte requirements are the same. Factors such as body weight, malnutrition, catabolism, and the specific illness play a huge role. Moreover, the organ function and any ongoing electrolyte losses also matter. Water. How much water do we need in a PN solution? Well, it's mainly about balancing the electrolytes and meeting fluid requirements. Regular insulin. You might wonder, why add insulin? It's because of the high concentration of glucose in the PN solution. We need to keep that blood sugar in check. Heparin. A nifty little addition to prevent that pesky fibrinous clot from forming at the catheter tip. Administering and ending PN. There are two main types to understand. Continuous PN. This runs 24/7, making it perfect for hospital scenarios. Intermittent or cyclic PN. This one's pretty flexible and often given overnight. This method allows patients to enjoy their daytime activities without the hassle of the IV setup. But remember, monitor those glucose levels. We don't want unexpected dips, especially when not infusing. Complications. Let's discuss some complications you might come across with parenteral nutrition. One of the major issues? Air embolism. This can occur if the catheter system is opened or the IV tubing gets disconnected. Be extra cautious during IV tubing changes to prevent any air entry. Always remember to clamp all ports of the IV catheter. If this situation arises, immediately place the patient on their left side with their head positioned lower than their feet. Notify the healthcare professional at once and ensure you administer oxygen. Next complication is hyperglycemia. So, what causes it? Well, there are a few key reasons. First, it can occur when there's a high concentration of dextrose in a solution. Secondly, it might arise if a client is receiving a solution too rapidly. Another reason? A lack of sufficient insulin. And let's not forget, infections can also be a contributing factor. Now, if you notice hyperglycemia signs, what should you do? First and foremost, get in touch with a healthcare provider. It might be necessary to adjust the infusion rate, perhaps slowing it down a bit. Regular monitoring of blood glucose levels is crucial, and if prescribed, make sure to administer regular insulin. Next complication of parenteral nutrition is hypervolemia. Now, what is it? Think of it as the result of either giving too much fluid too quickly or simply administering excessive fluids. Conditions like renal dysfunction, heart failure, or hepatic failure can also lead to hypervolemia. So, what do we do if we encounter it? First, you might want to slow down or even stop the IV infusion. Always make sure to alert the healthcare provider. Depending on the situation, you might also need to restrict fluids, maybe even prescribe diuretics. And in extreme cases, dialysis might be the way to go. Keep these interventions in mind. They're crucial. Next complication is hypoglycemia, related to parenteral nutrition. Now, one thing to always remember is that if you suddenly stop PN, it can lead to hypoglycemia. Imagine this. If you've been giving too much insulin alongside the PN, you've set up the body to expect a certain amount of glucose. So, when you're about to discontinue the PN, don't just stop it abruptly. What you should do is gradually reduce the PN solution. A helpful tip here is to infuse a 10% dextrose solution at the same rate as the PN. By doing this, you're essentially providing a buffer, which can prevent hypoglycemia for about 1 to 2 hours after the PN has been stopped. And as always, keep an eye on those glucose levels. It's a good practice to monitor them closely, and especially to check the glucose level about 1 hour after you've stopped the PN. This will give you a good indication of how the patient's body is responding. The next complication is infections. It can arise due to several reasons. Due to poor aseptic technique, catheter contamination, and due to contamination of solution. What action should the nurse take? Notify the healthcare provider is always the first step. Remove the catheter. If you believe it's the source of the infection, it needs to be removed immediately. Send the catheter tip to the laboratory for culture. Prepare to obtain blood cultures. Blood cultures will give further insights into the infection. Prepare for antibiotic administration. Based on the lab results, the right antibiotics will be administered to treat the infection. Next complication of parenteral nutrition is pneumothorax. Now, what is that? Well, If the catheter isn't placed precisely, it might puncture the pleural space. This can be dangerous. So, what should we do? First, always be vigilant. Observe the patient for any signs of pneumothorax. Symptoms might include shortness of breath or sharp chest pain. After placing the catheter, it's imperative to get a chest x-ray. This will help us determine whether the catheter is correctly positioned or not. And remember, never start the parenteral nutrition unless you're certain of two things: the catheter is properly placed, and there's no sign of pneumothorax. Now, we're diving into the nuances of nursing considerations when it comes to parenteral nutrition. First and foremost, always double check the PN solution against the doctor's prescription. Does it contain the right components? Some hospitals even ask 2 registered nurses to validate the prescription. This ensures accuracy and safety. An important safety tip: never mix IV medications and blood with the PN line. Why? To avoid any risk of infections and incompatibility of solutions. Now, if you're drawing blood for testing from the central venous access site, here's a key thing to remember. Do it from a different port, not the one you're using for PN infusion, and ensure the PN has been stopped for a bit. This is because the PN solution can affect the sample results. Even with a central venous access site, it's always good to have an alternate venipuncture site for the patient. For those patients on anticoagulants, always keep an eye on the partial thromboplastin time and prothrombin time. Similarly, it's essential to regularly monitor the patient's electrolyte, albumin levels, liver, and kidney functions, and other lab studies, especially when the client is on PN. Blood studies are typically done either every alternate day or 3 times a week. This is crucial for doctors to decide whether to continue or adjust the PN solution. Heads up for hyperglycemia. You'll need to monitor blood glucose levels. Typically, this is done every 4 hours because some components of the PN solution might spike up the sugar levels. A quick note on dehydrated patients. Don't be alarmed if you see their albumin levels drop right after starting PN. It's because we're restoring their hydration. And be extra cautious with severely malnourished patients. They're prone to what's called the refeeding syndrome, which means a sudden drop in their potassium, magnesium, and phosphate serum levels. Speaking of refeeding syndrome, its electrolyte shift can cause a range of problems, from cardiovascular and respiratory issues to neurological problems. Watch out for symptoms like shallow breathing, confusion, weakness, or even seizures. If any of these arise, inform the doctor without delay. Now, if you notice unusual liver function values, it could be a sign of intolerance to fat emulsion or issues with glucose and protein metabolism. And just as a heads up, abnormal renal function could be due to an excessive amount of amino acids. Let's talk storage. PN solutions should be refrigerated and used within 24 hours from when they're prepared. And always remember to take them out about 30 minutes to an hour before administering. A cloudy or discolored PN solution? Red flag. Don't use it. Return it to the pharmacy. If you're thinking of adding nutrients or any substances to PN solutions, hold that thought. This should always be done in the pharmacy.
Before we move ahead, let me take a quick moment to tell you something that could completely change your NCLEX journey. If you're serious about passing the NCLEX in just 1 week or even within a month, then the smartest move you can make right now is to enroll in our complete online NCLEX crash course. This isn't just another course, it's a shortcut, a clear step-by-step roadmap that has already helped over 100,000 nursing students pass the NCLEX with confidence. And here's the most incredible part. Not a single student who completed this course has failed. Yes, that's a 100% passing rate. We built this course based entirely on the feedback and insights of thousands of nurses who've successfully cleared the NCLEX in the last 5 years. That means we've removed all the fluff and focused only on what truly matters for your exam. Here's exactly what you'll get when you enroll. You'll get 100 hours of animated crash course content designed for rapid revision, 500 hours of comprehensive recorded lectures covering all the high-yield topics, and access to 10,000 real NCLEX questions to sharpen your test-taking skills. You'll also get 500 next-gen case-based questions to strengthen your clinical judgment, along with 15 full-length practice tests that simulate the real NCLEX experience. And of course, you'll receive our complete NCLEX ebook and PDF notes, plus 1 full year of access, so you can study at your pace on your schedule. And yes, we're currently offering a 70% discount for a very short period. Once the offer ends, it's gone. Thousands of students are enrolling in our online NCLEX course every month and passing the exam, but if you don't enroll now, you risk being left behind. Spots are filling fast and only a few seats are left. Visit our website to enroll now. Link is given in description box. Let's continue the video.
The next topic is various types of tubes used in patient care. The board is likely to ask 4 to 5 questions on this topic. We'll cover tubes used in the respiratory, gastrointestinal, and urinary systems, including the NG tube, Foley's catheter, endotracheal tube, and tracheostomy tube. Let's discuss the nasogastric tubes. These are medical devices used for intubating the stomach. They are inserted through the nose and extend into the stomach. The primary purpose of nasogastric tubes include decompressing the stomach to remove fluids or gas, promoting abdominal comfort, allowing surgical anastomosis to heal, reducing the risk of aspiration, administering medications to patients who cannot swallow, providing temporary nutrition, and removing toxic substances in cases of poisoning. There are different types of nasogastric tubes. Miller-Abbott tube. It is a specialized, long, double-lumen tube designed for draining and decompressing the small intestine. It features one lumen connected to a balloon, which is filled with a specific substance, typically tungsten, once positioned inside the stomach. The second lumen of the Miller-Abbott tube is dedicated to both irrigation and drainage functions. This dual lumen structure allows for effective and simultaneous decompression and management of intestinal contents, making it a valuable tool in specific gastrointestinal medical procedures. Levin tube. It is a single lumen tube made of plastic or rubber with a solid tip. It is designed for use in the stomach. It can be inserted either through the nose or mouth. This type of nasogastric tube is primarily employed for draining fluid and gas from the stomach, and it can be utilized for either intermittent suction or feeding purposes. The design and material of the Levin tube facilitate its specific function in gastrointestinal medical care, providing an effective solution for stomach decompression and content management. The Sangstaken-Blakemore tube. It is a 3-lumen medical device with 2 of its ports designed to inflate balloons in the esophagus and stomach for tamponade purposes. The third lumen is utilized for nasogastric suction. While this tube itself does not facilitate esophageal suction, an additional nasogastric tube can be inserted through the opposite nostril or the mouth. This additional tube is positioned to rest atop the esophageal balloon, thereby enabling esophageal suction. This arrangement significantly reduces the risk of aspiration, making the Sangstaken-Blakemore tube a critical tool in managing certain gastrointestinal conditions. Salem sump tube. The Salem sump tube is a double-lumen nasogastric tube featuring a small vent tube within a larger suction tube. This design is specifically intended to prevent mucosal suction damage. The small vent tube functions to regulate the pressure in the open eyes at the distal end of the tube, maintaining it at less than 25 mmHg. This careful pressure control is crucial for ensuring the safety and effectiveness of the tube in medical procedures, particularly in preventing damage to the stomach's mucosal lining during suction. Cantor tube. It is a single-lumen, long medical tube featuring a small inflatable bag at its distal end. To inflate this bag, a special substance, usually tungsten, is injected using a needle, 21 gauge or smaller, to prevent leakage, and syringe. This unique design, combining the long tube with the inflatable tungsten-filled bag, allows for specific medical applications, particularly in the gastrointestinal tract, where precise control and maneuverability are essential. Nasogastric tubes intubation procedures. When inserting a nasogastric tube, it is essential to follow the specific procedures outlined by the healthcare facility. Begin by explaining to the patient what the procedure entails, including any potential discomfort. Position the patient in a high Fowler's position, propped up with pillows for support. Check both nostrils and choose the one that seems more open for the insertion. Measure the tube length needed by running it from the patient's nose to their earlobe and then down to the xiphoid process. Mark this length on the tube with tape, remembering the acronym NEX. Nose, earlobe, xiphoid process. If the patient is conscious and able to swallow, encourage them to swallow or sip water during the procedure, as per your facility's guidelines. Lubricate the tube's tip with a water-soluble lubricant to ease insertion. Insert the tube gently into the nasopharynx, advancing it carefully. When the tube is at the back of the throat, indicated by the first black measurement mark on the tube, Instruct the patient to swallow or sip water if they're able to. If resistance is encountered, rotate the tube slowly, directing it downwards toward the closer ear. In patients who are intubated or semi-conscious, flex the head towards the chest while passing the tube. If there is any change in the patient's respiratory status during the procedure, immediately withdraw the tube. Once the tube is in place, confirm its placement with an abdominal X-ray. Connect the tube to suction, either intermittent or continuous, based on the prescription. And if the tube is intended for decompression, secure the tube in place with adhesive tape on the patient's nose and gown, ensuring to check for any allergies to the tape. Monitor the patient for signs of nausea, vomiting, abdominal fullness, or distension, and keep track of the gastric output. Regularly check the residual volumes in the stomach, especially before feedings and administering medications. Aspirate and measure the stomach contents, and if necessary, reinstate them to prevent excessive fluid and electrolyte loss, unless the residual is abnormal or too large. Always follow the guidelines of your healthcare facility for these steps. Before administering anything through the tube, such as irrigation solutions, feedings, or medications, aspirate stomach contents and check their pH to ensure the tube is correctly positioned in the stomach. Use normal saline for irrigation if needed, and always follow your facility's guidelines for this. Pay attention to the patient's fluid and electrolyte balance, and advise them on how to move to avoid nasal irritation and dislodging the tube. Daily, remove the adhesive tape. Clean and dry the skin around the nose to check for any irritation or damage, and then reapply fresh tape. Nasogastric tube irrigation. To irrigate a nasogastric tube effectively and safely, start by confirming the tube's placement. Regular irrigation, typically every 4 hours, is crucial for assessing and maintaining the tube's patency. For the irrigation process, gently instill 30 to 50 milliliters of water or normal saline, depending on your healthcare facility's policy, using an irrigation syringe. After instilling the fluid, use a syringe plunger to withdraw the fluid. This step helps in checking the patency of the tube. If you notice that the tube flow is sluggish, repeat the process to ensure the tube remains clear and functional. When it comes time to remove the nasogastric tube, instruct the patient to take a deep breath and hold it. Then, slowly and steadily remove the tube over a period of 3 to 6 seconds. It's helpful to coil the tube around your hand as you remove it, allowing for a controlled and smooth withdrawal. Gastrointestinal tube feedings. Administering feedings through a nasogastric tube involves several careful steps. First, verify the healthcare provider's prescription and your facility's policy regarding residual stomach contents. Typically, if the residual volume is less than 100 milliliters, you can proceed with the feeding. Be cautious, as large volume aspirates may indicate delayed gastric emptying, increasing the risk of aspiration. Before feeding, assess the patient's bowel sounds. If you do not detect any bowel sounds, hold off on the feeding and inform the healthcare provider. When positioning the patient, use a high Fowler's position for alert patients, or if the patient is comatose, place them in a high Fowler's position and on their right side. Next, check the tube placement by aspirating gastric contents and measuring their pH, which should be 3.5 or lower. Aspirate all stomach contents to measure the residual volume. Typically, you should return these contents to the stomach to avoid electrolyte imbalances, unless the color or characteristics are abnormal, or the volume exceeds 250 milliliters. Before administering the feeding, warm it to room temperature to prevent discomfort, such as diarrhea and cramps. For continuous or cyclic feedings, use an infusion feeding pump. In the case of bolus feeding, keep the patient in a high Fowler's position for at least 30 minutes post-feeding. Either use an infusion pump or allow the feeding to infuse via gravity, but avoid using force to plunge the feeding into the stomach. Finally, for continuous feeding, ensure the patient remains in a semi-Fowler's position at all times to facilitate digestion and reduce the risk of aspiration. Before administering any solutions through a gastrointestinal tube, including feeding solutions, medications, or other substances, Always assess the tube's placement. Incorrect placement can significantly increase the risk of aspiration in the patient. Regularly assess the patient's bowel sounds and refrain from administering feedings if bowel sounds are absent, as this could indicate a problem with gastrointestinal motility or function. Administer the feeding at the prescribed rate, or for intermittent bolus feedings, use gravity flow. Employ a 50 to 60 milliliter syringe with a plunger removed for this purpose. For maintaining hygiene and safety, change the feeding container and tubing every 24 hours or as per your healthcare facility's policy. To prevent bacterial growth, avoid hanging more feeding solution than needed for a 4-hour period. Always check the expiration date of the formula before use. Shake the formula thoroughly before pouring it into the feeding container, such as a feeding bag. Some feeding solutions use bags for adding formula, while others use bottles that directly connect to the feeding tube. Note that some tubing may have a Y-site connection, allowing for regular flushing programmed through the pump instead of manually through a piston syringe. After each feeding, gently flush the tube with 30 to 50 milliliters of water or normal saline using an irrigation syringe. This step helps in maintaining the patency of the tube and reduces the risk of blockages. Now we will discuss about gastric and esophageal tubes. Esophageal and gastric tubes are specialized medical devices with specific applications and precautions. Their primary use is to control bleeding in the esophagus, particularly from bleeding veins that other interventions can't manage or are contraindicated. However, they should not be used in patients with esophageal ulceration, necrosis, or previous esophageal surgery due to the risk of rupture. There are two main types of these tubes, the Sangston-Blakemore tube and the Minnesota tube. The Sangston-Blakemore tube, which is less commonly used, is a triple lumen gastric tube featuring an inflatable esophageal balloon to compress esophageal varices, an inflatable gastric balloon for pressure at the cardioesophageal junction, and a lumen for gastric aspiration. Alongside this, a nasogastric tube is inserted in the opposite nostril to collect secretions above the esophageal balloon. The Minnesota tube, more frequently used, is a variation of the Sangston-Blakemore tube with an additional lumen, making it a 4-lumen gastric tube. This extra lumen is for aspirating esophageal pharyngeal secretions. The correct placement of these tubes is confirmed via radiography of the upper abdomen and chest. In terms of interventions, there are several important steps and precautions. Before insertion, the patency and integrity of all balloons must be checked. Each lumen should be clearly labeled. The client is placed in an upright or Fowler's position for the insertion. Immediately after insertion, radiography is conducted to verify the placement. The patient's head should be kept elevated once the tube is in place. The balloon ports are double clamped to prevent air leaks, and scissors should be kept at the bedside to quickly deflate the balloons in case of respiratory distress. To avoid esophageal ulceration or necrosis, esophageal pressure should be released at intervals as prescribed and in accordance with agency policy. Monitoring for increased bloody drainage is crucial as it may indicate ongoing bleeding and rupture of the varices. Additionally, signs of esophageal rupture, such as a drop in blood pressure, increased heart rate, and back and upper abdominal pain, are medical emergencies and must be reported immediately. Now we will read about lavage tubes. Lavage tubes are medical devices designed to remove toxic substances from the stomach. They come in different types, each with specific features and functions. One type of lavage tube is the lavacurator. This orogastric tube has a large suction lumen and a smaller lavage vent lumen. The design of the lavacurator allows for continuous suction. The irrigation solution enters through the lavage lumen, while the stomach contents are simultaneously removed through the suction lumen. This dual lumen system facilitates efficient and effective stomach cleansing. Another type of lavage tube is the Ewald tube. This is a single lumen large tube primarily used for rapid, one-time irrigation and evacuation. The Ewald tube's design and size make it suitable for situations where quick and thorough stomach evacuation is necessary, such as in cases of acute poisoning or overdose, where immediate removal of toxic substances from the stomach is crucial. Both types of tubes are vital tools in medical emergencies involving the ingestion of toxic substances. allowing healthcare professionals to rapidly and effectively cleanse the stomach to reduce the absorption and systematic effects of the ingested toxins.
Before we move ahead, let me take a quick moment to tell you something that could completely change your NCLEX journey. If you're serious about passing the NCLEX in just 1 week or even within a month, then the smartest move you can make right now is to enroll in our complete online NCLEX crash course. This isn't just another course, it's a shortcut, a clear step-by-step roadmap that has already helped over 100,000 nursing students pass the NCLEX with confidence. And here's the most incredible part. Not a single student who completed this course has failed. Yes, that's a 100% passing rate. We built this course based entirely on the feedback and insights of thousands of nurses who've successfully cleared the NCLEX in the last 5 years. That means we've removed all the fluff and focused only on what truly matters for your exam. Here's exactly what you'll get when you enroll. You'll get 100 hours of animated crash course content designed for rapid revision, 500 hours of comprehensive recorded lectures covering all the high-yield topics, and access to 10,000 real NCLEX questions to sharpen your test-taking skills. You'll also get 500 next-gen case-based questions to strengthen your clinical judgment, along with 15 full-length practice tests that simulate the real NCLEX experience. And of course, you'll receive our complete NCLEX ebook and PDF notes, plus 1 full year of access, so you can study at your pace, on your schedule. And yes, we're currently offering a 70% discount for a very short period. Once the offer ends, it's gone. Thousands of students are enrolling in our online NCLEX course every month and passing the exam, but if you don't enroll now, you risk being left behind. Spots are filling fast and only a few seats are left. Visit our website to enroll now. Link is given in description box. Let's continue the video.
Next topic is urinary and renal tubes. The topic of urinary and renal tubes primarily focuses on the types of urinary catheters and the routine care associated with them. Types of urinary catheters. Single lumen catheters. These are typically used for straight catheterization, which involves emptying the bladder, obtaining sterile urine specimens, and measuring the residual urine after voiding. Double lumen catheters. These are employed when continuous bladder drainage is necessary. One of the lumens is used for drainage, while the other is for inflating a balloon that helps keep the catheter in place. Triple lumen catheters. These are used for both bladder irrigation and drainage. Among the 3 lumens, one is for instilling the bladder irrigant solution, another for continuous bladder drainage, and the third for balloon inflation. It is crucial to employ strict aseptic techniques during the insertion and care of these catheters to prevent infections. Routine urinary catheter care. Personal protective measures, like wearing gloves, should be taken, and the perineal area needs to be cleaned with warm, soapy water. For proper cleaning, the labia or foreskin should be retracted to expose the meatus. In adult males, the foreskin should be returned to its normal position afterward. The catheter itself should be cleaned along its length with soap and water. To prevent tugging or injury, the catheter should be anchored to the thigh. The catheter bag, which collects urine, must always be kept below the level of the bladder to ensure proper drainage and to prevent backflow, which could lead to infection. Now, we will discuss urinary catheters insertion procedures. To explain the urinary catheterization procedure and its potential discomfort to the client, follow these steps. Prepare the client for the procedure, explaining each step to ensure they understand and are comfortable. Discuss any discomfort they might experience, such as a sensation of pressure or slight discomfort during the insertion of the catheter. Position the client appropriately. For females, assist them into a dorsal recumbent position, lying on their back with knees flexed. Use pillows to support their legs, reducing muscle tension and enhancing comfort. For males, assist them into a supine position, with their thighs slightly abducted. Prior to the procedure, wear clean gloves and wash the perineal area with soap and water as needed, ensuring it's dry afterwards. Dispose of the gloves and perform hand hygiene. Open the catheter kit carefully, keeping in mind that all components inside are sterile. Arrange the supplies in order of use. Place a waterproof sterile drape under the client's buttocks, with the plastic side facing down. Adhere to sterile techniques throughout the procedure. Put on sterile gloves without contaminating them. Use a fenestrated drape to expose the necessary area, either the labia or penis, without touching any non-sterile surface. Lubricate the catheter appropriately. For females, 2.5 to 5 centimeters, 1 to 2 inches, and for males, 12.5 to 17.5 centimeters, 5 to 7 inches. Attach a pre-filled syringe to the balloon port and prepare cotton balls or swab sticks for cleansing the area. Maintain sterility by keeping the sterile field and gloved hands above waist level. Be mindful that the 1-inch border on the sterile field is considered contaminated. For catheter insertion in females, position the client in a dorsal recumbent position with legs open for full visualization. With a non-dormant hand, expose the urethral meatus by spreading the labia and using sterilized cotton balls or swab sticks to clean the area. Advance the catheter gently until urine flows, then a bit further. For catheter insertion in males, positioning the penis perpendicular to the body, clean it with antiseptic-soaked cotton balls or swab sticks. Insert the catheter while lifting the penis and apply light traction. Advance the catheter until urine flows, then a bit further. Inflate the catheter balloon as per the manufacturer's instructions and gently pull back until resistance is felt. Secure the catheter tubing to the inner thigh using an approved securing device. Document all relevant details of the procedure, including the type and size of catheter, the amount of fluid used for the balloon, urine characteristics, any specimen collected, the client's response, and confirm that educational instructions were provided. Now let's move to urinary catheters removal procedure. To remove a urinary catheter, begin the process by explaining to the patient what the procedure entails, including any potential discomfort they may experience. Position the patient in the same manner as they were during the catheterization. For female patients, place a towel between their thighs, and for male patients, position it over their thighs. This step is followed by the removal of the securing device. Next, use a 10 milliliter syringe to access the balloon injection port. Carefully and slowly withdraw all the solution from the balloon to ensure it is completely deflated. Inform the patient that they might feel a burning sensation during the catheter's withdrawal. It's crucial to pull the catheter out in a smooth and slow manner to minimize discomfort. After the catheter has been removed, closely monitor the patient's urinary function. This includes observing and documenting the first instance of voiding post-removal. Continue to record the time and amount of urine voided over the next 24 hours. This documentation is important to ensure that the patient's urinary function has returned to normal following the removal of the catheter. The next topic is endotracheal tubes. Endotracheal tubes are essential medical devices designed to maintain a patient's airway. Their primary use is in scenarios where a patient requires mechanical ventilation. In cases where a patient needs an artificial airway for an extended period, typically beyond 10 to 14 days, a tracheostomy is often performed.
Stancoast NCLEX
This procedure is preferred to avoid potential mucosal and vocal cord damage that prolonged use of an endotracheal tube can cause. A crucial component of the endotracheal tube is the cuff, located at its distal end. When inflated, this cuff creates a seal between the trachea and itself. This seal is vital for multiple reasons. It prevents the aspiration of fluids into the lungs and ensures that a set tidal volume is delivered during mechanical ventilation. Additionally, an inflated cuff blocks air from reaching the vocal cords, nose, or mouth. Another important feature of the endotracheal tube is the pilot balloon. This component allows for the insertion of air into the cuff and helps to prevent air from escaping. It also serves as an indicator for the presence or absence of air in the cuff, which is crucial for the proper functioning of the tube. Lastly, the endotracheal tube includes a universal adapter. This adapter is a key element as it enables the connection of the tube to mechanical ventilation tubing or other types of oxygen delivery systems. This versatility is essential in a clinical setting where the needs for oxygen delivery can vary greatly depending on the patient's condition. Interventions for ensuring proper placement and management of an endotracheal tube include several key steps. First, the placement of the tube is confirmed by a chest X-ray, ensuring it is positioned 1 to 2 centimeters above the carina. Next, placement is assessed by osculating both sides of the chest while manually ventilating with a resuscitation bag. This step is crucial to confirm that breath sounds and chest wall movement are not absent on the left side, which could indicate that the tube is in the right main stem bronchus. Additionally, auscultation over the stomach is performed to rule out esophageal intubation. If the tube is mistakenly placed in the stomach, breath sounds will be louder over the stomach than the chest. and abdominal distension will be present. After confirming correct placement, the tube should be secured immediately with adhesive tape. Monitoring the position of the tube at the lip or nose is also essential, along with regular checks on the patient's skin and mucous membranes. Suctioning of the tube is advised only when necessary. Furthermore, it's important to move the oral tube to the opposite side of the mouth daily. This practice prevents pressure and necrosis of the lips and mouth area, avoids nerve damage, and facilitates inspection and cleaning of the mouth. Moving the tube should be a task performed by 2 healthcare professionals to ensure safety and accuracy. To ensure the stability of an endotracheal or tracheostomy tube, it's crucial to prevent its dislodgement. Activities such as suction, coughing, and speaking attempts can place additional stress on the tube, increasing the risk of it becoming dislodged. Regularly assess the pilot balloon to confirm that the cuff is properly inflated. Maintaining cuff inflation is vital as it creates a seal, allowing for complete mechanical control of respiration. Monitoring cuff pressures is also an essential aspect of care. This should be done at least every 8 hours, or as specified by the healthcare facility's procedures, to ensure pressures do not exceed 20 mmHg. An aneroid pressure manometer is typically used for measuring cuff pressures. Employing minimal leak and occlusive techniques when inflating the cuff helps in accurately checking these pressures. Moreover, always keep a resuscitation ambu bag readily available at the bedside of a patient with an endotracheal or tracheostomy tube. This is a critical safety measure to provide immediate respiratory support if needed. Now let's discuss the extubation procedure of endotracheal tubes. The process of extubation, which involves the removal of an endotracheal tube, is a critical procedure in patient care. It begins by hyperoxygenating the patient and suctioning both the endotracheal tube and the oral cavity. This step is vital for ensuring that the patient's lungs are well oxygenated and free of secretions before the tube is removed. Next, the patient is positioned in a semi-Fowler's position. This semi-upright position helps in easing breathing and is preferred posture for respiratory comfort. Following this, the cuff of the endotracheal tube is deflated. As the cuff deflates, the patient is asked to inhale deeply. At the peak of their inhalation, the tube is removed. During this removal, suctioning of the airway through the tube is performed simultaneously, which helps in clearing out any residual secretions. After the tube is out, the patient is instructed to cough and take deep breaths. This practice is essential for helping to clear any accumulated secretions in the throat that may have built up during the time the tube was in place. Oxygen therapy is then applied as prescribed. This step ensures that the patient continues to receive adequate oxygen post-extubation, especially since the respiratory system may still be adjusting to the removal of the tube. Close monitoring for any respiratory difficulty is crucial after extubation. If any signs of respiratory distress are observed, it's imperative to contact the healthcare provider immediately. Lastly, patients are informed that experiencing hoarseness or a sore throat is normal after extubation. They are advised to limit speaking if they experience these symptoms, allowing their throat some time to recover from the irritation caused by the tube. The next topic is tracheostomy tubes. Tracheostomy is a medical procedure that involves surgically creating an opening directly into the trachea to establish an airway. This typically involves inserting a tracheostomy tube into the opening, which can be connected to a mechanical ventilator or other types of oxygen delivery devices. The procedure can be either temporary or permanent, with various types of tracheostomy tubes available. Ensuring the procedure's success and the patient's safety involves several crucial interventions. Regular assessments of the patient's breathing and checking for bilateral breath sounds are essential. Monitoring arterial blood gases and pulse oximetry is important to evaluate the patient's oxygen levels and respiratory status. Encouraging the patient to cough and breathe deeply is vital in maintaining clear airways. Keeping the patient in a semi-Fowler's or high Fowler's position can significantly improve breathing. Monitoring for signs of bleeding, difficulty breathing, absence of breath sounds, or crepitus is crucial, as these may indicate complications like hemorrhage or pneumothorax. Administering prescribed respiratory treatments and suctioning fluids as necessary, including pre-suctioning hyperoxygenation, are part of routine care. If the patient is eating, it is important to sit them up during meals and take precautions to prevent aspiration. Monitoring and maintaining cuff pressures as prescribed ensures the tracheostomy tube functions correctly. Regular assessment of the stoma and secretions for signs of blood or infection is necessary. Cleaning the tracheostomy site and inner cannula according to healthcare provider instructions and agency policy, often using half-strength hydrogen peroxide, is important. Providing humidified oxygen is necessary because the normal humidification process is bypassed in patients with a tracheostomy. Carefully changing tracheostomy ties with assistance ensures the safety and comfort of the patient. Keeping emergency equipment like a resuscitation bag, obtuator, clamps, and a spare tracheostomy tube of the same size at the bedside is crucial for immediate response to any complications. It's important to note that a plug should never be inserted into a tracheostomy tube until the cuff is deflated and the inner cannula is removed. Inserting a plug without taking these precautions can prevent airflow and pose serious risks to the patient. Types of tracheostomy tubes. Tracheostomy tubes come in various types, each designed for specific clinical needs, whether it's maintaining an open airway, facilitating mechanical ventilation, or aiding in the gradual transition to natural breathing. Here's an overview of some common types. Double lumen tube. This tube features two main parts: the outer cannula that fits into the stoma, maintaining the airway's openness. Attached to it is a faceplate, which indicates the tube's size and type, and has small holes on either side for securing the tubes with ties. The inner cannula, which snugly fits into the outer cannula and locks into place. This part is crucial for connecting to respiratory therapy equipment, like ventilators. Some inner cannulas are reusable after cleaning, while others are disposable. An obturator is also part of this setup, aiding in the tube's insertion by guiding its direction. It is removed after the tube is placed, but kept nearby for emergencies. The cuff, another key component, inflates to seal the airway, useful in mechanical ventilation or to prevent aspiration during tube feeding. Single lumen tube. This tube is similar to the double lumen variant but lacks an inner cannula. It requires more intensive nursing care due to the absence of an inner cannula to maintain a clear lumen. Fenestrated tube. This tube is designed with a pre-cut opening or fenestration in the outer cannula's upper posterior wall. It's used to gradually wean patients from tracheostomy, allowing them to breathe through their natural airway and enabling speech. Cuffed fenestrated tube. This tube is ideal for patients who need both mechanical ventilation and the ability to speak, such as those with spinal cord paralysis or neuromuscular diseases. This tube allows for ventilation when needed, and when the ventilator is not in use, the cuff can be deflated and the tube capped to enable speech. However, it's not recommended for weaning from a tracheostomy, as the deflated cuff might still partially obstruct the airway. Complications of a tracheostomy. Complications related to tracheal tubes can include various conditions, such as tube obstruction and dislodgement. Tracheomalacia, a condition where constant pressure from the cuff of the tube leads to tracheal dilation and erosion of the cartilage, is one such complication. Another issue is tracheal stenosis, which occurs when the tracheal lumen narrows due to scar formation. This scarring results from irritation of the tracheal mucosa caused by the cuff of the tube. Tracheoesophageal fistula, TEF, is another serious complication. It arises when excessive cuff pressure erodes the posterior wall of the trachea, leading to the formation of a hole between the trachea and the anterior esophagus. Patients with a nasogastric tube present are at the highest risk for this condition. Additionally, there's the risk of a trachea innominate artery fistula. This condition occurs when a malpositioned tube pushes its distal tip against the lateral wall of the trachea. Continued pressure can lead to necrosis and erosion of the innominate artery, making this a medical emergency.
Before we move ahead, let me take a quick moment to tell you something that could completely change your NCLEX journey. If you're serious about passing the NCLEX in just 1 week or even within a month, then the smartest move you can make right now is to enroll in our complete online NCLEX crash course. This isn't just another course, it's a shortcut, a clear step-by-step roadmap that has already helped over 100,000 nursing students pass the NCLEX with competence. And here's the most incredible part. Not a single student who completed this course has failed failed. Yes, that's a 100% passing rate. We built this course based entirely on the feedback and insights of thousands of nurses who've successfully cleared the NCLEX in the last 5 years. That means we've removed all the fluff and focused only on what truly matters for your exam. Here's exactly what you'll get when you enroll. You'll get 100 hours of animated crash course content designed for rapid revision, 500 hours of comprehensive recorded lectures covering all the high-yield topics, and access to 10,000 real NCLEX questions to sharpen your test-taking skills. You'll also get 500 next-gen case-based questions to strengthen your clinical judgment, along with 15 full-length practice tests that simulate the real NCLEX experience. And of course, you'll receive our complete NCLEX ebook and PDF notes, plus 1 full year of access, so you can study at your pace on your schedule. And yes, we're currently offering a 70% discount for a very short period. Once the offer ends, it's gone. Thousands of students are enrolling in our online NCLEX course every month and passing the exam, but if you don't enroll now, you risk being left behind. Spots are filling fast and only a few seats are left. Visit our website to enroll now. Link is given in description box. Let's continue the video.
Welcome to the next episode of our NCLEX review series. In this episode, we're going to dive deep into the essential topics of obstetrics and gynecology, which the NCLEX board frequently tests you on. Don't forget to hit that subscribe button, as we have over 100 more videos planned to assist you in acing your NCLEX exam. The gestation period. The gestation period, often referred to as pregnancy, marks the remarkable journey from the fertilization of the ovum to the eagerly anticipated due date. This period typically encompasses around 280 days, but it is essential to recognize that it can vary significantly among individuals. One method employed to estimate the due date is Nagel's rule. To apply this rule, a woman should have a regular 28-day menstrual cycle. Nagel's rule involves subtracting 3 months and adding 7 days to the first day of the last menstrual period, with an additional year added if necessary. Alternatively, one can add 7 days to the last menstrual period and count forward 9 months. Gravidity and parity. Gravidity and parity are terms that provide insight into a woman's reproductive history. Gravidity pertains to the number of pregnancies a woman has experienced, including her current one. A pregnant woman is referred to as a gravida. A nulli gravida is a woman who has never been pregnant, while a primigravida is embarking on her first pregnancy journey, and a multigravida has been pregnant at least once before. Parity, on the other hand, quantifies the number of live births a woman has had after reaching a gestational age of at least 20 weeks. Regardless of whether the infant was born alive or not. A nullipara has not given birth beyond 20 weeks of gestation. A primipara has experienced 1 such birth, and a multipara has experienced 2 or more pregnancies that reach the stage of fetal viability. To encapsulate this information, healthcare professionals often use the GTPAL acronym. G represents gravidity, the total number of pregnancies. T stands for term births, babies born after 36 weeks of gestation. P refers to preterm births, babies born before 37 weeks of gestation. A indicates abortions or miscarriages, counted in gravida if before 20 weeks of gestation, and in parity if past 20 weeks of gestation. L signifies the number of currently living children. Recognizing pregnancy signs. Pregnancy is a transformative phase marked by a myriad of signs and symptoms characterized as presumptive, probable, and positive signs. Presumptive signs are subjective indicators experienced by the mother, including amenorrhea, nausea, vomiting, breast changes, urinary frequency, quickening, the first perception of fetal movement, fatigue, and alterations in vaginal mucosa color. Probable signs are objective findings that can be observed by a healthcare provider, such as uterine enlargement, Hager's sign, softening of the lower uterine segment, Goodall's sign, softening of the cervix, Chadwick's sign, violet colorization of mucous membranes, allotment, fetal rebound on palpitation, Braxton Hicks contractions, and a positive pregnancy test that detects human chorionic gonadotropin. Positive signs are diagnostic and confirm the presence of pregnancy. These signs include detecting the fetal heartbeat using electronic devices, like a Doppler transducer, at 10 to 12 weeks, or a non-electronic fetoscope at 20 weeks, feeling active fetal movements, and visualizing the fetus through radiography or ultrasonography. Fundal height. Measuring fundal height is a valuable technique for evaluating the gestational age of the fetus during pregnancy. In the second and third trimesters, weeks 18 to 30, the fundal height in centimeters approximately corresponds to the fetal age in weeks minus 2 centimeters. For instance, at 20 weeks of pregnancy, the fundus should be positioned near the level of the umbilicus. At 16 weeks, the fundus is typically located midway between the symphysis pubis and the umbilicus, while at 36 weeks, it should reach the xiphoid process. It is crucial to exercise caution during fundal height assessments, particularly when the client is in the supine position, as it can lead to supine hypotension. The physiological transformation of the maternal body. Pregnancy instigates a profound array of physiological changes within a woman's body, subject to variation among individuals and influenced by cultural factors. Here are key physiological alterations that transpire. In the cardiovascular system, pregnancy induces several adjustments. Circulating blood volume increases, encompassing elevation in both plasma and total red blood cell volume. This shift can result in physiological anemia as plasma increase surpasses red blood cell production. Consequently, iron requirements escalate during pregnancy. Furthermore, the heart enlarges and shifts slightly upward and to the left due to the expanding uterus. Additionally, sodium and water retention may occur as part of these cardiovascular adaptations. Turning to the respiratory system, pregnancy brings about notable changes. Oxygen consumption rises by approximately 15 to 20%. The enlarging uterus exerts pressure on the diaphragm, pushing it upward, potentially causing shortness of breath in some women. Pulse rate may also increase by 10 to 15 beats per minute, while blood pressure undergoes a slight decrease in the second trimester before rising in the third trimester. Respiratory rate, however, mostly remains stable or slightly increases. In the gastrointestinal system, pregnant women experience distinct alterations. Nausea and vomiting are common in early pregnancy due to the secretion of human chorionic gonadotropin, although these symptoms typically subside by the third month. Decreased gastric motility may lead to reduced appetite. Pregnant individuals often report shifts in taste and smell perception. Furthermore, constipation can be a common issue, possibly due to increased progesterone production or pressure from the expanding uterus, causing decreased gastrointestinal motility. Physiologically, the gastrointestinal system undergoes alterations, sometimes leading to uncomfortable symptoms like flatulence, heartburn, and excessive saliva secretion, patilism. These changes are primarily driven by fluctuations in gastrointestinal motility, stomach emptying, and rising estrogen levels. Additionally, increased venous pressure may result in the development of hemorrhoids, and gum tissue may swell and bleed. The renal system is not immune to these shifts. Frequent urination becomes noticeable in both the first and third trimesters, often accompanied by reduced bladder tone due to heightened progesterone and estrogen levels. Furthermore, the renal threshold for glucose may decrease during pregnancy. Hormonal changes play a pivotal role throughout pregnancy. The basal metabolic rate increases, and various endocrine glands adapt to support the developing fetus. Notably, the anterior lobe of the pituitary gland enlarges to produce prolactin for lactation, while the posterior lobe generates oxytocin for uterine contractions. The thyroid experiences slight enlargement and heightened activity, and parathyroid glands also grow. These hormonal shifts contribute to weight gain and water retention. In the reproductive system, significant transformations occur to accommodate the growing fetus. The uterus undergoes hyperplasia and hypertrophy, while the cervix becomes shorter, more elastic, and larger in diameter. Ovaries adjust by inhibiting ovum production and secreting progesterone. Vaginal changes include hypertrophy, muscle thickening, and increased secretions. Breasts enlarge, become tender, and exhibit darker areolae with superficial veins becoming more prominent. Montgomery's follicles may hypertrophy, occasionally leading to colostrum leakage. Pregnancy also has visible effects on the skin. Elevated melanocyte-stimulating hormone results in increased pigmentation, including the appearance of the linea nigra on the abdomen. Chloasma, often referred to as the mask of pregnancy, may develop on the face. Reddish-purple stretch marks, known as stria gravidarum, may emerge on various body parts. Vascular spider nevi might appear, and hair growth may accelerate. Musculoskeletal changes are evident as well. Hormones like relaxin and progesterone affect posture and the lumbosacral curve, potentially leading to aches, numbness, and weakness. Pelvic joints become more mobile, and the abdominal wall stretches, causing a loss of tone. Beyond the physical, pregnancy triggers psychological shifts. Early on, ambivalence is common, characterized by conflicting feelings of dependence and independence, as well as uncertainty about role changes. Partners may also experience ambivalence regarding their new roles and financial responsibilities. Acceptance of pregnancy varies, influenced by readiness, identification with motherhood, the partner relationship, the bond with the unborn infant, and birth preparation. Emotional lability, marked by frequent emotional fluctuations, is a common, but not necessarily abnormal occurrence during pregnancy. Body image changes, driven by physical transformations and accompanying symptoms, can influence a woman's self-perception. The relationship with the growing fetus evolves from acknowledging pregnancy to nurturing the developing baby, encompassing preparations for birth and parenthood. Pregnancy often brings discomforts like nausea and vomiting in the first trimester, driven by hormonal changes and alterations in carbohydrate metabolism. Managing these discomforts may involve strategies such as consuming dry crackers and avoiding immediate toothbrushing upon waking. Managing nausea and vomiting. First on our list is the challenge of dealing with nausea and vomiting, particularly prevalent during the initial trimester of pregnancy. These symptoms are primarily driven by hormonal fluctuations and an increase in blood volume. To find relief, expecting mothers are encouraged to adopt some practical tactics. Opting for small, frequent, low-fat meals throughout the day. Sipping fluids between meals rather than during, avoiding fried and spicy foods. Considering acupuncture. Consultation with a healthcare provider might be necessary for certain methods. Discussing herbal remedies with their healthcare provider, HCP. And, when appropriate, taking prescribed antiemetic medications. Addressing syncope. Moving on to syncope, a condition that can surface in the first trimester, but may become more frequent in the second and third trimesters. Hormonal shifts, increased blood volume, anemia, fatigue, sudden position changes, or lying flat on your back can trigger syncope. To prevent fainting episodes, pregnant individuals should take specific precautions. This includes sitting with their feet elevated, being cautious about falls, making slow position changes, and avoiding the supine, lying flat on your back, position, especially in later trimesters to prevent supine hypotension due to pressure on the inferior vena cava. Dealing with urinary urgency and frequency. Urinary urgency and frequency are common discomforts, typically experienced in the first and third trimesters due to the pressure exerted on the bladder by the growing uterus. Managing these symptoms involves practical interventions. Expectant mothers are advised to stay hydrated by drinking at least 2,000 milliliters of fluids during the day, reduce fluid intake in the evening, empty the bladder regularly, sleep on their side at night, use perineal pads as needed, and perform Kegel exercises to strengthen pelvic floor muscles. Alleviating breast tenderness. Now, let's address breast tenderness, which can arise in any trimester due to elevated estrogen and progesterone levels. To alleviate this discomfort, pregnant individuals are encouraged to wear a supportive bra and avoid using soap on the nipples and areola area to prevent skin dryness. Managing increased vaginal discharge. Increased vaginal discharge is a common occurrence throughout pregnancy, driven by changes in vaginal mucosa and increased mucus production. Managing this discomfort involves practicing proper cleansing and hygiene techniques, wearing breathable cotton underwear, avoiding douching, and properly consulting with the healthcare provider, HCP, if an infection is suspected. Coping with nasal stuffiness. Nasal stuffiness, which can occur in any trimester due to increased estrogen levels, can lead to nasal tissue swelling and dryness. To alleviate this, individuals are advised to use a humidifier and consult their HCP before using nasal sprays or antihistamines. Tackling fatigue. Now, let's address fatigue, a common issue in the first and third trimesters, often related to hormonal changes. To combat fatigue, it is recommended to schedule regular rest periods throughout the day, maintain correct posture and body mechanics, engage in moderate exercise, perform relaxation and muscle strengthening exercises, and avoid stimulants found in foods and drinks throughout pregnancy. Relieving heartburn. Heartburn is a discomfort that typically occurs in the second and third trimesters due to increased progesterone levels, decreased gastrointestinal motility, esophageal reflux, and uterine enlargement. To alleviate heartburn, individuals should opt for small, frequent meals, sit upright for 30 minutes after eating, drink milk between meals, avoid fatty and spicy foods, and consult with their HCP about suitable antacids. Managing ankle edema. Ankle edema, or swelling of the ankles, is common in the second and third trimesters due to factors like vasodilation, venous stasis, and increased venous pressure below the uterus. To manage this, it is advisable to elevate the legs at least twice daily, sleep on your side, wear supportive stockings or support hose, and avoid extended periods of sitting or standing. Addressing varicose veins. Varicose veins, which typically appear in the second and third trimester, are often caused by weakened vein walls, or valves and venous congestion. Effective interventions include wearing supportive stockings or support hose, elevating the feet when sitting, lying with the feet and hips elevated, avoiding prolonged periods of standing or sitting, moving around to improve circulation while standing, refraining from leg crossing, avoiding constricting clothing like knee-high stockings, learning leg exercises, and minimizing prolonged airline travel. Managing headaches. Headaches are generally considered benign in the first trimester, but may require further investigation if they occur in the second and third trimesters. They can result from changes in blood volume and vascular tone. To manage headaches, individuals should change positions slowly, apply a cool cloth to the forehead, have a small snack, and use acetaminophen only if prescribed by the HCP. Alleviating hemorrhoids. Hemorrhoids are common in the second and third trimesters due to increased venous pressure and constipation. To alleviate discomfort, it is recommended to soak in a warm sitz bath, sit on a soft pillow, consume high-fiber foods, increase exercise such as walking, and use ointments, suppositories, or compresses as prescribed by the HCP. Addressing constipation. Constipation often occurs in the second and third trimesters due to hormonal changes, decreased intestinal motility, and pressure from the growing uterus. To address this issue, individuals should consume high-fiber foods like whole grains, fruits, and vegetables, drink at least 2,000 milliliters of fluids daily, engage in regular exercise such as a 20-minute walk, and consult with your HCP for stool softeners, laxatives, or enemas if needed. Managing backache. Backache is common in the second and third trimesters due to an enlarged uterus, causing an exaggerated lumbosacral curve. To alleviate back pain and reduce the risk of falls, it is recommended to take regular rest breaks, maintain correct posture, and body mechanics. In our comprehensive exploration of maternal risk factors, let's delve into the multifaceted aspects that can exert an influence on perinatal outcomes. One pivotal determinant is maternal age, and it wields a substantial impact on these outcomes. Elevated risks are associated with both youthful mothers under the age of 20 and more mature mothers over 35 years of age. When considering adolescent pregnancy, a myriad of factors converge to contribute to its occurrence. These encompass early menarche, shifts in sexual behaviors, familial discord, economic hardships, and limited reproductive and contraceptive knowledge. Regrettably, adolescent pregnancies bring forth a spectrum of formidable challenges, including insufficient nutritional intake, emotional and behavioral complexities, paucity of support systems, escalated risks of stillbirth, low birth weight infants, fetal mortality, cephalopelvic disproportion, and augmented maternal complications such as hypertension, anemia, prolonged labor, and infections. As healthcare providers, our pivotal role in mitigating the risks and consequences of adolescent pregnancy cannot be overstated. We must ardently advocate for prompt and continuous prenatal care, while judiciously referring adolescents to the requisite support systems when circumstances necessitate it, particularly in ameliorating the adverse effects of unfavorable socioeconomic conditions. Nutrition emerges as a foundational pillar of a healthy pregnancy. Adequate nutritional sustenance is indispensable for the unimpeded growth and development of the fetus, with distinct dietary requirements evolving throughout various stages of pregnancy. It is incumbent upon us to recommend folic acid supplements to women of childbearing age to preempt neural tube defects and orofacial clefts in the developing fetus. Genetic considerations loom large in this context. Genetic assessments facilitate the identification of inheritable risk factors for congenital anomalies. Timely prenatal care, which encompasses dental health, assumes paramount importance in curtailing the risk of preterm birth and low birth weight. Regrettably, some adolescents may find themselves ensnared in situations of abuse and violence, which can invariably escalate the risk of complications such as abruptio placentae, preterm birth, and infections stemming from unwanted or coerced sexual encounters. Thus, it is incumbent upon us to approach these issues with the utmost sensitivity, and offer appropriate support and interventions. Medical conditions such as diabetes mellitus, hypertensive disorders, or cardiac ailments can amplify the risks associated with pregnancy, underscoring the imperative for vigilant monitoring and adept management. Turning our attention to other risk factors, maternal infection with German measles, rubella, within the first 8 weeks of gestation pose the highest risk of fetal infection. Sexually transmitted infections carry significant implications during pregnancy as well. Syphilis, for example, can traverse the placental barrier, culminating in spontaneous abortions and an escalated risk of mental impairment and physical deformities. Condyloma acuminatum, human papillomavirus, can be transmitted during vaginal childbirth, fostering the development of epithelial tumors in the mucous membranes of the larynx in infants. Gonorrhea has the potential to infect the neonate at birth, giving rise to complications such as ophthalmia neonatorum, pneumonia, and sepsis. Chlamydial infection, when transmitted during vaginal delivery, can precipitate neonatal conjunctivitis, pneumonitis, premature rupture of membranes, premature labor, and postpartum endometritis. Trichomonas has been associated with premature rupture of membranes and postpartum endometritis. Genital herpes simplex virus, characterized by painful lesions, can entail grave consequences, accentuating the need for judicial assessment and management during pregnancy. Transmission of the human immunodeficiency virus, HIV, can transpire through various routes, including exposure during childbirth and breastfeeding. Preventive measures may encompass the perinatal administration of zidovudine. Substance abuse during pregnancy poses a substantial risk to fetal growth and development, potentially leading to fetal growth restriction, abruptio placentae, and fetal brachycardia. It is imperative to eschew teratogenic substances and over-the-counter medications without the approval of a healthcare provider. Finally, viral hepatitis. With further details available in Chapter 26 and Chapter 52 for hepatitis B, is an additional cause for concern. Now let us pivot our focus to antepartum diagnostic testing. Throughout pregnancy, healthcare visits typically adhere to a schedule of every 4 weeks, up to 28 to 32 weeks, every 2 weeks from 32 to 36 weeks, and weekly from 36 to 40 weeks. Crucially, blood type and Rh factor testing are indispensable in discerning blood compatibility and ascertaining the necessity for Rho-D immune globulin RhoGAM in Rh-negative clients. Rubella titer testing assumes pivotal importance. Clients exhibiting negative rubella titers should receive the requisite immunization postpartum, with a concerted emphasis on birth control and avoiding contact with immunocompromised individuals. The monitoring of hemoglobin and hematocrit levels stands as an imperative during pregnancy, as any decline may signal the onset of anemia. Furthermore, a Papa-Nicolau smear is conducted during the initial prenatal examination to screen for cervical neoplasia. Collectively, these factors and tests occupy an indispensable role in safeguarding the health and well-being of both the expectant mother and the burgeoning fetus during the intricate journey of pregnancy. Now we will explore a range of prenatal screening tests and procedures aimed at safeguarding the health and well-being of both the expectant mother and the developing fetus. Screening for sexually transmitted infections, STIs. This assessment is indispensable for gauging the client's risk and determining the need for further evaluation and treatment based on the outcomes. Sickle cell disease screening. Moving on to sickle cell disease screening, this is typically recommended for clients at risk. A positive test result might trigger the requirement for additional screening and follow-up, ensuring timely intervention and appropriate care. Tuberculin skin test. Following childbirth, healthcare providers may opt for the tuberculin skin test. A positive result on this skin test suggests the necessity of a chest radiograph. However, it's important to note that pregnant clients should only undergo radiography after reaching 20 weeks of gestation, when fetal organs are fully developed. Those who convert to a positive result may be referred for postpartum medication-based treatment. Hepatitis B surface antigen testing. Hepatitis B antigen testing is advisable for all pregnant women due to the prevalence of the disease in the general population. In specific cases such as healthcare workers, intravenous drug users, and individuals with particular risk factors, hepatitis B vaccination may be recommended. It's noteworthy that hepatitis B vaccination is not contraindicted during pregnancy and may be suggested by the healthcare provider for at-risk individuals. Urinalysis and urine culture. Next, we come to urinalysis and urine culture, which constitute an essential component of antepartum visits. During each visit, a urine specimen is collected for glucose and protein assessments. Glycosuria, which is often observed during pregnancy, may arise due to a lowered renal threshold. However, persistent glycosuria may be indicative of diabetes. Additionally, the presence of white blood cells in urine points to infection, while ketonuria can result from inadequate food intake or vomiting. Importantly, protein levels of 2+ to 4+ in urine may suggest infection or preeclampsia, necessitating further evaluation and management. Ultrasonography. Ultrasonography assumes a critical role in visualizing and identifying fetal and maternal structures. It assists in confirming gestational age, estimating the due date, and evaluating amniotic fluid volume through specialized measurements. Ultrasonography can be conducted abdominally or transvaginally during pregnancy. For abdominal ultrasounds, clients may be advised to consume water to fill the bladder, enhancing visualization. Transvaginal ultrasound entails the insertion of a lubricated probe into the vagina. Importantly, this procedure is not associated with any known risks to either the client or the fetus. Biophysical profile. The biophysical profile is a non-invasive evaluation of fetal well-being, encompassing assessments of fetal breathing movements, tone, amniotic fluid index, and fetal heart rate patterns through a non-stress test. Normal fetal biophysical activities indicate proper central nervous system function and adequate oxygenation, providing valuable insights into fetal well-being. Doppler blood flow analysis. Doppler blood flow analysis is a non-invasive ultrasound technique used to study blood flow in the fetus and placenta, facilitating the assessment of fetal circulation and health. Percutaneous umbilical blood sampling. PUBS. PUBS is carried out when fetal blood sampling becomes necessary. This procedure involves the insertion of a needle into the fetal umbilical vessel under ultrasound guidance. Fetal heart rate monitoring is required for 1 hour post-procedure, with a subsequent ultrasound to check for bleeding or hematoma formation. Rh-negative women may receive Rho-D immune globulin due to the increased risk of Rh sensitization. Alpha fetoprotein screening. Alpha fetoprotein screening involves the assessment of fetal serum protein levels. Abnormal levels can indicate open neural tube and abdominal wall defects, as well as help screen for spina bifida and Down syndrome. In the event of abnormal levels, repeat testing is advised, as false positives can occur. This screening entails a maternal blood sample taken between 16 and 18 weeks of gestation, followed by further evaluation and ultrasound examination for elevated levels. Deoxyribonucleic acid, DNA, genetic testing. DNA genetic testing is employed to identify abnormalities related to inherited conditions and to determine the risk of having a fetus with specific genetic disorders. This testing can be conducted as early as 7 weeks of gestation using a blood sample, offering valuable information to inform decision-making. Chorionic villus sampling, CVS. CVS is performed to detect genetic abnormalities by aspirating a small sample of chorionic villus tissue between 10 and 13 weeks of gestation. This procedure necessitates informed consent and may involve bladder filling for visualization, if performed before 20 weeks. It also entails monitoring vital signs and fetal heart rate. Rh-negative women may receive Rho-D immune globulin due to the increased risk of Rh sensitization. Amniocentesis. Amniocentesis entails the aspiration of amniotic fluid and is ideally conducted between 15 and 20 weeks of pregnancy. This procedure aids in the detection of genetic disorders, metabolic defects, and the assessment of fetal lung maturity. While amniocentesis is a valuable diagnostic tool, it carries potential risks such as maternal hemorrhage, infection, Rh isoimmunization, abruptio placentae, amniotic fluid emboli, and premature rupture of the membranes. Prior to amniocentesis, clients provide informed consent. Bladder status is considered, ultrasonography aids in locating the placenta, and continuous monitoring of vital signs and fetal heart rate is implemented. Kick counts. Fetal movement counting. Lastly, we have kick counts, a simple yet crucial practice. Clients are instructed to sit quietly or lie down on their side to count fetal kicks. Clients should promptly inform the healthcare provider if there are fewer than 10 kicks in 2 consecutive 2-hour periods, or as instructed by the provider, as this could indicate potential issues warranting further evaluation and monitoring. The Fern test. It serves as a microscopic slide examination to detect amniotic fluid leakage. This entails collecting a specimen from the cervix and vaginal pool, subsequently examining it under a microscope to identify a fern-like pattern, indicative of amniotic fluid presence. During this procedure, it is crucial to position the client in the dorsal lithotomy position and instruct her to cough, as this may induce amniotic fluid leakage if the membranes are ruptured. Now, let's delve into the nitrazine test, utilized to identify amniotic fluid in vaginal secretions. Vaginal secretions typically have a pH ranging from 4.5 to 5.5, which does not affect the test strip or swab. However, amniotic fluid with a pH ranging from 7.0 to 7.5 will cause the test strip or swab to turn blue. To conduct this test, position the client in the dorsal lithotomy position. Apply the test tape to the fluid and observe it for a blue to green, blue to gray, or deep blue color change, indicating the presence of ruptured membranes and amniotic fluid leakage. Lastly, let's discuss the fibronectin test, which involves collecting cervical and vaginal secretions to detect fetal fibronectin, a protein found during specific gestational periods. Positive results may suggest the onset of labor in 1 to 3 weeks, while negative results are more predictive of the absence of preterm labor. This test is typically employed when there is a risk of preterm labor. To perform the fibronectin test, place the client in a lithotomy position for a sterile speculum examination. Obtain cervical secretions using a cotton swab and send the samples to the laboratory for fibronectin presence analysis. Now let's move on to some guidelines regarding nutrition during pregnancy. Expectant mothers should aim for an expected weight gain of 25 to 35 pounds for those with a normal pregnancy weight. An additional 300 calories per day are needed during pregnancy, with calorie needs increasing in the later trimesters compared to the first. During lactation, an extra 500 calories per day are required. Folic acid supplements are essential for all women of childbearing age to prevent neural tube defects and oral facial clefts in the fetus. Adequate hydration is also vital, with the goal of consuming at least 8 to 10 8-ounce glasses of fluid daily, including 4 to 6 glasses of water. Sodium intake is not restricted unless prescribed by the healthcare provider. For individuals following vegan and vegetarian diets, it is crucial to ensure a varied diet to meet normal nutrient and energy requirements. Clients should be educated about consuming complementary proteins throughout the day to provide all essential amino acids. Potential deficiencies in these diets include energy, protein, vitamin B12, zinc, iron, calcium, omega-3 fatty acids, and vitamin D if limited sunlight exposure. Increasing protein consumption with a variety of vegetable protein sources, enhancing iron absorption by pairing it with vitamin D-rich foods, and including a variety of plant-based foods are recommended. Lactose intolerance can lead to digestive discomfort, and clients with this condition should incorporate non-dairy calcium sources into their diets. Cooked forms of milk, such as custards or fermented dairy products, may be tolerated, along with cheese and yogurt. Lactase supplements can be prescribed, and lactase-treated milk or lactose-free products are commercially available. Lastly, we discussed pica, a condition involving the consumption of non-food substances. This cause is unclear, but cultural beliefs may play a role. Pica can result in iron deficiency anemia, so addressing this behavior is important. Now, let's delve into the non-stress test, NST, and contraction stress test, CST. The non-stress test evaluates the function and oxygenation of the placenta and assesses fetal well-being by examining the fetal heart rate, FHR, response to fetal movement. To perform this test, an external ultrasound transducer and tachodynamometer are applied to the client to record a tracing lasting at least 20 minutes. This allows observation of both the FHR and uterine activity. Baseline blood pressure is measured, and blood pressure is monitored frequently. The client is positioned in the lateral, side-lying position to prevent vena cava compression. Additionally, the client may be instructed to press a button whenever she feels fetal movement, and the monitor records these movements as reference points for assessing the FHR response. Results for the non-stress test can be categorized as reactive, indicating a healthy fetus, non-reactive, abnormal, or unsatisfactory, when the tracing quality is insufficient for interpretation. Moving on to the contraction stress test, it is performed to assess placental oxygenation and function, evaluate the fetus's ability to tolerate labor, and assess fetal well-being. During this test, the fetus is exposed to contractions to evaluate placental perfusion under simulated labor conditions. It is typically performed when the non-stress test yields abnormal results. To perform the contraction stress test, an external fetal monitor is applied to the client, and a baseline strip of 20 to 30 minutes is recorded. Uterine contractions are induced, either through oxytocin administration or nipple stimulation, until 3 palpable contractions with a duration of 40 seconds or more in a 10-minute period are achieved. Frequent maternal blood pressure readings are taken, and monitoring occurs while oxytocin doses are increased. Now,
before we move ahead, let me take a quick moment to tell you something that could completely change your NCLEX journey. If you're serious about passing the NCLEX in just 1 week or even within a month, then the smartest move you can make right now is to enroll in our complete online NCLEX crash course. This isn't just another course, it's a shortcut, a clear step-by-step roadmap that has already helped over 100,000 nursing students pass the NCLEX with confidence. And here's the most incredible part. Not a single student who completed this course has failed. Yes, that's a 100% passing rate. We built this course based entirely on the feedback and insights of thousands of nurses who've successfully cleared the NCLEX in the last 5 years. That means we've removed all the fluff and focused only on what truly matters for your exam. Here's exactly what you'll get when you enroll. You'll get 100 hours of animated crash course content designed for rapid revision, 500 hours of comprehensive recorded lectures covering all the high-yield topics, and access to 10,000 real NCLEX questions to sharpen your test-taking skills. You'll also get 500 next-gen case-based questions to strengthen your clinical judgment, along with 15 full-length practice tests that simulate the real NCLEX experience. And of course, you'll receive our complete NCLEX ebook and PDF notes, plus 1 full year of access, so you can study at your pace, on your schedule. And yes, we're currently offering a 70% discount for a very short period. Once the offer ends, it's gone. Thousands of students are enrolling in our online NCLEX course every month and passing the exam, but if you don't enroll now, you risk being left behind. Spots are filling fast, and only a few seats are left. Visit our website to enroll now. Link is given in description box. Let's continue the video.
let's delve into laboratory values, a key topic on your NCLEX exam. This segment is crucial for your success as you'll encounter about 3 questions related to it on the exam. Understanding lab values is vital for patient care and is a must-know for any aspiring nurse. Get ready to explore this fascinating and essential subject. Serum sodium, crucial role as a major cation in the extracellular fluid, where it helps maintain osmotic pressure and acid-base balance and assists in transmitting nerve impulses. It is absorbed in the small intestine, and its excretion through urine varies based on dietary intake. The normal reference range for serum sodium is between 135 to 145 milliequivalents per liter. It's important to note that drawing blood from an extreme IV solution is infusing can yield inaccurate results, depending on the test and type of solution. Additionally, prolonged use of a tourniquet before venous sampling can elevate potassium levels in the blood. Serum potassium, a major intracellular cation, critical for regulating cellular water balance, electrical conduction in muscle cells, and acid-base balance. The body acquires potassium through diet, and the kidneys either conserve or excrete it according to cellular need. Potassium levels are vital for assessing cardiac, renal, gastrointestinal functions, and determining the necessity for IV therapy. Notably, if a client is receiving potassium supplements, this should be indicated on the laboratory form. Elevated blood cell and platelet counts can falsely increase potassium levels. The normal range for potassium is between 3.5 to 5.0 mils per liter. Activated partial thromboplastin, APTT, is used to evaluate the intrinsic clotting system by measuring the time it takes for recalcified citrated plasma to clot after adding partial thromboplastin. This test is useful for monitoring heparin therapy and screening for coagulars, excluding factors 7 and 13. The normal reference interval for an APTT is 28 to 35 seconds, although this can vary based on the activation used. Blood samples should be drawn 1 hour before the next heparin dose during intermittent therapy and should not be drawn from an arm heparin infusion. Immediate transport of the specimen to the laboratory is crucial. The APTT should be 1.5 to 2. Normal value during heparin therapy. If the APTT value is prolonged in a client receiving IV heparin therapy or at risk for thrombocytopenia, bleeding precautions should be initiated. Prothrombin time, PT, and International Normalized Ratio, INR, involve measuring the time for formation to monitor the response to warfarin sodium or to screen for extrinsic clotting system dysfunctions due to liver disease, vitamin K deficiency, or disseminated coagulation. Each laboratory establishes its own control value for PT, and a PT value within 2 seconds, or minus, of the control is considered normal. In obtaining blood samples, whether through vent puncture or intravenous lines, it's important to select an appropriate vein, ensure cleanliness and proper technique, specimens correctly per agency policy. This includes using antiseptic swabs, choosing the right angle for needle insertion, ensuring needle safety post-collection, and applying appropriate pressure at the insertion site. Hand hygiene and the transportation of the specimen to the laboratory are also vital steps in the process. The International Ratio, INR, is an essential test for measuring effectiveness of certain anticoagulants. It says the prothrombin time, PT ratio, by raising the observed PT ratio to the power of the International Center Index, which varies depending on the thromboplastin reagent used in the laboratory. Before starting anticoagulation therapy, it's important to obtain a baseline specimen, ensuring to note of collection on the lab form. Applying direct pressure for 3 to 5 minutes at the venipuncture site is crucial to prevent bleeding. Warfarin therapy, when given concurrently with heparin, extend the PT for up to 5 hours post-dosing. Diets rich in green leafy vegetables, which are high in vitamin K, can shorten the PT by enhancing vitamin K absorption. Oral anticoagulants typically maintain the PT at 1 to 5 to 2 times the normal laboratory value. For prothrombin time, normal ranges are 11 to 12 seconds, and for IR, it's 2 to 3 for standard warfarin therapy, and 3 to 4.5 for high-dose therapy. If the PT exceeds 32 seconds and the INR is above 3.0 in a patient receiving standard warfarin therapy, precautions should be initiated as per agency policy. Platelet count is another crucial test. Platelets playing a key role in hemostasis, clot retention, and coagulation factor activation. Produced by the bone marrow, their normal range is 150,000 to 400,000 m to the third power. It's important to monitor your site for bleeding in patients with thrombocytopenia. Factors like high altitudes, cold weather, and exercise can increase platelet counts. Bleeding precautions are necessary when platelet counts fall significantly below normal, and close monitoring is needed in patients undergoing chemotherapy to the risk of thrombocytopenia. Prior to any invasive procedure, coagulation studies and the platelet counts should be assessed. Hemoglobin and hematocrit tests are also key. Hemoglobin, the main component of red blood cells, transfusion and carbon dioxide, while hematocrit measures the mass of red blood cells, crucial in diagnosing anemia or polycythemia. Fasting is not required for these tests. Lipid panels include HDL, LDL, and triglycerides. Cholesterol is a major component of LDLs and is found in brain and nerve cells, cell membranes, and some gallstones. Triglycerides synthesized in the liver and obtained from diet are a significant part of very low-density lipoproteins. Cholesterol, LDL, and triglyceride levels increase the risk of coronary artery disease, while HDL offers some protection. Oral contraceptives may elevate lipid levels. Before testing, a 12 to 14-hour fasting period, excluding alcohol for 24 hours, and avoiding high cholesterol foods the evening before are advised. Testing blood glucose levels, vital for diagnosing diabetes and hypoglycemia, require an 8 to 12-hour fast. Diabetic patients should withhold morning insulin or hypoglycemic medication until after the test. Normal fasting glucose ranges from 70 to 110 mg per dl. The HbA1c test reflects blood glucose control for the past 3 to 4 months. Elevated levels usually indicate hyperglycemia in diabetic patients. This test does not require fasting, and normal ranges are between 4.0% to 6.0%. Renal function studies include serum creatinine and blood urea nitrogen tests. Creatinine indicate renal function, with increased levels suggesting a reduced glomerular filtration rate. Avoid excessive exercise and red meat intake before the test. Normal creatinine levels range from 0.6 to 1.3 m per dl. BUN reflects protein breakdown in the liver, with normal levels ranging from 6 to 20 mg per dl. Finally, white blood cell (WBC) counts are critical for understanding the body's immune defense. WBC differential provides detailed information on various types of WBC. Differential can indicate different health conditions, such as bacterial infections, marrow recovery. Normal WBC counts range from 5,000 to 10,000 mm to the third power. Exciting alert! Before we jump into our next topic, we've got a thrilling opportunity for you to win big. Yes, you heard right. $1,000 is up for grabs. We're sprinkling random questions every hour of this course, giving you multiple chances to win. Here comes your next contest questions. What is the most common type of renal stone in the human body? Next question is, Murphy's sign is associated with which disease? Type your responses in the comment box right away. Not just a test of your knowledge, but a chance to pop some serious cash. Ready, set, learn. Remember, each correct answer brings you closer to that sweet prize. Good luck. Now, back to the topic. Lab tests play a crucial role in medical diagnostics and monitoring. Among the various types of tests commonly performed, some of the most significant include metabolic tests. These tests are essential for determining a patient's fluid and electrolyte balance, along with other metabolic parameters like blood glucose levels, protein levels, and liver enzyme. There are two primary categories of metabolic tests: the metabolic panel, BMP, and the cumulative metabolic panel, CMP. The BMP typically includes 8 different tests, such as glucose, calcium, sodium, chloride, potassium, CO2, blood urea nitrogen, BUN, and creatinine, and is often part of routine physical examinations. The CMP, on the other hand, includes all the tests from the BMP plus additional liver function tests, making a total of 15 tests, which also cover parameters ALP, AST, ALT, bilirubin, total protein, albumin, and globulin. Complete blood counts, CBC. This test is crucial for determining the number and types of cells in a patient's blood sample. It includes several parameters, but the most common requested ones include hemoglobin, which is the protein component of red blood cells, transporting oxygen throughout the body, and hematocrit, which measures the proportion of red blood cells in the blood, and serves as an indicator of an individual's status. The test also measures white blood cells, WBCs, which are critical for the ability to fight off infections. Additionally, the CBC provides detailed information about red blood cell indices like mean corpuscular volume, MCV, corpuscular hemoglobin, CH, and red cell distribution width, RDW, which are helpful in diagnosing various conditions, including types of anemia. The CBC also measures platelet count, which is vital for understanding clotting disorders. Coagulation studies. These tests are designed to assess bleeding disorders and are more detailed account in a CBC. They are particularly important for patients with hematologic conditions or those taking anticoagulants. Common coagulation studies include prothrombin time, PTT, international ratio, INR, and activated partial thromboplastin time. Urine analysis. Typically performed as part of routine tests for patients admitted to hospitals, urine analysis helps in determining the presence of urinary tract infection, potential kidney damage, and a patient's hydration status. It is also useful in monitoring the response of patients with urinary tract infections to treatment. Arterial blood gases, ABGs. These tests are important for assessing not only the fluid and electrolyte balance, but also respiratory and metabolic conditions of patients, and critical information about the patient's blood levels and pH balance. Lipid profile. This set of tests determines the level of cholesterol, triglycerides, and other lipoproteins in the blood. It's instrumental in assessing a patient's risk for coronary arteries and guiding the management of these conditions. The hemoglobin test is a critical tool for diagnosing diabetes. It measures a patient's average blood glucose levels over a period of 3 to 4 months, coincides with the lifespan of a red blood cell. This test is particularly useful for monitoring a patient's adherence plan and evaluating their response to the obtaining samples from the patient. Firstly, the cornerstone of any medical procedure, including sample collection, is informed consent. It's vital to start by discussing with the patient why the sample is needed and how it will be collected. It isn't just a formality. It's about building trust and the patient is comfortable and informed. Next, we must coordinate collaboratory. This is a crucial step, ensures the sample we collect remains viable for testing. Imagine a relay race where the baton is the patient's sample and to pass it smoothly to the lab team for analysis. Now, let's talk about preparing our patient. If the test requires fasting, like a blood glucose test, we need to prepare well in advance. This preparation is essential for accurate results. Then, we explain the procedure in detail, ensuring the patient knows exactly what to expect. Lastly, we have the site from where the sample will be collected. This might involve cleaning the area with antiseptic, which is crucial to prevent infection. Moving on to the actual collection procedures, let's look at 3 types. Vein sample, central line sample, arterial blood gas. Each type has its steps. For instance, in a peripheral vein sample, we ask the patient to make a fist, locate the vein, and insert the needle. It's a bit like finding the right spot to pierce an orange peel without going too deep. After drawing the blood, we swiftly remove the needle and apply pressure to the site, discomfort and preventing bleeding. For a central line, it's a bit different. We clean the port with alcohol, let it air dry, and carefully draw the sample. This is similar to tapping a keg, but requires a gentle and precision. The arterial blood gas collection is quite unique. We explain that we're using an artery vein, which might make blood appear brighter. This collection requires a skill and care to ensure patient comfort and accurate sampling. When it comes to urine specimens, the midstream catch method is most common. We guide the patient cleaning the perineal area and the technique of collecting the sample. It's crucial that in the realm of nursing implications, timely handling of the sample is paramount. We must send the samples for analysis promptly to avoid any wastage or degradation. Also, monitoring lab values and understanding their implications for the patient's care is a significant responsibility. It's like being a detective, where lab results are clues to the patient's health puzzle. Finally, post-collection care is just as important. We need to provide the right care and monitoring to the patient, addressing any complications or concerns that arise. It's about ensuring the well-being of the patient throughout the entire process.
Before we move ahead, let me take a quick moment to tell you something that could completely change your NCLEX journey. If you're serious about passing the NCLEX in just 1 week or even within a month, then the smartest move you can make right now is to enroll in our complete online NCLEX crash course. This isn't just another course, it's a shortcut, a clear step-by-step roadmap that has already helped over 100,000 nursing students pass the NCLEX with competence. And here's the most incredible part. Not a single student who completed this course has failed. Yes, that's a 100% passing rate. We built this course based entirely on the feedback and insights of thousands of nurses who've successfully cleared the NCLEX in the last 5 years. That means we've removed all the fluff and focused only on what truly matters for your exam. Here's exactly what you'll get when you enroll. You'll get 100 hours of animated crash course content designed for rapid revision, 500 hours of comprehensive recorded lectures covering all the high-yield topics, and access to 10,000 real NCLEX questions to sharpen your test-taking skills. You'll also get 500 next-gen case-based questions to strengthen your clinical judgment, along with 15 full-length practice tests that simulate the real NCLEX experience. And of course, you'll receive our complete NCLEX ebook and PDF notes, plus 1 full year of access, so you can study at your pace on your schedule. And yes, we're currently offering a 70% discount for a very short period. Once the offer ends, it's gone. Thousands of students are enrolling in our online NCLEX course every month and passing the exam, but if you don't enroll now, you risk being left behind. Spots are filling fast and only a few seats are left. Visit our website to enroll now. Link is given in description box. Let's continue the video.
The next topic is provision of safety for patients. This topic is particularly important from an exam perspective, as the board is keen to assess how effectively a nurse can ensure the safety of patients in a hospital setting. Expect at least one question from this topic, so watch carefully. Also, don't forget to subscribe to our channel. In the upcoming days, you'll have access to more than 100 videos to help you prepare for the NCLEX exam. Now, let's begin this topic. First, we will discuss fire safety, specifically what a nurse should do in the event of a fire. In the event of a fire emergency, efficient management is crucial. The mnemonic RACE is a helpful tool to remember the key actions. First, rescue clients who are in immediate danger. Next, activate the fire alarm. Then, confine the fire by closing doors and windows. And finally, if possible, extinguish the fire. Alongside this, the pass technique is vital for using a fire extinguisher effectively. Pull the pin. Aim at the fire's base. Squeeze the handle, and sweep the nozzle side to side. An uncluttered environment is also essential in such emergencies. Keeping open spaces free of clutter ensures unobstructed movement and access, which can be life-saving. Equally important is the visibility and accessibility of fire exits, which should always be clearly marked and unblocked. Familiarity with fire safety equipment and procedures is another key aspect. Everyone should be aware of the locations of fire alarms, exits, and extinguishers. Understand the contact number for reporting fires, and be versed in the standard fire drill and evacuation procedures of the agency. In a fire, elevators are a hazard and must never be used as they may become inoperative or dangerous. Instead, stairs should be used for evacuation. Regarding oxygen and electrical appliances, these should be turned off near a fire to reduce the risk of exacerbation. When dealing with clients on life support, their respiratory status should be maintained manually with a resuscitation bag or ambu bag until they can be safely moved and reconnected to life support. Evacuation procedures vary based on the mobility of clients. Ambulatory clients should be directed to safe areas, possibly assisting in moving clients in wheelchairs, while bedridden clients should be evacuated using stretchers, beds, or wheelchairs, employing appropriate transfer techniques to ensure safety. Finally, in situations where the fire department personnel are present, they will provide assistance in evacuating clients. Regularly reviewing and memorizing the RACE and PASS mnemonics is essential to ensure prompt and effective responses during a fire, prioritizing safety and minimizing harm. For electrical safety, it's important to maintain all electrical equipment in good working order and ensure they are properly grounded to prevent hazards. Always use 3-pronged electrical cords, where the third, longer prong acts as a ground, and the other 2 prongs carry power. Regularly inspect electrical cords and outlets for any signs of exposed, frayed, or damaged wires. Overloading circuits should be avoided to prevent potential accidents. Understanding and following the warning labels on all equipment is crucial, and one should never operate equipment that is unfamiliar. When using safety extension cords, they should only be used when absolutely necessary, and they should be securely taped to the floor with electrical tape. Electrical wiring should never be run under carpets for safety reasons. When unplugging any device, it's important to grasp the plug itself, rather than pulling on the cord. Electrical appliances should never be used near sinks, bathtubs, or other water sources to avoid electrocution risks. Before cleaning any electrical equipment or appliances, always disconnect the plug from the outlet. In the event of an electrical shock to a client, the first step is to turn off the electricity before touching the client to ensure safety of both the rescuer and the victim. In terms of radiation safety, knowing and adhering to the protocols and guidelines of the healthcare agency is essential. Any potentially radioactive material should be clearly labeled. To reduce exposure to radiation, limit the time spent near the source. Make the distance from the source as great as possible, and use shielding devices such as lead aprons. Radiation exposure should be monitored with a dosimeter badge. Clients who have radiation implants should be placed in a private room. In the event that a radiation implant is dislodged, it should never be touched, and all linens should remain in the client's room until the implant is removed. When disposing of infectious wastes, all infectious materials should be handled as hazardous. Waste should be disposed of only in designated areas, using the proper containers for disposal. It's crucial that infectious material is labeled properly. All sharps, like needles, should be disposed of immediately after use in closed, puncture-resistant disposable containers that are leak-proof and either labeled or color-coded. Needles should not be recapped, bent, or broken due to the risk of accidental injury, such as needle sticks. Each of these practices plays a vital role in ensuring safety in a healthcare setting, both for the healthcare providers and the patients. It's important to regularly reinforce these practices through training and practical demonstrations to maintain a safe working environment. Preventing falls in a healthcare setting involves a comprehensive approach focused on assessing and managing the risk for each client. The first step is to assess the client's risk for falling, which allows for tailored preventive measures. Clients identified as being at risk should ideally be assigned to rooms close to the nurse's station for easier monitoring. It's also important to make all personnel aware of the client's risk for falling to ensure vigilant care. Frequent assessment of the client is crucial, alongside orienting them to their physical surroundings to minimize confusion. Clients should be instructed to seek assistance when getting up, emphasizing the importance of not attempting to move unaided. Educating the client on the use of the nurse call system provides them with a way to easily request help. The use of safety devices, such as floor pads and alarms for beds or chairs, plays a significant role. These alarms alert healthcare personnel when a person attempts to get out of bed or a chair, enabling prompt assistance. Ensuring that beds are kept in the low position with side rails adjusted according to the agency's policy is another key preventive measure. Additionally, locking all beds, wheelchairs, and stretchers prevents accidental movement that could lead to falls. Accessibility is another factor to consider. Keeping clients' personal items within easy reach and eliminating clutter and obstacles in their room can significantly reduce fall risks. Providing adequate lighting, especially during nighttime, helps clients navigate their surroundings safely. Addressing bathroom hazards is equally important, as many falls occur in this area. This involves maintaining a regular toileting schedule for the client throughout the day to minimize the urgency and frequency of unsupervised bathroom visits. By integrating these measures, healthcare facilities can significantly reduce the incidence of falls, ensuring a safer environment for their clients.
Before we move ahead, let me take a quick moment to tell you something that could completely change your NCLEX journey. If you're serious about passing the NCLEX in just 1 week or even within a month, then the smartest move you can make right now is to enroll in our complete online NCLEX crash course. This isn't just another course, it's a shortcut, a clear step-by-step roadmap that has already helped over 100,000 nursing students pass the NCLEX with confidence. And here's the most incredible part. Not a single student who completed this course has failed. Yes, that's a 100% passing rate. We built this course based entirely on the feedback and insights of thousands of nurses who've successfully cleared the NCLEX in the last 5 years. That means we've removed all the fluff and focused only on what truly matters for your exam. Here's exactly what you'll get when you enroll. You'll get 100 hours of animated crash course content designed for rapid revision, 500 hours of comprehensive recorded lectures covering all the high-yield topics, and access to 10,000 real NCLEX questions to sharpen your test-taking skills. You'll also get 500 next-gen case-based questions to strengthen your clinical judgment, along with 15 full-length practice tests that simulate the real NCLEX experience. And of course, you'll receive our complete NCLEX ebook and PDF notes, plus 1 full year of access so you can study at your pace on your schedule. And yes, we're currently offering a 70% discount for a very short period. Once the offer ends, it's gone. Thousands of students are enrolling in our online NCLEX course every month and passing the exam, but if you don't enroll now, you risk being left behind. Spots are filling fast and only a few seats are left. Visit our website to enroll now. Link is given in description box. Let's continue the video.
Understanding crisis intervention. Crisis intervention involves addressing a temporary state of severe emotional disorganization resulting from failed coping mechanisms and insufficient support. In such situations, individuals may struggle with decision-making and problem-solving abilities. The primary aim of treatment is to support both the client and their family through the challenging circumstances. Phases of crisis. The phases of a crisis typically unfold in a sequential manner. It begins with an external, precipitating event, followed by the perception of threat and an increase in anxiety. During this phase, the individual may either cope with or resolve the crisis. However, if coping mechanisms fail, the crisis progresses to a phase of increasing disorganization, marked by the emergence of physical symptoms and relationship problems. In the subsequent phase, efforts are made to mobilize internal and external resources with the goal of restoring the client to at least their pre-crisis level of functioning. Types of crises. Various types of crises exist, each with its own unique characteristics. Maturational crises stem from developmental stages and associated role changes, such as marriage or retirement. Situational crises arise from external sources, disrupting psychological equilibrium due to life events like job loss, financial changes, or the death of a loved one. Adventitious crises, on the other hand, result from disasters or events outside of everyday life, such as natural disasters, acts of terrorism, or war. Approaches in crisis intervention. In crisis intervention, immediate and supportive treatment is provided to address the immediate crisis. Interventions are goal-directed, acknowledging the client's feelings and providing opportunities for expression and validation. Moreover, connections are made between the event's meaning and the crisis, allowing the client to explore alternative coping mechanisms and adopt new behaviors. Let's start the next topic, that is grief. Grief, a natural emotional response to loss, compels individuals to navigate through various stages or tasks in an attempt to come to terms with the absence. This process involves a journey through different emotional landscapes, each presenting its unique challenges and opportunities for healing. Stages of grief. Initially, during the stage of shock and disbelief, the survivor grapples with numbness and disbelief, often leading to difficulties in decision-making and manifestations of denial or isolation. Moving forward, the experiencing the loss stage envelops the survivor in a whirlwind of emotions, including anger, guilt, and bargaining, as they confront the reality of the absence. This stage is marked by the need to process the loss, often accompanied by feelings of sadness and depression. Transitioning into the reintegration stage, the survivor begins to reconcile with the loss, gradually reorganizing their life and integrating the absence into their reality. Despite the ongoing challenge of adapting to life without the loved one, there's a gradual acceptance and a determination to move forward while still cherishing memories. Types of grief. Beyond the stages of grief, different types of grief emerge, each with its nuances and challenges. Normal grief, a common experience, entails a process of resolution that can span months to years, encompassing physical, emotional, cognitive, or behavioral reactions. Anticipatory grief, on the other hand, precedes the loss and is often linked with acute, chronic, or terminal illnesses, intensifying the emotional turmoil even before the actual loss occurs. Disenfranchised grief adds another layer of complexity, arising when a loss cannot be openly acknowledged due to societal norms or definitions. Dysfunctional grief signals a prolonged struggle with emotional instability, hindering progress towards coping with the loss effectively. Grief in different contexts. In children, grief manifests differently based on their developmental level, presenting unique challenges that require tailored approaches for support and understanding. Understanding these variations in grief allows for more effective interventions and support systems to aid individuals in navigating the complexities of loss and healing. Understanding loss and grief loss, whether actual, perceived, or anticipatory, embodies the absence of something desired or previously available. This absence can trigger a complex and multifaceted emotional response, commonly known as grief. Grief encompasses a range of emotions and behaviors experienced in response to loss, manifesting both internally and externally. Types of loss. Actual loss is identifiable by others, arising in response to or anticipation of a situation, while perceived loss is subjective and cannot be verified externally. Anticipatory loss is experienced before its occurrence, adding a layer of complexity to the grieving process. Mourning, the outward and social expression of loss, is influenced by cultural and religious beliefs. It serves as a means for individuals to navigate their grief publicly and find solace within their communities. Bereavement encompasses both internal emotions and external reactions to loss, including grief and mourning. Understanding the multifaceted nature of bereavement is crucial in providing support to those experiencing loss. Nurse's role in grief and loss. In the nurse's role concerning grief and loss, several key actions are essential. Firstly, the nurse must allow ongoing opportunities for fully informed choices, respecting the autonomy of the individual and their family. Additionally, facilitating the grief process involves assessing the survivor's emotions and aiding them in completing the necessary tasks to navigate their grief. Recognizing that grief impacts individuals physically, psychologically, socially, and spiritually, a multidisciplinary approach, including bereavement specialists, can enhance the effectiveness of support interventions. Communication and support. In communication with clients, families, and significant others, nurses must consider various factors such as cultural background, religion, family dynamics, coping mechanisms, and support systems. Sensitivity to personal boundaries, nonverbal cues, and the provision of emotional support are vital aspects of nursing care during times of grief. Encouraging the expression of feelings, actively listening, and offering reassurance are essential components of therapeutic communication. Nurses should also acknowledge their own emotions and be willing to share in the client's grief if appropriate.
Hello, future nurses. Welcome to the Nursing Foundation Crash Course, your ultimate guide to NCLEX success. We've packed this course with the most frequently tested topics on the NCLEX, so after watching this, you won't need to go through multiple books. Plus, we've included important NCLEX questions for every topic to sharpen your critical thinking. This video is a goldmine for your exam prep, so make sure to watch till the end. Let's get started. All right, let's go over ethical principles in nursing. First, we have veracity, which means being truthful. Nurses must always be honest when communicating with patients, families, and the healthcare team. For example, if a patient is starting a new medication, the nurse should explain both the benefits and possible side effects, even if they're unpleasant. Next is justice, which means fair and equal treatment. Every patient should receive care based on their medical needs, not their background, race, or financial status. For instance, a nurse should prioritize patients based on urgency, not on whether they have insurance. Then we have accountability, which means accepting responsibility. Nurses must own their actions, including mistakes. If a nurse gives the wrong medication, they should immediately report it to their supervisor and complete an incident report. Taking responsibility helps ensure patient safety and trust. Now, let's talk about non-maleficence, which means do no harm. Nurses must always work to prevent harm and protect patients, especially those who are vulnerable. For example, raising bed rails for a confused elderly patient helps prevent falls. Moving on to fidelity, which is about loyalty and commitment. Nurses must keep their promises to patients. If a nurse tells a patient they'll bring pain medication at a certain time, they should follow through. Patients rely on that trust. Now, we have beneficence, which means promoting good. Nurses should always act in the best interest of their patients. This can be as simple as providing emotional support to a patient who's dealing with a tough diagnosis. Now, let's test our understanding with an NCLEX question. A nurse is educating a patient about a new medication. The patient asks if it has any side effects. What is the best response? A, there are no side effects at all. B, I cannot disclose that information. C, this medication may cause dizziness and nausea, but I will inform you how to manage it. D, don't worry, you'll be fine. The correct answer is option C. It follows the principle of veracity by providing honest and helpful information to the patient. All right, class, let's talk about informed consent. First, the surgeon's role. The surgeon must explain the diagnosis, procedure, risks, and alternatives. They also need to answer any questions the patient has and ensure the patient fully understands before obtaining voluntary consent. Now, the nurse's role. The nurse witnesses the patient's signature, makes sure the patient is competent and signing voluntarily, and documents the entire consent process. But what happens if additional procedures are needed during surgery? In that case, the medical power of attorney, next of kin, or legal guardian must be contacted for consent. Now let's check your understanding with an NCLEX question. Which statement about informed consent is correct? A. The nurse is responsible for explaining the procedure. B. The nurse can obtain verbal consent over the phone. C. The nurse witnesses the signature but does not explain the procedure. D. The patient is forced to sign before surgery. Take a moment to think. The correct answer is C. The nurse's role is to witness the signature, not to explain the procedure. That's the surgeon's responsibility. Let's move on. Triage system. Triage is all about prioritizing patients based on the severity of their condition. In an emergency, not everyone can be treated at the same time, so healthcare providers need to decide who gets help first and who can wait. The goal is simple. Save as many lives as possible while using resources wisely. Now, let's break it down into 4 categories. Emergent, red tag, immediate care needed. Think of this category as help them right now or they won't survive. These patients have life-threatening conditions, but if treated immediately, they have a good chance of survival. For example, if a patient has airway obstruction, they can't breathe, and without oxygen, survival is impossible. This needs urgent intervention. Severe respiratory distress, like intention pneumothorax, where trapped air collapses a lung. This can quickly lead to death if untreated. Shock, whether due to severe bleeding, hemorrhagic shock, or infection spreading through the body, sepsis, needs rapid medical attention. Patients with major trauma, like open fractures with bleeding, need immediate stabilization. Active chest pain, possibly due to a heart attack, means time is critical. Every second counts. Stroke symptoms within 4.5 hours. This is the golden window for thrombolytic therapy, which can dissolve clots and save brain function. Urgent, yellow tag, can wait a few hours. These patients are sick or injured, but stable for now. Their condition is serious, but it won't kill them immediately, so they can wait a little while. For example, a closed fracture without blood vessel or nerve damage doesn't need immediate surgery, but still requires treatment soon. Abdominal pain, such as appendicitis without rupture, is concerning, but as long as there's no perforation, it's not life-threatening. Moderate burns that don't affect the airway can be painful, but they don't need immediate intervention. Someone with high blood pressure but no signs of organ damage should be treated, but it's not an emergency. Deep lacerations need stitches, but as long as bleeding is controlled, they can wait a few hours. Non-urgent, green tag, minor injuries. These are the walking wounded. These patients are stable, and their conditions won't get worse even if treatment is delayed for several hours. For example, minor burns, painful but not life-threatening, small lacerations. If they're not deep and bleeding is controlled, they can be stitched later. Sprains or minor fractures like a finger fracture don't need urgent care. Psychological distress, as long as the patient isn't at risk of harming themselves or others, they can wait. Expectant, black tag, no chance of survival. This is the most difficult category. These are patients with injuries so severe that survival isn't possible, given the resources available. In a mass casualty situation, the focus has to be on those who can be saved. For example, a patient with severe head trauma who doesn't respond to painful stimuli has a very poor prognosis. Someone with extensive full-thickness burns covering most of their body is unlikely to survive. Massive trauma, such as decapitation or a patient in cardiac arrest with no vital signs for a long time, means survival is not possible. Now let's go through some practice questions. A hospital is responding to a mass casualty event after a bus crash. There are multiple injured patients, and the medical team needs to decide who should be treated first. Which patient should receive immediate attention? A. A 50-year-old with an open femur fracture and stable vitals. B. A 23-year-old with burns covering 90% of the body and no palpable pulse. C. A 34-year-old with paradoxical chest movement and cyanosis. D. A 42-year-old with a sprained ankle and minor lacerations. Correct answer is option C. A 34-year-old with paradoxical chest movement and cyanosis. Let's break this down. The key phrase here is paradoxical chest movement and cyanosis. This suggests flail chest, which can quickly lead to respiratory failure. If the airway is compromised, the patient needs immediate intervention to survive. This makes them a red tag, emergent priority. Now let's go over why the other choices are not the highest priority. Option A, open femur fracture with stable vitals, is serious but not immediately life-threatening. This patient is a yellow tag, urgent, and can wait a little longer. Option B, 90% burns, no pulse, means the patient has little to no chance of survival, so they receive a black tag, expectant, meaning resources should be focused on those who can be saved. Option D, sprained ankle and minor lacerations, is clearly not life-threatening. This patient is stable, able to walk, and can wait several hours, making them a green tag, non-urgent. So, in mass casualty situations, always prioritize airway and breathing first, which is why the patient with flail chest and cyanosis is treated immediately. Now, let's look at another scenario. A 67-year-old patient with COPD comes to the emergency department. Which symptom indicates they need immediate intervention? A, oxygen saturation 89% on room air. B, barrel chest and clubbing. C, sudden confusion and difficulty speaking. D, mild shortness of breath with exertion. Answer C, sudden confusion and difficulty speaking. Here's why. Sudden confusion and difficulty speaking suggest a neurological change which could indicate a stroke or severe CO2 retention, hypercapnia crisis, in a COPD patient. Both are life-threatening conditions requiring immediate intervention. That's why this patient is classified as red tag, emergent priority. Now let's go over the other choices. Option A, oxygen saturation, 89%, may sound concerning, but for a COPD patient, this is actually not critically low. Their body is adapted to lower oxygen levels, so this does not require immediate action. Option B, barrel, chest, and clubbing, are chronic signs of COPD, meaning they have developed over time and do not indicate an emergency. Option D, mild shortness of breath with exertion, is a common symptom of COPD, but does not signal an immediate crisis. So, the takeaway here is, sudden changes in mental status or breathing are red flags, and these patients must be treated immediately. Now, let's move on to a disaster setting. Imagine there's been a natural disaster and resources are extremely limited. The medical team must decide who receives treatment and who does not. In this situation, which patient should be classified as expectant, black tag? A, a 40-year-old with tension pneumothorax. B, a 55-year-old with third-degree burns covering 80% of the body. C, a 30-year-old with a closed femur fracture. D, a 70-year-old with an asthma exacerbation requiring nebulizers. Answer: B, a 55-year-old with third-degree burns covering 80% of the body. Let's think about this logically. Black tag expectant is given to patients who are not expected to survive, even with treatment. In mass casualty or disaster settings, medical resources are limited, so care is focused on saving those who have the best chance of survival. Here's why the correct answer is option B. A patient with third-degree burns over 80% of the body has a very low survival rate, even with advanced medical care. In a disaster situation, the chances of saving this patient are almost zero, so they are classified as expectant, black tag, meaning they receive comfort care, not aggressive treatment. Now, let's see why the other choices are not black tag. Option A, tension pneumothorax, red tag, emergent. This is life-threatening, but treatable with a chest decompression. Option C, closed femur fracture. Yellow tag, urgent. This is a serious injury, but not life-threatening. The patient can wait for treatment. Option D, asthma requiring nebulizers, green or yellow tag. Depending on severity, this patient could be stable enough to wait and would not be classified as expectant. So, in disaster triage, the focus is on using resources wisely. If a patient has injuries that are beyond medical help, they are given a black tag, allowing medical teams to prioritize those who can be saved. Final triage tips for NCLEX: always prioritize airway, breathing, and circulation, ABCs. This helps determine who needs the most urgent care. Red tag, emergent patients, are treated first because they have life-threatening conditions but can still be saved. Black tag, expectant patients, receive comfort care. They are not the priority in resource-limited situations. If a patient is stable and able to walk, they get a green tag, minor injuries, because they can wait for care. Before moving to the next topic, I want to share something exciting. You can now enroll in our NCLEX Review Crash Course, where you'll get 100 hours of animated crash lessons, 300 hours of recorded classes on high-yield topics, PDF notes, 5,000 previously asked NCLEX questions, 15 practice tests, and an exclusive ebook, all with 1-year access and a 99% passing rate. Don't miss this chance to boost your NCLEX prep. Join now. Leadership styles play a crucial role in shaping team performance, patient outcomes, and workplace culture. One of the most rigid forms is autocratic leadership, authoritarian, where the leader makes all decisions without team input. This style is characterized by strict control and a lack of collaborative decision-making. While it may seem restrictive, it is highly effective in emergencies or high-risk situations. For instance, during a cardiac arrest, a nurse leader swiftly delegates tasks without discussion to ensure immediate and efficient patient care. In contrast, democratic leadership, participative, fosters a more inclusive approach by encouraging team input and discussion. This leadership style promotes collaboration and shared decision-making, leading to higher staff satisfaction. However, the downside is that it may slow down the decision-making process. A common example is when a nurse manager consults staff members before making changes to scheduling. This style is often tested in NCLEX exams with questions such as, a nurse leader encourages team input on a new patient safety protocol. Which leadership style is this? The correct answer is A, democratic. On the other end of the spectrum, laissez-faire leadership, hands-off, takes a minimalistic approach, providing little direction or supervision. This style works best with highly skilled, independent professionals who require little oversight. However, in teams with inexperienced members, it can lead to disorganization and inefficiency. An example of this is a nurse manager who tells staff, "You can handle things however you see fit," leaving decision-making entirely up to the team. For those aiming to inspire and drive positive change, transformational leadership is an ideal approach. This leadership style focuses on long-term goals, motivation, and professional development. Transformational leaders encourage innovation and mentorship, helping staff grow while improving patient care. A prime example is a nurse leader who actively promotes staff education and mentorship programs to enhance healthcare quality. Lastly, transactional leadership, rewards and punishment, relies on a structured system of rewards and consequences to maintain order. This style is practical for managing day-to-day operations, but does not emphasize long-term growth or innovation. It works well in environments where clear guidelines and expectations are necessary. For instance, a nurse leader may offer bonuses for meeting patient satisfaction targets while issuing warnings for excessive tardiness. Let's discuss some questions. A nurse manager offers extra paid time off as an incentive for meeting infection control goals. Which leadership style is being used? A, democratic, B, transformational, C, transactional, D, laissez-faire. Answer, C, transactional. Let's move to the next question. In an emergency, a nurse leader takes full control, giving orders without consulting the staff. Which leadership style is being demonstrated? A, democratic, B, autocratic, C, laissez-faire, D, transformational. Answer, B, autocratic. Now, let's look at another scenario. A nurse leader provides minimal supervision and allows staff to make most decisions. Which leadership style does this describe? A, democratic, B, autocratic, C, laissez-faire, D, transformational. Answer, C, laissez-faire. Wait, before we move to the next topic, if you want the ultimate study advantage, check out our NCLEX Review Crash Course. With 100 hours of engaging animations, 300 hours of recorded lectures covering high-yield topics, PDF notes, 5,000 real NCLEX questions, 15 full-length practice tests, and a must-have NCLEX ebook, you'll have everything you need to pass. Plus, you get 1-year access and a 99% passing rate. Don't leave your success to chance. Enroll now. Personal protective equipment, PPE, plays a crucial role in ensuring the safety of healthcare workers and preventing the spread of infections. When putting on PPE, it is important to follow the correct sequence, which follows a reverse alphabetical order with one exception. The mask is put on second. The correct donning sequence is gown first, followed by the mask, then goggles, and finally gloves. This order ensures maximum protection while minimizing contamination risks. On the other hand, when removing PPE, the process follows an alphabetical order to safely prevent self-contamination. The correct doffing sequence is gloves first, followed by goggles, then the gown, and finally the mask. This method ensures that the most contaminated items are removed first while preventing exposure to harmful pathogens. To reinforce this concept, consider the following NCLEX-style question. A nurse is about to remove PPE after caring for a patient under contact precautions. What is the correct sequence? A. Mask, gloves, gown, goggles. B. Gloves, goggles, gown, mask. C. Goggles, mask, gown, gloves. D. Gown, goggles, mask, gloves. The correct answer is B. Gloves, goggles, gown, mask, as it follows the proper doffing sequence based on alphabetical order, ensuring safe removal and reducing the risk of contamination. Delegation in nursing is essential for ensuring efficient patient care while maintaining safety and adherence to professional roles. Registered nurses are responsible for assessing, teaching, evaluating, and managing unstable patients, as these tasks require critical thinking and advanced clinical judgment. In contrast, licensed practical nurses primarily care for stable patients and administer medications, except for intravenous push medications in most cases. Meanwhile, unlicensed assistive personnel focus on activities of daily living such as bathing, feeding, ambulation, and measuring vital signs in stable patients. Understanding these roles is crucial for making appropriate delegation decisions. To apply this knowledge, consider the following NCLEX-style question. Which task is appropriate to delegate to a UAP? A. Teaching a diabetic patient how to administer insulin. B. Assessing pain level in a post-op patient. C. Measuring a stable patient's vital signs. D. Administering oral pain medication. The correct answer is C. Measuring a stable patient's vital signs, as this falls within the UAP's scope of practice. Tasks requiring assessment, education, or medication administration should not be delegated to UAPs. Another scenario further highlights the importance of proper delegation. An LPN is assigned a patient with newly diagnosed diabetes. Which task is most appropriate for the RN to perform? A. Administering insulin. B. Teaching the patient how to monitor blood glucose. C. Collecting a urine sample. D. Monitoring the patient's oral intake. The correct answer is B. Teaching the patient how to monitor blood glucose, as teaching falls under the RN's responsibilities. While LPNs and UAPs can assist with various tasks, patient education and evaluation require the expertise of an RN to ensure accurate understanding and safe management of the condition. Using a cane correctly is essential for maintaining balance and mobility, especially for individuals with weakness on one side of the body. The proper technique begins with holding the cane on the strong side, which provides better support and stability while walking. When moving, the cane should be advanced first, followed by the weak leg, and finally the strong leg stepping forward to complete the movement. This sequence ensures a steady gait and prevents falls. To reinforce this concept, consider the following NCLEX-style question. A nurse is teaching a patient with right-sided weakness how to use a cane. Which instruction is correct? A. Hold the cane in your right hand for better support. B. Move the cane and the strong leg together. C. Move the cane first, then the weak leg, followed by the strong leg. D. Move the strong leg first, then the cane and weak leg together. The correct answer is C. Move the cane first, then the weak leg, followed by the strong leg. This method provides the necessary stability and support, allowing the patient to walk safely while minimizing the risk of imbalance or falls. Prioritization in nursing is a fundamental skill that ensures patient safety by addressing the most critical conditions first. When prioritizing care, it is important to note that age and gender are not criteria for prioritization. Instead, nurses must focus on the severity and urgency of a patient's condition. In general, acute conditions take priority over chronic conditions as they pose an immediate threat to the patient's health. Similarly, postoperative patients within the first 12 hours are prioritized over those beyond 12 hours, as they are at higher risk for complications. A key concept in prioritization is distinguishing between stable and unstable patients. Stable patients who require lower priority include those with chronic illnesses, post-op recovery beyond 12 hours, local or regional anesthesia, or expected symptoms of a known disease. In contrast, unstable patients require immediate attention and include those with acute illnesses or injuries, post-op recovery within the first 12 hours, general anesthesia, or unexpected symptoms. Additionally, certain conditions are always considered unstable and high priority, such as hemorrhage, high fevers exceeding 105 degrees Fahrenheit, severe hyperglycemia such as DKA, HHNS, and pulselessness or breathlessness, which necessitate immediate CPR. To further refine prioritization, problems are classified into 3 levels based on severity. First-level prioritization involves life-threatening emergencies such as airway obstruction, respiratory distress, cardiac arrest, severe bleeding, and anaphylaxis. These require immediate intervention to prevent death. Second-level prioritization includes serious but not immediately life-threatening conditions such as altered mental status, severe pain, acute urinary retention, uncontrolled blood sugar, and critical abnormal lab values, such as dangerously high or low potassium levels. Finally, third-level prioritization deals with long-term problems and routine care, such as patient education, mobility issues, and psychosocial needs. To apply these concepts, consider the following NCLEX-style questions. A 72-year-old patient with chronic kidney disease reports mild leg swelling, while a 50-year-old patient has an active GI bleed. Who should the nurse see first? Answer is the 50-year-old patient with an active GI bleed, since this is an unstable, acute condition requiring immediate intervention. Next question is, a nurse receives 4 patients. Which one should be seen first? A patient with pneumonia reporting mild shortness of breath. B, a post-op patient with a mild fever. A patient with a history of COPD experiencing severe dyspnea. D, a diabetic patient with a fasting blood sugar of 150 mg per deciliter. Correct answer is option C. The patient with severe dyspnea due to COPD, as acute respiratory distress takes priority over other conditions. A modified radical mastectomy is a surgical procedure that involves the removal of the breast, axillary lymph nodes, and superior apical nodes while preserving the chest muscles. This approach helps in managing breast cancer while maintaining some structural integrity of the chest. However, a significant postoperative concern is the risk of lymphedema, a condition caused by lymph fluid buildup due to the removal of lymph nodes. To prevent lymphedema, certain precautions must be followed. The affected arm should be kept elevated on pillows to promote proper drainage and reduce swelling. Additionally, it is crucial to avoid blood pressure measurements, intravenous insertions, or blood draws on the affected arm, as these can increase the risk of complications. Proper post-mastectomy positioning also plays a vital role in recovery. Patients should be positioned in semi-Fowler's position, with the affected arm elevated to further aid in fluid drainage and prevent swelling. To reinforce this concept, consider the following NCLEX-style question. A post-mastectomy patient is at risk for lymphedema. What should the nurse avoid? A, elevating the arm on pillows. B, applying compression bandages. C, drawing blood from the affected arm. D, encouraging hand and arm exercises. The correct answer is option C. Drawing blood from the affected arm, as any medical procedures on the affected side can contribute to lymphedema and should be strictly avoided. Positioning clients for procedures. Proper patient positioning is essential for ensuring successful procedures and preventing complications. Different procedures require specific positions to optimize safety and effectiveness. For instance, patients undergoing paracentesis should be placed in high Fowler's position, as this allows fluid to accumulate in the lower abdomen for easier drainage. In cases of suspected air embolism, Trendelenburg position is recommended to trap the embolism in the right ventricle and prevent it from traveling to the brain or lungs. For chest tube placement, raising the arms above the head helps expand the rib cage and provides better access to the insertion site. After a liver biopsy, patients should be positioned on their right side to apply pressure to the puncture site, minimizing the risk of bleeding. Meanwhile, for thoracentesis, an upright position with the patient leaning forward allows for better lung expansion and facilitates fluid removal. To reinforce this concept, consider the following NCLEX-style question. A patient just had a liver biopsy. How should they be positioned? A, on their left side. B, on their right side. C, supine. D, in high Fowler's. The correct answer is option B, on their right side, as this position helps prevent bleeding by applying pressure to the biopsy site. Jehovah's Witness patients. Caring for Jehovah's Witness patients requires understanding their religious beliefs regarding medical treatment. One of their fundamental principles is the refusal of blood transfusions, even in life-threatening situations. However, they can accept IV fluids such as normal saline and lactated ringers, which help maintain circulation without violating their religious beliefs. Additionally, they may receive apoetin alpha, a medication that stimulates red blood cell production as an alternative to blood transfusion. To apply this knowledge, consider the following NCLEX-style question. A Jehovah's Witness patient has severe anemia. What treatment is appropriate? A. Blood transfusion. B. Normal saline infusion. C. Platelet transfusion. D. Administer epoetin alpha. The correct answer is D. Administer epoetin alpha, as it enhances red blood cell production without the need for a transfusion, aligning with the patient's beliefs. Good Samaritan Law. The Good Samaritan Law protects healthcare providers from civil liability when they render emergency care outside of a clinical setting. This legal protection applies as long as the care is provided in good faith and without gross negligence. However, it is crucial that the provider acts within their scope of practice and follows standard medical guidelines. Importantly, nurses cannot accept payment for services rendered under the Good Samaritan Law, as it is intended to encourage voluntary assistance in emergencies. For example, if a nurse witnesses a car accident and performs CPR on an unresponsive victim, resulting in broken ribs, the nurse is protected from legal consequences because the care was given in an emergency, in good faith, and without negligence. To test this understanding, consider the following NCLEX-style question. A nurse driving home witnesses an elderly man collapse on the sidewalk. The nurse initiates CPR and continues until EMS arrives. Which statement is true regarding the nurse's legal protection under the Good Samaritan Law? A. The nurse can be held liable if the man does not survive. B. The nurse must accept payment from the family for the provided care. C. The nurse is protected as long as they acted within their scope of practice. D. The nurse should have waited for EMS to arrive before intervening. The correct answer is C. The nurse is protected as long as they acted within their scope of practice, ensuring that emergency care is provided safely and ethically. Abuse reporting. Nurses have a legal obligation to report any suspected or confirmed cases of abuse. This responsibility ensures the protection of vulnerable individuals, especially children, who may not be able to advocate for themselves. Child abuse can occur at any age, but it is particularly common in infants and toddlers due to their dependence on caregivers. In many cases, perpetrators of child abuse struggle with low self-esteem and often have a history of growing up in domestic violence, making abuse a recurring cycle. Additionally, substance abuse is a common contributing factor among those who commit child abuse, further increasing the risk of harm. For instance, if a nurse notices multiple bruises on a child's arms and back during a routine checkup, and the parent casually states, "They just fall a lot," the nurse is legally required to report this situation for further investigation. Failure to report could result in continued harm to the child. To reinforce this concept, consider the following NCLEX-style question. A nurse in the pediatric unit notices bruises in various stages of healing on a child's body. What is the best nursing action? A. Confront the parents about the bruises and demand an explanation. B. Document the findings and report the suspected abuse to Child Protective Services. C. Ask the child to describe how the bruises occurred and take no further action. D. Notify the physician only if the child confirms being physically abused. The correct answer is option B. Document the findings and report the suspected abuse to Child Protective Services. This ensures proper intervention and protects the child from further harm. Advanced care planning. Advanced care planning is a crucial process that helps individuals determine their future healthcare preferences in case they become unable to make medical decisions. This planning includes two key components, a healthcare proxy and a living will. A healthcare proxy, also known as a durable power of attorney for healthcare, is a designated person who makes medical decisions on behalf of the patient. Meanwhile, a living will or advance directive is a written document that outlines specific medical treatments the person wishes to accept or refuse in certain situations. It is important to note that providing oxygen via nasal cannula is considered a comfort measure, not a resuscitation method. Therefore, it can still be administered to a patient even if they have a Do Not Resuscitate (DNR) order. For example, if a terminally ill cancer patient with a DNR order is experiencing shortness of breath, the nurse can provide oxygen, as it enhances comfort without violating the patient's end-of-life wishes. To apply this concept, consider the following NCLEX-style question. A patient has a living will stating they do not want mechanical ventilation. The healthcare provider suggests intubation for respiratory distress. What is the nurse's priority action? A. Follow the physician's order and prepare for intubation. B. Verify the living will and discuss the patient's wishes with the healthcare provider. C. Inform the patient that intubation is necessary and cannot be refused. D. ignore the living will and allow the family to make the decision? The correct answer is option B. Verify the living will and discuss the patient's wishes with the healthcare provider. This ensures the patient's autonomy is respected while also facilitating ethical decision-making in their care. Local organ procurement services play a vital role in coordinating organ donations and must be notified for every clinical death as per hospital protocol. During this process, cardiac and respiratory support must be maintained while organ donation is discussed or performed, ensuring the viability of the organs for transplantation. One critical aspect of organ donation is that family consent is not required if the patient is a registered organ donor. The patient's prior decision takes precedence, reinforcing the ethical and legal importance of respecting their wishes. Additionally, concerns about postmortem appearance are unnecessary because organ donation does not disfigure the body, allowing funeral arrangements to proceed as usual without any visible alterations. For instance, consider the scenario where a brain-dead patient has a signed organ donor card, but the family refuses to proceed with the donation. In this case, the hospital must honor the patient's document consent, as their decision legally and ethically overrides the family's objections. A NCLEX-style question highlights this principle. A patient is declared brain dead and is a registered organ donor. The family refuses to consent to organ donation. What is the best nursing action? A. Respect the family's wishes and cancel the donation. B. Inform the family that the patient's prior consent allows organ donation to proceed. C. Wait until the family changes their mind before proceeding. D. Contact the legal team to obtain a court order for organ donation. The correct answer is option B. Inform the family that the patient's prior consent allows organ donation to proceed, ensuring that the patient's wishes are fulfilled while maintaining legal and ethical standards. Before we dive into the next topic, here's a game changer for your NCLEX prep. Our NCLEX review crash course is now open for enrollment, but spots are limited. Get 100 hours of animated crash courses, 300 hours of recorded high-yield lectures, PDF notes, 5,000 past NCLEX questions, 15 practice tests, and an exclusive ebook. Plus, you'll enjoy 1-year access and a proven 99% passing rate. Don't wait until it's too late. Secure your spot today. Now we will discuss about arterial blood gas interpretation is an essential diagnostic tool used to assess a patient's oxygenation, ventilation, and acid-base balance. Proper analysis helps in identifying respiratory and metabolic disturbances, guiding appropriate treatment strategies. To determine the type of acid-base imbalance, a simple rule applies. If pH and bicarbonate move in the same direction, both increasing or both decreasing, it indicates a metabolic imbalance. However, if pH and CO2 move in opposite directions, the cause is respiratory in nature. Understanding these patterns allows for quick identification of underlying conditions affecting acid-base homeostasis. The key components of an ABG and their normal values are as follows: pH 7.35 to 7.45, partial pressure of CO2 35 to 45 millimeters of mercury, bicarbonate 22 to 26 milliequivalents per liter, partial pressure of O2 80 to 100 millimeters of mercury. Oxygen saturation greater than 95%. Changes in pH significantly impact the body, leading to specific symptoms. When pH increases means alkalosis occurs, the patient may become irritable, hyperexcitable, restless, and tachycardic. A classic example is anxiety-induced hyperventilation, leading to respiratory alkalosis. Additionally, in alkalosis, potassium levels drop, causing hypokalemia. Conversely, when pH decreases means acidosis occurs, the patient may present with lethargy, weakness, bradycardia, and obtundation. A common cause is chronic obstructive pulmonary disease, which leads to CO2 retention, resulting in respiratory acidosis. Unlike alkalosis, acidosis is associated with hyperkalemia due to the shift of potassium out of cells. Respiratory versus metabolic imbalances. Respiratory alkalosis occurs when the pH increases and carbon dioxide levels decrease, occurs due to hyperventilation, which may result from anxiety, pain, pulmonary embolism, PE, or high-altitude exposure. Patients often experience tachypnea, dizziness, tingling, and tetany. Management involves slowing the breathing rate, such as using a paper bag method for anxiety-related cases and addressing the underlying cause. Respiratory acidosis occurs when the pH decreases and carbon dioxide levels increase, is caused by hypoventilation, leading to CO2 retention. Common causes include COPD, narcotic overdose, and airway obstruction. Symptoms range from confusion and lethargy to decreased respiratory drive. Treatment focuses on improving ventilation, oxygen therapy, and using bronchodilators when necessary. Metabolic alkalosis occurs when the pH increases and bicarbonate levels rise, results from acid loss, commonly due to vomiting, nasogastric, NG suctioning, or diuretic use. Symptoms include hypokalemia, muscle cramps, and cardiac arrhythmias. Management involves treating the underlying cause and replacing electrolytes to restore balance. Metabolic acidosis occurs when the pH decreases and bicarbonate, or HCO3-, also decreases occurs due to excess acid production or bicarbonate loss. Common causes include diarrhea, HCO3 loss, diabetic ketoacidosis, DKA, lactic acidosis, shock, sepsis, and renal failure. Patients may present with Kussmaul respirations, deep rapid breathing, hyperkalemia, and confusion. Treatment depends on the cause: insulin for DKA, IV fluids for dehydration, and dialysis for renal failure, by following a systematic approach, examining pH first, then identifying whether PaCO2 or HCO3 is responsible. You can determine the underlying condition. A 45-year-old patient with COPD presents with confusion and lethargy. The ABG results are pH 7.28, low, indicating acidosis. PaCO2, 55 millimeters of mercury, high, suggesting CO2 retention and a respiratory cause. HCO3, 24 milliequivalents per liter. Normal, ruling out a metabolic issue. Given these findings, the most likely acid-base imbalance is A. Metabolic acidosis, B. Metabolic alkalosis, C. Respiratory acidosis, D. Respiratory alkalosis. Answer: C. Respiratory acidosis. Since the pH is low, the patient has acidosis. The elevated PaCO2 indicates that the acidosis is due to CO2 retention, a hallmark of respiratory acidosis, commonly seen in COPD patients who have difficulty expelling carbon dioxide. A patient experiencing severe vomiting for 3 days presents with the following ABG results. pH 7.49, high, indicating alkalosis. PaCO2, 42 millimeters of mercury, normal, meaning the issue is not respiratory. HCO3, 30 milliequivalents per liter, high, suggesting a metabolic cause. Based on these values, the most likely cause of this imbalance is A. Diabetic ketoacidosis, B. Hyperventilation, C. Excessive NG suctioning, D. Narcotic overdose. Answer: C. Excessive NG suctioning. Since the pH is high, the patient has alkalosis. The elevated HCO3- confirms a metabolic origin. Vomiting and NG suctioning remove gastric acid, leading to metabolic alkalosis due to excessive acid loss. Question 3. A patient with sepsis presents with confusion and deep, rapid breathing, Kussmaul respirations. The ABG results are pH 7.30, low, indicating acidosis. PaCO2, 33 millimeters of mercury, low, suggesting the lungs are compensating. HCO3, 18 milliequivalents per liter, low, pointing to a metabolic issue. Which condition is most likely? A. Respiratory acidosis, B. Metabolic acidosis, C. Metabolic alkalosis, D. Respiratory alkalosis. Answer: B. Metabolic acidosis. The low pH confirms acidosis, and the low HCO3- indicates a metabolic cause. The PaCO2 is also low, showing that the body is compensating with Kussmaul respirations, a deep and rapid breathing pattern typical in metabolic acidosis, seen in conditions like sepsis. Final tip for NCLEX. If partial pressure of carbon dioxide is abnormal, the problem is respiratory. If bicarbonate is abnormal, the problem is metabolic. Always analyze the pH first, then determine whether the issue is related to CO2 or bicarbonate to correctly identify the imbalance. The cranial nerves play a vital role in sensory and motor functions, and their assessment is crucial in identifying neurological abnormalities. The olfactory nerve, also known as cranial nerve 1, is a sensory nerve responsible for the sense of smell. To assess its function, one nostril is occluded at a time, and the patient is asked to identify familiar aromas such as coffee, vanilla, or peppermint. A loss of smell, also called anosmia, can indicate neurological conditions like Parkinson's disease or a head injury. Next, the optic nerve, also known as cranial nerve 2, controls visual acuity and pupil reaction. It is assessed using the Snellen chart, where the patient reads at a distance of 20 feet, keeping their glasses on except for reading glasses. Additionally, pupils equal, round, reactive to light and accommodation, abbreviated as PERRLA, is checked. Damage to the optic nerve can result in vision loss or blurring, commonly seen in conditions like glaucoma and optic neuritis. The oculomotor nerve, also known as cranial nerve 3, is responsible for vertical eye movement and pupil constriction. It is tested by asking the patient to track an object moving up and down while also using a pen light to check pupil reaction. If damaged, it may lead to drooping of the eyelid, also called ptosis, or fixed dilated pupils. Similarly, the trochlear nerve, also known as cranial nerve 4, controls downward and inward eye movement and is assessed by tracking an object in those directions. A lesion in this nerve can cause double vision, also called diplopia, specifically vertical diplopia. The trigeminal nerve, also known as cranial nerve 5, is a mixed nerve responsible for facial sensation and mastication, which means chewing. Assessment includes a light touch test on the forehead, cheeks, and chin with the patient's eyes closed, along with palpation of the temporal and masseter muscles while they clench their teeth. Damage to this nerve can result in trigeminal neuralgia, which causes severe facial pain. The abducens nerve, also known as cranial nerve 6, is responsible for lateral eye movement. It is tested by asking the patient to move their eyes laterally while following an object. Damage can lead to crossed eyes, also called strabismus, or double vision, also called diplopia. The facial nerve, also known as cranial nerve 7, controls facial expression and taste in the front 2/3 of the tongue. It is assessed by asking the patient to smile, frown, and raise their eyebrows, as well as identify sweet or salty tastes on the tip of the tongue. Disorders like Bell's palsy affect this nerve, causing facial droop. The acoustic nerve, also called the vestibulocochlear nerve and known as cranial nerve 8, governs hearing and balance. It is evaluated using the whisper test and Weber and Rhine tests with a tuning fork. Damage to this nerve can cause vertigo, tinnitus, or hearing loss. The glossopharyngeal nerve, also known as cranial nerve 9, plays a role in taste in the back 1/3 of the tongue and swallowing. The assessment involves checking the gag reflex with the tongue depressor and asking the patient to say, "ah," while observing uvula movement. An absent gag reflex increases the risk of aspiration, which means food or liquid entering the airway. The vagus nerve, also known as cranial nerve 10, is involved in speech and swallowing. It is assessed by asking the patient to speak and swallow, checking for hoarseness or difficulty. Damage may lead to difficulty swallowing, also called dysphagia, or voice changes. The spinal accessory nerve, also known as cranial nerve 11, controls shoulder and head movements. Assessment involves asking the patient to shrug their shoulders and turn their head against resistance. If damaged, it may cause shoulder droop or weakness. Finally, the hypoglossal nerve, also known as cranial nerve 12, is responsible for tongue movement. It is tested by asking the patient to stick out their tongue and move it side to side, as well as say, "light, tight, dynamite" to assess articulation. Damage can result in tongue deviation to one side. Healthcare is categorized into different levels based on the type and complexity of services provided. Understanding these levels is essential for nurses as they play a crucial role in promoting health, preventing disease, and providing care across all stages of illness and recovery. These levels range from preventative measures to highly specialized treatments and rehabilitation, ensuring comprehensive care for individuals at different points in their health journey. The first level, preventative health care, focuses on educating and equipping clients to reduce and control risk factors for disease before health issues arise. This includes screenings such as blood pressure checks, cholesterol level monitoring, and cancer screenings like mammograms or colonoscopies. Additionally, immunizations such as flu shots, HPV vaccines, and tetanus shots help prevent infectious diseases. Lifestyle counseling, including stress management, smoking cessation programs, and weight management, also plays a significant role in prevention. Furthermore, injury prevention education, such as promoting seatbelt use, fall prevention for the elderly, and helmet use for cyclists is essential in reducing the risk of accidents. Nurses play a key role in patient education, ensuring individuals understand how to maintain health through lifestyle changes and routine checkups. Next, primary health care focuses on health promotion and early disease detection through routine medical visits and screenings. This includes prenatal care and well baby checkups, as well as routine physical exams and vaccinations to prevent illness. Other examples include family planning and birth control counseling, vision and hearing screenings, and nutrition counseling for managing chronic conditions like diabetes or hypertension. In this setting, nurses provide education, administer vaccines, and collaborate with healthcare providers to ensure early intervention and optimal patient outcomes. Moving forward, secondary health care involves the diagnosis and treatment of acute conditions, illnesses, or medical emergencies. This level includes emergency room visits for conditions such as trauma, stroke, or myocardial infarction. It also encompasses hospital admissions for infections like pneumonia, kidney infections, or fractures, as well as diagnostic services like MRI scans, CT scans, and laboratory tests. Additionally, surgical procedures such as appendectomies, gallbladder removal, or orthopedic surgeries fall under this category. Nurses in secondary healthcare settings play a critical role in assessing and stabilizing patients, administering medications, performing procedures, and coordinating care with the medical team to ensure efficient treatment and recovery. For more complex health conditions, tertiary health care provides highly specialized and advanced medical care. This includes intensive care units, ICU, for ventilator-dependent patients, oncology centers for chemotherapy or radiation therapy, and burn centers for managing severe burns and skin grafting. Additionally, specialized surgical units such as neurosurgery and cardiac surgery departments cater to patients requiring advanced procedures. Nurses working in tertiary care settings require expert knowledge and skills to care for critically ill patients, manage complex treatments, and provide life-saving interventions. Finally, restorative health care focuses on rehabilitation and follow-up care to restore function and quality of life after illness or injury. This level includes home health care for post-surgical recovery, rehabilitation centers for stroke patients undergoing physical therapy, and skilled nursing facilities for wound care, IV therapy, and pain management. Additionally, in-home respite care provides support to caregivers of chronically ill patients. Nurses in restorative care settings are essential in patient education, discharge planning, and rehabilitation, ensuring long-term recovery and improved quality of life. Injury prevention and emergency care. Carbon monoxide, CO poisoning, is a serious and often fatal condition caused by exposure to a colorless, odorless, and tasteless gas. CO binds to hemoglobin with an affinity 200 to 250 times greater than oxygen, reducing oxygen transport to tissues and leading to hypoxia. Common sources of CO exposure include faulty furnaces, gas stoves, water heaters, fireplaces, and car exhaust in enclosed spaces. To prevent CO poisoning, it is essential to install carbon monoxide detectors in homes and regularly check their batteries. Additionally, ensuring proper ventilation when using fuel-burning appliances and avoiding running a car engine in a closed garage can help reduce the risk of exposure. Despite preventive measures, CO poisoning can still occur, with early symptoms including headache, dizziness, nausea, vomiting, and confusion. If left untreated, severe cases can progress to loss of consciousness, cherry red skin, seizures, and even death. Immediate management of CO poisoning involves moving the patient to fresh air and administering 100% oxygen via a non-rebreather mask. In severe cases, hyperbaric oxygen therapy may be required to rapidly remove CO from the bloodstream. First aid measures. In cases of bleeding, hemorrhage, applying direct pressure using sterile gauze is crucial to control blood loss. However, if an impaled object is present, it should not be removed. Instead, it must be stabilized to prevent further injury. For fractures, immobilization is key to preventing further damage. The affected limb should be splinted, and the neurovascular status should be assessed using the 5 Ps: pain, pallor, pulse, paresthesia, and paralysis to detect potential complications. Sprains, which involve ligament injuries, are best managed using the RICE method. Rest the affected area, apply ice for 20 minutes every 2 hours, use compression with an elastic bandage, and keep the limb elevated above heart level to reduce swelling. Frostbite requires careful rewarming of the affected area with lukewarm water at 98.6 to 108 degrees Fahrenheit or 37 to 42 degrees Celsius, as using hot water can cause additional tissue damage. A tetanus vaccine should be administered to prevent infection, and rubbing the frostbitten area should be avoided to prevent worsening the injury. For burns, stopping the burning process is the first priority, which may involve removing the source of the burn, such as flames, chemicals, or electricity. Elevating extremities helps reduce swelling, while IV fluids should be administered to prevent hypovolemic shock. If necessary, a tetanus vaccine should also be given to prevent infection. The inflammatory response is the body's natural defense mechanism against injury or infection, occurring in 3 distinct stages. The first stage, known as the vascular response, is characterized by erythema, redness, warmth, edema, and pain. These symptoms occur due to increased blood flow to the affected area, which helps deliver immune cells and essential nutrients to begin the healing process. And following this, the second stage, called the cellular response, involves the activation of white blood cells, WBCs, that attack pathogens. As a result, exudate forms consisting of fluid, WBCs, dead cells, and bacteria. This exudate can vary in appearance, with different types indicating the nature of the inflammation. Serous exudate is clear, such as the fluid found in blisters. Sanguineous exudate contains blood, commonly seen in fresh wounds. Serosanguineous exudate is a mix of clear fluid and blood, while purulent exudate is thick, yellow-green, and contains pus, indicating an infection. Finally, the third stage, known as tissue repair and healing, begins when the damaged tissue is replaced by scar tissue. This stage restores structural integrity to the affected area, completing the body's inflammatory response and promoting recovery. Fall prevention, seizure precautions, and restraint use in nursing. Preventing falls is a key priority in patient safety, especially for individuals at risk due to conditions such as orthostatic hypotension. To minimize the risk of falls, patients should be encouraged to sit at the side of the bed before standing and be instructed to change positions slowly to prevent dizziness or sudden drops in blood pressure. For patients who are particularly vulnerable to falls, additional precautions should be taken. These include regular toileting schedules to prevent rushing to the restroom, providing skid-proof socks for better grip, and ensuring the bed is in the lowest position, with brakes locked. Hourly rounding by healthcare staff can further reduce fall risks, as it allows for timely assistance. Additionally, keeping essential items like the call button, water, and phone within reach can prevent unnecessary movement that could lead to falls. However, it is important to avoid using all 4 side rails, as this can lead to entrapment or increase the risk of injury if the patient attempts to climb over them. In addition to fall prevention, seizure precautions and management are crucial for patients with a history of seizures. Before a seizure occurs, preventative measures should be in place, such as padding the bed rails to prevent injury and keeping suction and oxygen equipment at the bedside in case of airway compromise. During a seizure, immediate action should be taken to ensure patient safety. The priority is to lower the patient to the floor or bed and turn them to their side to prevent aspiration. The area should be cleared of any hard or sharp objects, and any restrictive clothing should be loosened to avoid constriction. It is essential to never restrain the patient or put anything in their mouth, as this can cause further harm. After the seizure, postictal phase, the nurse should assess vital signs and neurological status, reorient the patient as they may be confused or drowsy, and identify possible triggers such as missed medication, stress, or flashing lights to prevent future seizures. Another important aspect of patient safety is the appropriate use of restraints. Restraints should always be a last resort and used only when necessary to prevent the patient from harming themselves or others. They can be classified as physical restraints, such as vests, belts, and mittens, or chemical restraints, which include sedatives and antipsychotic medications. Before applying restraints, alternative strategies should be attempted first. These include reorientation, where the patient is reminded of their surroundings, time, and situation, supervision, such as assigning a sitter or using video monitoring, and diversions, like engaging the patient in activities such as folding towels or listening to music. These measures can help reduce agitation and promote patient safety without the need for restraints. Creating a safe and comfortable environment for patients is essential in healthcare settings. Simple modifications such as reducing noise, adjusting lighting, or positioning the patient near the nursing station can help improve their well-being and prevent agitation. However, in some situations, restraints may be necessary to ensure patient and staff safety, but they must be applied according to strict guidelines. In emergencies, a registered nurse can apply restraints immediately, but a provider's prescription must be obtained within 1 hour. The duration of restraint orders varies based on the patient's age. For adults, the maximum duration is 4 hours. For ages 9 to 17, it is 2 hours, and for children under 9 years, it is limited to 1 hour. Additionally, restraint orders must be rewritten every 24 hours, and PRN, as needed orders, are not permitted to ensure continuous reassessment of the patient's condition. Proper restraint placement is crucial to prevent complications. The padded portion should be applied to the wrist to protect the skin from injury, and neurovascular checks must be performed every 2 hours to assess circulation, movement, and sensation. Regular skin integrity assessments, frequent range of motion (ROM) exercises, and the use of the least restrictive restraint necessary help minimize harm. For example, mittens are a less restrictive option than wrist restraints and may be preferable when preventing IV removal. Additionally, restraints should never be too tight. Ensuring that 2 fingers can fit between the restraint and the patient's limb helps prevent circulation issues. For safety and quick removal, a quick release slip knot should be used instead of a square knot. Restraints must be secured to the movable part of the bed frame, never to the side rails or fixed parts of the bed to prevent injury. When using belt restraints, they should always be placed over clothing or gowns to avoid direct skin damage. To illustrate these principles, consider the following situations. 1. A confused elderly patient with dementia repeatedly pulls out their intravenous and attempts to climb out of bed. In this case, the first approach should be non-restrictive interventions such as reorientation, diversions, and supervision. If these fail, mittens may be a better option than wrist restraints, since they prevent intravenous removal while allowing some mobility. 2. A patient with schizophrenia becomes aggressive and tries to harm staff members. In this situation, chemical restraints, such as an antipsychotic or sedative, may be considered before physical restraints. If physical restraints are necessary, they should only be used as a last resort and removed as soon as possible to avoid unnecessary restriction of movement. Before we move to the next topic, I have great news for you. Our NCLEX Review Crash Course is now open for enrollment. This comprehensive program includes 100 hours of animated crash lessons, 300 hours of recorded lectures covering high-yield topics, PDF notes, 5,000 previously asked NCLEX questions, 15 full-length practice tests, and an exclusive ebook, all with 1-year access and a 99% passing rate. If you're serious about passing the NCLEX, this is the course for you. Join now and take the next step towards success. Fire safety procedures are essential in healthcare settings to ensure the protection of patients, staff, and facilities. The RACE protocol is a structured approach to fire response, guiding healthcare professionals through the necessary steps to manage a fire emergency effectively. The first step in RACE is R, rescue, which involves moving patients to a safe location. The priority is horizontal evacuation, meaning patients should be relocated within the same floor if possible. If the situation escalates, a lateral evacuation to a different floor may be required. Next, A, alarm emphasizes the importance of activating the fire alarm system to alert emergency responders promptly. Once the alarm is raised, C, contain comes into play by closing doors and windows to prevent the fire from spreading. Additionally, any oxygen sources should be turned off to reduce fire intensity. The final step, E, extinguish, involves using a fire extinguisher to put out the fire, but only if it is small and safe to do so. When using a fire extinguisher, the PASS technique ensures its proper operation. The first step, P, pull, requires pulling the pin to unlock the extinguisher. Then A, aim directs the user to target the base of the fire, not the flames, for maximum effectiveness. Following this, S, squeeze, instructs the user to press the handle to release the extinguishing agent. Finally, S, sweep, involves moving the nozzle side to side until the fire is completely out. Understanding different bed positions and their uses is essential in patient care, as each position serves a specific purpose in promoting comfort, recovery, and medical intervention. One commonly used position is Sims's position, where the patient lies on their left side with the left hip and lower extremity straight, while the right hip and knee are bent. This position is primarily used for enemas, rectal examinations, and rectal medication administration. For instance, when a nurse needs to administer a suppository, placing the patient in Sims's position ensures proper medication delivery. Another important position is the Trendelenburg position, where the entire bed is tilted so that the head of the bed HOB is lower than the foot. This position is beneficial for promoting venous return and is commonly used in cases of hypotension, shock, or postural drainage. For example, a patient experiencing hypovolemic shock may be placed in Trendelenburg to improve blood flow to vital organs. Conversely, the reverse Trendelenburg position involves tilting the bed with the foot lower than the head, which is particularly useful for promoting gastric emptying and preventing acid reflux. Patients with gastroesophageal reflux disease, GERD, may be positioned this way to reduce reflux symptoms. Another variation is the modified Trendelenburg position, where the patient lies flat with legs elevated above heart level. This position is beneficial in cases of hypovolemia, as it promotes venous return. For instance, a patient who experiences syncope, fainting, can be placed in this position to restore blood flow. In cases where aspiration prevention and improved ventilation are necessary, the semi-Fowler's position, 15 to 45 degrees, usually 30 degrees, is often used. A post-operative patient receiving tube feeds would benefit from this position to prevent aspiration. Fowler's position, 45 to 60 degrees, is slightly more elevated and is commonly used during procedures like suctioning and to improve ventilation, as seen in patients recovering from pneumonia. A further increase in elevation leads to high Fowler's position, 60 to 90 degrees, which is crucial for patients with severe dyspnea or those at risk of aspiration during meals, such as individuals with COPD and respiratory distress. When full body support is needed, the supine position, where the patient lies flat on their back, is recommended, especially for post-operative care and spinal surgery recovery. In contrast, the prone position, where the patient lies on their stomach, is often used to prevent hip flexion contractures after lower extremity amputation, and is particularly beneficial for patients with acute respiratory distress syndrome, ARDS. During the COVID-19 pandemic, many patients in severe respiratory distress were placed in a prone position to improve oxygenation. Finally, for patients experiencing breathing difficulties, the orthopneic position is highly effective. In this position, the patient sits on the side of the bed with their arms resting on an overbed table, which helps promote lung expansion. Patients with COPD often adopt this position to facilitate easier breathing. Proper bed positioning is essential for patient care, as it helps prevent complications and promotes recovery in various medical conditions and procedures. For a mastectomy, the affected arm should be elevated on a pillow, and the patient should turn only to the unaffected side or remain on their back. This positioning helps prevent lymphatic fluid accumulation, lymphedema, reducing swelling, and complications. Similarly, for head injuries or post-surgical patients, a semi-Fowler's position, 30 to 45 degrees, with the head in midline and no flexion, is recommended. This helps reduce intracranial pressure, ICP, and promotes venous drainage, preventing further brain injury. Patients with COPD or respiratory distress benefit from a high Fowler's or tripod position, as this helps increase lung expansion and maximize oxygenation. When administering an enema, the left lateral or SIMS position is preferred because it facilitates the natural flow of the solution into the colon by gravity, ensuring effective cleansing. In the case of leg amputation, the affected limb should be elevated for the first 24 hours to reduce swelling, but after that, the patient should lie prone twice daily for 20 to 30 minutes to prevent contractures. Following a thyroidectomy, the patient should be in a semi-Fowler's position with neck support while turning, which helps reduce swelling and prevent airway obstruction. For patients in shock, a modified Trendelenburg position is used to improve perfusion to vital organs. Meanwhile, during a thoracentesis, the patient should be seated upright and leaning over an overbed table, ensuring better access to the pleural space for fluid removal. A liver biopsy requires specific positioning. During the procedure, the patient lies on their left side, and after the procedure, they must be positioned on their right side to prevent post-procedure bleeding. Similarly, for paracentesis, a semi-Fowler's or upright position allows for an optimal needle insertion angle, ensuring efficient fluid drainage. Patients undergoing nasogastric, NG, or gastrostomy tube, GT placement, should be in a high Fowler's position during insertion and in a semi-Fowler's, 30 degrees position, during feeding to prevent aspiration. After a laminectomy, spinal surgery, the patient must be kept straight and log-rolled for turning to prevent spinal twisting and further injury. For stroke patients, positioning depends on the type of stroke. In ischemic stroke, a flat position is recommended to optimize cerebral perfusion, while in hemorrhagic stroke, the head of the bed should be elevated to 30 degrees to reduce intracranial pressure. Following a cardiac catheterization, the patient should remain on bed rest for 6 hours, with the affected limb kept straight, and the HOB should not be elevated beyond 30 degrees to prevent bleeding at the insertion site. Finally, for maternal patients experiencing dizziness due to supine hypotension syndrome, the left lateral position is advised, as it prevents compression of the inferior vena cava by the uterus, ensuring adequate blood flow to both mother and baby. Proper use of crutches is essential for mobility and preventing further injury. When positioning crutches, the crutch tips should be placed 6 inches laterally and 6 inches in front of the patient's feet to provide stability. Additionally, the crutch pads must be positioned 1.5 to 2 inches, or approximately 2 to 3 finger widths, below the axilla to prevent nerve damage and discomfort. To ensure proper support and maneuverability, the elbows should be slightly flexed at around 30 degrees while using crutches. Different crutch gait patterns are used depending on the patient's condition and mobility needs. The 2-point gait involves moving a crutch and the opposite leg together, providing a balanced and steady motion. The 3-point gait requires moving both crutches and the affected leg forward together, followed by moving the unaffected leg, making it suitable for patients with one injured limb. In the 4-point gait, movement is more gradual as the patient moves one crutch, then the opposite leg, followed by the other crutch and the remaining leg. For individuals with paraplegia, the swing-to or swing-through gait is used, where both crutches are moved forward first, followed by swinging the legs forward to meet or pass the crutches. When using crutches on stairs, the technique varies depending on whether the patient is ascending or descending. When going up the stairs, the patient should step up with the unaffected leg first, then move the affected leg and crutches up together. In contrast, when descending stairs, the process is reversed. The patient must move the affected leg and crutches down first, followed by stepping down with the unaffected leg. Using a walker correctly is essential for ensuring both patient safety and effective mobility support. When using a walker, the elbows should be flexed at a 30-degree angle to provide stability and prevent strain. Additionally, when taking steps, it is crucial to step with the weaker leg first, followed by the stronger leg to maintain balance and reduce the risk of falls. One important safety precaution is to never pull on the walker to stand up. Instead, the patient should push up from the chair first before gripping the walker to avoid instability. For the NCLEX, understanding safe patient handling is key to preventing injuries for both the patient and the nurse. Using proper body mechanics is essential. This includes keeping the back straight, bending the knees rather than the waist, and avoiding twisting movements. Additionally, nurses must be familiar with the correct use of assistive devices such as crutches, canes, and walkers to ensure patients use them safely and effectively. Another critical aspect of patient care is knowing how to transfer and position patients correctly, such as moving them safely from a bed to a wheelchair and preventing complications like foot drop. Above all, safety and fall prevention should always be the top priority, as proper techniques and precautions can significantly reduce the risk of injury. Understanding the chain of infection is essential for infection prevention. The process begins with an infectious agent such as bacteria, viruses, fungi, or parasites, including Staphylococcus aureus and the influenza virus. These pathogens reside in a reservoir, which may be the human body, soil, water, or contaminated surfaces. The portal of exit refers to how the pathogen leaves the host, such as through blood, respiratory droplets, feces, or skin wounds. The infection then spreads via a mode of transmission, including contact, droplet, or airborne routes, such as hand-to-hand contact, coughing, or contaminated surfaces. Next, the pathogen enters a new host through a portal of entry, which may include breaks in the skin, inhalation, or mucous membranes. Finally, a susceptible host becomes infected, particularly those at higher risk, such as immunocompromised individuals, the elderly, infants, and people with chronic diseases. Several risk factors increase susceptibility to infection. A weakened immune system due to chemotherapy or organ transplants significantly raises the risk. Chronic and acute diseases such as diabetes, chronic obstructive pulmonary disease, cancer, and autoimmune disorders further contribute to vulnerability. Poor personal hygiene and hand hygiene, crowded living conditions such as in nursing homes, prisons, and dormitories, intravenous drug use, unprotected sex, and poor sanitation, including contaminated water and improper waste disposal, also increase infection risk. Infections progress through 4 distinct stages. The incubation period is the time between exposure and the first appearance of symptoms, which varies depending on the infection. For example, chickenpox has an incubation period of 10 to 21 days. During the prodromal stage, nonspecific symptoms such as mild fever, fatigue, and malaise appear, making this the most infectious stage. The illness stage follows, where disease-specific symptoms become evident, such as a rash in measles or a severe cough in pneumonia. Finally, the convalescence stage marks the recovery phase, during which symptoms gradually resolve. To prevent the spread of infections, infection control measures must be followed. Standard precautions applicable to all patients include hand hygiene before and after patient contact, wearing gloves when contact with body fluids is expected, and ensuring the proper disposal of sharps and biohazard materials. In cases requiring additional protection, transmission-based precautions are necessary. For airborne infections such as measles, varicella, and tuberculosis, patients should be placed in a private room with negative pressure, and healthcare providers must wear an N95 respirator mask, along with gloves, gowns, and eye protection as needed. Droplet precautions required for infections like influenza, meningitis, rubella, pertussis, mumps, and diphtheria involve private rooms or cohorting with the same infection and require masks within 3 feet of the patient. Contact precautions used for infections such as methicillin-resistant Staphylococcus aureus, vancomycin-resistant Enterococcus clostridioides difficile, wound infections, and respiratory syncytial virus include wearing gloves and gowns, preferring a private room, and performing hand hygiene with soap and water for Clostridioides difficile infections. Maintaining a sterile field is essential to prevent contamination during medical procedures. To uphold sterility, it is crucial to avoid coughing, sneezing, or talking over the sterile field, as airborne contaminants can compromise its integrity. Additionally, the outer 1-inch edge of the sterile field is not sterile, so any item that touches this area must be discarded. Furthermore, objects held below the waist or above the chest are considered contaminated and should not be used. To maintain sterility while adding objects, they must be dropped onto the field from at least 6 inches above to prevent accidental contamination. Additionally, healthcare professionals must never turn their back on a sterile field or reach across it, as doing so increases the risk of introducing contaminants. Lastly, any sterile item that comes into contact with moisture is considered non-sterile, as moisture can carry microorganisms onto the field. Success in the NCLEX isn't about luck, it's about preparation. Before we move on, I want to invite you to enroll in our NCLEX Review Crash Course and take control of your journey. You'll get 100 hours of engaging animated lessons, 300 hours of recorded lectures on essential topics, PDF notes, 5,000 real NCLEX questions, 15 practice tests, and a must-have ebook, all designed to give you 1-year access and a 99% passing rate. Give yourself the best chance at success. Sign up today and make your NCLEX dream a reality. When performing a physical assessment, 4 key techniques are used. The first is inspection, which relies on sight to assess the size, shape, color, and symmetry of body structures. Next is palpation, which involves using touch to evaluate temperature, texture, and tenderness. The dorsal surface of the hand is best for assessing temperature, while the palmar surface is ideal for detecting vibrations. The third technique, percussion, involves tapping body parts to assess size, tenderness, and density of underlying structures. The final technique is auscultation, which requires listening to body sounds such as those from the heart, lungs, and bowels. Typically, assessments follow the order of inspection: palpation, percussion, auscultation, except in abdominal assessments, where the order changes to inspection, auscultation, percussion, palpation to prevent disrupting bowel sounds. For an eye assessment, several key evaluations help determine eye function and alignment. The extraocular muscles include the inferior and superior oblique, lateral, medial, inferior, and superior rectus muscles, which control eye movement. The corneal light reflex test involves shining a light at the patient's eyes to check for a symmetrical reflection on the corneas, indicating proper alignment. Another important test is the cover and uncover test, which detects strabismus by observing for movement when one eye is uncovered. Additionally, the 6 cardinal gaze positions test eye muscle function by having the patient follow a finger in an H pattern. Lastly, the PERRLA acronym is used to assess pupil function. Pupils should be clear, equal in size, round, reactive to light, and able to accommodate to near and far objects. Ear assessment and blood pressure measurement. Proper ear assessment is essential for identifying any abnormalities and ensuring accurate diagnosis. When evaluating ear alignment, the auricles should be level with the inner canthus of the eyes to indicate normal positioning. When using an otoscope, technique varies based on the patient's age. For adults, the auricle should be pulled up and back, whereas for children under 3 years old, the auricle should be pulled down and back to straighten the ear canal. The otoscope should be inserted 1 to 1.5 centimeter into the canal without touching the walls to prevent discomfort and injury. Equally important is the proper measurement of blood pressure, which includes assessing pulse pressure, the difference between systolic and diastolic blood pressure. A normal pulse pressure ranges from 30 to 50 millimeters of mercury. A widened pulse pressure, greater than 50 millimeters of mercury, may indicate conditions such as hypertension, aortic regurgitation, or increased intracranial pressure. In contrast, a narrow pulse pressure, less than 30 millimeters of mercury, could be a sign of hypovolemic shock, heart failure, or cardiac tamponade, all of which require immediate medical attention. Accurate BP measurement also depends on using the correct cuff size. The cuff width should be 40% of the arm's circumference, while the bladder length should cover 80% of the arm. Using an incorrect cuff size can lead to inaccurate readings. A cuff that is too large results in a falsely low BP, while a cuff that is too small leads to a falsely high BP. Additionally, BP should not be measured on an arm with an IV infusion running, a history of mastectomy on that side, or an AV fistula used for dialysis, as this can cause complications. To estimate systolic blood pressure using palpation, follow these steps. 1. Palpate the radial pulse. 2. Inflate the cuff until the pulse disappears. 3. Add 30 millimeters of mercury more for accuracy. 4. Slowly release the pressure and note when the pulse returns. Lastly, proper patient positioning is crucial for an accurate BP reading. The patient should be seated with feet flat on the floor and legs uncrossed to prevent any false variations in blood pressure readings. A blood pressure classification is essential in assessing cardiovascular health and guiding appropriate interventions. Blood pressure is measured using two values: systolic blood pressure, which represents the pressure in the arteries when the heart contracts, and diastolic blood pressure, which indicates the pressure when the heart relaxes between beats. A normal blood pressure reading is less than 120 millimeters of mercury for systolic and less than 80 millimeters of mercury for diastolic. When blood pressure starts to rise but has not yet reached hypertensive levels, it falls into the prehypertension category, with systolic readings between 120 and 139 millimeters of mercury and diastolic readings between 80 and 89 millimeters of mercury. This stage signals an increased risk for hypertension, making lifestyle modifications crucial. If blood pressure continues to rise, it is classified as Stage 1 hypertension, where systolic pressure ranges from 140 to 159 millimeters of mercury and diastolic pressure from 90 to 99 millimeters of mercury. This stage often requires medical intervention in addition to lifestyle changes. More severe elevation leads to Stage 2 hypertension, defined by a systolic pressure of 160 millimeters of mercury or higher, and a diastolic pressure of 100 millimeters of mercury or higher, requiring more intensive treatment to prevent complications such as stroke or heart disease. On the other hand, hypotension occurs when systolic pressure falls below 90 millimeters of mercury, which can lead to inadequate blood flow to organs, causing dizziness, fainting, or shock in severe cases. Recognizing these classifications helps healthcare professionals manage blood pressure effectively and reduce the risk of serious cardiovascular conditions. Pulses and nasogastric tube care. Assessing pulses is a fundamental part of patient evaluation, providing critical insights into cardiovascular function. A normal pulse rate varies by age, with adults typically ranging from 60 to 100 beats per minute, while infants have a faster rate of 120 to 160 beats per minute. When performing a pulse assessment, it is essential to evaluate rate to identify normal rhythm, bradycardia, or tachycardia. Rhythm, determining if it is regular or irregular, and equality, comparing pulses on both sides of the body for consistency. Additionally, the pulse strength scale is used to classify pulse intensity. A pulse rated 0 is absent, 1+ is weak or diminished, 2+ is normal, 3+ is strong, and 4+ is bounding, which may indicate conditions such as hypertension or fluid overload. Different methods of pulse measurement include the radial and apical pulses. The radial pulse, located on the thumb side of the wrist, should be counted for 30 seconds and multiplied by 2 if regular, but for a full minute if irregular. In contrast, the apical pulse, found at the 5th intercostal space at the left midclavicular line, must always be counted for a full minute if irregular or if the patient is on cardiac medications. A crucial concept in pulse assessment is the pulse deficit, which is calculated by subtracting the radial pulse from the apical pulse. A difference greater than 2 beats may indicate atrial fibrillation, heart failure, or an arrhythmia requiring further evaluation. Shifting focus to nasogastric tube care, proper technique and precautions are essential for patient safety. During insertion, the patient should be placed in a high Fowler's position to reduce the risk of aspiration. Clear patient communication is necessary, and a signal system should be established so the patient can indicate discomfort. Before insertion, a towel should be placed across the chest to prevent messes, and a water-based lubricant should be used to facilitate smooth passage. As the tube is inserted, the patient should be encouraged to sip water, aiding the tube's passage into the esophagus. If gagging or choking occurs, the insertion should be paused slightly to allow recovery before proceeding. Proper placement confirmation is critical. The gastric pH should be checked, and an X-ray should be obtained before the first feeding. Additionally, pre-feeding checks involve verifying the presence of bowel sounds and reassessing gastric content, pH, to ensure safe administration of nutrition or medications. Thank you for watching this lecture. I appreciate your time and dedication to learning. I hope this session helped deepen your understanding of the topic. Before we move ahead, let me take a quick moment to tell you something that could completely change your NCLEX journey. If you're serious about passing the NCLEX in just 1 week or even within a month, then the smartest move you can make right now is to enroll in our complete online NCLEX crash course. This isn't just another course, it's a shortcut, a clear step-by-step roadmap that has already helped over 100,000 nursing students pass the NCLEX with confidence. And here's the most incredible part. Not a single student who completed this course has failed. Yes, that's a 100% passing rate. We built this course based entirely on the feedback and insights of thousands of nurses who've successfully cleared the NCLEX in the last 5 years. That means we've removed all the fluff and focused only on what truly matters for your exam. Here's exactly what you'll get when you enroll. You'll get 100 hours of animated crash course content designed for rapid revision, 500 hours of comprehensive recorded lectures covering all the high-yield topics, and access to 10,000 real NCLEX questions to sharpen your test-taking skills. You'll also get 500 next-gen case-based questions to strengthen your clinical judgment, along with 15 full-length practice tests that simulate the real NCLEX experience. And of course, you'll receive our complete NCLEX ebook and PDF notes, plus 1 full year of access, so you can study at your pace on your schedule. And yes, we're currently offering a 70% discount for a very short period. Once the offer ends, it's gone. Thousands of students are enrolling in our online NCLEX course every month and passing the exam, but if you don't enroll now, you risk being left behind. Spots are filling fast and only a few seats are left. Visit our website to enroll now. Link is given in description box. Let's continue the video. Are you struggling with NCLEX pharmacology? We've got you covered. NCLEX loves to test you on meds, and we've compiled all the must-know drugs in this short review. Watch till the end, and you won't need to waste hours reading. This is everything you need to pass. Let's dive in. Warfarin, Coumadin, is an oral anticoagulant that works by inhibiting vitamin K-dependent clotting factors 2, 7, 9, and 10, as well as proteins C and S. By reducing the blood's ability to clot, it helps prevent the formation of new clots. However, it does not dissolve existing ones. Due to its anticoagulant properties, warfarin is commonly prescribed for conditions that increase the risk of blood clots. For instance, in patients with atrial fibrillation, it helps prevent stroke by reducing clot formation. Similarly, those with mechanical or artificial heart valves require warfarin to prevent embolism. Individuals with a history of deep vein thrombosis, DVT, or pulmonary embolism, PE, are also prescribed this medication to prevent recurrence. Additionally, warfarin is used as a post-surgical prophylaxis, particularly after orthopedic surgeries, to minimize the risk of clot formation. Moreover, patients with hypercoagulable disorders such as factor V Leiden or protein CS deficiency benefit from warfarin therapy to regulate excessive clotting tendencies. Since warfarin has a narrow therapeutic range, careful monitoring is essential to ensure safety and efficacy. This is done through international normalized ratio testing, which measures how long it takes for blood to clot. The target INR range depends on the condition being treated. For most conditions, including DVT, PE, and atrial fibrillation, the recommended INR range is 2.0 to 3.0. In patients with mechanical heart valves, a slightly higher range of 3.0 to 3.5 is required to prevent clot formation. Because several factors can influence INR levels, frequent monitoring is especially important after dosage changes, starting new medications, or significant dietary adjustments. In cases where warfarin levels become too high, leading to an increased risk of bleeding, an antidote is necessary to reverse its effects. The primary antidote is vitamin K, phytonadione, which helps restore clotting function. However, in severe bleeding cases, fresh frozen plasma FFP, prothrombin complex concentrate PCC, or activated recombinant factor 7 may be required for more rapid reversal. Since warfarin's effectiveness is closely tied to vitamin K levels, dietary consistency is crucial. Consuming too much vitamin K can reduce warfarin's effect, while too little can increase the risk of excessive anticoagulation. Therefore, patients should maintain a steady intake of vitamin K-rich foods rather than eliminating them completely. Some foods high in vitamin K that require monitoring include leafy greens such as spinach, kale, broccoli, Brussels sprouts, cabbage, liver, and green tea. Additionally, certain beverages like cranberry juice, grapefruit juice, and alcohol can increase INR levels, thereby heightening the risk of bleeding. Warfarin interacts with various medications and substances, some of which increase bleeding risk while others reduce its efficacy. Patients should avoid or use caution with the following: NSAIDs, ibuprofen, naproxen, and aspirin, which can significantly increase bleeding risk. Alcohol, which can enhance warfarin's anticoagulant effects. Antibiotics, such as ciprofloxacin, azithromycin, metronidazole, sulfonamides, which may alter INR levels. Herbal supplements, such as garlic, ginseng, ginkgo, ginger, St. John's wort, turmeric, which can either enhance or reduce warfarin's effects, and other anticoagulants, which can further increase bleeding risk when combined. Despite its benefits, warfarin is not suitable for all patients. It is strictly contraindicated in pregnancy due to its teratogenic effects, Category X, which can lead to fetal warfarin syndrome, craniofacial abnormalities, and skeletal defects. Instead, pregnant patients requiring anticoagulation are typically prescribed heparin or enoxaparin. Warfarin is also contraindicated in patients with active bleeding disorders or recent hemorrhage, severe liver or kidney disease, which affects its metabolism and clearance, uncontrolled hypertension, as it increases the risk of bleeding, and recent major surgery or trauma, where the risk of excessive bleeding is high. To maximize warfarin's effectiveness and minimize risks, patients must follow strict adherence guidelines. Take the medication at the same time daily, usually in the evening. Do not stop warfarin abruptly without consulting a healthcare provider, as this can lead to clot formation. Avoid activities that pose a high risk of bleeding, such as contact sports. Use a soft bristle toothbrush and an electric razor to reduce the risk of bleeding from minor cuts. Additionally, patients should report any signs of abnormal bleeding immediately, including unusual bruising, black tarry stools, melena, hematuria, blood in urine, excessive bleeding from minor cuts, bleeding gums, epistaxis, nosebleeds, and sudden severe headache, which may indicate brain hemorrhage. If a patient is prescribed antibiotics, they should notify their healthcare provider promptly, as antibiotics can cause INR fluctuations, requiring dosage adjustments. The length of time a patient must take warfarin depends on their underlying condition. For DVT or PE, therapy usually lasts 3 to 6 months but may be extended for recurrent cases. In atrial fibrillation, warfarin is typically taken lifelong to prevent stroke. For patients with mechanical heart valves, lifelong therapy is required. Following major surgery, warfarin is used temporarily depending on the individual's clotting risk. Now let's discuss the heparin. Heparin is a fast-acting anticoagulant that works by enhancing the activity of antithrombin 3, which inactivates thrombin and factor Xa. This prevents clot formation, though it does not dissolve existing clots. Unlike warfarin, heparin is administered parenterally, either through intravenous infusion for rapid anticoagulation or subcutaneous injection for clot prevention, since it is not absorbed orally. Heparin plays a crucial role in the treatment and prevention of various thromboembolic disorders, including deep vein thrombosis, DVT, and pulmonary embolism, PE. It is commonly used in acute coronary syndromes, ACS, such as myocardial infarction, and in atrial fibrillation to reduce the risk of clot-related stroke. Additionally, it is indicated for conditions like disseminated intravascular coagulation, DIC, post-surgical prophylaxis in orthopedic surgeries and prolonged immobility, as well as during hemodialysis and extracorporeal circulation procedures, such as in heart-lung machines. When rapid anticoagulation is required, intravenous heparin is preferred, while subcutaneous administration is commonly used for DVT prevention, especially in immobile patients. Since heparin has a narrow therapeutic range, regular monitoring of the activated partial thromboplastin time, PTT, is essential. The therapeutic APTT range is typically 1.5 to 2.5 times the normal value. Normal, 25 to 35 seconds. Therapeutic, 46 to 70 seconds. For patients receiving intravenous heparin, a PTT should be checked every 6 hours, and dose adjustments should be made accordingly to maintain safe and effective anticoagulation. In cases of excessive anticoagulation or severe bleeding due to heparin, protamine sulfate serves as the antidote, effectively reversing its effects. This intervention is particularly critical in emergencies involving heparin overdose. A more predictable alternative to standard heparin is low molecular weight heparin, LMWH, such as enoxaparin. LMWH has several advantages, including a longer half-life, more stable anticoagulation, and the convenience of not requiring frequent APTT monitoring. It is commonly used for DVT and PE prophylaxis and is preferred over warfarin during pregnancy due to its safer profile. Administered as a subcutaneous injection, usually in the abdomen, LMWH provides a more convenient anticoagulation option for many patients. The most common adverse effect of heparin therapy is bleeding, which can manifest as bruising, hematuria, black tarry stools, nosebleeds, or excessive bleeding from minor cuts. A serious but less common complication is heparin-induced thrombocytopenia, HIT, an immune-mediated reaction that leads to a dangerous drop in platelet count and paradoxical clotting. Regular platelet count monitoring is essential, and if HIT occurs, heparin must be discontinued immediately and replaced with a non-heparin anticoagulant, such as argatrobin. Other potential complications include osteoporosis with long-term use and hypersensitivity reactions, such as fever, chills, or urticaria. Heparin should not be used in patients with active bleeding disorders, such as hemorrhagic stroke, gastrointestinal bleeding, or peptic ulcers. It is also contraindicated in severe thrombocytopenia, particularly in cases of HIT, and in uncontrolled hypertension due to the increased risk of brain hemorrhage. Additionally, patients who have recently undergone major surgery or trauma should avoid heparin due to the heightened risk of bleeding. Special caution is required in those receiving spinal or epidural anesthesia, as heparin use in such cases can lead to spinal hematoma, potentially resulting in paralysis. Certain medications can increase the risk of bleeding when taken alongside heparin, including NSAIDs, ibuprofen, naproxen, aspirin, and other anticoagulants. Therefore, concurrent use should be avoided unless specifically indicated by a healthcare provider. For patients self-administering subcutaneous heparin, proper technique is crucial. Injection sites should be rotated with the abdomen at least 2 inches from the umbilicus being the preferred area. Massaging the injection site should be avoided, as it can cause bruising. To minimize bleeding risks, patients should use a soft bristle toothbrush and an electric razor instead of a traditional blade. Additionally, they should be vigilant for signs of excessive bleeding, including unusual bruising, blood in the stool or urine, or persistent bleeding from minor cuts. Any sudden decrease in platelet count or signs of HIT, such as new clot formation or severe bruising, should be reported immediately. Now let's talk about ACE inhibitors. ACE inhibitors recognized by their -pril suffix, such as lisinopril, enalapril, captopril, ramipril, are widely used in the management of cardiovascular conditions. Their primary mechanism of action involves blocking the conversion of angiotensin I to angiotensin II, a potent vasoconstrictor. As a result, blood vessels relax, leading to vasodilation and a subsequent reduction in blood pressure. Additionally, these drugs decrease aldosterone secretion, which means less sodium and water retention while increasing potassium retention. Due to their effects, ACE inhibitors are commonly prescribed for several conditions. They serve as a first-line treatment for hypertension by effectively lowering blood pressure. In heart failure, they help by reducing the workload on the heart through decreased afterload. Following a myocardial infarction, they play a crucial role in preventing heart remodeling. Furthermore, in diabetic nephropathy, ACE inhibitors slow the progression of kidney damage, offering renal protection. However, in patients with chronic kidney disease, they must be used cautiously, as they can be both protective and potentially harmful, depending on the stage of kidney dysfunction. When administering ACE inhibitors, several nursing considerations must be kept in mind. Blood pressure should always be checked beforehand, and the medication should be withheld if the systolic BP is below 90 millimeters of mercury. Since these drugs increase potassium levels, regular monitoring is essential to prevent hyperkalemia. Additionally, kidney function should be assessed by checking creatinine and BUN levels, as ACE inhibitors may cause renal impairment. One of the most common complaints among patients is a persistent dry cough, which, if intolerable, may necessitate discontinuation. Moreover, patients should be monitored for orthostatic hypotension and educated to change positions slowly to prevent dizziness and falls. A particularly serious adverse effect to watch for is angioedema, which manifests as swelling of the face, lips, tongue, or throat. This is a life-threatening reaction requiring immediate discontinuation and emergency care. Additionally, ACE inhibitors are strictly contraindicated in pregnancy due to their potential to cause fetal harm. Patients should also be advised to avoid potassium-rich foods such as bananas, oranges, spinach, and potatoes to prevent excessive potassium accumulation. While ACE inhibitors offer significant benefits, they also come with potential side effects. The most common include dry cough, dizziness, and hypotension. More severe adverse effects include angioedema, hyperkalemia, which increases the risk of cardiac arrhythmias, acute kidney injury requiring close renal function monitoring, and reflex tachycardia, a temporary heart rate increase due to lowered blood pressure. Due to these risks, ACE inhibitors are contraindicated in specific conditions. They should not be used during pregnancy, in individuals with a history of angioedema, or in patients with severe kidney disease, as they can further impair renal function. Moreover, in those with bilateral renal artery stenosis, ACE inhibitors can lead to kidney failure. For patients who cannot tolerate ACE inhibitors, particularly those experiencing a persistent cough or angioedema, an alternative option is ARBs, angiotensin II receptor blockers. These medications, such as losartan and valsartan, work similarly but do not cause the dry cough associated with ACE inhibitors. From an NCLEX perspective, there are several key points to remember. If a patient reports swelling of the lips, tongue, or throat, the medication must be stopped immediately and emergency assistance should be sought. Blood pressure and potassium levels should always be checked before administration, and potassium supplements or potassium-sparing diuretics like spironolactone should be avoided to prevent hyperkalemia. Additionally, patients should be instructed to rise slowly to prevent falls due to orthostatic hypotension. Lastly, the use of NSAIDs, such as ibuprofen and naproxen, should be avoided, as these drugs can reduce the effectiveness of ACE inhibitors and worsen kidney function. Let's discuss CCB, calcium channel. Blockers, CCBs, play a crucial role in cardiovascular management by blocking calcium from entering cardiac and smooth muscle cells. This action leads to vasodilation, a decreased heart rate, and reduced myocardial contractility, ultimately easing the workload on the heart. In simpler terms, CCBs act like Valium for the heart, promoting relaxation and reducing strain. Due to these effects, they are primarily used for hypertension as they lower blood pressure, angina by reducing cardiac workload, atrial fibrillation and atrial flutter to control heart rate, and supraventricular tachycardia, SVT. Recognizing CCBs by their drug name patterns can aid in quick identification. Many of these medications end in -M, such as diltiazem, or -IN, like amlodipine, nifedipine, and verapamil. These drugs are further classified into two main types: dihydropyridines, DHPs, and non-dihydropyridines, non-DHPs. Dihydropyridines primarily target vascular smooth muscle, making them highly effective for hypertension and angina. Examples include amlodipine, nifedipine, and felodipine, which work by causing potent vasodilation with minimal effects on heart rate. However, they may lead to adverse effects such as reflex tachycardia, peripheral edema, and dizziness. On the other hand, non-dihydropyridines such as diltiazem and verapamil act on both the heart and blood vessels. These are best suited for conditions like atrial fibrillation, angina, and hypertension, as they slow the heart rate, reduce contractility, and provide mild vasodilation. Despite their benefits, they can cause bradycardia, heart block, and constipation, with verapamil being particularly associated with severe constipation. When administering CCBs, several key nursing considerations must be kept in mind. First, blood pressure should always be monitored before administration, and the medication should be held if systolic BP falls below 100 millimeters of mercury. Similarly, heart rate should be assessed, as CCBs, particularly non-DHPs, should be used with caution if HR drops below 60 beats per minute. Additionally, patients should be advised to avoid grapefruit juice as it can increase drug levels and lead to toxicity. Abrupt discontinuation of CCBs should also be avoided to prevent rebound hypertension. Moreover, patients with hypertension should steer clear of over-the-counter OTC cold medications containing decongestants like pseudoephedrine, which can cause vasoconstriction and worsen hypertension. Given that dizziness is a major side effect due to hypotension, fall risk precautions are essential, and patients should be instructed to change positions slowly. Common side effects of CCBs include dizziness, headache, flushing, and peripheral edema, while severe reactions may involve bradycardia, heart block, or constipation, particularly with verapamil. Due to these potential complications, CCBs are contraindicated in certain conditions, including heart failure, as some CCBs may exacerbate it, second or third degree AV block due to the risk of severe bradycardia, and hypotension, where further lowering of blood pressure could be dangerous. For the NCLEX exam, nurses should remember key priorities when dealing with CCBs. If a patient reports dizziness, the first step is to check blood pressure. If it's low, the medication should be held and the provider should be notified. Additionally, verapamil is the CCB most likely to cause constipation, and patients should be advised to avoid grapefruit juice while taking these medications to prevent toxicity. Now, we will read about beta blockers. Beta blockers are a class of medications primarily used to lower heart rate, reduce blood pressure, and decrease the workload on the heart. By blocking the effects of adrenaline on beta receptors, these drugs help manage several cardiovascular conditions. They are commonly prescribed for hypertension to lower blood pressure, angina to relieve chest pain, and arrhythmias to regulate irregular heartbeats. Additionally, they play a crucial role in preventing future heart issues after a heart attack, managing certain cases of heart failure, and even lowering eye pressure in glaucoma patients. Beyond cardiovascular uses, beta blockers are also effective in preventing migraines. There are two main categories of beta blockers, cardioselective and non-selective. Cardioselective beta blockers, such as metoprolol, atenolol, and esmolol, primarily affect the heart and are considered safer for asthma patients. In contrast, non-selective beta blockers, including propranolol, timolol, used in glaucoma, and nadolol, affect both the heart and lungs, making them unsuitable for individuals with asthma or chronic obstructive pulmonary disease, COPD, due to their potential to cause bronchospasms. However, beta blockers are contraindicated in certain conditions. Patients with asthma or COPD should avoid them as they can cause wheezing and breathing difficulties. Similarly, those with bradycardia or a slow heart rate should not take beta blockers as they can further reduce heart rate to dangerously low levels. They are also not recommended for individuals with hypotension as they may further decrease blood pressure, and those with second or third degree heart block since they can worsen conduction issues. Furthermore, diabetic patients should use them cautiously because beta blockers can mask the typical symptoms of low blood sugar, such as an increased heart rate, making hypoglycemia harder to detect. When administering beta blockers, it is essential to monitor for potential side effects. Bradycardia, or a slow heart rate, requires checking the patient's pulse before administration, with the medication being withheld if the heart rate is below 60 beats per minute. Hypotension necessitates monitoring blood pressure, and the drug should be withheld if systolic blood pressure drops below 90 millimeters of mercury. Additionally, non-selective beta blockers can cause bronchospasms, making it critical to avoid their use in asthma patients and to monitor for wheezing or difficulty breathing. Fatigue and dizziness are common initially, but often improve over time. Another important consideration is that beta blockers can mask symptoms of hypoglycemia, meaning diabetic patients should be monitored for sweating and confusion rather than relying solely on heart rate. Moreover, erectile dysfunction is a known side effect that may impact medication adherence. To ensure patient safety, several key nursing considerations should be followed. Heart rate and blood pressure should always be checked before administering beta blockers, with the medication held if the heart rate is below 60 or blood pressure is below 90 over 60 millimeters of mercury. Patients should never stop taking beta blockers abruptly, as this can cause rebound hypertension and tachycardia. For asthma and COPD patients, these drugs should generally be avoided due to the risk of bronchospasm. Diabetic patients must be educated on the potential for beta blockers to mask symptoms of low blood sugar. Lastly, informing patients about possible dizziness and fatigue is important, as these side effects are typically temporary and improve over time. Let's move to most important topic, digoxin. Digoxin is a cardiac glycoside that plays a crucial role in increasing the strength of heart contractions, known as a positive inotropic effect. At the same time, it slows the heart rate and conduction through the AV node, demonstrating a negative chronotropic and dromotropic effect. As a result, digoxin reduces the overall workload of the heart. However, it is important to note that digoxin is not a vasodilator, meaning it does not directly widen blood vessels. Clinically, digoxin is primarily used for two conditions: heart failure and atrial fibrillation, AFib. In heart failure, it enhances the efficiency of the heart's pumping ability, thereby improving circulation and reducing symptoms. In atrial fibrillation, it slows down the rapid heart rate by affecting AV node conduction, helping to maintain a more stable heart rhythm. Since digoxin is excreted primarily through the kidneys, it is essential to monitor kidney function by checking creatinine and blood urea nitrogen, BUN, levels. Patients with impaired kidney function are at a significantly higher risk of digoxin toxicity, as the drug can accumulate in the body when not adequately excreted. Digoxin toxicity occurs when levels exceed 2.0 nanograms per milliliter, leading to a range of symptoms that progress in severity. The earliest signs are gastrointestinal, GI, symptoms, including nausea, vomiting, loss of appetite, anorexia, and abdominal pain. As toxicity worsens, neurological symptoms may appear, such as confusion, weakness, and dizziness. Visual disturbances, such as blurred vision, yellow-green halos, or color changes, occur later and are considered a late warning sign. The most dangerous complications of toxicity involve cardiac arrhythmias, including bradycardia, heart blocks, and life-threatening ventricular arrhythmias. A key factor that increases the risk of digoxin toxicity is hypokalemia, low potassium levels. Since low potassium enhances the drug's effects on the heart, it is crucial to monitor potassium levels, ensuring they remain within the normal range of 3.5 to 5.0 milliequivalents per liter. If potassium is low, the risk of toxicity significantly increases, making electrolyte balance a critical aspect of digoxin therapy. Certain patients should not receive digoxin due to an increased risk of adverse effects. Contraindications include bradycardia, HR less than 60 beats per minute, as digoxin slows the heart further, kidney disease, which can lead to drug accumulation, hypokalemia, which heightens toxicity risk, and heart blocks, where further conduction slowing could be dangerous. Before administering digoxin, nurses must complete several important pre-administration checks. First, the apical pulse must be measured for 1 full minute, and digoxin should be held if the heart rate is below 60 beats per minute. Additionally, digoxin levels should be checked to ensure they remain within the therapeutic range of 0.5 to 2.0 nanograms per milliliter. Potassium levels must also be evaluated, as low potassium increases the likelihood of toxicity. Finally, kidney function tests, creatinine and BUN, should be reviewed to assess proper drug excretion. If digoxin toxicity is suspected, immediate intervention is required. If a patient presents with a digoxin level above 2.0 nanograms per milliliter, along with symptoms, the drug should be stopped immediately. Continuous heart rhythm monitoring is necessary due to the risk of life-threatening arrhythmias. Electrolyte imbalances, particularly potassium levels, must be corrected to reduce toxicity effects. In cases of severe digoxin toxicity, the antidote, digoxin immune fab, Digibind, is administered to counteract the drug's effects and restore normal cardiac function. Key nursing considerations include consistently monitoring the heart rate before administration, holding the drug if the HR is below 60 beats per minute, and regularly checking digoxin and potassium levels to ensure safe therapeutic ranges. Early signs of toxicity, particularly gastrointestinal symptoms, should not be overlooked. Patients should be educated on recognizing vision changes, nausea, or dizziness as potential warning signs and instructed to avoid over-the-counter medications that lower potassium, such as diuretics and steroids. A common NCLEX practice question related to digoxin administration asks, a nurse is preparing to administer digoxin to a patient. Which finding should make the nurse hold the medication? A. Potassium level of 4.0 milliequivalents per liter. B. Digoxin level of 1.5 nanograms per milliliter. C. Heart rate of 52 beats per minute. D. Blood pressure of 140 over 88 millimeters of mercury. The correct answer is C. Heart rate of 52 beats per minute, because digoxin slows the heart rate. If the HR is below 60 beats per minute, the dose should be held, and the provider should be notified to prevent severe bradycardia or conduction abnormalities. Now, we will read about nitroglycerin. Nitroglycerin is one of the most important drugs frequently tested on the NCLEX exam. It is a powerful vasodilator, meaning it widens blood vessels, which helps decrease preload, the workload of the heart, and improves blood flow to the heart. However, due to its strong vasodilatory effects, it puts patients at risk for hypotension, making blood pressure monitoring crucial. Uses, indications. Nitroglycerin is primarily used for angina, chest pain, because it improves oxygen delivery to the heart, relieving discomfort. It is also beneficial in heart failure, as it reduces the strain on the heart by decreasing preload. Additionally, it plays a critical role in hypertensive emergencies where rapid blood pressure reduction is necessary. How to take sublingual nitroglycerin, SL tablet or spray. For sublingual administration, the standard dosage is 1 pill every 5 minutes, with a maximum of 3 doses. If chest pain is not relieved after the first dose, the patient must call emergency services, 911, immediately. It is crucial to remember that the pill should not be swallowed, but rather placed under the tongue for rapid absorption. Patients should avoid eating or drinking until the medication has fully dissolved. Common side effects. Like any medication, nitroglycerin has side effects. Headache is a common and expected reaction due to blood vessel dilation. Additionally, flushing, redness of the face, occurs because of blood vessel relaxation. Patients may also experience dizziness and lightheadedness, increasing the risk of falls due to hypotension. A tingling sensation under the tongue is normal and indicates that the medication is working effectively. Nursing considerations: nurses must closely monitor patients taking nitroglycerin. If a patient reports dizziness or lightheadedness, this signals a risk for falls, requiring further assessment. Additionally, a significant drop in blood pressure is a serious concern, so checking blood pressure before administration is essential. Precautions. Before giving nitroglycerin before administering nitroglycerin, it is crucial to check the patient's blood pressure. The drug should be held if the systolic blood pressure, SBP, is below 90 millimeters of mercury to prevent severe hypotension. Another critical precaution is assessing whether the patient is taking erectile dysfunction, ED medications such as sildenafil, Viagra. If the patient has taken Viagra within the last 24 to 48 hours, nitroglycerin should not be given, as the combination can lead to life-threatening hypotension. Patient education: to ensure patient safety, certain key instructions must be provided. Patients should sit or lie down before taking nitroglycerin to prevent falls caused by dizziness. The medication should be stored in a cool, dark place, away from heat and light, to maintain its potency. Additionally, nitroglycerin tablets must be replaced every 6 months. As older pills lose effectiveness, alcohol should be avoided as it further increases the risk of low blood pressure. NCLEX practice. Question: a patient with chest pain is given nitroglycerin. Which statement by the patient requires further teaching? A. I will call 911 if my chest pain doesn't go away after one pill. B. I should keep my medication in a cool, dark place. C. If I get a headache, I should stop taking the medication. D. I should sit down before taking the medication. Correct answer: C. If I get a headache, I should stop taking the medication. Headache is a common side effect of nitroglycerin. The patient should not stop taking the medication due to this side effect. Moving to next drug. NSAIDs, or non-steroidal anti-inflammatory drugs, are among the most commonly tested medications on the NCLEX exam. These drugs play a crucial role in reducing pain, inflammation, and fever. However, they also come with serious risks that must be carefully managed. Some of the most commonly used NSAIDs include ibuprofen, naproxen, aspirin, indomethacin, and ketorolac, with the latter being particularly known for its high risk of kidney injury. One of the most significant risks associated with NSAIDs is gastrointestinal bleeding and peptic ulcers. Patients taking NSAIDs may experience symptoms such as black, tarry stools, melena, stomach pain, and hematemesis, vomiting blood. To minimize these risks, it is advisable to take NSAIDs with food to reduce stomach irritation, avoid alcohol as it increases the likelihood of GI bleeding, and consider using a proton pump inhibitor, PPI, like omeprazole, for long-term NSAID therapy. In addition to GI complications, NSAIDs pose a risk of kidney injury, nephrotoxicity, by reducing blood flow to the kidneys. This makes it essential to monitor kidney function through blood urea nitrogen, BUN, and creatinine levels, especially in patients with pre-existing kidney disease or dehydration, as these conditions further increase the risk of kidney damage. Another major concern is the impact of NSAIDs on cardiovascular health. These medications can cause fluid retention, leading to increased blood pressure and worsening heart failure. Therefore, it is crucial to monitor blood pressure, particularly in hypertensive patients, and avoid NSAIDs in those with heart failure. In cases where pain management is necessary, acetaminophen is often a safer alternative. Furthermore, NSAIDs increase the risk of bleeding by inhibiting platelet function. This is particularly concerning for patients taking blood thinners such as warfarin or heparin, as well as those scheduled for surgery. Signs of excessive bleeding, including bruising, prolonged bleeding, or black stools, should be closely monitored. Given these risks, certain patient groups should completely avoid NSAIDs. These include individuals with a history of peptic ulcers or GI bleeding, those with kidney disease, patients with hypertension or heart failure, individuals taking blood thinners, and COPD patients, as aspirin can trigger bronchospasms. To reinforce this knowledge, consider the following NCLEX-style question. A nurse is caring for a patient with chronic pain and hypertension who takes NSAIDs daily. Which finding requires immediate follow-up? The options are A. Blood pressure of 152 over 90 millimeters of mercury. B. Mild stomach discomfort after eating. C. Black tarry stool. Or D. Swelling in the feet after standing all day. The correct answer is C. Black, tarry stool, as it indicates GI bleeding, a serious complication requiring urgent intervention. Now we will discuss tissue plasminogen activator. TAEPA is a powerful clot-busting drug classified as a thrombolytic. It is primarily used in the treatment of ischemic stroke, myocardial infarction, and pulmonary embolism. However, its effectiveness is time-dependent, as it must be administered within 3 to 4.5 hours of symptom onset to maximize benefits and minimize complications. Despite its life-saving potential, TPA carries significant risks, particularly in patients with conditions that increase the likelihood of severe bleeding. For this reason, it is contraindicated in individuals who have undergone recent surgery within the past 2 weeks, as they face an elevated risk of hemorrhage. Additionally, patients with platelet counts below 100,000 or those with coagulation disorders are at an increased risk of uncontrolled bleeding, making TPA an unsuitable treatment for them. Due to the high potential for bleeding complications, it is essential to closely monitor patients receiving TPA. Neurological assessments are particularly important, as any changes in mental status could indicate a brain bleed. To further reduce the risk of bleeding, invasive procedures such as intramuscular injections and Foley catheter insertions should be avoided whenever possible. One of the most critical NCLEX tips regarding TPA is that it should never be given for a hemorrhagic stroke. Since TPA dissolves clots, administering it to a patient with active bleeding could lead to catastrophic consequences. Therefore, it is crucial to rule out hemorrhagic stroke with a CT scan before initiating TPA therapy. One of the most important drugs frequently tested on the NCLEX exam is ferrous sulfate, an iron supplement used to treat iron deficiency anemia. To ensure optimal absorption, it should be taken on an empty stomach, ideally 1 hour before or 2 hours after meals. However, certain substances can interfere with its effectiveness. For instance, calcium and antacids reduce iron absorption, so it should never be taken with milk or dairy products. On the other hand, vitamin C enhances absorption, making it beneficial to take iron supplements with orange juice or another source of vitamin C. While ferrous sulfate is effective, it also comes with some common side effects. Constipation is a frequent issue, so patients should be encouraged to increase their fluid and fiber intake. Another common concern is dark or tarry stools, but this is a normal effect of iron supplementation and not a sign of bleeding. Some individuals may experience gastrointestinal upset, including nausea and stomach pain. In such cases, taking iron with food may help, although it can slightly decrease absorption. For NCLEX preparation, it is also essential to remember a few key safety tips. When taking liquid iron, using a straw can prevent teeth staining. Additionally, since iron supplements can be toxic in high doses, they should always be stored out of reach of children to prevent accidental ingestion. Moving to the most important drug category, corticosteroids play a crucial role in reducing inflammation and are commonly used for conditions such as COPD, asthma, and autoimmune diseases. In addition to their anti-inflammatory properties, they also suppress the immune system, making them effective in managing various medical conditions. Some commonly prescribed corticosteroid drugs include prednisone, which is taken orally, and dexamethasone, which can be administered either orally or intravenously. Hydrocortisone is available in oral, intravenous, and topical forms, while methylprednisolone, Solu-Medrol, is given intravenously. Additionally, fluticasone is an inhaled corticosteroid frequently used for respiratory conditions. A key consideration when administering corticosteroids is their effect on blood sugar levels, as they can cause an increase in blood glucose. Therefore, it is essential to monitor glucose levels, particularly in diabetic patients who may require adjustments in their insulin dosage. Another critical point is that corticosteroids must be tapered slowly and never stopped abruptly, as sudden discontinuation can lead to adrenal insufficiency. Corticosteroids also come with several common side effects, including hyperglycemia, which results in high blood sugar levels, as well as weight gain and fluid retention. Due to their immunosuppressive effects, they increase the risk of infections, making patients more susceptible to illnesses. Long-term use can also weaken bones, leading to osteoporosis. Because of these risks, an important NCLEX tip is that patients on long-term corticosteroid therapy should report any signs of infection, such as fever or sore throat, since their immune response may be suppressed. Now, we will explore anti-tubercular drugs. Anti-tubercular drugs play a crucial role in treating tuberculosis by either killing or inhibiting the growth of Mycobacterium tuberculosis. These medications are used for both active and latent TB, ensuring effective disease management. The most commonly used anti-tubercular drugs follow the RIPE therapy regimen, which includes rifampin, isoniazid, pyrazinamide, and ethambutol. Each of these drugs has specific considerations that nurses must be aware of to ensure patient safety and treatment efficacy. One of the most critical nursing considerations is the risk of liver toxicity, hepatotoxicity, which necessitates monitoring liver function tests, including AST and ALT. To prevent further liver damage, patients should strictly avoid alcohol and acetaminophen. Another significant side effect is peripheral neuropathy, primarily associated with isoniazid, INH. To mitigate this risk, vitamin B6, pyridoxine, should be administered to prevent nerve damage. Additionally, rifampin is known to turn body fluids orange, a harmless but notable side effect that does not require discontinuation of the medication. However, patients should be informed that this discoloration can stain contact lenses and clothing. Furthermore, ethambutol can cause vision problems, including blurred vision and changes in color perception, particularly green-red color blindness. Any visual disturbances should be promptly reported to a healthcare provider. Patient education is essential for successful TB treatment. To ensure optimal drug absorption, patients should take their medications on an empty stomach. Since these drugs can cause liver damage, alcohol must be strictly avoided. Completing the full course of treatment, which typically lasts 6 to 9 months, is crucial, as stopping early can lead to drug resistance. Moreover, women taking rifampin should be advised to use backup birth control methods, as the drug reduces the effectiveness of oral contraceptives. A key NCLEX tip involves a patient on isoniazid who reports tingling in the hands and feet. In this situation, the nurse should administer vitamin B6, pyridoxine, to prevent neuropathy, ensuring the patient remains safe while continuing their TB treatment. Now, we will read about tetracycline. Tetracycline is an antibiotic used to treat bacterial infections, including skin infections, respiratory infections, sexually transmitted infections, and Lyme disease. When administering tetracycline, it is crucial to take it on an empty stomach, ideally 1 hour before or 2 hours after meals, to ensure optimal absorption. Additionally, patients must avoid consuming dairy products, iron supplements, or antacids, as these substances significantly reduce drug absorption. To prevent complications such as esophagitis and ulcers, tetracycline should always be taken with a full glass of water. Another key consideration is the risk of photosensitivity, which makes patients more susceptible to sunburn. Therefore, they should be advised to wear sunscreen and avoid prolonged sun exposure. Furthermore, tetracycline decreases the effectiveness of birth control, making it essential for patients to use additional contraception as a backup method. Patients must also be educated on avoiding tetracycline before bedtime due to the increased risk of esophageal irritation. Completing the full course of antibiotics is critical to prevent antibiotic resistance, and pregnant women or children under 8 should not take this medication, as it can cause permanent tooth discoloration. A vital NCLEX tip involves recognizing the signs of a photosensitivity reaction. If a patient taking tetracycline reports severe sunburn after brief sun exposure, the nurse should emphasize the importance of wearing sunscreen and protective clothing to minimize the risk of further skin damage. Adenosine is the first-line drug for supraventricular tachycardia, and it must be administered as a rapid intravenous push within 1 to 2 seconds, immediately followed by a saline flush. It is crucial to use a large-bore IV access in a vein closest to the heart, such as the antecubital vein. Patients may experience transient asystole, flushing, dizziness, or chest discomfort, which are expected side effects. Continuous ECG monitoring is essential during administration to ensure patient safety. Moving on to nicardipine, a calcium channel blocker and vasodilator, it is used to rapidly lower blood pressure in cases of severe hypertension, such as post-stroke situations where systolic blood pressure exceeds 240 millimeters of mercury. However, blood pressure should not drop below 170 millimeters of mercury to maintain adequate cerebral perfusion. The priority intervention is to monitor for hypotension, dizziness, and reflex tachycardia. This medication is administered via IV infusion, and the dose must be carefully titrated. Similarly, angiotensin II receptor blockers, ARBs, recognized by their sartan suffix, such as losartan, are used for hypertension, heart failure, and kidney protection in diabetics. However, these drugs are contraindicated in pregnancy due to the potential for fetal harm. A key concern with ORBs is the risk of hyperkalemia, necessitating regular potassium level monitoring. Additionally, patients should avoid salt substitutes, as they often contain potassium. On the other hand, clopidogrel, an antiplatelet agent, prevents platelet aggregation, thereby reducing the risk of stroke and heart attack. Before any surgery, it should be discontinued 5 to 7 days in advance to minimize bleeding risk. Monitoring platelet count is essential, and any count below 150,000 should be reported to a healthcare provider. Due to its mechanism of action, clopidogrel increases bleeding risk, requiring vigilance for signs such as bruising, gastrointestinal bleeding, or hematuria. When considering cholesterol management, statins play a vital role in lowering LDL cholesterol, total cholesterol, and triglycerides. These medications should be taken at night with an evening meal for optimal absorption. However, a serious side effect includes muscle aches or weakness, which could indicate rhabdomyolysis and should be reported immediately. Additionally, liver function should be assessed before initiating therapy. For hypothyroidism treatment, levothyroxine is the standard therapy as it replaces thyroid hormone deficiency. It is safe during pregnancy and crucial for fetal brain development. Patients must take it on an empty stomach in the morning, separate from other medications to enhance absorption. Certain substances, including calcium, iron, and antacids, should be avoided due to their interference with drug absorption. Since levothyroxine is a lifelong therapy, regular TSH monitoring is required, with noticeable improvement in symptoms within 3 to 4 weeks and full effect in 6 to 8 weeks. Shifting focus to desmopressin, this medication mimics antidiuretic hormone, ADH, and reduces urine output. It is used in conditions such as diabetes insipidus, bedwetting, and bleeding disorders. However, close monitoring is necessary to prevent water intoxication and hyponatremia, which can manifest as headache, confusion, or weakness. Severe hyponatremia can lead to seizures, coma, or even death, making it a critical side effect to watch for. Methotrexate, commonly used for rheumatoid arthritis and psoriasis, functions as an immunosuppressant that reduces inflammation but also increases the risk of infection. Live vaccines should be avoided, with only killed vaccines such as flu and pneumonia vaccines being permitted. Additionally, alcohol consumption must be avoided due to the risk of hepatotoxicity. Since methotrexate is highly teratogenic, strict contraception is necessary to prevent pregnancy. Another concern is bone marrow suppression, necessitating regular CBC monitoring to assess for anemia, infection, or bleeding risks. In terms of neurological medications, levetiracetam, Precis Keppra, is an anticonvulsant used for seizure prevention. Patients may experience drowsiness and fatigue, which usually improve after a few weeks. However, it is crucial to monitor for suicidal ideation and report any behavioral changes. Furthermore, a serious adverse reaction is Stevens-Johnson syndrome, so any rash must be reported immediately. Driving restrictions apply until clearance from a healthcare provider is obtained. For migraine relief, sumatriptan works by vasoconstricting cranial blood vessels. However, it is contraindicated in patients with coronary artery disease, CAD, and uncontrolled hypertension due to the risk of heart attack or stroke. Common side effects include chest pressure, flushing, and dizziness, which require monitoring. Regarding motion sickness prevention, scopolamine is a transdermal patch that should be applied at least 4 hours before travel. It remains effective for 72 hours and should be placed behind the ear. Patients must avoid touching their eyes after handling the patch, as it can cause pupil dilation, mydriasis. Phenytoin, an anti-seizure medication, has a therapeutic range of 10 to 20 micrograms per milliliter. Tube feedings decrease its absorption, so it is recommended to pause feedings 1 to 2 hours before and after administration. Early signs of toxicity include nystagmus, abnormal eye movements, and gait instability. Additionally, a common side effect is gingival hyperplasia, requiring good oral hygiene. Now, benzodiazepines used for anxiety and sedation are typically taken at bedtime due to their sedative effects. Abrupt discontinuation should be avoided, as it may lead to withdrawal symptoms, including seizures. Midazolam is a benzodiazepine commonly used for conscious sedation during procedures, and in cases of overdose, flumazenil serves as the antidote. Linezolid should be avoided with concurrent use of SSRIs to prevent serotonin syndrome, which presents with symptoms such as agitation, hypertension, tachycardia, and tremors. Similarly, macrolide antibiotics like azithromycin, erythromycin, and clarithromycin may cause prolonged QT intervals, increasing the risk of cardiac arrhythmias. Therefore, ECG monitoring is essential, especially in patients with pre-existing heart conditions. Additionally, these antibiotics can lead to hepatotoxicity, necessitating monitoring of liver enzymes AST, ALT. For intravenous vancomycin, trough levels 10 to 20 micrograms per milliliter must be checked before administration. The infusion should be given slowly over at least 60 minutes to prevent red man syndrome, which manifests as flushing, rash, and hypotension. Monitoring blood pressure is crucial, as rapid infusion may lead to hypotension. Furthermore, assessing for hypersensitivity reactions such as rash, itching, and difficulty breathing is important. Severe reactions like anaphylaxis, which includes wheezing, swelling, and angioedema, should also be monitored. Checking the IV site every 30 minutes is necessary to detect phlebitis, and for long-term use, a central venous catheter is preferred. Since vancomycin is nephrotoxic, creatinine levels must be monitored, as elevated creatinine indicates toxicity. Docusate sodium is a stool softener that prevents straining, thereby reducing stress on the heart. This is particularly important because straining can stimulate the vagus nerve, leading to a risk of bradycardia, especially in cardiac patients. In contrast, furosemide, Lasix, is a commonly used diuretic for heart failure and fluid overload. However, potassium levels should be closely monitored due to the risk of hypokalemia. Additionally, rapid intravenous push administration can cause ototoxicity, which presents as tinnitus and hearing loss. Ginkgo biloba increases the risk of bleeding, requiring caution when used with anticoagulants, such as warfarin and aspirin. Celecoxib, a COX-2 inhibitor, carries a black box warning due to its increased risk of cardiovascular complications, including myocardial infarction and stroke. It is important to monitor for symptoms such as back pain, nausea, and vomiting, as these may indicate cardiac issues. Morphine, on the other hand, reduces cardiac workload by decreasing preload and afterload and is used for pain management as well as terminal dyspnea, in end-stage respiratory distress. Lidocaine, when used intravenously, decreases cardiac irritability and is indicated for ventricular arrhythmias such as ventricular tachycardia. For transdermal patches, general guidelines include avoiding shaving the skin before application to prevent irritation, rotating sites to minimize skin irritation, and avoiding heat application over the patch, as it can increase absorption and lead to overdose. Specifically, clonidine, an antihypertensive patch, should be applied every 7 days, and if dizziness occurs, it should not be removed as this is an expected side effect. Additionally, rotating the application site with each use is necessary to prevent skin irritation. Potassium chloride, KCl, is available in various forms, including liquid, IV, and extended-release tablets. If a patient has difficulty swallowing, a pharmacist should be consulted for alternative forms. Importantly, extended-release tablets should never be crushed. When administered intravenously, KCl must be given slowly to avoid cardiac complications. Similarly, the fentanyl patch must be changed every 72 hours, and to prevent misuse, it should be folded before discarding. Cutting the patch is not advised as it alters drug release, and applying heat over it should be avoided due to the risk of overdose. When administering eardrops, the technique varies based on age. For children older than 3 years, the ear should be pulled up and back, while for children younger than 3, it should be pulled down and back. After administration, the child should be positioned prone or supine, and the drop should be warmed to room temperature to prevent discomfort. The medication should be dropped against the ear canal wall to minimize irritation. For rectal suppository administration, age-appropriate distraction techniques should be used. Infants should be positioned supine with knees and feet raised. Older children should be placed in a side-lying position with knees bent, and toddlers should be engaged with toys. Preschoolers and older children can be encouraged to take deep breaths or count during the procedure. Using a water-soluble lubricant facilitates insertion, and for children under 3 years, the fifth finger, pinky, should be used. Holding the buttocks together briefly after insertion ensures proper absorption. Patient-controlled analgesia, PCA, pumps require Y tubing connected with normal saline to keep the vein open. Continuous IV fluids are necessary for proper function, and children can use PCA pumps if they understand how they work. Aminophylline, a bronchodilator, has a therapeutic range of 10 to 20 micrograms per milliliter, with levels above 20 indicating toxicity. Signs of toxicity include seizures, nausea, tachycardia, and arrhythmias. Isotretinoin, Accutane, used for severe cystic acne resistant to other treatments, requires special precautions. Patients should not take vitamin A supplements due to the risk of toxicity. Additionally, blood donation is not allowed while on the medication. Since isotretinoin is highly teratogenic, requiring 2 forms of contraception is mandatory to prevent severe birth defects. Thank you for watching this. Before we move ahead, let me take a quick moment to tell you something that could completely change your NCLEX journey. If you're serious about passing the NCLEX in just 1 week or even within a month, then the smartest move you can make right now is to enroll in our complete online NCLEX crash course. This isn't just another course, it's a shortcut, a clear step-by-step roadmap that has already helped over 100,000 nursing students pass the NCLEX with confidence. And here's the most incredible part. Not a single student who completed this course has failed. Yes, that's a 100% passing rate. We built this course based entirely on the feedback and insights of thousands of nurses who've successfully cleared the NCLEX in the last 5 years. That means we've removed all the fluff and focused only on what truly matters for your exam. Here's exactly what you'll get when you enroll. You'll get 100 hours of animated crash course content designed for rapid revision, 500 hours of comprehensive recorded lectures covering all the high-yield topics, and access to 10,000 real NCLEX questions to sharpen your test-taking skills. You'll also get 500 next-gen case-based questions to strengthen your clinical judgment, along with 15 full-length practice tests that simulate the real NCLEX experience. And of course, you'll receive our complete NCLEX ebook and PDF notes, plus 1 full year of access, so you can study at your pace on your schedule. And yes, we're currently offering a 70% discount for a very short period. Once the offer ends, it's gone. Thousands of students are enrolling in our online NCLEX course every month and passing the exam, but if you don't enroll now, you risk being left behind. Spots are filling fast and only a few seats are left. Visit our website to enroll now. Link is given in description box. Let's continue the video. Welcome to the Maternity NCLEX Fast Track course. If you're short on time, this course is for you. Master key maternity concepts quickly and efficiently. Let's get started. Blood pressure monitoring in pregnancy is crucial, and nurses should closely observe pregnant clients' blood pressure levels. Normally, blood pressure decreases gradually during the 2nd trimester and returns to pre-pregnancy levels in the 3rd trimester. However, an increase of more than 15 millimeters of mercury in diastolic BP or more than 30 millimeters of mercury in systolic BP before 32 weeks is concerning, as it may indicate gestational hypertension or preeclampsia. When managing syphilis during pregnancy, the gold standard treatment is an intramuscular injection of benzathine penicillin G. If a patient is allergic to penicillin, desensitization is necessary, as penicillin is the only safe and effective option for treating syphilis during pregnancy. Failure to treat syphilis significantly increases the risk of miscarriage, stillbirth, preterm birth, and congenital syphilis in the newborn. For estimating the due date, Nagel's rule can be applied using 2 methods. The first method involves taking the first day of the last menstrual period, LMP, adding 9 months, and then adding 7 days. The second method requires subtracting 3 months from the first day of the LMP and then adding 7 days. However, it is essential to confirm the estimated due date with an ultrasound, particularly in cases of irregular menstrual cycles. Weight gain recommendations during pregnancy vary depending on the trimester and pre-pregnancy BMI. In the first trimester, the expected weight gain is approximately 1 pound per month, totaling around 3 to 4 pounds. During the 2nd and 3rd trimesters, the recommended weight gain is about 1 pound per week. The total weight gain should be 28 to 40 pounds for underweight women, 25 to 35 pounds for those with a normal BMI, 15 to 25 pounds for overweight women, and 11 to 20 pounds for obese women. A quick formula to estimate ideal weight gain is week of gestation minus 9. Constipation is a common issue during pregnancy due to increased progesterone levels, which decrease gastric motility, and iron supplements, which may contribute to constipation. Management strategies include consuming a high-fiber diet with whole grains, fruits, and vegetables, increasing fluid intake, engaging in regular exercise, and using bulk-forming fiber supplements such as psyllium. However, pregnant individuals should avoid tea, soda, and caffeine as they can worsen dehydration, and they should not take iron supplements with dairy products as this reduces iron absorption. Regarding alcohol consumption during pregnancy, no amount of alcohol is considered safe. Exposure to alcohol increases the risk of fetal alcohol syndrome, FAS, which can lead to microcephaly, developmental delays, facial abnormalities, and cognitive impairment. Nurses should educate clients to stop drinking before conception to prevent teratogenic effects. Oligohydramnios, defined as an amniotic fluid index AFI of less than 5 centimeters, can result from placental insufficiency, premature rupture of membranes, PROM, or fetal renal abnormalities such as renal agenesis or Potter syndrome. This condition can lead to complications, including umbilical cord compression, which causes variable decelerations on fetal heart rate monitoring, pulmonary hypoplasia if oligohydramnios occurs early, and restricted fetal movement, which may result in limb contractures. Diagnosis is confirmed via ultrasound, and management strategies include amnioinfusion in cases of fetal distress, close monitoring of fetal growth and well-being, and hydration therapy using oral or IV fluids for mild cases. Anemia in pregnancy is a common complication, often resulting from iron deficiency. The diagnostic criteria include hemoglobin levels below 11 grams per deciliter in the first and third trimesters or below 10.5 grams per deciliter in the second trimester, while a hematocrit level below 33% also indicates anemia. One notable symptom associated with iron deficiency anemia is pica, which refers to an abnormal craving for non-nutritive substances such as ice, clay, or starch. To diagnose anemia, healthcare providers order hemoglobin and hematocrit tests as a screening measure. Management involves iron supplementation, which is best absorbed when taken with vitamin C. Additionally, consuming iron-rich foods such as red meat, poultry, fish, leafy green vegetables, beans, lentils, and iron-fortified cereals is essential. However, calcium-rich foods like milk and cheese should be avoided around the time of iron intake, as they can inhibit absorption. Proper nutrition during pregnancy is crucial, with essential nutrients playing a key role in maternal and fetal health. Folic acid, found in leafy greens, citrus fruits, beans, and fortified cereals, helps prevent neural tube defects. Iron, which prevents anemia, is abundant in red meat, spinach, legumes, and fortified grains. Whole grains such as brown rice, whole wheat bread, and oats provide energy and aid digestion, while omega-3 fatty acids from sources like salmon, flax seeds, and walnuts support fetal brain development. Conversely, certain foods should be avoided due to potential risks. Unpasteurized dairy poses a listeria risk, while raw or undercooked meat, eggs, and fish increase the chances of salmonella and toxoplasmosis infections. Deli meats and hot dogs should be reheated to steaming to eliminate the risk of listeria. High mercury fish, including shark, swordfish, king mackerel, and tilefish, should also be avoided, along with liver, as excessive vitamin A intake can lead to birth defects. Hypertensive disorders in pregnancy require careful monitoring, as they pose risks to both the mother and baby. Gestational hypertension is characterized by new-onset blood pressure of 140/90 millimeters of mercury or higher after 20 weeks of gestation without proteinuria or end organ damage. Preeclampsia, on the other hand, presents with elevated blood pressure along with proteinuria or signs of organ dysfunction such as elevated liver enzymes and renal impairment. Symptoms include headaches, facial swelling, and visual disturbances like blurry vision and scotomas. If preeclampsia progresses to eclampsia, which is marked by seizures, it becomes a medical emergency, requiring magnesium sulfate to prevent further seizures. Another serious condition in pregnancy is disseminated intravascular coagulation, DIC, which is associated with high risk factors such as placental abruption, fetal demise, severe preeclampsia, and amniotic fluid embolism. The underlying pathophysiology involves widespread clotting that depletes clotting factors, leading to uncontrolled bleeding. Clinical manifestations include excessive bleeding at IV sites, gums, and surgical wounds, as well as internal bleeding indicated by petechiae, ecchymosis, and hematuria. Additionally, patients may exhibit shock symptoms such as hypotension and tachycardia. Management involves obtaining baseline coagulation labs, including PT, a PTT, fibrinogen, platelets, and D-dimer levels, along with the administration of blood products such as fresh frozen plasma and platelets. Ectopic pregnancy, where a fertilized egg implants outside the uterus, most commonly in the fallopian tube, is another critical condition requiring prompt intervention. Symptoms include severe unilateral abdominal or pelvic pain, as well as referred shoulder pain due to blood irritating the diaphragm. If rupture occurs, patients may develop hypotension, dizziness, and tachycardia, necessitating emergency surgery. In cases where the ectopic pregnancy is unruptured and there is no fetal cardiac activity, methotrexate is administered as a medical management option. However, a ruptured ectopic pregnancy requires emergency laparoscopic surgery to prevent further complications. Fetal heart rate monitoring is essential for assessing fetal well-being. It can be detected via Doppler as early as 10 to 12 weeks of gestation, with a normal fetal heart rate ranging between 110 and 160 beats per minute. Abnormal patterns indicate potential complications such as bradycardia, defined as a fetal heart rate below 110 beats per minute, which may be caused by fetal hypoxia, maternal hypotension, or umbilical cord compression. Conversely, tachycardia, characterized by a fetal heart rate exceeding 160 beats per minute, can result from maternal fever, infection, or fetal distress. Monitoring and timely interventions are crucial to ensuring a healthy pregnancy outcome. Placenta abruptio presents with a sudden onset of vaginal bleeding, severe abdominal pain, uterine tenderness, and hypertonic contractions. This condition occurs due to the premature separation of the placenta from the uterine wall, leading to hemorrhage, fetal distress, and maternal complications. Several risk factors contribute to placenta abruptio, including hypertension, preeclampsia, trauma, smoking, cocaine use, prior abruption, and advanced maternal age. The complications can be severe, with risks such as disseminated intravascular coagulation, DIC, fetal hypoxia, and maternal hemorrhagic shock. Management involves continuous fetal monitoring, fluids, and blood transfusion if necessary. In cases of fetal distress or significant hemorrhage, an emergency C-section is required. In contrast, placenta previa is characterized by painless vaginal bleeding, typically occurring in the second or third trimester. Diagnosis is confirmed through ultrasound, which reveals the placenta covering or near the cervical OS. Risk factors for placenta previa include a history of prior C-section, multiple gestations, uterine scarring, smoking, and advanced maternal age. Management strategies focus on pelvic rest, which includes avoiding douching, vaginal exams, and intercourse. Additionally, large-bore intravenous access is essential for potential fluid resuscitation, and serial ultrasounds are conducted to monitor placenta position. A C-section is planned after 36 weeks, before the onset of labor. A key nursing tip to remember is that a vaginal exam should never be performed in a patient with suspected placenta previa due to the risk of severe hemorrhage. Preterm birth, defined as birth before 37 weeks of gestation, has multiple risk factors, with the most significant being a history of prior preterm birth. Other contributing factors include previous cervical surgery such as cone biopsy or LEEP procedure, tobacco, alcohol, or drug use, and maternal age below 17 or above 35 years. Additionally, Black race is associated with a higher risk due to health disparities and an increased inflammatory response. Infections such as urinary tract infections, UTIs, bacterial vaginosis, and chorioamnionitis, as well as periodontal disease, have been linked to systemic inflammation and preterm labor. Multiple gestations, including twins or triplets, also increase the risk. Management strategies include progesterone therapy to prevent preterm labor in high-risk patients, cervical cerclage for cervical incompetence, defined as less than 25 millimeters, and corticosteroids like betamethasone to promote fetal lung maturity if preterm birth is imminent. Furthermore, tocolytics such as nifedipine, indomethacin, and terbutaline are used to delay labor. Regarding vaccines in pregnancy, certain vaccines are safe and recommended, while others are contraindicated. Safe vaccines include the inactivated influenza vaccine, flu shot, and the TDAP vaccine, which is administered between 27 and 36 weeks to provide passive immunity to the newborn. However, live vaccines should be avoided during pregnancy, including the influenza nasal spray, MMR, measles, mumps, rubella, and varicella vaccines. Additionally, pregnancy should be avoided for at least 4 weeks after receiving a live vaccine. Hyperemesis gravidarum, or severe morning sickness, is characterized by persistent nausea and vomiting, leading to dehydration and weight loss. Clinical features include weight loss exceeding 5% of pre-pregnancy weight, and signs of dehydration such as poor skin turgor, dry mucous membranes, tachycardia, and hypotension. Electrolyte imbalances are common, with findings such as hypokalemia, hyponatremia, and ketonuria due to starvation and fat breakdown. Additionally, increased urine-specific gravity is noted due to dehydration, while metabolic alkalosis occurs as a result of excessive vomiting and gastric acid loss. Management involves IV fluid administration using normal saline or lactated Ringer's solution with electrolyte replacement. The first-line treatment includes vitamin B6 combined with doxylamine, while antiemetics such as ondansetron, Zofran, metoclopramide, and promethazine may also be used. In cases of prolonged vomiting, thiamine supplementation is necessary to prevent wernicke encephalopathy. Prenatal teaching is essential for ensuring a healthy pregnancy, and it includes guidance on healthcare provider HCP visits, laboratory values, common conditions, and necessary interventions. Regular prenatal visits follow a structured schedule, once a month until week 28, then every 2 weeks until week 37, and weekly from week 37 until delivery. If labor has not started by week 42, the healthcare team considers induction or a cesarean section. Alongside these visits, monitoring hemoglobin levels is crucial, as normal values vary across trimesters. During the first trimester, hemoglobin can be as low as 11 grams per deciliter, while in the second and third trimesters, levels may drop to 10.5 grams per deciliter, due to hemodilution. However, if levels fall below 10 grams per deciliter, anemia is diagnosed, necessitating iron supplementation. Another important condition in pregnancy is intrahepatic cholestasis of pregnancy, ICP, a liver disorder that causes intense itching, particularly on the hand, and feet, which worsens at night. Though it presents without a rash, ICP increases the risk of fetal distress, preterm birth, and stillbirth. Because of these risks, it requires close monitoring of bile acid levels. Management includes administering ursodeoxycholic acid, UDCA, to reduce bile acids and performing frequent fetal assessments such as non-stress tests, NSTIA, and biophysical profiles, BPP. In severe cases, early delivery at 37 weeks is recommended. Another essential prenatal test is the indirect Coombs test, which screens for Rh sensitization in Rh-negative mothers such as those with an O-negative blood type. If maternal and fetal blood mix due to trauma, amniocentesis, abortion, ectopic pregnancy, or delivery, an Rh-negative mother may develop antibodies against an Rh-positive fetus. This can lead to hemolytic disease of the newborn, HDN. To prevent this, Rh immune globulin, RhoGAM, is administered at 28 weeks of gestation, within 72 hours postpartum if the newborn is Rh positive, and after any event that may cause fetal-maternal blood mixing. Nutritional support is also a key aspect of prenatal care, with folic acid, vitamin B9, playing a vital role in preventing neural tube defects, NTDs, such as spina bifida and anencephaly. Women planning pregnancy and those in the first trimester should consume 400 to 800 micrograms of folic acid daily. This can be obtained from fortified grains such as cereal, bread, and pasta, as well as leafy green vegetables like spinach, kale, and asparagus. Other good sources include legumes like lentils, chickpeas, and black beans, along with citrus fruits such as oranges and papaya. In addition to these key topics, understanding fundal height measurements is helpful in assessing fetal growth. By 12 weeks, the fundus is just above the pubic symphysis. At 20 weeks, it reaches the umbilicus, and after 20 weeks, it typically grows about 1 centimeter per week, with a normal variation of plus or minus 2 centimeters. Another important indicator of fetal well-being is kick counts, where expecting mothers should feel at least 10 fetal movements within 2 hours. If fewer than 10 kicks are detected, drinking cold water, resting, and reassessing may help. However, if fetal movements remain reduced, immediate contact with the healthcare provider is necessary. Finally, recognizing danger signs in pregnancy is critical for early intervention. Symptoms requiring immediate evaluation include severe headache, vision changes, epigastric pain, or right upper quadrant pain, which may indicate preeclampsia. Painless vaginal bleeding could suggest placenta previa, while a sudden gush of fluid before 37 weeks may signal preterm premature rupture of membranes. PPROM. Additionally, decreased fetal movements necessitate urgent fetal monitoring to ensure the baby's well-being. By staying informed about these essential aspects of prenatal care, expectant mothers can help ensure a safe and healthy pregnancy. Measuring fundal height is an essential aspect of prenatal assessment as it helps estimate gestational age. After 20 weeks of pregnancy, the fundal height in centimeters approximately corresponds to the number of weeks pregnant. To ensure an accurate measurement, the bladder should be emptied to prevent distortion, and the client should be positioned supine with knees slightly flexed. A non-elastic measuring tape is then used to measure from the symphysis pubis to the highest point of the fundus. The position of the fundus changes with gestational age, making it a useful indicator of fetal growth. At 12 weeks, the fundus is just above the symphysis pubis, while by 16 weeks, it is midway between the symphysis pubis and the umbilicus. By 20 to 22 weeks, the fundus reaches the level of the umbilicus, and at 36 weeks, it approaches the xiphoid process. However, after 37 to 40 weeks, the fundal height may decrease slightly as the baby engages in the pelvis, a phenomenon known as lightening. In addition to fundal height, quickening, or the first fetal movement, is another milestone in pregnancy. This typically occurs around 18 to 20 weeks in primigravida, first-time pregnancies, and as early as 14 to 16 weeks in multigravida, subsequent pregnancies. Recognizing these changes helps in monitoring fetal development and maternal well-being. A crucial consideration during pregnancy is uterine displacement and the risk of supine hypotension. If a pregnant client lies flat on their back, the uterus can compress the inferior vena cava, reducing blood return to the heart and leading to hypotension, pallor, and dizziness. To prevent this, the first intervention is to tilt the client laterally, preferably to the left side. This positioning is also vital in emergency pregnancy trauma care, where lateral tilting should be done before initiating resuscitation efforts to maintain adequate perfusion to both the fetus and the mother. Medication use during pregnancy requires caution, especially with NSAIDs. In the first and second trimesters, NSAIDs are classified as Category C, meaning they should only be used if the benefits outweigh the risks. However, in the third trimester, they fall under Category D and should be avoided due to the risk of premature closure of the ductus arteriosus and oligohydramnios. Instead, acetaminophen, Tylenol, is recommended as a safer alternative for pain relief. Hypertensive disorders of pregnancy, such as preeclampsia and eclampsia, pose significant risks to both mother and baby. Preeclampsia is characterized by hypertension, blood pressure greater than 140/90, and proteinuria, greater than 300 milligrams per 24-hour urine, while eclampsia involves seizures occurring after 20 weeks of gestation. The only definitive cure is delivery. However, magnesium sulfate is used to prevent and control seizures. Its therapeutic level ranges from 4 to 7 milliequivalents per liter, 2.0 to 3.5 millimoles per liter, and deep tendon reflexes, DTRs, should be closely monitored for signs of toxicity. If magnesium toxicity occurs, calcium gluconate serves as the antidote. During a seizure, it is crucial to turn the client on their left side, maintain a patent airway, and monitor for respiratory depression, respiratory rate less than 12 per minute, and urine output less than 30 milliliters per hour, both of which may indicate magnesium toxicity. Another common pregnancy symptom is morning sickness, typically occurring in the first trimester due to increased levels of human chorionic gonadotropin, HCG, and estrogen. To alleviate nausea and vomiting, eating dry carbohydrates, such as crackers or toast, before getting out of bed, consuming high-protein snacks before bedtime, and having small frequent meals are effective strategies. Additionally, drinking cold, carbonated fluids between meals and incorporating ginger and vitamin B6-rich foods, such as nuts, seeds, and legumes, can help reduce nausea. Gestational diabetes mellitus, GDM, is another condition that requires screening between 24 to 28 weeks of pregnancy. The initial test is a 1-hour glucose tolerance test, which involves drinking a 50-gram glucose solution without the need for fasting. A normal result is less than 140 milligrams per deciliter, whereas an abnormal result greater than 140 milligrams per deciliter necessitates a 3-hour glucose tolerance test for further evaluation. If left untreated, GDM can lead to complications such as macrosomia, neonatal hypoglycemia, and respiratory distress in the newborn. Another important screening in pregnancy is for Group B streptococcus, GBS, a normal vaginal flora found in approximately 30% of women, but one that can cause neonatal sepsis and pneumonia. Testing is done between 35 to 37 weeks, and if positive, intravenous penicillin G is the preferred treatment during labor. For clients allergic to penicillin, clindamycin or vancomycin can be used as alternatives. If GBS status is unknown, empirical treatment is recommended if risk factors such as preterm labor, prolonged rupture of membranes greater than 18 hours, or maternal fever are present. Finally, pyrosis, heartburn, is a common pregnancy discomfort caused by increased progesterone, which relaxes the lower esophageal sphincter, and the enlarging uterus, which pushes the stomach upward. To prevent and manage heartburn, keeping the head of the bed elevated, staying upright for 30 to 60 minutes after meals, and eating small, frequent meals can be beneficial. Additionally, avoiding large meals, fried or fatty foods, caffeine, and chocolate helps reduce symptoms. The MMR, measles, mumps, rubella vaccine, is administered only during the postpartum period if the mother was not previously vaccinated. Since it is a live vaccine, it is contraindicated during pregnancy due to its teratogenic effects. Furthermore, women who receive this vaccine should avoid pregnancy for at least 1 to 3 months after administration to prevent any potential risks to the fetus. Another important obstetric procedure is cerclage, which is placed in cases of cervical insufficiency to prevent preterm labor. After the procedure, bed rest is required only for the first few days. However, the patient should report any signs of labor, such as lower back pain, contractions, pelvic pressure, or rupture of membranes to their healthcare provider, HCP. Typically, cerclage remains in place until 36 to 37 weeks of gestation, but early removal is necessary if preterm labor or rupture of membranes occurs. In cases of spontaneous abortion, miscarriage, defined as unintentional pregnancy loss before 20 weeks of gestation, patients should follow specific nursing care instructions. They should avoid tampons and sexual intercourse for 2 weeks and report any severe pain, foul-smelling discharge, or heavy bleeding. Continuing prenatal vitamins and increasing iron intake are recommended, while ibuprofen can be taken for pain relief. Additionally, Rh immunoglobulin, Rho-GAM, is required for Rh-negative mothers to prevent isoimmunization. Certain medications, such as ACE inhibitors and ARBs, should be avoided during pregnancy due to their risk of causing fetal renal dysfunction and congenital defects. Moreover, laboratory values like WBC count tend to be normally elevated during pregnancy even in the absence of infection, which should be considered when interpreting lab results. During labor, the phases of labor are categorized into 3 stages. The latent phase, 0 to 3 centimeters dilation, involves mild, irregular contractions, and the mother is generally comfortable. As labor progresses to the active phase, 4 to 7 centimeters dilation, contractions become stronger and more regular, occurring every 3 to 5 minutes, often requiring pain management such as epidural administration. The transition phase, 8 to 10 centimeter dilation, is characterized by intense contractions every 1 to 2 minutes, increased pressure, and the urge to push. To induce labor or prevent postpartum hemorrhage, oxytocin, pitocin is commonly used, but it requires continuous fetal and maternal monitoring due to its potential risks. These include uterine hyperstimulation, contractions lasting more than 90 seconds or occurring less than 2 minutes apart, abnormal fetal heart rate patterns such as bradycardia and decelerations, and increased risks for emergency C-section, placental abruption, or uterine rupture. Additionally, oxytocin has antidiuretic effects, which can lead to water intoxication. It should always be administered via a secondary IV line and should not be given with other uterotonic medications like misoprostol. On the other hand, tocolytics are used to stop labor in preterm cases. Magnesium sulfate is administered for neuroprotection and preterm labor management, but monitoring for hypermagnesemia is essential. Symptoms include decreased heart rate, blood pressure, reflexes, respiratory rate, and level of consciousness. Reflexes should be maintained at +2. If decreased, the infusion should be slowed, and if increased, the dosage should be adjusted. Another tocolytic, terbutaline, is used for short-term preterm labor management but may cause maternal tachycardia. When preterm labor occurs before 34 weeks gestation, several interventions are anticipated. IM antenatal glucocorticoids, some drugs, are administered to mature fetal lungs, while IV antibiotics, penicillin, are given as prophylaxis for Group B streptococcus, GBS. If the pregnancy is under 32 weeks, magnesium sulfate is used for fetal neuroprotection. Importantly, artificial rupture of membranes, AROM, should be avoided to prevent umbilical cord prolapse. In cases where umbilical cord prolapse does occur, it leads to abrupt fetal heart rate deceleration, fetal bradycardia, and oxygen disruption. The priority interventions include performing a sterile vaginal exam to assess cord compression and repositioning the patient into a knee-chest or Trendelenburg position to relieve pressure on the cord. In most cases, an emergency C-section is required to ensure fetal safety. Another important consideration in labor is the mucus plug, whose expulsion is not necessarily a definitive sign of labor. To determine the likelihood of a successful vaginal delivery, the Bishop score is used with a score greater than 6 to 8 indicating better readiness for labor induction. For pain relief during the late second stage of labor, a pudendal nerve block is a highly effective option, especially when rapid relief is needed before birth. Similarly, an amniotomy, AROM, or artificial rupture of membranes is performed to induce or accelerate labor, but comes with risks such as umbilical cord prolapse and infection. Therefore, nursing actions include assessing fetal heart rate before and after the procedure, checking the characteristics of amniotic fluid, color, odor, presence of meconium, and encouraging the mother to maintain an upright sitting position. Post-procedure. Shoulder dystocia is a medical emergency that occurs when the fetal shoulder becomes lodged behind the maternal symphysis pubis, preventing delivery. Immediate interventions are crucial to prevent fetal hypoxia and other complications. During such an emergency, nursing interventions include precisely documenting the times of events and verbalizing the passing time every 5 minutes to maintain awareness. Additionally, requesting extra assistance from the healthcare team ensures timely and effective management. Maneuvers such as the McRoberts maneuver, which involves flexing the maternal thighs to the abdomen and applying suprapubic pressure to dislodge the shoulder, are essential. However, fundal pressure must be strictly avoided as it may worsen the impaction. To improve fetal perfusion and oxygenation, certain steps should be taken. If fetal distress is noted, discontinuing oxytocin, pitocin, can help mitigate further complications. Repositioning the client to the left lateral side enhances circulation while administering oxygen at 8 to 10 liters per minute. Via a non-rebreather mask ensures adequate oxygenation. Additionally, providing an IV bolus of lactated Ringer's solution or normal saline supports maternal hemodynamic stability. However, when an epidural block is used for pain management, it can inhibit the sympathetic nervous system, leading to vasodilation and potential hypotension. Therefore, monitoring for signs of lightheadedness, dizziness, nausea, or hypotension is essential. The first step in such cases is to assess the client's blood pressure. And if hypotension occurs, interventions should include intravenous fluid administration, left lateral positioning, oxygen supplementation, and notifying the provider. When administering intravenous opioids in labor, timing is critical to avoid neonatal respiratory depression. The safest window for administration is 2 to 4 hours before birth, ideally during active labor, 7 to 8 centimeter dilation, when contractions are well established. To minimize fetal exposure to the medication, opioids should be given during the peak of a contraction. Meanwhile, distinguishing between true and false labor is vital in labor assessment. True labor is characterized by regular contractions that increase in intensity, along with cervical dilation and effacement, and contractions that persist despite activity changes. In contrast, false labor involves irregular contractions, no significant cervical changes, and pain that is relieved by rest or hydration. Fetal heart rate, FHR, monitoring plays a crucial role in assessing fetal well-being. The Veal-Chop mnemonic helps interpret FHR changes. Variable decelerations indicate cord compression, requiring maternal repositioning. Early decelerations are caused by head compression and are considered normal, requiring only documentation. Accelerations signify adequate oxygenation and are reassuring, whereas late decelerations indicate placental insufficiency and necessitate immediate lie-in interventions. Left side repositioning, intravenous fluids, oxygen administration, and notifying the provider. Specific FHR patterns provide additional insights into fetal status. Acceleration, which is a temporary increase in FHR, is a reassuring sign. However, a low fetal heart rate, below 110 beats per minute, requires stopping pitocin and implementing LION interventions, while a high fetal heart rate, above 160 beats per minute, may indicate infection, requiring maternal temperature assessment. Variability in FHR is another key factor. Low baseline variability is concerning and demands lie-in interventions, whereas high baseline variability is reassuring and should be documented. Decelerations provide further clues to fetal well-being. Early decelerations, where FHR dips before or at the beginning of contractions, are normal and require only documentation. However, variable decelerations, which indicate cord prolapse, require repositioning and possibly pushing the presenting part off the cord. The most concerning are late decelerations, which occur after the contraction onset and signal fetal distress, requiring immediate lie-in interventions. Severe fetal distress is particularly evident when late decelerations persist beyond the end of contractions, indicating uteroplacental insufficiency and compromised fetal oxygenation. In such cases, oxytocin must be stopped immediately, the client repositioned to the left lateral side, oxygen administered at 8 to 10 liters per minute. Via a face mask, an intravenous bolus of normal saline or lactated Ringer's given, and the provider notified without delay. A sinusoidal fetal heart rate pattern, which appears as a wave-like pattern with no variability and no response to contractions, suggests severe fetal anemia, hypoxia, or Rh incompatibility. This is an obstetric emergency requiring immediate intervention, including emergency delivery or intrauterine resuscitation. Regarding OB medications, pain medication should not be administered if birth is imminent to prevent neonatal respiratory depression. Intravenous pain medications peak within 15 to 30 minutes, so their timing is crucial to avoid complications. Lastly, surfactant is administered post-birth to neonates with immature lungs via an endotracheal tube, ETTA, directly into the lungs, ensuring improved respiratory function. Before we move ahead, let me take a quick moment to tell you something that could completely change your NCLEX journey. If you're serious about passing the NCLEX in just 1 week or even within a month, then the smartest move you can make right now is to enroll in our complete online NCLEX crash course. This isn't just another course, it's a shortcut, a clear step-by-step roadmap that has already helped over 100,000 nursing students pass the NCLEX with confidence. And here's the most incredible part. Not a single student who completed this course has failed. Yes, that's a 100% passing rate. We built this course based entirely on the feedback and insights of thousands of nurses who've successfully cleared the NCLEX in the last 5 years. That means we've removed all the fluff and focused only on what truly matters for your exam. Here's exactly what you'll get when you enroll. You'll get 100 hours of animated crash course content designed for rapid revision, 500 hours of comprehensive recorded lectures covering all the high-yield topics, and access to 10,000 real NCLEX questions to sharpen your test-taking skills. You'll also get 500 next-gen case-based questions to strengthen your clinical judgment, along with 15 full-length practice tests that simulate the real NCLEX experience. And of course, you'll receive our complete NCLEX ebook and PDF notes, plus 1 full year of access, so you can study at your pace on your schedule. And yes, we're currently offering a 70% discount for a very short period. Once the offer ends, it's gone. Thousands of students are enrolling in our online NCLEX course every month and passing the exam, but if you don't enroll now, you risk being left behind. Spots are filling fast and only a few seats are left. Visit our website to enroll now. Link is given in description box. Let's continue the video. We're about to dive into the Medical Surgical NCLEX review. This crash course is designed so comprehensively that nothing beyond this will be asked on your exam. So stay focused, stay confident, and make sure you stick with me until the very end. Let's talk about emergency nursing principles and management, starting with triage in emergency nursing. Triage is the process of prioritizing patient care based on acuity, especially in emergency situations or during mass casualty events. It helps determine who needs immediate attention and who can safely wait. Based on acuity, triage is divided into 3 main categories. First is the emergent category, which includes life-threatening conditions that require immediate attention. Examples of this include respiratory distress, active chest pain, which may suggest a myocardial infarction or heart attack, major trauma, stroke, severe burns, shock, and severe allergic reactions known as anaphylaxis. Second is the urgent category, which includes serious conditions, but they are not immediately life-threatening. These patients need quick treatment, but not necessarily immediate care. Some examples include major fractures, whether open or closed, pain that is uncontrolled, dehydration, high fever accompanied by neurological symptoms, and active bleeding that is not considered life-threatening. Third is the non-urgent category, which includes stable conditions that can wait without any immediate risk. Examples include minor cuts, scrapes, also known as abrasions, sprains, mild burns, sore throat, and infections of the ear. Now, in situations involving mass casualties where resources like time, staff, or equipment are limited, a tagging system is used. This is called mass casualty triage, and it categorizes patients based on their likelihood of survival. Class 1, also known as the red tag category, is for immediate cases that are critical and life-threatening. These patients require urgent intervention in order to survive. Examples include severe respiratory distress, tension pneumothorax, which is when air gets trapped in the chest, severe burns, major bleeding, also called major hemorrhage, and penetrating injuries to the chest or abdomen. Class 2, also known as the yellow tag category, includes patients with major injuries, but they are stable enough to wait for treatment if necessary. Examples include open fractures without heavy bleeding, large soft tissue injuries, and burns that cover a moderate area of the body. Class 3, also called the green tag category, includes patients with minor injuries, often referred to as the walking wounded. These individuals do not need immediate medical care. Examples include sprains, small cuts, scrapes, and minor burns. Class 4, also known as the black tag category, includes patients who are either deceased or are expected to die due to the severity of their injuries. These individuals have minimal chances of survival, and the focus may shift toward providing comfort care. Examples include massive head trauma with signs of brain herniation, full-thickness burns covering more than 90% of the body, and high spinal cord injuries that result in no spontaneous breathing. Now let's move on to emergency priorities, which are guided by the ABCDE approach. A stands for airway. The first step is to ensure that the airway is open and not obstructed. To do this, we use the head tilt, chin lift maneuver. But if a cervical spine injury is suspected, then we use the jaw thrust maneuver instead. We may also need to consider procedures like intubation, suctioning, or using airway devices such as an oropharyngeal airway. B stands for breathing. Here, we assess and support ventilation. This involves checking if the patient is receiving enough oxygen. We use tools like pulse oximetry or arterial blood gases, abbreviated as ABG, if necessary. Depending on the situation, we may provide oxygen therapy through devices like a non-rebreather mask, bi-level positive airway pressure or BiPAP, continuous positive airway pressure or CPAP, or even mechanical ventilation. C stands for circulation. This step is about managing blood flow and blood pressure. We check the patient's pulses, measure blood pressure, observe skin color, and test capillary refill time. If the patient is bleeding, we control it by applying direct pressure or using a tourniquet if required. At the same time, we establish intravenous access using large-bore intravenous lines for fluid resuscitation. D stands for disability. This refers to checking the patient's neurological status. We assess the level of consciousness using the Glasgow Coma Scale. We also examine the pupils, check body movements, and observe the response to painful stimuli. During this step, we consider possible causes such as lack of oxygen, stroke, or physical trauma. E stands for exposure. This final step is about identifying hidden injuries and preventing hypothermia. We remove any wet clothing, cover the patient with warm blankets, and, if needed, provide warmed intravenous fluids. It's also important to check the entire body, including areas not easily seen, such as the back, especially in trauma patients. And that brings us to the end of the key emergency nursing principles, covering both triage systems and the critical ABCDE approach to emergency care. Let's begin with the topic of poisoning management. The very first and most important point to remember is do not induce vomiting. The use of syrup of ipecac is no longer recommended and should be avoided. Now moving on to management strategies for poisoning. First, we use activated charcoal, which helps absorb ingested toxins. It is most effective when given within 1 hour of ingestion. Second, we consider gastric lavage, but only if a potentially lethal dose of poison was ingested and the patient presents within 1 hour. Third, we may use whole bowel irrigation, which is especially useful in cases where the patient has consumed sustained release or enteric-coated drugs. Examples include iron, lithium, or in cases involving body packers, people who internally conceal drugs. Fourth, we use antidotes, but only if they are applicable to the specific poisoning case. For example, in an acetaminophen overdose, the antidote is N-acetylcysteine, also called NAC. In an opioid overdose, the antidote is naloxone. In a benzodiazepine overdose, the antidote is flumazanil. In cases of organophosphate poisoning, the antidotes are atropine and pralidoxim. And don't forget, always call the rapid response team if the patient is showing any signs of rapid deterioration. Now let's move on to cardiac emergencies, specifically the management of ventricular fibrillation, which is abbreviated as VFib, and ventricular tachycardia, abbreviated as VTACH. Step 1 is to initiate basic life support, or BLS, along with cardiopulmonary resuscitation, commonly known as CPR. The focus should be on delivering high-quality chest compressions. Step 2, if there is no pulse, proceed with defibrillation. This can be done using an automated external defibrillator or a manual defibrillator. Step 3 is to establish intravenous access and administer emergency medications. These include epinephrine, 1 milligram given intravenously every 3 to 5 minutes, amiodarone, with a first dose of 300 milligrams given intravenously and a second dose of 150 milligrams. Other medications like lidocaine, magnesium, or preconamide may also be considered depending on the situation. Now let's explore some important pharmacological considerations for emergency medications, focusing on adrenergic receptors and their functions. There are several types of receptors to understand. Alpha-1 receptors are located in the skin, mucous membranes, and veins. Their main function is to cause vasoconstriction, which increases blood pressure, reduces congestion, and helps stop superficial bleeding. Medications that act on alpha-1 receptors include epinephrine and phenylephrine. Beta-1 receptors are located in the heart. They work to increase heart rate and cardiac output. Examples of medications that act here include dobutamine and dopamine, especially at low doses. Beta-2 receptors are found in the lungs and the uterus. They cause bronchodilation and relaxation of uterine smooth muscle. Medications acting on these receptors include albuterol and terbutaline. Dopamine receptors are mainly found in the kidneys and the heart. At low doses, dopamine increases renal perfusion. At higher doses, it increases blood pressure and heart rate. Now let's go over a few key medications commonly used in emergencies. Epinephrine acts on alpha-1, beta-1, and beta-2 receptors. Its effects include vasoconstriction, which raises blood pressure, increasing heart rate, and causing bronchodilation. It is used in cases of anaphylaxis, cardiac arrest, and severe asthma. Side effects include hypertensive crisis, abnormal heart rhythms or dysrhythmias, and chest pain known as angina. Next is dobutamine, a beta-1 agonist. It increases both heart rate and the strength of the heart's contractions. It is used to treat heart failure and cardiogenic shock. However, it may cause side effects like abnormal heart rhythms and rapid heart rate, also called tachycardia. Then we have dopamine, which has dose-dependent effects. At low doses, it causes renal vasodilation. At moderate doses, it increases heart rate by stimulating beta-1 receptors. At high doses, it causes vasoconstriction by stimulating alpha-1 receptors. It is commonly used in cases of shock and heart failure. Side effects include irregular heart rhythms and chest pain. Let's look at question 1, emergency triage and prioritization. A nurse is working in the emergency department during a mass casualty incident. 4 patients arrive at the same time. The question is which patient should receive a red tag, also known as Class 1, according to triage protocols. Let's go through the options one by one. Option A describes a 45-year-old male with an open tibial fracture and controlled bleeding, who is reporting severe pain. Option B is a 32-year-old female with a penetrating head wound showing agonal breathing and a Glasgow Coma Scale score of 3. Option C is a 60-year-old male with severe chest pain, sweating also called diaphoresis, and shortness of breath. Option D is a 25-year-old female who has minor abrasions and a sprained ankle, and she is able to walk without any assistance. Now, the correct answer is option C, the 60-year-old male with chest pain, sweating, and shortness of breath. Here's why. This patient is showing signs of a possible myocardial infarction, also called a heart attack. This is a life-threatening emergency and requires immediate intervention, which means he should receive a red tag or Class 1 designation. Option A. The patient with the open fracture and controlled bleeding has a major injury, but it is not immediately life-threatening, so he falls under the yellow tag or Class 2. Option B. The patient with the penetrating head wound and a Glasgow Coma Scale of 3 has minimal chances of survival. That means she should receive a black tag, or Class 4. Option D, who has only minor injuries and is able to walk, falls into the green tag group, also called Class 3. She can safely wait for treatment. Now moving on to question 2, emergency airway management. A nurse in the emergency department is assessing an unconscious trauma patient who was found unresponsive after a motor vehicle accident. The patient's jaw is clenched and there is concern for a possible cervical spine injury. The question is, what is the priority nursing action in this situation? Let's review the options. Option A says to perform the head tilt chin lift maneuver to open the airway. Option B suggests inserting an oropharyngeal airway to maintain airway patency. Option C recommends using the jaw thrust maneuver to open the airway while keeping the spine stable. Option D suggests preparing for immediate endotracheal intubation with rapid sequence induction. Now, the correct answer is option C, use the jaw thrust maneuver while maintaining spinal precautions. Here's the rationale. When a cervical spine injury is suspected, we must protect the neck and avoid any movements that could cause further harm. That means the head tilt, chin lift method is contraindicated and should not be used when to auto, which eliminates option A. The jaw thrust maneuver is the preferred technique in these cases because it helps open the airway without moving the neck. An oropharyngeal airway, as mentioned in option B, may be used, but only after the airway has already been opened manually. Endotracheal intubation, mentioned in option D, is necessary if the patient does not start breathing on their own after the airway has been opened. So once again, jaw thrust is the correct first action here. Now, before we continue, let me ask you something important. Do you want to pass the NCLEX exam, the National Council Licensure Examination, in just 1 week or 1 month on your very first try? If yes, then this message is for you. We have created the ultimate NCLEX crash course with a 99% passing rate. Over 5,000 nurses have already passed in the last 5 years using this exact course, and now it's your turn. Here's what you'll get. A 100-hour animated mini crash course perfect for those who are short on time and want to pass in just 7 days. A 300-hour comprehensive lecture series covering 300 high-yield NCLEX topics, the topics the exam absolutely loves to test. Access to 5,000 previously asked NCLEX questions, so you'll be fully familiar with the types of questions you'll see on the real exam. 15 full-length practice tests, including computerized adaptive testing, exams giving you the full real exam experience, an exclusive NCLEX ebook, your complete guide to passing, and finally, a full 1-year access so you can study at your own pace anytime, from anywhere. Seats are limited. If you enroll right now, you'll get a massive 70% discount. So don't miss this opportunity. Visit our website now. The link is in the description. Now let's move on to an important topic: neurologic diagnostic procedures. These tests are essential for evaluating brain function, detecting abnormalities, and guiding medical interventions. Let's begin with the cerebral angiogram. This procedure helps us visualize the blood vessels in the brain. A catheter is inserted either into the femoral artery in the groin or the carotid artery in the neck, and then threaded up into the brain. Here are some key points to remember. First, it uses contrast dye. So before the procedure, always check for allergies to iodine or shellfish. Second, evaluate renal function. That means checking blood urea nitrogen, abbreviated as BUN, and creatinine levels. This is important because impaired kidney function can prevent the body from excreting the contrast dye, which may lead to toxicity. Also, make sure to assess if the patient is pregnant. Since the contrast dye is harmful to the fetus, it is teratogenic. Now, for pre-procedure care, the patient should be nothing by mouth for 4 to 6 hours before the procedure. In addition, anticoagulant medications should be held since they increase the risk of bleeding. After the procedure, monitor closely for bleeding at the catheter insertion site. Also check for distal pulses and circulation in the affected limb to make sure blood flow is adequate. Be alert for signs of hematoma formation or stroke, such as weakness on one side, slurred speech, or confusion. Next is the CT scan, also known as computed tomography. This scan uses X-rays and sometimes contrast dye to create detailed images of the brain. Key points include the following. Before administering contrast dye, check for iodine or shellfish allergies. Also, evaluate kidney function using BUN and creatinine levels. During the scan, the patient must remain still to avoid blurry images. After the scan, encourage increased fluid intake to help flush the contrast dye from the body. Now let's talk about the EEG, which stands for electroencephalogram. An EEG is used to detect seizure activity, sleep disorders, and behavior changes by measuring the electrical activity of the brain. Here's what to remember. Before the test, the patient doesn't need to fast, but they should avoid caffeine as it can interfere with brain activity. Also, the patient should wash their hair beforehand. No oils, sprays, or conditioners should be used. Sometimes the test may require sleep deprivation to increase the likelihood of detecting abnormal brain activity. The patient might also be exposed to flashing lights or asked to hyperventilate during the test to stimulate the brain. During the test, the procedure usually takes about 1 hour, and it is non-invasive and completely painless. After the test, the patient can resume normal activities unless instructed otherwise by the healthcare provider. Let's now discuss the Glasgow Coma Scale. The Glasgow Coma Scale is used to assess the level of consciousness in patients who have experienced brain injuries. On this scale, the highest possible score is 15, indicating that the patient is fully alert. A score of 8 or less indicates severe head injury or coma. The assessment is based on 3 main components. The first component is eye-opening response, which is scored from 1 to 4. A score of 4 indicates the patient's eyes open spontaneously without any prompt. A score of 3 means the patient opens their eyes only to verbal commands. A score of 2 means eyes open only in response to pain. A score of 1 indicates there is no eye opening at all. The second component is verbal response, scored from 1 to 5. 5 indicates the patient speaks coherently and is fully oriented. 4 means the patient is confused but still able to converse. 3 indicates the use of inappropriate words. 2 is given if the patient makes incomprehensible sounds. A score of 1 indicates no vocal response. The third component is motor response, scored from 1 to 6. 6 means the patient can follow commands fully. 5 is given if the patient localizes or moves toward the source of pain. 4 indicates the patient withdraws or pulls away from pain. 3 is decorticate posturing, characterized by arms flexed inward, bent toward the core. 2 is decerebrate posturing, where arms are extended and wrists rotated outward. A score of 1 indicates no motor response at all. Next, let's talk about intracranial pressure monitoring, commonly called ICP monitoring. Intracranial pressure monitoring is essential for patients with a Glasgow Coma Scale score of 8 or less. It measures the pressure inside the skull, helping prevent further brain injury. The devices commonly used for intracranial pressure monitoring include intraventricular catheter, which is considered the gold standard, subarachnoid screw or bolt, epidural or subdural sensors. There are certain signs indicating increased intracranial pressure that nurses must watch for carefully. Early signs include irritability and restlessness, severe headache, decreased level of consciousness, and abnormalities in pupils such as unequal or sluggish reactions. Late signs include Cheney-Stokes respirations, which is an irregular breathing pattern, as well as abnormal body posturing like decorticate or decerebrate positions. The normal range of intracranial pressure is between 10 to 15 millimeters of mercury. Now let's move to the next topic, lumbar puncture, also called a spinal tap. A lumbar puncture is performed to collect cerebrospinal fluid. It helps diagnose conditions such as infections like meningitis or syphilis, multiple sclerosis, or to check for increased intracranial pressure. There are key points for nurses and patients to remember about this procedure. Before the lumbar puncture, the patient should empty their bladder. Positioning is important. The patient should either lie curled in a fetal position, sometimes called the cannonball position, or sit upright, leaning forward. Local anesthetic is applied to the puncture site to minimize discomfort before inserting the needle. After the procedure, certain steps must be taken. The patient should lay flat for several hours to prevent cerebrospinal fluid leakage and the occurrence of a spinal headache. It is essential to monitor the puncture site carefully for any bleeding or signs of infection. Increasing fluid intake is encouraged to help the body replenish cerebrospinal fluid. If a spinal headache develops from fluid leakage, a blood patch procedure may be required to relieve symptoms. Moving forward, let's discuss magnetic resonance imaging. An MRI provides detailed images of the brain using magnetic fields, and sometimes it involves injecting a contrast dye. Key points nurses should ensure before this test include checking if the patient has allergies, particularly to shellfish or iodine, if contrast dye will be used, removing all metal objects from the patient, such as jewelry, hearing aids, and dentures. Verifying if the patient has implants like pacemakers, orthopedic joints, artificial heart valves, intrauterine devices, or aneurysm clips, as these could interfere with the test. Assessing the patient for claustrophobia, as sedation might be required. Providing earplugs as the MRI machine is quite loud. Finally, let's cover the positron emission tomography scan. A PET scan is a nuclear medicine imaging test that helps detect tumor activity and assess brain function by measuring glucose metabolism in the brain. Important points for patients undergoing a PET scan include avoiding caffeine, alcohol, and tobacco before the procedure, as these substances can interfere with the results. The patient may also need to fast before the scan. During the procedure, a radioactive tracer is injected to highlight areas of high metabolic activity, such as tumors or abnormal brain function. Now, let's discuss X-rays. X-rays are sometimes used in neurological evaluations to identify fractures, abnormal curvatures, or dislocations that could potentially damage the nervous system. Specifically, X-rays can detect skull or spinal fractures, cervical spine injuries, and vertebral abnormalities. Let's practice an NCLEX question related to neurological assessments. A nurse is caring for a patient who just underwent a lumbar puncture. Which of the following nursing interventions is the priority? Option A. Encourage the patient to ambulate as soon as possible. Option B. Place the patient in a semi-Fowler's position. Option C. Monitor the puncture site for leakage and have the patient lie flat. Option D. Restrict fluid intake to prevent cerebral edema. The correct answer is option C, which is to monitor the puncture site for leakage and have the patient lie flat. Lying flat after a lumbar puncture reduces the risk of cerebrospinal fluid leakage, which could lead to severe spinal headaches. It is also important for the nurse to closely monitor the puncture site for signs of leakage or other complications. Let's briefly discuss why the other options are incorrect. Option A, encouraging the patient to ambulate early, is incorrect because moving around too soon increases the risk of cerebrospinal fluid leakage and spinal headaches. Option B, placing the patient in a semi-Fowler's position, is also incorrect because patients must remain flat for several hours to prevent post-lumbar puncture headaches. Option D, restricting fluid intake to prevent cerebral edema, is incorrect because after a lumbar puncture, fluids should actually be increased to replenish cerebrospinal fluid and help prevent headaches related to dehydration. Let's try another practice question. A nurse is preparing a patient for a magnetic resonance imaging scan, also known as an MRI scan. Which of the following assessments is the priority before the procedure? Option A, assess the patient for a history of claustrophobia. Option B, check for metal implants such as pacemakers or aneurysm clips. Option C, instruct the patient to remove all jewelry and metal objects. Option D, determine if the patient has an allergy to iodine or shellfish. The correct answer is option B, to check for metal implants such as pacemakers or aneurysm clips. An MRI uses powerful magnetic fields that can interact dangerously with metal implants, potentially causing life-threatening complications. Therefore, this assessment is the highest priority. Why are the other options incorrect? Option A, assessing the patient for claustrophobia, is important but not the first priority. If severe claustrophobia is present, sedation may be considered. Option C, instructing the patient to remove jewelry and other metal objects is necessary, but implanted metal devices pose a greater risk than removable objects. Option D, checking for iodine or shellfish allergies, is incorrect because MRI contrast agents do not contain iodine. Allergy concerns to iodine or shellfish pertain more to CT scans. Next, let's move on to the important topic of pain management, an essential concept in patient care. Pain can be categorized based on how long it lasts, where it originates, and what mechanism underlies it. Understanding these classifications helps nurses manage pain effectively. There are two main types of pain based on duration. The first type is acute pain, which is temporary, protective, and resolves as the tissue heals. Acute pain commonly occurs after surgery, injuries, or inflammation. It often feels sharp or intense, but improves as the underlying cause heals. The second type is chronic pain, which persists beyond 6 months. Chronic pain can be continuous or intermittent and is often associated with psychological effects, such as depression, anxiety, and fatigue. Chronic pain typically reduces a patient's ability to function normally and significantly impacts quality of life. Pain is also classified based on the underlying cause. First, we have nociceptive pain, which is caused by tissue damage or inflammation. This type of pain typically feels throbbing, aching, and localized. Nociceptive pain can be further divided into somatic pain, which originates from bones, joints, muscles, skin, and connective tissues. Visceral pain, originating from internal organs such as the stomach or intestines. This pain is often diffuse, deep cramping, and sometimes referred to other parts of the body. Cutaneous pain, arising from the skin or subcutaneous tissue, and often described as sharp or burning. Another category is neuropathic pain, which results from nerve damage or dysfunction. Neuropathic pain typically presents as a burning sensation, shooting pain, electric-like feelings, or tingling sensations described as pins and needles. Common examples include diabetic neuropathy, which is nerve damage from prolonged high blood sugar, and phantom limb pain, experienced in limbs that have been amputated. Treatments for neuropathic pain may include muscle relaxants, antidepressants such as amitriptyline or duloxetine, anticonvulsants like gabapentin or pregabalin, or antispasmodic medications. Finally, let's discuss how nurses systematically assess pain using the PQRST method. P stands for provocation or palliation, what triggers or relieves the pain. Q stands for quality. Can the patient describe the type of pain? Is it dull, sharp, throbbing, or burning? R stands for radiation. Does the pain spread to other areas of the body? S stands for severity. Ask the patient to rate the pain on a scale from 1 to 10. T stands for timing. When did the pain start, and how long does it usually last? Other important factors to assess include the setting in which pain began, what the patient was doing when the pain started, and how the pain impacts their daily life. It's also crucial to identify aggravating factors, which are things that make the pain worse, and relieving factors, which are actions or treatments that ease the pain. Now let's discuss pain management approaches which are essential for effective nursing care. Pain can be managed using two main approaches: non-pharmacological methods, which do not involve medication, and pharmacological methods, which use medicines to relieve pain. Let's first understand the non-pharmacological methods. One effective method is physical therapy, which improves the patient's movement and reduces pain. Another useful approach is transcutaneous electrical nerve stimulation, known as TENS. This involves using small electrical impulses to help reduce the sensation of pain. We also commonly use heat or cold therapy. Heat therapy relaxes muscles and provides relief, while cold therapy reduces swelling and inflammation. Additionally, treatments such as acupuncture and therapeutic massage help by stimulating circulation and relieving muscle tension. To address stress-related pain, relaxation techniques and guided imagery are beneficial. These methods promote mental relaxation, which often decreases the patient's perception of pain. Now let's move to pharmacological management, where medications are prescribed based on the patient's reported pain severity. For accurate assessment, we use a pain severity scale ranging from 0, indicating no pain, up to 10, which represents the worst possible pain. If the pain is mild, rated between 1 and 3 out of 10. Common medications include non-steroidal anti-inflammatory drugs, also known as NSAIDs, and acetaminophen. When pain is moderate, rated between 4 and 6 out of 10, we use weak opioids like tramadol or low-dose oxycodone combined with NSAIDs. For severe pain, rated 7 to 10 out of 10, strong opioids such as morphine or fentanyl are necessary. Let's understand non-steroidal anti-inflammatory drugs, or NSAIDs, in more detail. Examples include ibuprofen, naproxen, meloxicam, celecoxib, aspirin, diclofenac, and indomethacin. While effective, these medications may cause side effects like gastric irritation, gastrointestinal bleeding, and increased risk of ulcers. Specifically, aspirin can cause unique side effects like tinnitus, which is a ringing sound in the ears, vertigo or dizziness, and decreased hearing. These symptoms indicate salicylate toxicity. Aspirin should always be avoided in children because of the risk of Ray's syndrome. It's also important to monitor bleeding times carefully if a patient is taking aspirin along with anticoagulant medications. Moving to acetaminophen, commonly known as Tylenol, it's mainly used to manage mild pain and fever. However, precautions must be taken. The maximum daily dose should never exceed 4 grams per day due to the risk of liver damage known medically as hepatotoxicity. Also, acetaminophen should not be given if the patient is already taking medications like Vicodin or Percocet, because these drugs already contain acetaminophen. Next are opioids, medications frequently prescribed for moderate to severe pain. Examples of opioids include morphine, hydromorphone, known by its brand name Dilaudid, fentanyl, oxycodone or Percocet, hydrocodone or Vicodin, and tramadol. Opioids are commonly used for managing post-surgical pain, cancer-related pain, and pain during palliative or end-of-life care. Fentanyl, in particular, is often preferred for cancer pain and end-of-life comfort due to its strong effectiveness and availability as a transdermal skin patch. Opioids have several important side effects and considerations. Constipation is very common and is managed by stool softeners such as Docusate and increasing dietary fiber. Orthostatic hypotension, or dizziness upon standing, may occur, so patients should change positions slowly. Another issue can be urinary retention, so urine output needs monitoring, sometimes requiring catheterization. Nausea and vomiting might also occur, and these are managed effectively with antiemetic medications such as ondansetron. Additionally, opioids may cause sedation, so continuous monitoring of mental status is necessary. The most serious opioid side effect is respiratory depression, where breathing becomes dangerously slow. Nurses should carefully monitor respiratory rates, especially when opioids are given intravenously. To quickly reverse respiratory depression caused by opioids, an opioid antagonist known as naloxone or Narcan is administered if the respiratory rate falls below 8 breaths per minute. After giving naloxone, always monitor the patient closely for signs of opioid withdrawal. Here are some key takeaways for the NCLEX exam to remember clearly. Always remember that pain is subjective, meaning the patient's self-reported pain is the most accurate measure. For a thorough pain assessment, we use the PQRST method to fully understand the patient's pain experience. Patients taking NSAIDs must be educated about the risk of gastrointestinal irritation and bleeding, so advise them to take these medications with food. Acetaminophen carries a risk of liver failure or hepatotoxicity, so monitor for jaundice and ensure patients avoid alcohol consumption. With opioids, the risk of respiratory depression is significant, so always have naloxone readily available. Remember, constipation is the most common opioid side effect, making hydration and increased fiber intake essential. Lastly, chronic pain typically requires a multimodal management approach, combining medication and non-drug therapies for the most effective pain relief. Now, let's review 2 quick NCLEX style questions to reinforce understanding. A nurse is assessing a patient's pain using the PQRST method. The patient reports a burning, shooting pain that radiates down the leg. Based on this description, which type of pain is the patient experiencing? A. Somatic pain. B. Visceral pain. C. Neuropathic pain. D. Nociceptive pain. The correct answer is C. Neuropathic pain. This type of pain results from nerve damage or dysfunction and typically feels burning, shooting, or like pins and needles. Question number 2. A patient with moderate pain rated 5 out of 10 is prescribed tramadol. The nurse should educate the patient on which potential side effect associated with this medication. A. Respiratory depression. B. Constipation. C. Hepatotoxicity. D. Salicylate toxicity. The correct answer is B. Constipation. Opioids like tramadol commonly cause constipation due to their effects on the gastrointestinal tract. Patients should increase fluid and fiber intake, and stool softeners may be recommended. Hey, future nurses, if you want to pass the NCLEX in one try, we've got the ultimate shortcut for you. Our NCLEX Review Crash Course has a 99% passing rate, and more than 5,000 nurses have already passed using it. Now it's your turn. Here's what's inside the course: 100-hour animated crash course, ideal for those with very little time to study. 300-hour comprehensive lectures, covering 300 must-know NCLEX topics. 5,000 real NCLEX questions, learn from past exams, 15 full-length practice tests, including CAT simulations, exclusive ebook, and 1-year access. So you can study whenever you want. Limited spots. Left. Enroll now and get 70% off, but only for a short time. Click the link in the description and get started today. Let's now discuss meningitis, an inflammation of the meninges, the protective membranes covering both the brain and spinal cord. Meningitis can be either viral or bacterial. Viral meningitis, also known as aseptic meningitis, is more common and typically self-limiting, meaning it usually resolves without specific treatment. In contrast, bacterial meningitis is severe, contagious, and potentially fatal, requiring urgent antibiotic therapy to prevent serious complications such as brain damage, hearing loss, or death. Vaccinations play a key role in preventing meningitis. The Hib vaccine protects against Haemophilus influenzae type B, a common bacterial cause of meningitis. The meningococcal vaccine is recommended for adolescents and individuals living in crowded conditions, such as college dormitories or military barracks. Pneumococcal vaccines are recommended for infants, elderly individuals, and those who are immunocompromised. Typical signs and symptoms include the classic triad: severe headache, stiff neck, nuchal rigidity, and sensitivity to light, photophobia. Other systemic signs include fever, chills, nausea, vomiting, rapid heartbeat, tachycardia, and altered mental status, confusion, drowsiness, irritability. Neurological symptoms can include seizures, increased intracranial pressure, ICP, and positive Kernig's and Brudzinski signs. Kernig's sign refers to the inability to extend the knee when the hip is flexed at 90 degrees, and Brudzinski's sign involves involuntary flexion of the hips and knees when the neck is flexed. Skin findings specific to meningococcal meningitis can include a red macular rash progressing to purpura or petechiae, indicating disseminated intravascular coagulation. Diagnosis involves cerebrospinal fluid analysis through lumbar puncture. Viral meningitis presents with clear cerebrospinal fluid, normal or slightly elevated white blood cells, normal or mildly elevated protein, and normal glucose levels. Bacterial meningitis shows cloudy cerebrospinal fluid, significantly increased white blood cells and protein, and decreased glucose due to bacterial consumption. Additionally, bacterial meningitis typically demonstrates elevated opening pressure caused by increased ICP. Nursing interventions include initiating droplet precautions for bacterial meningitis until 24 hours after starting antibiotics, then shifting to standard precautions. Monitoring for increased ICP is crucial. Nurses should keep the head of the bed elevated at 30 degrees, discourage coughing, sneezing, or straining, and implement seizure precautions, padded side rails, oxygen, and suction equipment at bedside. A quiet, dimly lit room helps minimize photophobia-related discomfort. Hydration is important, but monitoring for the syndrome of inappropriate antidiuretic hormone secretion, SIADH, is also essential, as it can lead to fluid retention, diluted blood, concentrated urine, and hyponatremia, resulting in confusion, decreased urine output, muscle weakness, and seizures. Medications typically include broad-spectrum antibiotics such as ceftriaxone and vancomycin until specific bacteria are identified. Corticosteroids, like dexamethasone, may be used to reduce inflammation and prevent neurological complications. Antipyretics like acetaminophen manage fever. Analgesics, opioids or NSAIDs, control pain. And anti-seizure medications, phenytoin or levetiracetam, manage seizures if they occur. Complications include increased intracranial pressure, potentially causing brain herniation, septic emboli traveling to other organs leading to stroke or organ failure, and SIADH. Key points for the NCLEX include recognizing bacterial meningitis as a medical emergency requiring immediate antibiotic therapy. Understanding viral meningitis is self-limiting with supportive care. Following droplet precautions for 24 hours after antibiotics start, closely monitoring increased ICP, and distinguishing between viral and bacterial meningitis through lumbar puncture findings. Now shifting focus to seizures, these are neurological conditions characterized by sudden, uncontrolled electrical activity in the brain, resulting in altered consciousness, motor, and sensory disturbances. Epilepsy is a chronic disorder involving recurrent seizures due to abnormal brain electrical activity. Seizures can have various causes, such as fever, especially febrile seizures in children under 2, genetic predisposition, head trauma, cerebral edema, brain swelling, meningitis or encephalitis, electrolyte imbalances like hyponatremia, hypocalcemia, hypomagnesemia, hypoglycemia, hypoxia, toxic exposures, lead poisoning, carbon monoxide, drugs, alcohol, brain tumors or structural abnormalities and withdrawal from drugs or alcohol. Trigger factors include emotional stress, fatigue, excessive caffeine or stimulant use, flashing lights or visual stimuli, photosensitive seizures, and hyperventilation. Seizures are classified into generalized and partial, focal. Generalized seizures involve both brain hemispheres and include tonic-clonic, grand mal seizures, absence, petit mal. Seizures common in children, myoclonic seizures causing brief muscle jerks, and atonic or drop seizures leading to sudden falls. Partial seizures involve one hemisphere. Simple partial seizures do not cause loss of consciousness, but can result in twitching or sensory changes, while complex partial seizures impair awareness, cause repetitive movements like lip smacking, and may involve confusion or aura. Nursing interventions during a seizure include ensuring patient safety by gently lowering the patient to the ground, turning them onto their side to prevent aspiration, moving away nearby objects, and loosening restrictive clothing. Nurses must avoid restraining the patient or placing objects into their mouth. Post-seizure care involves documenting seizure details, onset, duration, symptoms, monitoring vital signs, reorienting the patient, maintaining a side-lying position until fully conscious, and implementing seizure precautions, including padded bed rails and availability of oxygen and suction equipment. Medication management includes anti-epileptic drugs such as phenytoin, carbamazepine, valproic acid, levetiracetam, and lamotrigine. For phenytoin specifically, monitoring serum levels, practicing good oral hygiene to prevent gingival hyperplasia, and noting its interaction with oral contraceptives and warfarin are important. Advanced treatments include vagal nerve stimulation, where an implanted device controls seizures, avoiding MRI and microwaves, and surgical removal of epileptic focus for drug-resistant seizures, such as temporal lobectomy or corpus callosotomy. Now, let's discuss status epilepticus, which is a medical emergency. Status epilepticus is defined as a seizure lasting longer than 5 minutes, or multiple seizures occurring back-to-back without the patient regaining consciousness between episodes. In managing status epilepticus, the first step is to protect the patient's airway and administer oxygen immediately. Next, establish intravenous access quickly, as rapid medication administration is crucial. Continuous monitoring of the heart using electrocardiography, also called EKG, as well as pulse oximetry to measure oxygen levels, should also be done throughout the episode. When it comes to medications for treating status epilepticus, benzodiazepines such as lorazepam, commonly known as Ativan, or diazepam, known as Valium, are typically the first-line treatments. For longer-term control, medications like phenytoin, Dilantin, or fosphenytoin, Cerebix, are used. Let's review 2 NCLEX-style practice questions to understand this topic better. Question 1. A nurse is caring for a patient experiencing a tonic-clonic seizure. Which intervention should be the nurse's priority? A. Insert a tongue blade to prevent the patient from biting their tongue. B. Restrain the patient to prevent injury. C. Turn the patient onto their side. D. Elevate the head of the bed to 90 degrees. The correct answer is option C. Turn the patient onto their side. The rationale behind this answer is that turning the patient onto their side helps prevent aspiration and maintains an open airway. Using a tongue blade or restraining the patient can cause injury, and elevating the head of the bed is not appropriate during an active seizure. Question 2. A patient with epilepsy is prescribed phenytoin, also known as Dilantin. Which statement by the patient indicates the need for further teaching? A. I will maintain good oral hygiene to prevent gum problems. B. I need to have my blood levels checked regularly. C. This medication may decrease the effectiveness of my birth control pills. D. I can stop taking the medication once my seizures stop. The correct answer is option D. I can stop taking the medication once my seizures stop. The rationale for this answer is that patients should never abruptly stop taking anti-epileptic medications because doing so may cause seizures to recur or lead to status epilepticus. The other statements demonstrate correct understanding about the use of phenytoin. Next, we will discuss Parkinson's disease. Parkinson's disease is a progressive neurodegenerative disorder that affects motor function. It happens due to an imbalance between dopamine and acetylcholine. In Parkinson's disease, dopamine levels become too low because of degeneration in a brain region called the substantia nigra. This reduction of dopamine leads to excess stimulation by acetylcholine of the basal ganglia, which is responsible for controlling movement. The key symptoms of Parkinson's disease include tremors, specifically a pill-rolling tremor, which is more noticeable at rest and decreases during movement. Muscle rigidity, often described as cogwheel rigidity, causing stiffness and resistance when moving. Bradykinesia, or slowness of movement. Postural instability, resulting in poor balance and increased risk of falls. Shuffling gait, known as festinating gait, characterized by short, slow steps with a stooped posture. A mask-like facial expression, due to reduced facial movements caused by muscle rigidity. Dysphagia and difficulty chewing, which increases the risk of aspiration pneumonia due to swallowing difficulties, mood swings, and cognitive impairment, which can progress to dementia in advanced stages. There is no definitive diagnostic test for Parkinson's disease. It is usually diagnosed clinically based on symptoms and the patient's response to dopamine therapy. Imaging tests such as magnetic resonance imaging or computed tomography scans may be used to rule out other conditions. Important nursing interventions for patients with Parkinson's disease include monitoring, swallowing ability closely, and having suction equipment readily available to prevent aspiration. Encouraging a diet with high-calorie, nutrient-dense foods and thickening liquids if swallowing difficulty occurs. Allowing extra time for meals with smaller and more frequent portions. Encouraging range of motion exercises, abbreviated as ROM, and regular ambulation to reduce stiffness. Suggesting gentle activities like yoga and Tai Chi to improve balance and flexibility. Speaking slowly, clearly, and using alternate methods of communication if the patient has speech difficulties. Implementing fall precautions such as using assistive devices like a walker or cane. Encouraging slow walking and avoiding multitasking during movement. Removing rugs, clutter, and installing grab bars at home. Medication management is essential for Parkinson's disease. Key medications include levodopa, carbidopa, known as Sinemet, which increases dopamine levels. This medication is best absorbed on an empty stomach, and protein intake should be moderate because too much protein can decrease its effectiveness. Anticholinergic medications like benztropine and trihexyphenidyl help reduce tremors by balancing acetylcholine. However, these should be used cautiously in elderly patients due to risks of confusion, urinary retention, and glaucoma. Amantadine, an antiviral medication that helps increase dopamine release. MAOB inhibitors, such as selegiline and rosigaline, prevent dopamine breakdown. Patients should avoid foods rich in tyramine, like cheese and wine, to prevent hypertensive crises. Potential complications of Parkinson's disease include aspiration pneumonia, which can be prevented by eating upright and having suction ready. Falls and fractures preventable by using assistive devices and removing hazards at home. Depression and cognitive decline, which may benefit from support groups and cognitive therapy. To summarize, the key NCLEX nursing priorities for Parkinson's disease include monitoring swallowing ability and thickening liquids if needed, having suction equipment ready at the bedside, encouraging exercises and range of motion activities to prevent stiffness, teaching fall prevention strategies such as wearing non-slip shoes and using assistive devices, educating the patient about proper medication timing and dietary restrictions, particularly regarding levodopa and protein intake. What do all successful NCLEX passers have in common? A solid study plan. Our NCLEX review crash course has helped 5,000 plus nurses pass in just one try with a 99% success rate. And you can be next. Here's your winning formula for success. 100-hour animated crash course for those who need to pass in just 1 week. 300-hour in-depth lectures covering the most high-yield NCLEX topics. 5,000 real NCLEX questions. Get used to the actual exam format. 15 full-length practice tests plus CAT simulations - Train Like a Pro. Exclusive NCLEX ebook plus 1-year access. Study smarter, not harder. This is your chance. Enroll now and grab 70% off. Click the link in the description and start your NCLEX journey today. Now we will discuss Alzheimer's disease, also known as AD. It is a progressive and irreversible neurodegenerative disorder that affects memory, cognition, and behavior. Alzheimer's disease primarily occurs after the age of 65, and it is the most common cause of dementia. Several risk factors increase the chances of developing Alzheimer's disease. The primary risk factor is advanced age. Other risk factors include genetic predisposition, particularly involving the APOE gene, a history of head trauma or previous traumatic brain injury, exposure to toxic metals or environmental pollution, and certain viral infections like herpes virus. Alzheimer's disease progresses through 7 distinct stages. Stage 1 involves no impairment. Patients have normal functioning without noticeable symptoms. Stage 2 involves very mild cognitive decline. Patients may experience slight forgetfulness, but it's generally not noticeable. Stage 3 includes mild cognitive decline, where short-term memory loss becomes noticeable to family members and close friends. Stage 4 involves moderate cognitive decline, where patients may experience noticeable personality changes and begin forgetting their personal history. Stage 5 is characterized by moderately severe cognitive decline. At this point, patients require assistance with activities of daily living and may forget important personal information such as their address. Stage 6 is severe cognitive decline. In this stage, patients may experience incontinence, wandering behavior, and significant difficulties communicating. Stage 7, the final stage, is very severe cognitive decline. Patients lose the ability to speak, become completely dependent on caregivers, and often have difficulty swallowing. Diagnosis of Alzheimer's disease can be challenging, as there is no definitive test. Diagnosis is made primarily through clinical assessment. Imaging tests such as magnetic resonance imaging or computed tomography scans can be used to rule out other potential causes. Healthcare providers also frequently use the mini mental state exam to evaluate the level of cognitive decline. Several nursing interventions can significantly improve the quality of life for patients with Alzheimer's disease. Nurses should frequently reorient patients using items such as clocks, calendars, and familiar photographs. Using short, simple instructions with repetition and consistency is helpful. Establishing a structured daily routine reduces confusion, and avoiding overstimulation, like loud noises or excessive visitors, can keep patients calm. To manage incontinence, it's important to maintain a regular toileting schedule. Finally, encouraging independence with daily activities for as long as safely possible can help preserve the patient's dignity. When caring for Alzheimer's patients at home, certain safety measures are crucial. Floors should remain clutter-free, and loose rugs should be removed to prevent falls. Locks should be installed on doors and windows since patients may wander away from home. Night lights should be used to reduce nighttime confusion, and brightly colored tape should be placed at the edges of stairs for better visibility. Additionally, lowering beds or placing mattresses on the floor can help prevent injuries from falls. Several medications are used in the management of Alzheimer's disease. Donepezil prevents the breakdown of acetylcholine, helping to improve memory. Rivastigmine and galantamine are cholinesterase inhibitors that slow disease progression. Memantine blocks NMDA receptors to protect brain cells. Antipsychotics like haloperidol and risperidone may be used for severe agitation but should always be considered a last resort. Potential complications of Alzheimer's include aspiration pneumonia due to difficulty swallowing, wandering and falls, which require careful home safety precautions, and malnutrition or dehydration, making nutritional monitoring essential. Let's summarize important NCLEX nursing priorities for Alzheimer's disease. Frequently reorient the patient using calendars, clocks, and familiar objects. Maintain a structured and consistent environment to reduce confusion. Ensure home safety by removing rugs, installing secure door locks, and using nightlights. Encourage independence and activities of daily living, but provide supervision when necessary. Closely monitor swallowing and offer thickened liquids if difficulty swallowing, known as dysphagia, is present. Now let's practice with 2 NCLEX-style questions. First question. A nurse is caring for a client with Parkinson's disease who has difficulty swallowing. Which intervention should the nurse include in the client's plan of care? Option A. Encourage the client to tilt their head backward while swallowing. Option B. Offer thin liquids to help with swallowing. Option C. Keep suction equipment at the bedside. Option D. Provide large meals 3 times a day to ensure adequate nutrition. The correct answer is option C. Keep suction equipment at the bedside. The rationale is that clients with Parkinson's disease have an increased risk of aspiration pneumonia due to difficulty swallowing and excess drooling. Having suction equipment ready helps clear secretions promptly and prevents aspiration. Option A is incorrect because clients should tilt their head forward in what is called the chin tuck position, not backward, to avoid aspiration. Option B is incorrect because thin liquids increase choking risk. Instead, thickened liquids are preferred. Option D is incorrect since smaller, frequent meals are easier to tolerate than large meals. Second question, a nurse is teaching the family of a client with moderate stage Alzheimer's disease about home safety modifications. Which statement by the family indicates a need for further teaching? Option A, we will install door locks that cannot be easily opened. Option B, we will use bright colored tape at the edges of stairs. Option C, we will place mirrors throughout the house to help with recognition. Option D, we will remove all loose rugs from the home. The correct answer is option C. We will place mirrors throughout the house to help with recognition. The rationale here is that patients with Alzheimer's disease can become confused or agitated when seeing reflections, leading to increased distress. Therefore, mirrors should be removed or covered if they cause issues. Option A is correct. Installing secure locks prevents wandering, which is a major safety concern. Option B is correct. Bright colored tape increases visibility and reduces fall risk. Option D is correct. Removing rugs prevents tripping hazards. Passing the NCLEX doesn't have to be hard. With the right strategy, you can pass on your first try. We've helped over 5,000 nurses achieve their dream with our 99% passing rate NCLEX review course, and you can be next. Here's what's inside. 100-hour mini crash course, perfect if you need to pass fast. 300-hour comprehensive lectures covering 300 high-yield NCLEX topics. 5,000 real NCLEX questions, no surprises on exam day. 15 full-length practice tests with CAT simulation, train like it's the real exam. Exclusive NCLEX ebook plus 1-year access. Study at your own pace. Spots are filling fast. Enroll now and get 70% off. Click the link in the description and start your NCLEX journey today. Let's start with multiple sclerosis, commonly known as MS. Multiple sclerosis is an autoimmune disorder that causes demyelination in the central nervous system, including both the brain and spinal cord. Plaques form specifically in the white matter, damaging the protective myelin sheath around nerves. This damage disrupts normal nerve impulse transmission. The condition is chronic, progressive, and currently has no cure, but it typically has periods of relapse and remission. Certain factors increase the risk of developing MS. It usually affects individuals aged between 20 and 40 years and is more commonly seen in women. Both genetic factors and environmental influences play a role. There are specific triggers that can cause an exacerbation or worsening of symptoms in MS patients. These triggers include infections, especially viral illnesses, extreme temperatures like hot or cold weather, emotional stress, fatigue, pregnancy, and physical injuries. Patients with MS experience several clinical symptoms. Visual disturbances are common, including double vision, known as diplopia, involuntary eye movements, or nystagmus, optic neuritis, and blurred vision. Sensory changes can also occur, such as ringing in the ears, known as tinnitus, decreased hearing ability, numbness, and tingling sensations. Motor dysfunction often includes muscle spasticity, weakness, difficulty swallowing, known as dysphagia, slurred speech, and tremors. Additionally, patients may experience bowel and bladder issues such as incontinence or urinary retention, cognitive impairments including poor judgment and memory loss, and sexual dysfunction. Diagnosis of MS involves imaging studies such as MRI, which reveal plaques in the brain and spinal cord. Another test, lumbar puncture, shows increased immunoglobulin G levels. Medications for MS management include cyclosporine, an immunosuppressant that reduces relapse frequency, and prednisone, a corticosteroid with anti-inflammatory properties that helps reduce exacerbations. Muscle relaxants like dantrolene, baclofen, and diazepam are often used to manage muscle spasticity. Nursing responsibilities important for the NCLEX exam include encouraging patients to avoid known triggers like hot showers, stress, and infections. Patients should have fall precautions in place due to muscle weakness and impaired coordination. Nurses should closely monitor swallowing and speech to prevent aspiration. Bladder training and intermittent catheterization may be required if urinary retention occurs. Additionally, nurses should encourage regular rest periods to prevent fatigue and promote physical therapy to maintain mobility and function. Now let's move on to amyotrophic lateral sclerosis, commonly known as ALS. ALS is a progressive neurodegenerative disorder that affects both upper and lower motor neurons. It leads to muscle atrophy, paralysis, and ultimately respiratory failure. There is no known cure for ALS, and patients typically pass away within 3 to 5 years after diagnosis due to respiratory complications. Importantly, cognitive functions remain intact, meaning the patient is fully aware of their condition and its progression. Common symptoms of ALS include muscle weakness and atrophy that typically start in the extremities and then progress towards the core muscles. Patients often experience difficulty swallowing or dysphagia, leading to a high risk of aspiration. Slurred speech, known medically as dysarthria, is common. Eventually, respiratory muscles weaken, leading to respiratory failure, which is the main cause of death. Diagnosis involves electromyography, or EMG, which detects loss of motor neuron function. Elevated levels of creatine kinase, or CK, may also be present due to muscle breakdown. The medication riluzole is a glutamate antagonist used to slow disease progression. Complications include pneumonia caused by aspiration and respiratory failure due to progressive paralysis. Nursing responsibilities essential for ALS care include maintaining airway patency by suctioning secretions as needed, monitoring respiratory status closely, and preparing for mechanical ventilation if necessary. Nurses should take steps to prevent aspiration by elevating the head of the bed during meals or considering a percutaneous endoscopic gastrostomy tube for nutrition. Assisting with communication through writing boards or speech devices, encouraging range of motion exercises to prevent joint stiffness, and providing psychosocial support since the patient is fully aware of their condition are also crucial. Finally, let's discuss myasthenia gravis, commonly referred to as MG. Myasthenia gravis is an autoimmune disorder affecting the neuromuscular junction. In this condition, antibodies block acetylcholine receptors, preventing muscle contractions. This results in muscle weakness that worsens with activity but improves with rest with periods of exacerbation and remission. Risk factors and triggers include fatigue, infections or illnesses, pregnancy, extreme temperatures like hot water or infections, and thymus gland hyperplasia. Patients often experience muscle weakness, particularly worsening with activity and improving after rest. Visual symptoms like double vision or diplopia and drooping eyelids known as ptosis are common. Other symptoms include difficulty swallowing, called dysphagia, slurred speech, and respiratory muscle weakness, increasing the risk for respiratory failure. Additionally, bowel and bladder dysfunction, leading to incontinence, may occur. Diagnostic tests include the Tensilon test, also known as the edrophonium test. If symptoms improve with Tensilon, MG is confirmed. However, if symptoms worsen, it indicates a cholinergic crisis or excessive acetylcholine. In such cases, atropine is administered as the antidote. EMG typically shows decreased muscle response, and imaging like CT or MR. I may detect thymoma, a tumor of the thymus gland. Medications used in MG include pyridostigmine and neostigmine, which are cholinesterase inhibitors that prevent the breakdown of acetylcholine, thus improving muscle strength. Corticosteroids like prednisone reduce autoimmune responses. Other treatments include plasmapheresis, which removes harmful antibodies, intravenous immunoglobulin therapy, and thymectomy, which involves the removal of the thymus gland. It's critical for NCLEX preparation to understand the difference between myasthenic crisis and cholinergic crisis. In myasthenic crisis, there is too little acetylcholine, causing severe muscle weakness and respiratory failure, which improves with Tensilon. Treatment involves giving pyridostigmine. In cholinergic crisis, there is too much acetylcholine, leading to muscle twitching, slow heart rate called bradycardia, and sweating, which worsens with Tensilon. Atropine is given as treatment. Nursing responsibilities for MG include maintaining a patent airway with emergency intubation equipment nearby, providing small, frequent, high-calorie meals to prevent fatigue, positioning patients upright during meals to reduce aspiration risk, adding thickeners to food for easier swallowing, providing lubricating eye drops due to difficulty blinking, and taping eyelids shut at night to prevent corneal damage. Key NCLEX tips include prioritizing respiratory function in ALS and MG due to high risks of respiratory failure, implementing fall precautions for MS patients due to muscle weakness and coordination issues, understanding the difference clearly between myasthenic crisis and cholinergic crisis, and recognizing the importance of the Tensilon test, ensuring atropine is always available. Let's discuss some important NCLEX-style questions along with their rationales. First, a nurse is educating a patient with multiple sclerosis about managing their symptoms. Which statement by the patient indicates that further teaching is needed? Option A says, I should avoid hot showers and baths. Option B says, stress can worsen my symptoms, so I should find ways to relax. Option C says, I will take frequent rest breaks throughout the day. Option D says, I will increase my daily exercise routine to prevent fatigue. The correct answer is option D, I will increase my daily exercise routine to prevent fatigue. The rationale behind this is that overexertion can actually trigger exacerbations of multiple sclerosis. Patients should balance activity with rest to avoid fatigue. Next, a nurse is monitoring a patient with amyotrophic lateral sclerosis, also known as ALS. Which complication is the most common cause of death in this condition? Option A, cardiovascular collapse. Option B, renal failure. Option C, respiratory failure. Option D, severe nurse is monitoring a patient with amyotrophic lateral sclerosis, also known as ALS. Which complication is the most common cause of death in this condition? Option A, cardiovascular collapse. Option B, renal failure. Option C, respiratory failure. Option D, severe muscle spasms. The correct answer is option C, respiratory failure. The rationale here is that ALS leads to progressive weakening of respiratory muscles, ultimately causing respiratory failure, which is the most common cause of death. Now, let's look at a nurse preparing to administer edrophonium, also called tensilon, to a patient suspected of having myasthenia gravis. What should the nurse do before administering this medication? Option A, ensure atropine is available. Option B, place the patient in Trendelenburg position. Option C, administer oxygen through nasal cannula. Option D, have the patient perform deep breathing exercises. The correct answer is option A, ensure atropine is available. The rationale for this is that edrophonium can cause a cholinergic crisis, and atropine acts as an antidote, so it must be readily available in case of severe slowing of the heart rate or respiratory distress. Now, moving on to eye disorders. Good vision is essential for daily life, and various eye disorders can impair sight. Let's discuss some key conditions, their symptoms, treatments, and nursing responsibilities. First, macular degeneration. Macular degeneration is the progressive degeneration of the macula, leading to central vision loss, primarily affecting adults over 60 years old. There are two types: dry, also known as non-exudative, which is the most common and progresses slowly due to drusen deposits, and wet, also called exudative, which is more severe and progresses rapidly because of abnormal blood vessel growth. Common symptoms include blurred vision, loss of central vision causing difficulty reading or recognizing faces, visual distortions where straight lines appear wavy, and difficulty seeing in low light. While there's no cure, progression can be slowed with antioxidants, carotene, vitamin E, vitamin B12, and zinc. Anti-VEGF therapy, like ranibizumab or bevacizumab, can help inhibit abnormal vessel growth in the wet type. Laser therapy and photodynamic therapy might also be used. Nursing responsibilities include encouraging a diet rich in leafy greens, fish, and vitamins, providing low-vision aids such as magnifiers or large print books, referring patients to community resources for assistance with daily activities, and educating them on home safety measures to prevent falls, like removing rugs and improving lighting. Next, cataracts. Cataracts involve the lens becoming opaque, causing progressive and painless vision loss. Symptoms include blurred vision, double vision, also known as diplopia, sensitivity to glare and light, seeing halos around lights, and an absent red reflex during an ophthalmoscopic exam. The definitive treatment is surgical removal of the cloudy lens with an artificial lens implantation. Postoperative nursing responsibilities focus on preventing increased intraocular pressure. Patients should avoid bending at the waist, sneezing, coughing, straining, or lifting objects heavier than 10 pounds. They should also avoid tilting the head backward, rapid movements, driving, or high-impact activities. Patients must use prescribed eye drops, avoid rubbing their eyes, and wear sunglasses outdoors to reduce glare and UV exposure. Immediately report any yellow or green discharge indicating infection or sudden sharp eye pain, nausea, or vomiting, suggesting increased pressure inside the eye. Complete healing typically occurs within 4 to 6 weeks. Finally, glaucoma. Glaucoma refers to increased intraocular pressure leading to optic nerve damage and vision loss. There are two main types. First, open-angle glaucoma, which is the most common and has a gradual onset due to partial blockage of the eye's drainage system. Symptoms include loss of peripheral vision, mild eye pain, and increased pressure above 21 millimeters of mercury. Second, closed-angle glaucoma, a medical emergency with sudden onset due to complete blockage of aqueous humor drainage. Symptoms are severe eye pain, headache, nausea, vomiting, halos around lights, blurred vision, sensitivity to light, and significantly elevated eye pressure. Treatment includes medications such as pilocarpine to constrict pupils, timolol beta blockers to reduce fluid production, mannitol as an emergency measure, and acetazolamide to decrease fluid production. Surgery like laser trabeculoplasty or iridotomy may be needed if medications aren't effective. Nursing responsibilities include correctly administering eye drops by waiting 5 minutes between different medications, applying gentle pressure to the inner corner of the eye to prevent systemic absorption, and ensuring the dropper tip doesn't touch the eye. Educate patients to avoid actions increasing intraocular pressure, like bending at the waist, straining, coughing, sneezing, lifting heavy objects, and avoiding dark rooms to prevent pupil dilation. Regular eye exams every 6 to 12 months are important for monitoring eye pressure. Retinal detachment is a condition where the retina separates from its underlying tissue. This condition can lead to permanent vision loss if it's not treated promptly. Several causes contribute to retinal detachment, including aging, trauma, diabetes, and myopia, commonly known as nearsightedness. Patients with retinal detachment usually experience sudden floaters, which appear as black spots floating in their vision. They may also notice flashes of light, known medically as photopsia. Another significant symptom is a curtain-like shadow affecting their vision. Importantly, retinal detachment causes painless but progressively worsening vision loss. Treatment for retinal detachment typically requires emergency surgery. Procedures like scleral buckle, pneumatic retinopexy, or vitrectomy may be performed. Additionally, laser photocoagulation or cryotherapy can help seal tears in the retina. Postoperative care is critical in managing patients after retinal detachment surgery. Correct positioning is extremely important and depends on the type of surgery performed. For example, after pneumatic retinopexy, patients must lie face down to ensure the gas bubble used in the surgery remains correctly positioned. Nurses should instruct patients to report immediately any sudden increases in pain, loss of vision, or the appearance of new floaters, as these could indicate redetachment. Patients also need thorough education about avoiding activities that can increase intraocular pressure. These include straining, heavy lifting, bending, sneezing, or coughing. Using prescribed eye drops is essential to prevent infection. Furthermore, patients must avoid air travel until cleared by their doctor because gas bubbles can expand at high altitudes. Now, for the NCLEX exam, remember these key nursing priorities. First, patient positioning after retinal detachment surgery is a frequently tested topic. Second, post-cataract surgery care focuses heavily on infection prevention and avoiding straining. Third, glaucoma medication administration and avoiding activities that increase intraocular pressure are crucial areas. Fourth, differentiating between early and late signs of macular degeneration is important. Lastly, recognizing acute angle closure glaucoma as a medical emergency is critical. Let's look at some NCLEX-style questions. Question 1 addresses post-cataract surgery care. A nurse gives discharge instructions to a patient after cataract surgery. Which patient statement indicates the need for additional teaching? A. I will wear sunglasses when going outside. B. I should avoid lifting anything heavier than 10 pounds. C. If I have mild eye itching, I should rub my eye gently. D. I will report any yellow or green drainage from my eye to my healthcare provider. The correct answer is C because patients should never rub their eyes after cataract surgery to prevent infection and lens displacement. Mild itching can be relieved by prescribed eye drops. Question 2 covers glaucoma medications. A nurse administers timolol eye drops to a patient with open-angle glaucoma. What's the most important nursing action during this procedure? A. Tell the patient to close their eyes tightly after giving drops. B. Apply pressure to the inner corner of the eye, known as the lacrimal duct, for 30 to 60 seconds. C. Instruct the patient to blink rapidly to distribute the medication. D. Put the drops directly onto the cornea for better absorption. The correct answer here is B. Timolol is a beta blocker, and applying pressure to the inner corner prevents systemic absorption, reducing risks like bradycardia or low blood pressure. Eye drops should be placed in the conjunctival sac, not on the cornea. Let's be real, failing. The NCLEX is not an option. It means wasting time. It means delaying your career. It means another round of stress and anxiety. But here's the good news. You don't have to risk failure. With our 99% passing rate NCLEX crash course, you'll have everything you need to pass on your first try. 100-hour mini crash course, ideal if you have very little time to prepare. 300-hour detailed lectures covering the 300 most tested NCLEX topics, 5,000 real NCLEX questions. No more surprises on exam day. 15 full-length practice tests plus CAT simulation. Get the real NCLEX experience before exam day. Exclusive NCLEX ebook plus 1 year full access. Study whenever, wherever. Spots are limited. Enroll now and grab 70% off before it's too late. Click the link in the description and start preparing today. Next, we discuss ear disorders, specifically otitis media or middle ear infections. Several risk factors increase the likelihood of developing otitis media. These include frequent colds or respiratory infections, enlarged adenoids blocking the eustachian tubes, exposure to tobacco smoke, bottle-feeding infants while lying flat, and allergies or sinus infections. Common symptoms include ear pain, known as otalgia, irritability, especially in young children, a red, inflamed, bulging eardrum with visible fluid or bubbles, hearing loss, fever, headache, and ear drainage if the eardrum ruptures. Nursing responsibilities for patients with otitis media involve assessing for ear pain or infection signs, particularly in children who may pull their ears or become unusually fussy or restless. When administering ear drops, nurses must pull the ear differently based on age. For children under 3 years old, pull the ear pinna down and back, while for adults, pull it up and back. Additionally, educating parents about completing antibiotic courses fully, encouraging fluid drainage by elevating the child's head, and teaching prevention strategies such as breastfeeding and avoiding supine bottle feeding are essential parts of nursing care. Meniere's disease is an inner ear disorder characterized by a classic triad of symptoms. The first symptom is tinnitus, which means a ringing sensation in the ears. The second symptom is unilateral sensorineural hearing loss, meaning hearing loss affecting only one ear. The third classic symptom is vertigo, a spinning sensation that comes in episodes and can last anywhere from several hours to a few days. Certain risk factors can increase the likelihood of developing Meniere's disease. These include viral or bacterial infections that damage the inner ear, medications that are harmful to the ears called ototoxic medications. Apart from the classic symptoms, patients may experience additional signs like nystagmus, which is involuntary eye movements, nausea, vomiting, problems with balance, and increased sensitivity to loud sounds. Nurses play a crucial role in managing patients with Meniere's disease, especially during acute attacks. Safety always comes first, so nurses must implement fall precautions by keeping the bed at its lowest position and raising side rails. To minimize symptoms, the patient should be placed in a quiet, dark environment to reduce stimuli and encourage to rest. Nurses should also administer prescribed medications such as meclizine, which helps relieve vertigo. Patient education is equally important in managing Meniere's disease. Patients should be advised to avoid caffeine, alcohol, smoking, and high salt intake, as these substances can increase fluid retention in the inner ear and worsen symptoms. It is also helpful to space out fluid intake throughout the day rather than drinking large amounts at once. Patients should lie down immediately when they begin to experience vertigo. Ototoxic medications are drugs that can cause damage to the ear and should be recognized and managed carefully. Examples of these medications include aminoglycoside antibiotics, such as gentamicin and amikitin, antibiotics like metronidazole, certain diuretics such as furosemide, also known by its brand name Lasix, chemotherapy agents, and other drugs like anticholinergics, antihistamines often used for nausea, vomiting, and tinnitus, and droperidol, which is commonly given for nausea and vomiting. Recognizing and managing these medications can help prevent further damage to hearing and balance in patients. Let's discuss head injuries, specifically traumatic brain injury. It's crucial for nurses to immediately stabilize the cervical spine, known as C-spine precautions, especially if the patient had a car accident or a fall. This is done until any spinal injury is ruled out. Next, nurses must carefully assess for increased intracranial pressure. Monitoring the patient's Glasgow Coma Scale is essential because a score of 8 or less indicates a severe brain injury. Early signs of increased intracranial pressure include irritability and restlessness, often the first indicators. Patients may also experience headaches, projectile vomiting without feeling nauseous, and altered consciousness, such as drowsiness or confusion. Late signs become more severe and include fixed, dilated pupils that don't respond to light, and something called Cushing's triad. This triad consists of three main symptoms: increased blood pressure with a widened pulse pressure, bradycardia or slow heart rate, and irregular respirations, which may include patterns like Cheney-Stokes breathing or even apnea. Additional late signs are abnormal posturing, known as decorticate or decerebrate posturing, and leakage of cerebrospinal fluid from the nose or ears. Nurses can detect this leakage by the halo sign, which is blood surrounded by a yellowish ring on bed sheets, or by testing the fluid for glucose, confirming it's cerebrospinal fluid if positive. Now, let's focus on high-yield nursing responsibilities for managing increased ICP. Nurses must always prioritize airway, breathing, and circulation. They also need to control carbon dioxide levels because high carbon dioxide can further elevate ICP. Hyperventilating the patient helps reduce carbon dioxide levels, aiming for normal ranges between 35 to 45 millimeters of mercury. Activities that could raise intracranial pressure should be strictly avoided. This includes avoiding frequent suctioning, preventing the patient from blowing their nose or straining, and administering stool softeners to prevent constipation. Nurses should ensure urinary catheters function well to avoid additional abdominal pressure. It's important to keep the head of the bed elevated at less than 30 degrees, but for surgeries below the tentorium cerebelli, known as infratentorial surgeries, the patient should remain flat. Also, nurses must keep the patient's neck in a neutral position, avoiding any flexing or extending. Medications commonly given for increased intracranial pressure include mannitol, an osmotic diuretic that reduces cerebral swelling but requires close electrolyte monitoring. Pentobarbital is used to decrease brain metabolism. Phenytoin to prevent seizures, and morphine or fentanyl for pain management, noting the risk of respiratory depression. Regarding surgical management, a craniotomy might be performed, which involves removing a bone flap to relieve pressure. After surgery, positioning varies. For supratentorial procedures, meaning above the tentorium cerebelli, the head of the bed is raised to 30 degrees. For infratentorial procedures, typically involving the brainstem, the patient stays flat on either side to avoid pressure on the incision site. Several complications can arise from head injuries, including brain herniation, diabetes insipidus or DI, syndrome of inappropriate antidiuretic hormone, known as SIADH, and cerebral salt wasting syndrome, abbreviated as CSWS. Brain herniation signs include dilated pupils, loss of consciousness, abnormal posturing, and irregular breathing. Diabetes insipidus occurs due to pressure on the hypothalamus, leading to excessive urine output, dehydration, and high sodium levels. In contrast, SIADH, caused by excessive antidiuretic hormone secretion, results in fluid retention, low sodium levels, and decreased urine output. Cerebral salt wasting syndrome leads to low sodium, dehydration, and decreased blood volume. High-yield nursing actions for these complications are critical. Brain herniation is an emergency. Nurses must notify the healthcare provider immediately and prepare for potential intubation and surgery. For diabetes insipidus, monitor urine output, administer desmopressin, also known as DDAVP, and rehydrate the patient. Managing SIADH involves fluid restriction and administering hypertonic saline, 3% if needed. For cerebral salt wasting syndrome, intravenous fluids with sodium replacement are necessary, along with close electrolyte monitoring. Now, let's discuss stroke, also known as a cerebrovascular accident. Stroke is a medical emergency that happens when blood flow to the brain is disrupted, leading to oxygen deprivation and potentially causing brain cell death. There are three main types of stroke. First is hemorrhagic stroke, which occurs when an artery or aneurysm bursts, causing bleeding inside the brain. Second is thrombotic stroke, which happens when a blood clot, called a thrombus, forms directly in a brain artery, blocking blood flow. Third is embolic stroke, where a blood clot, called an embolus, travels from another part of the body, commonly from the heart due to conditions like atrial fibrillation, and then blocks a brain artery. Several risk factors can increase the chance of a stroke. Non-modifiable risk factors include age, where older adults are at higher risk, family history, gender, as males are more likely affected, and race, particularly African Americans. Modifiable risk factors, on the other hand, are things we can control, such as hypertension, diabetes mellitus, smoking, atrial fibrillation, high cholesterol levels, hyperlipidemia, obesity, lack of exercise, excessive alcohol intake, and carotid artery disease. Signs and symptoms of stroke often include visual disturbances, dizziness, slurred speech, facial drooping, and sudden weakness or paralysis on one side of the body. A helpful way to remember this is the fast mnemonic: facial droop, arm weakness, speech difficulty, and time to call 911 immediately. Stroke symptoms also differ based on which side of the brain is affected. For a left hemisphere stroke, which affects the right side of the body, patients often experience deficits in language areas like Broca's and Wernicke's, math skills, and analytical thinking. They may have aphasia, which is difficulty speaking or understanding language, and trouble reading and writing, known as alexia and agraphia. They also commonly experience right-sided paralysis or weakness and loss of vision on one or both sides. On the other hand, a right hemisphere stroke, affecting the left side of the body, leads to difficulties in visual and spatial awareness. These patients may show poor impulse control and judgment, increasing their risk of falls and often neglect or ignore their left side completely. They typically experience left-sided paralysis or weakness. An easy memory aid is left equals language problems and right equals reckless or impulsive behavior. Nursing responsibilities, especially important for exams like NCLEX, involve acute stroke management. Firstly, assess blood pressure carefully. If the systolic is greater than 180 millimeters of mercury, or the diastolic exceeds 110 millimeters of mercury, it suggests an ischemic stroke. For dysphagia precautions, nurses should always check the patient's gag reflex before giving anything by mouth. Positioning the patient upright at 90 degrees during meals, teaching the chin tuck method when swallowing, and providing thickened liquids if necessary can help prevent aspiration. Preventing tissue injuries and pressure ulcers is crucial, so repositioning the patient every 2 hours and using pillows or heel protectors is important. In patients with visual field loss, known as homonymous hemianopsia, teach them to use a scanning technique, turning their head fully from the unaffected side toward the affected side when eating or walking. Promoting mobility and safety involves regular range of motion exercises to prevent muscle contractures, assisting patients with ambulation using a gait belt, and implementing fall precautions like bed alarms, assistive devices, and a clutter-free environment. Regarding medications for stroke, antiplatelets such as aspirin and clopidogrel help prevent clot formation. Anticoagulants, including warfarin and heparin, are used especially in patients with atrial fibrillation to prevent further clotting. Thrombolytic medications, known as clot busters like Alteplase, must be administered within 4.5 hours from symptom onset for ischemic strokes, but must never be used if a hemorrhagic stroke is suspected. In some cases, surgical interventions like carotid artery angioplasty with stenting might be performed to remove clots and open blocked arteries. Finally, patient teaching focuses on stroke prevention. Controlling blood pressure and diabetes, regular exercise, maintaining a healthy weight, quitting smoking, limiting alcohol, and consistently taking prescribed anticoagulants, especially in patients with conditions like atrial fibrillation. Let's quickly review 2 common NCLEX-style questions. First, if a patient suddenly develops slurred speech, right-sided weakness, and facial drooping, with a blood pressure of 190 over 110 millimeters of mercury, what should the nurse do first? The correct answer is to obtain a blood glucose level because low blood sugar, or hypoglycemia, can mimic stroke symptoms, and it's important to rule that out before initiating stroke treatment. Second, if a stroke patient indicates that drinking thin liquids helps them swallow more easily, this shows the need for further teaching, because thin liquids actually increase aspiration risk. Instead, thickened liquids are recommended to help prevent choking and aspiration. Your NCLEX results will decide your future. Will you be celebrating as a licensed nurse, or will you be stuck retaking the exam? Don't leave your success to chance. We've designed the ultimate NCLEX crash course with a 99% passing rate, and over 5,000 nurses have already passed using it. Now, it's your turn. 100-hour animated crash course for those who want to pass in just 1 week. 300-hour comprehensive lectures covering 300 NCLEX favorite topics, 5,000 real NCLEX questions so you're never caught off guard. 15 full-length practice tests plus CAT simulations - feel 100% ready for the real exam. Exclusive NCLEX ebook plus 1-year access. Study at your convenience. Limited seats. Enroll now and grab 70% off before it's too late. Click the link in the description and secure your spot today. Now we will discuss spinal cord injuries, also called SCI, which happen due to trauma affecting the spinal cord, leading to different levels of motor and sensory loss depending on where the injury occurs. First, let's understand the classification of SCI based on the injury level. If the injury happens in the cervical spine, meaning above thoracic level 1, known as T1, it results in quadriplegia, also called tetraplegia. Quadriplegia means paralysis affecting both arms and legs. Injuries at cervical level 4 or C4 and above affect the phrenic nerve. This damage causes respiratory failure, meaning the patient can't breathe effectively on their own and thus needs mechanical ventilation and intubation. If the injury occurs below T1, involving the thoracic or lumbar spine, it results in paraplegia. Paraplegia means loss of function only in the lower extremities, while the upper limbs remain functional. An important condition related to spinal cord injury above thoracic level 6 or T6 is called neurogenic shock. This happens due to disruption in autonomic pathways. The main symptoms include low blood pressure, medically known as hypotension, slow heart rate called bradycardia, warm and dry skin, loss of the ability to regulate body temperature, and swelling known as dependent edema. To manage neurogenic shock, medications like vasopressors, specifically norepinephrine or dopamine, are given to support blood pressure, and atropine is used to correct the slow heart rate. Now, let's differentiate between upper and lower motor neuron injury effects. If an injury occurs above lumbar level 1 or 2, L1 or L2, it's considered an upper motor neuron injury. This type of injury causes spastic paralysis, which results in a spastic neurogenic bladder. That means the bladder contracts involuntarily, causing urinary incontinence. On the other hand, injuries below lumbar level 1 or 2, L1 or L2, are lower motor neuron injuries. These result in flaccid paralysis and a flaccid neurogenic bladder. Patients with this condition require intermittent catheterization because their bladder cannot contract effectively. Now, let's talk about symptoms commonly seen in SCI patients. Patients often lose sensation, meaning they can't feel light touch or differentiate between sharp and dull stimuli. Deep tendon reflexes, also called DTRS, are usually absent. Flaccid muscle tone is typical in lower motor neuron injuries, while spastic muscle tone appears in upper motor neuron injuries. Hypotension due to autonomic dysfunction is common. Another critical complication seen in injuries above T6 is autonomic dysreflexia, a life-threatening condition. Moving on to nursing interventions and management during the acute phase of spinal cord injury, the first priority is airway and breathing support. Nurses should closely monitor for respiratory failure, especially in cervical SCI above C4, and prepare for mechanical ventilation and intubation when needed. Maintaining hemodynamic stability is crucial. Nurses must watch carefully for signs of neurogenic shock, like bradycardia and hypotension. To manage this, vasopressors such as norepinephrine or dopamine are administered, and atropine is used to treat severe bradycardia. Performing regular neurological assessments is essential to detect any changes in sensory and motor functions. Additionally, nurses should assess patients for signs of autonomic dysreflexia, especially in injuries above T6. Proper bowel and bladder management is also critical. In upper motor neuron injuries causing a spastic bladder, scheduled voiding, along with anticholinergic medications such as oxybutynin, are recommended. In lower motor neuron injuries with flaccid bladder, intermittent catheterization and cholinergic medications like bethanacol are typically used. For bowel management, a daily bowel routine involving stool softeners, a high-fiber diet, and digital rectal stimulation is essential. Another critical role of nurses is preventing complications such as orthostatic hypotension, pressure ulcers, and deep vein thrombosis, also called DVT. To prevent orthostatic hypotension, nurses should help patients change positions slowly, use compression stockings, and abdominal binders. For pressure ulcer prevention, frequent repositioning every 2 hours, skin assessments, and the use of pressure-relieving devices are vital. DVT is prevented by giving anticoagulant medications like heparin or enoxaparin and using sequential compression devices or SCDs. Finally, let's review the key medications commonly used in SCI. Glucocorticoids, specifically methylprednisolone, help reduce spinal cord swelling during the acute phase. Vasopressors like dopamine or norepinephrine maintain blood pressure during neurogenic shock. Muscle relaxants, such as baclofen or dantrolene, treat muscle spasticity seen in upper motor neuron injuries. Anticholinergics, including oxybutynin, manage a spastic neurogenic bladder. And stool softeners like docusate help prevent constipation, a common complication for SCI patients. Now let's talk about autonomic dysreflexia, a serious medical emergency that can occur in patients with spinal cord injuries above the 6th thoracic vertebra, T6. Autonomic dysreflexia happens when there is an excessive sympathetic nervous response triggered by a painful or irritating stimulus, and the body cannot balance it out with the parasympathetic nervous system. The most common causes include bladder distension, such as from a blocked catheter or a full bladder. Other frequent triggers are fecal impaction, tight clothing, or pressure ulcers. Typical symptoms of autonomic dysreflexia are severe hypertension, often with a systolic blood pressure higher than 200 millimeters of mercury, along with bradycardia, a pounding headache, sweating above the level of injury, blurred vision, nasal congestion, and facial flushing. Immediate nursing interventions for autonomic dysreflexia include: first, immediately sit the patient upright in a high Fowler's position. Next, quickly identify and remove the trigger by checking if the bladder is distended and emptying it if necessary, assessing for fecal impaction and removing it if found, and loosening any tight clothing. Frequently monitor blood pressure. Administer antihypertensive medications such as nifedipine or hydralazine if the blood pressure stays elevated, and notify the healthcare provider immediately. Let's move on to high-yield nursing responsibilities for spinal cord injury (SCI) patients, crucial for NCLEX examinations. Priority nursing actions involve assessing airway, breathing, and circulation, often referred to as the ABCs. Regularly monitor the patient's neurological status using the Glasgow Coma Scale and check motor and sensory functions. Recognize and promptly manage neurogenic shock and autonomic dysreflexia. Maintain strict immobilization using a cervical collar and other spinal precautions. Prevent complications such as pressure ulcers, deep vein thrombosis, and infections. Educate patients thoroughly on bowel and bladder training. Common NCLEX questions regarding spinal cord injuries often include recognizing symptoms of autonomic dysreflexia, identifying the first nursing actions when autonomic dysreflexia occurs, understanding why patients with injuries at the C4 vertebra require mechanical ventilation, knowing interventions to prevent orthostatic hypotension, and determining appropriate medications for bradycardia in neurogenic shock. Now, let's discuss essential diagnostic and therapeutic procedures like arterial blood gases, bronchoscopy, thoracentesis, and chest tubes. Arterial blood gases, or ABGs, are vital for assessing oxygenation, ventilation, and acid-base balance. Before drawing blood from the radial artery, perform an Allen's test. In this test, compress both the ulnar and radial arteries, release pressure from the ulnar artery, and ensure capillary refill occurs within 5 to 15 seconds. This confirms arterial patency, meaning it is safe to proceed with the ABG procedure. After drawing an arterial blood gas, apply direct pressure at the puncture site for at least 5 minutes. For patients taking anticoagulants, pressure should be held for at least 20 minutes. Monitor closely for complications like a hematoma, where firm pressure is needed, or an air embolism, where immediate treatment includes positioning the patient on their left side in the Trendelenburg position. Symptoms of an air embolism include difficulty breathing, chest pain, anxiety, and the feeling of air hunger. Next, bronchoscopy is used to visualize airways, perform biopsies, remove foreign objects, or clear secretions. Before bronchoscopy, keep the patient NPO, nothing by mouth, for 8 to 12 hours. Administer viscous lidocaine, or a local anesthetic throat spray to numb the throat, and sometimes atropine is given to reduce secretions and prevent aspiration. After bronchoscopy, ensure the gag reflex returns before allowing the patient to eat or drink, usually around 2 hours after the procedure. Mild blood-tinged sputum, sore throat, or a dry cough may occur normally. Monitor closely for complications like bronchospasm or airway obstruction, which present with difficulty breathing, wheezing, or stridor. These require immediate intervention. Now, thoracentesis is a procedure done to remove fluid from the pleural space, diagnose pleural effusions, or instill medications. Before the procedure, position the patient upright with arms supported on a bedside table and encourage them to remain still. After thoracentesis, monitor respiratory status hourly for the first few hours. It's essential to limit fluid removal to no more than 1 liter per session to avoid cardiovascular collapse. Watch for complications such as pneumothorax, which involves symptoms like tracheal deviation, uneven chest movement, air hunger, rapid heartbeat, and shallow respirations. Also, look out for signs of internal bleeding, including low blood pressure and rapid heart rate and mediastinal shift, a dangerous displacement of thoracic structures. Chest tubes are essential devices used in healthcare to drain air, blood, or fluid from the pleural space, especially in conditions such as pneumothorax, meaning air in the pleural space, and hemothorax, meaning blood in the pleural space. When placing a chest tube, the positioning depends on what's being drained. For pneumothorax, the tube's tip should be directed upward, pointing toward the shoulder, because air naturally rises. In cases of hemothorax or pleural effusion, the tip should point downward toward the posterior chest, since fluid tends to settle at the bottom. Now let's discuss the chest tube drainage system. The first part is called the water seal chamber, which prevents air from flowing back into the pleural space. It's normal to see slight movement of water here, known as tidling. However, continuous bubbling is not normal and indicates an air leak, which must be investigated immediately. The second part of the drainage system is the suction control chamber, which maintains negative pressure inside the chest. The most common negative pressure setting is -20 centimeters of water. Gentle bubbling in this chamber is expected and normal with wet suction. As nurses, there are important responsibilities to follow when managing a patient with a chest tube. Encourage the patient to cough and deep breathe every 2 hours. Additionally, check the water seal level every 2 hours and add sterile water if needed. Drainage should be monitored closely every hour for the first 24 hours and then every 8 hours afterward. If the drainage exceeds 70 milliliters per hour, notify the healthcare provider immediately. For optimal lung expansion, keep the patient in a semi-Fowler's or high Fowler's position. Always keep emergency supplies at the bedside, including hemostat, sterile water, and an occlusive dressing. In case of emergencies, if the chest tube becomes accidentally dislodged, apply an occlusive dressing taped on 3 sides immediately to prevent attention pneumothorax. If the drainage system becomes compromised, immerse the tube's tip in sterile water to maintain the seal. Signs of attention pneumothorax include tracheal deviation, absent breath sounds, respiratory distress, and chest asymmetry. This condition requires immediate intervention. When removing a chest tube, instruct the patient to take a deep breath, exhale, and then bear down. After removal, quickly apply an airtight sterile petroleum jelly gauze dressing and monitor closely for signs of respiratory distress. Now, let's go through some NCLEX practice questions. First question, a nurse is preparing to obtain an arterial blood gas, or ABG, sample from a patient's radial artery. What action should the nurse take first? A. Clean the puncture site with an antiseptic solution. B. Assess for a history of bleeding disorders. C. Perform the Allen's test. D. Apply pressure for at least 5 minutes after the procedure. The correct answer is option C. Perform the Allen's test. Second question. A nurse is caring for a patient who just had an arterial blood gas drawn. The patient suddenly develops shortness of breath, chest pain, and anxiety. Which action should the nurse take first? A. Notify the healthcare provider. B. Place the patient in Trendelenburg position on the left side. C. Administer oxygen via nasal cannula. D. Apply pressure to the puncture site. The correct answer is option B. Place the patient in Trendelenburg position on the left side. Third question. A nurse is giving pre-procedure instructions to a patient scheduled for a bronchoscopy. Which statement by the patient indicates a need for further teaching? A. I should avoid eating or drinking for 8 hours before the procedure. B. I may receive a local anesthetic to numb my throat. C. I should lie flat for the procedure to prevent complications. D. I might have a sore throat and blood-tinged sputum afterward. The correct answer is option C. I should lie flat for the procedure to prevent complications. Fourth question. A nurse is monitoring a patient after a bronchoscopy. Which finding requires immediate intervention? A. Mild sore throat. B. Blood-tinged sputum. C. Absence of gag reflex 2 hours after the procedure. D. Dry cough. The correct answer is option C. Absence of gag reflex 2 hours after the procedure. Fifth question. A patient develops sudden shortness of breath and rapid heart rate after a thoracentesis. Upon auscultation, the nurse finds absent breath sounds on one side. What complication should the nurse suspect? A. Mediastinal shift. B. Pneumothorax. C. Pulmonary embolism. D. Pleural effusion. The correct answer is option B. Pneumothorax. Sixth question. A nurse is caring for a patient with a newly inserted chest tube for hemothorax. Which finding should the nurse report immediately? A. Gentle bubbling in the suction control chamber. B. Fluctuation or titling in the water seal chamber. C. Continuous bubbling in the water seal chamber. D. Drainage of 40 milliliters per hour. The correct answer is option C. Continuous bubbling in the water seal chamber. Seventh question. A nurse notices a patient's chest tube has accidentally dislodged. What's the priority nursing action? A. Cover the insertion site with an occlusive dressing taped on 3 sides. B. Clamp the remaining chest tube to prevent air entry. C. Reinsert the chest tube using sterile technique. D. Place the patient in the prone position. The correct answer is option A. Cover the insertion site with an occlusive dressing taped on 3 sides. Now we will discuss oxygen therapy and mechanical ventilation. Understanding different oxygen delivery systems, signs of hypoxia, and safety measures is crucial for nurses caring for patients requiring oxygen support. Let's start with the oxygen delivery systems. The first type is the nasal cannula, which provides a flow rate of 1 to 6 liters per minute and delivers 24 to 44% fraction of inspired oxygen. It is ideal for patients who have mild hypoxia or chronic lung disease. Nursing responsibilities for a nasal cannula include checking the skin around the ears and nostrils for breakdown, making sure the prongs are positioned correctly, and using humidification if the flow rate is 4 liters per minute or higher to prevent mucosal dryness. The second system is the simple face mask, delivering oxygen at a flow rate of 5 to 8 liters per minute, providing 40 to 60% fraction of inspired oxygen. This mask is generally used for short-term oxygen therapy. Nurses must ensure a snug fit to prevent room air from diluting the oxygen and should remove the mask every 1 to 2 hours to dry the skin and avoid irritation. The third type is the partial rebreather mask, providing a flow rate of 6 to 11 liters per minute, delivering 60 to 75% fraction of inspired oxygen. The important point here is to never let the reservoir bag deflate completely. Nursing responsibilities include adjusting the oxygen flow to maintain inflation of the reservoir bag and monitoring closely for signs of carbon dioxide retention. The fourth device is the non-rebreather mask, offering the highest concentration of oxygen at a flow rate of 10 to 15 liters per minute, delivering 80 to 95% fraction of inspired oxygen. It's used for severe hypoxia and emergency situations. Nurses must ensure that the reservoir bag remains at least 2/3 full during each inhalation and should perform hourly checks on the mask's valve and flap for proper function. The fifth type is the Venturi mask, which provides the most precise control of oxygen concentration, ranging from 24 to 50% fraction of inspired oxygen. The flow rate varies based on the adapter used. It's especially beneficial for patients with chronic obstructive pulmonary disease who require a fixed low fraction of inspired oxygen to prevent carbon dioxide retention. Nurses should monitor for a proper fit and verify that the correct flow rate adapter is selected. The sixth type includes the aerosol mask or face tent, usually used for patients with facial injuries, burns, or those having a tracheostomy. These devices deliver oxygen with high humidity. Nursing responsibilities involve frequent checks for moisture buildup and ensuring good skin integrity. Now let's discuss the signs of hypoxia, which is oxygen deficiency in tissues. It is critical for nurses to recognize these signs early. Early signs of hypoxia include rapid breathing, also called tachypnea, increased heart rate, known as tachycardia, restlessness or anxiety, pale skin and mucous membranes, elevated blood pressure, hypertension, use of accessory muscles during breathing, nasal flaring, and abnormal lung sounds. If hypoxia is not addressed promptly, it progresses to late signs, including confusion, stupor, bluish discoloration of skin and mucous membranes, called cyanosis, slow breathing, known as bradypnea, decreased heart rate, bradycardia, low blood pressure, hypotension, and abnormal heart rhythms or cardiac dysrhythmias. Lastly, let's talk about oxygen toxicity and safety considerations. Signs of oxygen toxicity include a non-productive cough, pain beneath the sternum, substernal pain, nasal congestion, nausea or vomiting, headache, sore throat, and in severe cases, decreased breathing rate, hypoventilation. To prevent oxygen toxicity, nurses should always administer oxygen at the lowest effective concentration and carefully monitor patients, especially those on mechanical ventilation, for signs of toxicity. General oxygen safety precautions include keeping oxygen sources away from open flames, so absolutely no smoking near oxygen, and using cotton clothing instead of wool or synthetic fabrics, which can create static electricity. It's also important to avoid using volatile or flammable materials like alcohol or petroleum-based products near oxygen. Let's now discuss non-invasive ventilation, which is commonly used to assist patients with breathing difficulties. The first type is called continuous positive airway pressure. This is often used for conditions such as obstructive sleep apnea. Continuous positive airway pressure works by continuously providing positive air pressure, keeping the airways open. As a nurse, your main responsibilities with continuous positive airway pressure include ensuring that the patient's mask has a proper seal. Additionally, monitor the patient regularly for any skin breakdown or dryness caused by the mask. Another type of NIV is called bilevel positive airway pressure, or BiPAP. This therapy is used for conditions like sleep apnea, respiratory failure, or as a step before or after using a mechanical ventilator. BiPAP is unique because it provides different air pressures during inhalation and exhalation. With BiPAP, your nursing responsibilities include regularly assessing the patient's respiratory effort and oxygen saturation levels. Providing frequent oral care is also important to maintain patient comfort and prevent infections. Moving on to mechanical ventilation, let's first talk about preparing a patient for this procedure. Before intubation, you must suction the airway thoroughly to remove any secretions. Make sure a manual resuscitation bag with a face mask and oxygen is readily available in case it's needed. Regular oral and skin care is critical during ventilation to prevent complications such as ventilator-associated pneumonia. After the patient is extubated or after removing the breathing tube, your care continues. You should encourage the patient to cough and practice deep breathing exercises. Immediately after extubation, monitor their oxygen saturation and vital signs every 5 minutes. Keep the patient positioned in semi-Fowler's position to help prevent aspiration and encourage them to use incentive spirometry, which promotes lung expansion. Always monitor for signs of airway obstruction, such as noisy breathing known as stridor, or signs of respiratory distress. Now, let's address common ventilator alarms and how to handle them effectively. First is the low-pressure alarm. This alarm usually indicates issues like disconnection, a leak in the cuff, or displacement of the breathing tube. When this alarm sounds, your responsibilities are to quickly check the ventilator tubing for any disconnections, reinflate the cuff if it has a leak, and make sure all connections in the ventilator circuit are secure. Next is the high-pressure alarm, which can be triggered by excess secretions, a kinked tube, the patient biting the tube, coughing, pulmonary edema, bronchospasm, or even a collapsed lung known as pneumothorax. When the high-pressure alarm goes off, you should immediately suction secretions if needed, check for any kinks in the tubing, and assess if the patient is biting the tube, as sedation might sometimes be required. Also, closely monitor the patient for signs of pneumothorax and notify the healthcare provider promptly if you suspect this complication. A helpful mnemonic to remember ventilator alarms easily is high equals kink, low equals leak. Finally, let's quickly review important focus areas for nursing responsibilities on the NCLEX exam related to oxygenation and ventilation. Recognize early versus late signs of hypoxia. Ensure precise oxygen delivery, especially when using devices like a Venturi mask. Follow strict oxygen safety precautions, including prohibiting smoking and encouraging patients to wear cotton clothing to reduce fire risk. Prevent oxygen toxicity by carefully monitoring oxygen therapy. Recognize and effectively respond to ventilator alarms immediately. Provide thorough post-extubation care to prevent complications. Now, let's discuss rhinitis and sinusitis. Rhinitis refers to the inflammation of the nasal mucosa, causing symptoms such as a runny nose, congestion, sneezing, and nasal itching. This condition can be triggered by various factors, including viral or bacterial infections, allergens, irritants, or environmental conditions. Effective management includes increasing fluid intake, using a humidifier to maintain moisture, practicing proper cough etiquette by coughing into your shoulder, and maintaining good hand hygiene. Additionally, medications such as antihistamines like loratadine, decongestants such as pseudoephedrine, and intranasal corticosteroids like fluticasone are helpful in managing symptoms. Sinusitis is similar to rhinitis, but it specifically involves inflammation of the sinuses. If sinusitis is caused by bacteria, antibiotics like amoxicillin are typically used. Other effective treatments include nasal irrigation, decongestants, and pain relievers. As nurses, it's important to educate patients on nasal irrigation techniques, encourage increased hydration and humidified air use, and closely monitor for potential complications such as sinus infections. Next, let's move on to influenza. Influenza, commonly known as the flu, is a highly contagious viral infection that presents with severe headaches, muscle aches, fever, chills, fatigue, nausea, vomiting, and diarrhea. Treatment involves antiviral medications like oseltamivir, which must be started within 24 to 48 hours after symptoms appear to be effective. Supportive care, including rest, proper hydration, and treating symptoms individually, is also essential. To prevent influenza, an annual flu vaccination is recommended for everyone older than 6 months. Nursing responsibilities include educating patients about the importance of vaccination, monitoring for complications such as pneumonia, and implementing droplet precautions to prevent spread. Now we'll discuss pneumonia. Pneumonia is an infection that causes inflammation of the alveoli, leading to fluid accumulation in the lungs. Common symptoms include fever, chills, cough, either productive or non-productive, shortness of breath, chest pain, crackles, wheezing, and confusion in elderly patients. Diagnosis is confirmed through a chest X-ray showing lung consolidation, sputum cultures collected before starting antibiotics, and pulse oximetry readings below 95% indicating hypoxia. Treatment involves positioning the patient in a high Fowler's position, sitting upright at 90 degrees, encouraging coughing, deep breathing, and the use of an incentive spirometer. Oxygen therapy may be required, along with increased calorie and fluid intake of 2 to 3 liters per day. Medications typically used include antibiotics like azithromycin for bacterial pneumonia, bronchodilators such as albuterol, and anti-inflammatory drugs like prednisone. Nurses must monitor for worsening symptoms and signs of sepsis, assess response to antibiotics, educate patients on pneumonia vaccination, pneumovax for high-risk groups, and watch for side effects of corticosteroids such as gastrointestinal bleeding and high blood sugar levels. Hey, future nurses, listen up. If you want to pass the NCLEX in one try, we've got the ultimate shortcut for you. Our NCLEX Review Crash Course has a 99% passing rate, and more than 5,000 nurses have already passed using it. Now it's your turn. Here's what sits inside the course: 100-hour animated crash course, ideal for those with very little time to study. 300-hour comprehensive lectures covering 300 must-know NCLEX topics. 5,000 real NCLEX questions learned from past exams. 15 full-length practice tests, including CAT simulations, exclusive ebook, and 1-year access, so you can study whenever you want. Limited spots left. Enroll now and get 70% off, but only for a short time. Click the link in the description and get started today. Moving forward to asthma, which is a chronic inflammatory disorder that causes intermittent and reversible airway obstruction. Symptoms include wheezing, coughing, prolonged exhalation, decreased oxygen saturation, and, in chronic cases, a barrel-shaped chest. Asthma is diagnosed through pulmonary function tests and using a peak flow meter, noting the highest of 3 readings. Treatment includes placing the patient in a high Fowler's position, administering oxygen therapy, and using medications like short-acting beta agonists, such as albuterol for acute attacks, anticholinergics like ipratropium for maintenance, theophylline, monitoring for toxicity, long-acting beta agonists like salmeterol for prevention, and anti-inflammatory medications like glucocorticoids and leukotriene antagonists. In emergencies such as status asthmaticus, a severe asthma attack unresponsive to standard treatment, immediate administration of oxygen, bronchodilators, and possibly epinephrine is essential. Nursing responsibilities include teaching proper inhaler techniques, using a spacer with steroids to prevent oral thrush, monitoring medication side effects, and educating patients on asthma triggers and prevention strategies. Finally, let's discuss chronic obstructive pulmonary disease, also known as COPD. COPD is a progressive, irreversible lung disease divided into 2 main categories. Emphysema, characterized by loss of lung elasticity and destruction of alveoli causing carbon dioxide retention, and chronic bronchitis, characterized by inflammation of bronchi with excessive mucus production. Risk factors include smoking, environmental exposure, aging, and genetic factors such as alpha-1 antitrypsin deficiency. Symptoms typically include shortness of breath, wheezing, accessory muscle use during breathing, barrel chest, clubbing of fingers, low oxygen levels, less than 80 millimeters of mercury, and high carbon dioxide levels greater than 45 millimeters of mercury. Dependent edema may also occur due to right-sided heart failure associated with pulmonary hypertension. COPD is diagnosed using pulmonary function tests, arterial blood gas analysis indicating respiratory acidosis, and chest X-rays showing hyperinflated lungs. Treatment includes maintaining the patient in a high Fowler's position, encouraging pursed lip and diaphragmatic breathing, providing low-flow oxygen therapy to prevent excessive carbon dioxide retention, and recommending a high-calorie, high-protein diet. Medications include bronchodilators like albuterol and ipratropium, theophylline with careful monitoring for toxicity, mucolytics such as acetylcysteine, and corticosteroids, watching for side effects like high blood sugar and fluid retention. Nurses must monitor for frequent respiratory infections, signs of right-sided heart failure, cor pulmonale, educate patients on breathing techniques, encourage smoking cessation, and teach early recognition of infection through symptoms like increased sputum or fever. Monitoring for signs of carbon dioxide retention, such as confusion or drowsiness, is also crucial. Now, we'll practice some important NCLEX questions related to patient education and disease management. The first question is, a nurse is providing education to a patient who has rhinitis, which means inflammation of the nasal passages, about managing their symptoms. Which statement made by the patient shows that they need further teaching? Option A says, I will increase my fluid intake to help with congestion. Option B says, using a humidifier can help relieve nasal irritation. Option C says, I should take my antibiotics as prescribed to treat the viral infection. Option D says, practicing hand hygiene can help prevent the spread of infection. The correct answer here is option C. This is because rhinitis caused by viruses doesn't require antibiotics. Antibiotics are used only for bacterial infections. Drinking more fluids, using a humidifier, and washing hands are all appropriate ways to manage rhinitis. Moving to question 2. The nurse is assessing a patient who might have bacterial sinusitis, an infection of the sinuses caused by bacteria. Which symptom most strongly indicates bacterial sinusitis? Option A mentions clear nasal drainage and sneezing. Option B describes purulent nasal discharge, meaning thick yellow or green mucus, along with facial pain. Option C states dry cough and mild sore throat. Option D includes nasal congestion and postnasal drip. The correct answer is option B. Purulent nasal discharge along with facial pain strongly suggests bacterial sinusitis. Clear drainage and sneezing typically point towards allergies. Dry cough and mild sore throat are general symptoms, not specific enough for bacterial sinusitis. Now, question 3. A nurse is caring for a patient diagnosed with pneumonia. What's the highest priority nursing intervention in this case? Option A says encouraging the patient to drink 2 to 3 liters of fluids each day. Option B involves giving bronchodilators, medications that help open airways. Option C mentions placing the patient in high Fowler's position, meaning sitting them upright. Option D suggests obtaining a sputum culture before starting antibiotics. The correct answer is option D. Taking a sputum sample before starting antibiotics is crucial because it ensures the right antibiotic is chosen for effective treatment. While the other interventions are important, they do not come before identifying the correct antibiotic. Next, we'll talk about tuberculosis, commonly called TB. Tuberculosis is a highly contagious disease caused by the bacteria Mycobacterium tuberculosis. It mainly affects the lungs but can spread to other parts of the body, which is called extrapulmonary TB. TB spreads through airborne droplets when an infected person coughs, sneezes, or speaks. Therefore, special precautions are necessary. Patients should stay in a negative pressure isolation room. Healthcare workers must wear an N95 respirator mask. The patient must wear a surgical mask whenever they leave their room. Certain factors increase the risk of getting TB. Crowded environments like prisons, homeless shelters, and nursing homes. Poor socioeconomic conditions such as low income, malnutrition, and limited healthcare access. Health issues that weaken the immune system like HIV, chemotherapy, organ transplants, and diabetes. Substance abuse, including alcoholism and intravenous drug use. Recognizing TB symptoms can be remembered with the phrase TB coughs and sweats, persistent cough lasting more than 3 weeks, producing mucus that can be bloody or purulent, containing pus. Unexplained and significant weight loss, extreme fatigue and lethargy, loss of appetite, also known as anorexia, night sweats, and a low-grade fever. Diagnosing TB involves the tuberculin skin test, also called the Mantoux test. An induration or raised area of 10 millimeters or greater is positive for most people, and 5 millimeters or greater is positive for immunocompromised patients. A previous BCG vaccine can cause false positives, requiring a chest x-ray for confirmation. Chest x-rays help identify active TB lesions. Sputum cultures, specifically an acid-fast bacilli test, need 3 early morning sputum samples collected on different days. Treatment usually involves ripe therapy for 6 to 12 months, consisting of rifampin, which can affect the liver and causes orange-red discoloration of bodily fluids like urine, sweat, and tears. It may even stain contact lenses. Isoniazid, also affecting the liver and causing peripheral neuropathy, nerve damage. Vitamin B6, or pyridoxine, can prevent this. Pyrazinamide, another liver-affecting drug that can cause gout, so patients should drink plenty of fluids. Ethambutol, known to affect vision, leading to color blindness or changes in eyesight, requiring regular eye checkups. Streptomycin, an alternative medication that can cause hearing damage, thus hearing checks are essential. Nurses must also ensure regular sputum cultures every 2 to 4 weeks until 3 consecutive negative cultures confirm the patient is no longer infectious. It's critical to maintain medication adherence to prevent drug-resistant TB. Sometimes directly observed therapy, or DOT, is required to ensure compliance. Since TB is a reportable disease, healthcare providers must notify local health authorities. Educating the patient is key, emphasizing avoiding alcohol to protect the liver, practicing good cough hygiene by covering the mouth and safely disposing of tissues, and ensuring household contacts are screened for TB. Now, we will discuss myocardial infarction and percutaneous coronary intervention, essential concepts in cardiac care. Percutaneous coronary intervention, known as PCI, aims to open blocked coronary arteries. Methods used include balloon angioplasty, placing stents, or removing plaque. This procedure must be performed within 90 minutes after symptoms of myocardial infarction appear. Typical signs of a myocardial infarction, also called a heart attack, include crushing chest pain that may radiate to the jaw, left arm, or shoulder. However, some patients, especially women, may show atypical symptoms like nausea, excessive sweating known as diaphoresis, shortness of breath, or fatigue. There are 2 main types of myocardial infarction, STEMI and NNSTEMI. STEMI stands for ST segment elevation myocardial infarction, which appears on an electrocardiogram as ST elevation and is more dangerous. And STEMI means non-ST elevation myocardial infarction, appearing as ST depression or inverted T waves. As a nurse caring for patients undergoing PCI, your responsibilities begin before the procedure. The patient must remain without food or drink for 8 hours. It's important to assess for allergies to shellfish or iodine, as these indicate a possible allergy to contrast dye. Monitoring kidney function is also necessary since the kidneys excrete the dye. After the PCI procedure, carefully monitor the groin site for bleeding. Regularly check pedal pulses to ensure good blood circulation in the feet. Keep the patient flat and on bed rest for 4 to 6 hours. Administer medications like antiplatelet or thrombolytic agents, and encourage intravenous fluids to help flush out the contrast dye. Advise patients to avoid strenuous activities and heavy lifting. Continuously monitor for signs of internal bleeding, such as low blood pressure or a rapid heart rate. One serious complication after PCI is cardiac tamponade, a medical emergency. Signs include low blood pressure, distended neck veins known as jugular vein distension, muffled heart sounds, and paradoxical pulse. Next, we will discuss coronary artery bypass graft, commonly called CABG, a surgical procedure used to bypass blocked coronary arteries. Surgeons typically use the saphenous vein from the leg or the internal mammary artery from the chest. After surgery, encourage patients to perform coughing and deep breathing exercises to prevent pneumonia, and teach them to use an incentive spirometer. Initially, patients may have an endotracheal tube and require mechanical ventilation. Monitor surgical incisions in the chest and leg carefully for signs of infection. Closely observe chest tube drainage. More than 150 milliliters per hour could indicate bleeding, and you must notify the healthcare provider immediately. Maintain a low core body temperature post-operatively to reduce oxygen demands. Educate patients about necessary lifestyle changes, including diet, exercise, and smoking cessation. Now, we will discuss peripheral artery disease, a condition restricting blood flow to the extremities. Patients typically experience intermittent claudication, which is pain during exercise that resolves with rest. Another sign is rest pain, relieved by lowering the legs below heart level. Additional symptoms include absent or weak pulses, cold, shiny, hairless skin, and feet that appear mottled or dusky with thickened toenails. For peripheral bypass grafts, your responsibilities as a nurse include pre-operative fasting for 8 hours. Post-operatively, instruct patients not to cross their legs to prevent blockage. Frequently check pulses, skin color, temperature, and capillary refill in the feet. Maintain strict bed rest for 18 to 24 hours with legs kept straight, and apply compression stockings. Be alert for complications such as compartment syndrome, which is a medical emergency. Look for the 5 Ps: pain, pulselessness, paresthesia or tingling sensation, paralysis, and pallor. Immediate treatment with a surgical fasciotomy is required to relieve the pressure. Finally, let's discuss angina and myocardial infarction, two conditions involving reduced blood flow to the heart. Angina can be stable, occurring during exercise and relieved by rest or nitroglycerin, unstable, occurring even at rest and progressively worsening, or variant, caused by coronary artery spasms that happen at rest. Symptoms of a myocardial infarction typically last longer than 30 minutes, distinguishing them from angina. Patients often experience shortness of breath, heavy sweating, feelings of impending doom, cool, clammy skin, and rapid heart rate. Risk factors include being male or a postmenopausal female, high blood pressure, smoking, high cholesterol, diabetes, and stress. On an electrocardiogram, a STEMI shows ST elevation, whereas an NSTEMI shows ST depression and inverted T waves. Nitroglycerin is commonly used to treat cardiac chest pain. Be cautious of orthostatic hypotension. Patients should stop activities, sit, and rest before taking the medication sublingually. If pain persists after 3 doses, call emergency services immediately. Headaches are common side effects. Other medications include opioid pain relievers like morphine and beta blockers, which require pulse checks before administration. We'll discuss heart failure and pulmonary edema, two closely related conditions. Heart failure is a chronic condition where the heart becomes unable to pump blood effectively to meet the body's needs. We typically classify heart failure into 2 types based on the area of congestion: right-sided heart failure, leading to congestion in the body, and left-sided heart failure causing congestion in the lungs. Let's quickly review how blood flows through a healthy heart. First, deoxygenated blood returns to the right atrium, moves into the right ventricle, and is pumped to the lungs for oxygenation. Then, oxygen-rich blood returns to the left atrium, moves into the left ventricle, and is pumped out to supply the entire body. In heart failure, this pumping action is impaired. If the left side of the heart fails, blood backs up into the lungs, causing pulmonary congestion. If the right side fails, blood accumulates in the body, causing systemic congestion. Now let's understand these 2 types of heart failure separately. First, right-sided heart failure, also known as systemic congestion. Here, blood accumulates in the body's circulation, causing symptoms like swelling or peripheral edema in the legs, ankles, and sacral area. You may also notice visibly distended jugular veins called jugular vein distension or JVD. Additionally, fluid can collect in the abdomen, leading to ascites or abdominal enlargement, and the liver may enlarge. This is known as hepatomegaly, causing pain in the right upper quadrant. Weight gain due to fluid retention is also common. Second, left-sided heart failure, which leads to pulmonary congestion. Here, blood backs up into the lungs, making it harder to breathe. Common symptoms include crackles in the lungs, difficulty breathing known as dyspnea, and trouble breathing when lying flat called orthopnea. Pulmonary edema can develop presenting as pink-tinged frothy sputum, which is a serious medical emergency. Patients might also experience sudden nighttime shortness of breath called paroxysmal nocturnal dyspnea or PND, along with fatigue and weakness due to decreased cardiac output. Moving to diagnostic tests and laboratory findings, we have specific markers to detect heart failure. The brain natriuretic peptide, or BNP level, becomes elevated in heart failure. Normally, BNP is less than 100 picograms per milliliter, but in heart failure, levels typically rise above 400 picograms per milliliter. Ejection fraction, or EF, which measures how well the heart pumps, is reduced from the normal range of 50 to 70% down to below 40%. We also see certain hemodynamic changes: an increase in central venous pressure, an increase in pulmonary wedge pressure, elevated pulmonary artery pressure, and decreased cardiac output. For imaging studies, the echocardiogram is considered the gold standard, helping assess ejection fraction and heart chamber function. A chest X-ray can show heart enlargement, known as cardiomegaly, and signs of pulmonary congestion. Additionally, transesophageal echocardiography can provide detailed images of heart function. Next, let's highlight some critical nursing interventions that are high yield for NCLEX. Daily weights are essential as they are the best indicator of fluid retention. Always report a weight gain of more than 2 pounds in 24 hours. Strict monitoring of intake and output helps manage fluid overload. Provide oxygen therapy to support proper oxygenation and position patients in high Fowlers to improve breathing. Assisting with activities of daily living helps reduce the heart's workload. Fluid restriction and limiting sodium intake to less than 2 grams per day are crucial to preventing fluid retention. Additionally, monitor patients for signs of digoxin toxicity, such as visual disturbances, nausea, vomiting, and slowed heart rate. Regarding medications, we have several important drug classes used in heart failure management, essential for the NCLEX exam. First, diuretics reduce fluid overload. Loop diuretics, such as furosemide or bumetanide, can cause low potassium levels or hypokalemia, leading to muscle cramps or arrhythmias, so encourage patients to eat potassium-rich foods like bananas, oranges, or potatoes. They also carry a risk of ototoxicity if given too quickly intravenously. Thiazide diuretics, like hydrochlorothiazide, similarly risk hypokalemia and may also cause hyperglycemia or high blood sugar. Second, ACE inhibitors, ending with pril, and ARBs, ending with sartan, reduce afterload, easing the heart's workload. ACE inhibitors like lisinopril and enalapril can cause angioedema, dry cough, and elevated potassium or hyperkalemia. Always monitor blood pressure before administering due to a risk of hypotension. ARBs, like losartan or valsartan, have similar risks but are often used as alternatives if the patient develops a cough from ACE inhibitors. Third, beta blockers ending with LOL reduce the workload of the heart. Common examples include metoprolol or carvedilol, which can lead to bradycardia, hypotension, and fatigue. Always check the heart rate before administration, holding the medication if the rate is below 60 beats per minute. Fourth, digoxin increases heart muscle contractility. Always check the apical pulse for 1 full minute before giving digoxin, holding it if the pulse is below 60 beats per minute. Watch for signs of toxicity, including nausea, vomiting, fatigue, muscle weakness, confusion, and visual disturbances like seeing yellow-green halos. Remember, low potassium levels increase the risk of digoxin toxicity. Lastly, calcium channel blockers, ending with pine, such as amlodipine and nifedipine, can lead to hypotension and peripheral edema. Finally, let's address pulmonary edema, a critical medical emergency. Pulmonary edema happens when fluid rapidly accumulates in the lungs due to severe left-sided heart failure. Patients may show extreme difficulty breathing, gasping for air, crackles, or wheezing in the lungs, and cough up pink, frothy sputum. Initially, patients have rapid heart rate, tachycardia, and high blood pressure, hypertension. But this may quickly progress to low blood pressure or shock. Emergency nursing interventions here include immediately administering oxygen and placing the patient in high Fowler's position, giving intravenous diuretics like furosemide for rapid fluid removal, administering nitroglycerin to reduce both preload and afterload, and giving morphine to reduce anxiety and dilate blood vessels to improve circulation. Always closely monitor arterial blood gases and oxygenation levels. Advanced interventions in cardiac care include placing a pacemaker, which is commonly used to manage conduction defects in the heart. Another advanced intervention is the use of a left ventricular assist device, specifically for patients experiencing severe heart failure. In end-stage heart failure, a heart transplant may be the only viable solution. Patients undergoing a heart transplant will need lifelong immunosuppressive medications to prevent organ rejection. Now, let's discuss some of the most important nursing responsibilities that you might encounter on the NCLEX exam. Firstly, performing daily weight checks on your patients is crucial, and you should immediately report if there's a weight gain of more than 2 pounds within 24 hours. Before administering cardiac medications such as ACE inhibitors, beta blockers, or digoxin, always monitor the patient's blood pressure and heart rate. It is also essential to assess your patients for signs of pulmonary congestion, such as crackles in the lungs, difficulty breathing, or the presence of pink, frothy sputum. Monitoring electrolyte imbalances is vital because patients on diuretics may develop low potassium levels, hypokalemia, whereas those on ACE inhibitors or ARB may have elevated potassium levels, hyperkalemia. Educate your patients clearly about fluid and sodium restrictions to help manage their symptoms. Always watch carefully for signs of digoxin toxicity, which includes visual changes, nausea, vomiting, and a slow heart rate. If your patient is experiencing shortness of breath, elevate the head of the bed and provide supplemental oxygen. Moving forward, let's talk about valvular heart disease commonly. VHD occurs when one or more heart valves become narrowed, known as stenosis, or leaky, known as insufficiency. This issue disrupts the normal flow of blood, impacting cardiac output and overall oxygenation. Early identification and treatment are critical. In terms of pathophysiology, remember that the heart has 4 valves: mitral, aortic, tricuspid, and pulmonary. Stenosis happens when a valve stiffens and blocks blood flow. On the other hand, insufficiency or regurgitation occurs when a valve does not close fully, allowing blood to flow backward. Valvular heart disease can have several causes. Infectious causes include rheumatic heart disease from untreated group A streptococcal infections, infective endocarditis typically caused by Streptococcus viridans or Staphylococcus aureus, and rarely syphilis. Degenerative causes such as aging lead to fibrotic thickening and stiffness in the valves. Congenital causes include conditions like a bicuspid aortic valve, a common birth defect. Systemic conditions like chronic high blood pressure and connective tissue disorders such as Marfan syndrome or Ehlers-Danlos syndrome also affect valve health. Clinically, patients with valvular heart disease often present with murmurs due to turbulent blood flow, extra heart sounds like S3 and S4, or arrhythmias such as atrial fibrillation, particularly common in mitral stenosis. Symptoms can include shortness of breath, fatigue, dizziness, fainting, and signs of pulmonary congestion like crackles in the lungs. Right-sided valve dysfunction typically leads to peripheral swelling or fluid accumulation in the abdomen, ascites. Diagnostic tests for valvular heart disease include an echocardiogram, which is considered the gold standard because it assesses valve function. A chest X-ray helps detect an enlarged heart or pulmonary congestion. An electrocardiogram identifies irregular heart rhythms like atrial fibrillation. Cardiac catheterization measures pressure differences across heart valves. Medical management involves medications to relieve symptoms. Diuretics, especially loop diuretics like furosemide, reduce fluid volume, decreasing the workload on the heart. Watch for side effects like low potassium levels and encourage your patients to eat potassium-rich foods such as potatoes, bananas, leafy greens, and oranges. When administering intravenous potassium, never exceed 20 milliequivalents per hour. ACE inhibitors and ARBs help reduce resistance the heart pumps against and improve cardiac output. They may cause side effects like swelling, angioedema, a persistent dry cough, or increased potassium levels. Beta blockers reduce the oxygen demand of the heart muscle and control heart rate, especially in atrial fibrillation. Side effects include a slow heart rate, low blood pressure, and fatigue. Calcium channel blockers like diltiazem, verapamil, or amlodipine decrease afterload and manage arrhythmias but might cause low blood pressure, swelling, or dizziness. Digoxin strengthens heart contractions and slows the heart rate. Be alert for digoxin toxicity with symptoms like nausea, vomiting, visual disturbances, confusion, and slow heart rate. Always check the apical pulse for 1 full minute before administering digoxin and hold the medication if the heart rate is below 60 beats per minute. Procedures and surgical options include percutaneous balloon valvuloplasty, a minimally invasive technique used to widen narrowed valves. Valve repair or annuloplasty may be possible to preserve the natural valve. Valve replacements can be either mechanical, requiring lifelong anticoagulation therapy with warfarin, or bioprosthetic, which does not require anticoagulation, but typically lasts a shorter time. Finally, some nursing responsibilities frequently tested on the NCLEX include listening carefully for murmurs and noting their location and timing, monitoring signs of heart failure such as difficulty breathing, crackles, and swelling, and regularly checking blood pressure and heart rate. Educate your patients about dietary adjustments, including low-sodium diets to reduce fluid retention and high-potassium diets when on loop diuretics. Advise patients to avoid over-the-counter NSAIDs, which can increase fluid retention and blood pressure. Patients with prosthetic valves or repairs must have antibiotic prophylaxis before dental or invasive procedures to prevent infective endocarditis. After valve replacement surgery, monitor closely for signs of blood clots or bleeding complications. Educate patients thoroughly about lifelong anticoagulation, regular INR monitoring, and signs of bleeding such as bruising, blood in the urine, or black stools. Be vigilant for emergency situations like acute pulmonary edema or sudden valve dysfunction post-surgery, indicated by shortness of breath, chest pain, or new murmurs. Let's review some key NCLEX points to remember. First, streptococcal infections are a major cause of valvular heart disease, especially rheumatic fever and endocarditis. Next, distinguishing between systolic and diastolic murmurs helps differentiate valve stenosis from regurgitation. Also, loop diuretics reduce preload in the heart, but watch carefully for hypokalemia, meaning low potassium levels. On the other hand, ACE inhibitors help reduce afterload. However, monitor patients closely for hyperkalemia, high potassium levels, and signs of angioedema, which is facial or throat swelling. Remember, mechanical heart valves require lifelong anticoagulation therapy with warfarin. Regularly check the International Normalized Ratio, or INR, and keep it between 2.5 and 3.5. Additionally, patients with heart conditions must take antibiotic prophylaxis before undergoing dental or surgical procedures to prevent infections. Lastly, always check the apical pulse for 1 full minute before administering digoxin. If the pulse is below 60 beats per minute, hold the medication. Now, let's discuss inflammatory disorders of the heart, specifically pericarditis, rheumatic endocarditis, and infective endocarditis. These disorders are frequently triggered by infections, particularly streptococcal infections, and require prompt treatment to avoid serious complications. Starting with rheumatic endocarditis, it is primarily caused by group A beta hemolytic streptococcus infection, typically after untreated or poorly treated strep throat, known as streptococcal pharyngitis. In this condition, the body's immune response to the infection leads to heart inflammation, creating Aschoff bodies, which are nodules within the heart muscle, and damaging the heart valves. Risk factors include untreated strep throat, crowded living conditions, poor sanitation, and lower socioeconomic status. Common signs and symptoms are new heart murmurs, especially affecting the mitral valve, a pericardial friction rub, fever with chills, chest pain, shortness of breath, small red spots or petechiae on the trunk and limbs, joint pain, and swelling called polyarthritis, involuntary muscle movements known as chorea, and painless lumps under the skin, known as subcutaneous nodules. As nurses, your key responsibilities include early detection by assessing recent sore throat symptoms and obtaining throat cultures. Monitor patients closely for cardiac complications by listening for new or worsening murmurs. Administer penicillin antibiotics promptly, as it's the first-line medication to prevent disease progression. Additionally, manage symptoms with non-steroidal anti-inflammatory drugs and educate patients on the importance of prophylactic antibiotics before dental or invasive procedures. Next, let's examine pericarditis. This condition can result from viral or bacterial infections, including tuberculosis after a heart attack, known as Dressler's syndrome, autoimmune diseases, or trauma. It involves inflammation of the pericardial sac surrounding the heart, potentially leading to fluid accumulation called pericardial effusion, and in severe cases, cardiac tamponade. Patients typically experience sharp chest pain that worsens when lying down and improves upon sitting up and leaning forward. Other symptoms include a pericardial friction, rub heard best at the left sternal border, shortness of breath, fever with chills, and specific ECG changes like ST segment elevation across multiple leads. In caring for these patients, encourage them to sit upright and lean forward to relieve chest pain. Administer medications like ibuprofen, aspirin, or colchicine for inflammation and pain. Vigilantly monitor for signs of cardiac tamponade, including low blood pressure, distended jugular veins, and muffled heart sounds known as Beck's triad. Keep an eye on ECG changes and be prepared for pericardiocentesis if fluid drainage becomes necessary. Lastly, we'll cover infective endocarditis. It is often caused by bacteria like Streptococcus viridans or Staphylococcus aureus, and commonly occurs in intravenous drug users, patients who recently had heart surgery, or individuals with prosthetic heart valves. The bacteria enter the bloodstream and settle on damaged heart valves, forming vegetations that may break off and travel to other organs. Risk factors include intravenous drug use, artificial heart valves, previous endocarditis, congenital heart defects, and poor dental hygiene or recent dental procedures. Symptoms to watch for include fever, flu-like symptoms such as chills, malaise, weakness, a new or worsening heart murmur, tiny red spots or petechiae on the skin, red streaks under the nails called splinter hemorrhages, painless red spots on the palms or soles known as Janeway lesions, painful raised spots on fingers or toes called Osler's nodes, and retinal hemorrhages with white centers called Roth spots. Nursing responsibilities for infective endocarditis involve obtaining multiple blood cultures before starting antibiotics to identify the organism accurately. Administer long-term intravenous antibiotics, typically a combination of vancomycin and gentamicin, for 4 to 6 weeks. Carefully monitor for complications like stroke, pulmonary embolism, or kidney damage due to emboli. Regularly assess for signs of heart failure, such as new murmurs, worsening breathing difficulty, and peripheral swelling. Educate patients on the necessity of prophylactic antibiotics before dental or invasive procedures to prevent recurrence. Regarding laboratory and diagnostic tests for these inflammatory heart conditions, blood cultures help identify the infectious organism. Throat cultures detect group A streptococcus, and elevated levels of ESR and CRP indicate inflammation. ECGs reveal important changes like ST segment elevations in pericarditis or conduction problems. Echocardiograms detect vegetations and valve damage, while chest X-rays can show enlarged hearts or fluid buildup around the heart. Now, let's summarize the treatment approaches for key cardiovascular conditions clearly and concisely. The first condition is rheumatic endocarditis, mainly caused by untreated strep throat infections. Patients often show symptoms such as heart murmurs, fever, joint pain, rash, and involuntary movements known as chorea. Treatment involves administering penicillin to eliminate the bacterial infection, along with non-steroidal anti-inflammatory drugs, also known as NSAIDs, and corticosteroids to manage inflammation and symptoms. The second condition is pericarditis, an inflammation of the heart's pericardial sac. It usually occurs due to viral infections, but bacterial infections, autoimmune conditions, and Dressler's syndrome following a heart attack, myocardial infarction, can also cause this condition. Common symptoms include sharp chest pain that improves when sitting upright, a friction rub sound heard upon examination, and shortness of breath. The recommended treatments include NSAIDs, colchicine, steroids for inflammation, and pericardiocentesis, which is the drainage of fluid if cardiac tamponade occurs. The third condition is infective endocarditis, often linked to intravenous drug use, prosthetic heart valves, and invasive dental procedures. Patients commonly present with heart murmurs, fever, splinter hemorrhages under the nails, tender nodules called Osler's nodes, and painless spots known as Janeway lesions. Treatment typically involves intravenous antibiotics administered over 4 to 6 weeks. Severe cases may require surgical valve replacement. Next, let's review the most important NCLEX nursing priorities. Always assess patients who present with heart murmurs for any recent sore throat or respiratory infections. Ensure blood cultures are drawn before starting antibiotic therapy in cases suspected of endocarditis. Continuously monitor for serious complications, including embolic events, cardiac tamponade, and signs of heart failure. Educate high-risk patients, such as those with prosthetic valves or a history of endocarditis, about the need for prophylactic antibiotics before undergoing invasive procedures. Recognize life-threatening signs quickly, such as Beck's triad and cardiac tamponade, which includes hypotension, jugular venous distension, and muffled heart sounds, as well as symptoms of embolic stroke. Moving on, we'll now discuss peripheral vascular diseases, abbreviated as PVDs, which encompass peripheral arterial disease and peripheral venous disorders. These conditions affect blood circulation, especially in the lower extremities, potentially leading to ischemia, ulcers, or venous insufficiency. Focusing specifically on peripheral arterial disease, this condition occurs when blood flow to the lower limbs is restricted due to atherosclerosis, which is plaque buildup in the arteries. PAD can result in reduced blood supply or ischemia. Risk factors for PAD include modifiable factors such as obesity, high cholesterol, hyperlipidemia, diabetes, high blood pressure, hypertension, smoking, and a sedentary lifestyle. Non-modifiable risk factors include advancing age, over 50 years, and a family history of vascular diseases. Patients with PAD commonly experience intermittent claudication, described as burning or cramping pain in the legs during exercise, which is relieved by placing the legs down. In severe cases, patients may experience pain even while resting, especially at night. On physical examination, typical findings include delayed capillary refill taking more than 3 seconds, decreased or absent pulses in the lower limbs, shiny, dry, scaly, or mottled skin, loss of hair on the lower legs and feet, thickened toenails, elevation pallor, which means legs appear pale when raised, and dependent rubor, which is redness observed when legs are lowered. Additionally, patients may have ischemic ulcers on their toes and are at increased risk for gangrene. Nursing interventions for managing PAD include encouraging patients to progressively walk until pain develops, resting briefly, and then walking slightly further each time. Patients should be advised to avoid crossing their legs and wearing restrictive clothing. Maintaining warmth by wearing insulated socks can help dilate blood vessels, but direct heat sources should be avoided due to decreased sensation. Additionally, avoiding vasoconstrictive factors such as stress, caffeine, and nicotine is important. Legs should be kept in a dependent or lowered position to improve circulation, rather than elevated. Finally, nurses should mark pedal pulses clearly to monitor any changes in the patient's circulation effectively. Now let's discuss the medical and surgical management related to peripheral vascular conditions. First, we have medications. Antiplatelet medications, like aspirin and clopidogrel, help reduce blood viscosity, meaning they make the blood thinner to prevent clots. Additionally, statins are medications that lower cholesterol levels, helping prevent plaque buildup in the arteries. Next, surgical procedures are available to manage these conditions. One procedure is percutaneous transluminal angioplasty. During this procedure, doctors insert a balloon or a stent to open narrowed blood vessels. Another common procedure is bypass grafting, which reroutes blood flow around blocked arteries. After surgery, specific care is crucial. Nurses must closely monitor for graft occlusion, watching for signs such as diminished pulses, increased pain, or changes in color and temperature in the affected limb. Additionally, patients must keep their extremities straight for about 6 to 8 hours following bypass surgery. Nurses should also be alert for compartment syndrome, identified by symptoms like severe pain, numbness, swelling, and tightness. Moving on, let's talk about peripheral venous disorders. These conditions impair the vein's ability to return blood to the heart, leading to issues like venous stasis, blood clots, or venous insufficiency. A significant disorder in this category is venous thromboembolism, specifically deep vein thrombosis, or DVT. A DVT is a blood clot that forms deep within a vein, typically in the legs. If this clot breaks loose and travels to the lungs, it becomes a serious condition called a pulmonary embolism. Several risk factors for DVT are summarized by Virchow's triad. These include hypercoagulability, which is an increased tendency to clot, often seen in conditions like cancer, pregnancy, or with oral contraceptive use. Another factor is venous stasis, caused by immobility, recent surgery, or heart failure. Lastly, endothelial damage, such as injury from surgery, trauma, or central intravenous lines, can also trigger clot formation. Signs and symptoms of DVT typically include pain in one calf or groin, sudden swelling of the affected limb, warmth, redness, and hardness over the involved vein. Although Homan's sign, which is pain on flexing the foot upwards, is mentioned frequently, it is not considered reliable for diagnosis. For patients with DVT, nursing interventions include elevating the affected extremity above heart level. Nurses should avoid placing pillows under the knees to prevent compressing the veins and must never massage the area, as this could dislodge the clot. Applying warm, moist compresses can help relieve discomfort, and compression stockings, usually thigh-high, are recommended once the clot has resolved. Medications for managing DVT include heparin, given intravenously or subcutaneously, and low molecular weight heparin, like enoxaparin. For patients on heparin, monitoring activated partial thromboplastin time is essential, keeping it within 1.5 to 2.5 times the normal range. Nurses should also monitor for heparin-induced thrombocytopenia. Protamine sulfate serves as the antidote if excessive bleeding occurs. Warfarin, commonly called Coumadin, is another anticoagulant used orally. For patients on warfarin, it's critical to monitor prothrombin time, or PT, and the international normalized ratio, aiming for a therapeutic international normalized ratio between 2 and 3. Warfarin takes several days to be effective, so bridging therapy with heparin is usually required. The antidote for warfarin is vitamin K. In severe cases, thrombolytic medications such as alteplase, also known as TPA, may be used to dissolve existing clots. Patient education regarding anticoagulant therapy is important. Patients should avoid injuries by using electric razors and soft toothbrushes and maintain consistent vitamin K intake if on warfarin. Chronic venous insufficiency is another condition affecting the lower extremities. This occurs when vein valves become incompetent, causing venous stasis, ulcers, and swelling. Risk factors include prolonged sitting or standing, obesity, and pregnancy. Symptoms often include brown discoloration around the ankles or calves, edema, and venous stasis ulcers, typically shallow with irregular borders found near the ankles. Nursing interventions for chronic venous insufficiency involve leg elevation above the heart, compression therapy applied after reducing edema, and encouraging regular walking to improve circulation. Varicose veins are enlarged, twisted veins caused by faulty valves, commonly affecting the legs. Risk factors include advancing age, obesity, pregnancy, prolonged standing, and family history. Symptoms include visibly swollen veins, aching pain, and heaviness in the legs. Treatment options include sclerotherapy, which involves injecting a solution to close off the vein, surgical vein stripping, and the use of compression stockings with leg elevation. Diagnostic tests to evaluate venous disorders include the D-dimer blood test, which, if elevated, suggests a possible clot, and venous duplex ultrasound, used to confirm the presence of DVT. Lastly, key nursing responsibilities for the NCLEX include promoting walking and dependent limb positioning for peripheral arterial disease, assessing pulses frequently after surgery, never massaging a leg with suspected DVT, elevating affected limbs, administering anticoagulants carefully, and monitoring for signs of pulmonary embolism like sudden shortness of breath or chest pain. For CVI and varicose veins, nurses should encourage compression therapy, leg elevation, and carefully assess for the development of ulcers. When managing anticoagulation therapy, regular monitoring of a PTT for heparin and INR for warfarin, along with patient education on bleeding precautions, is crucial. Before we move ahead, I want to ask you something. Do you want to pass the NCLEX in just 1 week or 1 month on your first try? If yes, then this is for you. We have created the ultimate NCLEX crash course with a 99% passing rate. Over 5,000 nurses have already passed in the last 5 years using this course, and now it's your turn. Here's what you get: 100-hour animated mini crash course, perfect if you have very little time and want to pass in just 1 week. 300-hour comprehensive recorded lectures covering 300 high-yield NCLEX topics that the exam loves to test. 5,000 previously asked NCLEX questions. Get familiar with real exam questions. 15 full-length practice tests, including CAT exams, simulate the real NCLEX experience. Exclusive NCLEX ebook, your ultimate guide to passing. 1 year full access. Study at your own pace, anytime, anywhere. Limited seats only. If you enroll right now, you'll get a massive 70% discount. Don't miss out. To enroll, visit our website. The link is in the description. Now, let's discuss hypertension. Hypertension is a chronic condition characterized by persistently elevated blood pressure. It significantly increases the risk for serious conditions such as cardiovascular disease, stroke, and kidney failure. Let's first understand how blood pressure is classified. Normal blood pressure is less than 120 over less than 80 millimeters of mercury. Prehypertension, or elevated blood pressure, ranges between 120 to 129 over less than 80. Stage 1 hypertension is defined as 130 to 139 over 80 to 89. Stage 2 hypertension involves readings equal to or above 140 over equal to or above 90. Finally, a hypertensive crisis, which is a medical emergency, occurs with blood pressure greater than 180 over greater than 120. There are two main types of hypertension. First, primary hypertension, also called essential hypertension, has no identifiable cause and accounts for 90 to 95% of cases. Its risk factors include non-modifiable factors like genetics, age, and being of African American ethnicity. Modifiable risk factors include excess sodium intake, obesity, lack of physical activity, smoking, excessive alcohol use, high cholesterol, and stress. Second, secondary hypertension occurs due to an underlying medical condition. Common causes include renal disorders such as chronic kidney disease or narrowing of the renal artery, endocrine disorders like Cushing's disease, pheochromocytoma, and hyperaldosteronism, cardiovascular disorders such as coarctation of the aorta, and neurological disorders that cause increased intracranial pressure. If hypertension is not controlled, serious complications can arise, known as target organ damage. This damage can affect the heart, causing issues such as left ventricular hypertrophy, heart failure, or heart attack. It can affect the brain, leading to stroke or transient ischemic attacks. It can damage the eyes, resulting in hypertensive retinopathy and vision loss, and it can harm the kidneys, potentially leading to chronic kidney disease or renal failure. Hypertension is often called a silent killer because it frequently shows no symptoms. However, severe cases may cause noticeable symptoms like headaches, especially in the morning, dizziness, blurred vision, or nosebleeds. Now, let's talk about pharmacological management. Various medications lower blood pressure through different mechanisms. First, diuretics reduce blood volume by increasing urine output. Examples include thiazide diuretics like hydrochlorothiazide, which require monitoring for low potassium. Loop diuretics, such as furosemide, also carry risks of low potassium, and hearing damage known as ototoxicity. Potassium-sparing diuretics like spironolactone may lead to high potassium levels. Calcium channel blockers, or CCBs, relax blood vessels. Common examples are verapamil, amlodipine, and diltiazem. Nurses should advise patients to avoid grapefruit juice to prevent drug toxicity and monitor for slow heart rate, low blood pressure, and swelling in extremities. ACE inhibitors, medications ending in pril, block the enzyme that causes blood vessels to constrict. Examples are lisinopril and enalapril. Side effects can include angioedema, dry cough, and elevated potassium levels. Angiotensin II receptor blockers, or ARBs, ending in sartan, block angiotensin II, thereby reducing blood pressure. Examples include losartan and valsartan, with potential side effects like angioedema, high potassium, and worsening heart failure. Beta blockers, ending in LOL, lower both heart rate and blood pressure. Examples are metoprolol and propranolol. Patients may experience fatigue, weakness, sexual dysfunction, and they can mask signs of low blood sugar in diabetic patients. Aldosterone receptor antagonists block aldosterone and may cause increased potassium, low sodium, and elevated triglycerides. Central alpha agonists such as clonidine lower blood pressure through the central nervous system, possibly causing sedation, dry mouth, and dizziness upon standing, known as orthostatic hypotension. In a hypertensive crisis, symptoms like severe headache, blurred vision, and dizziness occur. Treatment involves intravenous antihypertensive medications such as nitroprusside, labetalol, or nicardipine. For nursing responsibilities, important for NCLEX, nurses must correctly measure blood pressure using the proper cuff size and technique, measuring initially in both arms and using the higher reading. Blood pressure should be checked while seated with feet flat and arm at heart level. Assessing for orthostatic hypotension is crucial. Patients should be instructed to change positions slowly to avoid falls. Lifestyle modifications are first-line interventions before medications. These include the DASH diet, low in sodium and rich in potassium, calcium, and magnesium. Limiting alcohol consumption, quitting smoking, managing stress, and losing weight. Patient education on medications is critical. Patients should take medications consistently, never stop them abruptly to avoid rebound hypertension, and recognize important side effects. Recognizing hypertensive crisis is crucial on the NCLEX. Immediate action is required if blood pressure exceeds 180 over 120, especially if accompanied by symptoms like confusion, chest pain, shortness of breath, or seizures. Nurses should administer intravenous antihypertensives as prescribed and monitor blood pressure every 5 to 15 minutes until stabilized. Monitoring renal function is also important. Nurses should regularly assess blood urea nitrogen, creatinine, and glomerular filtration rate, and watch for signs of fluid overload like edema or rapid weight gain. Finally, here is a sample NCLEX practice question. A patient with newly diagnosed hypertension is prescribed lisinopril. Which statement by the patient requires further teaching? Option A, I will check my blood pressure regularly at home. Option B, I need to notify my provider if I develop a persistent cough. Option C, I can stop taking this medication once my blood pressure is normal. Option D, I should avoid using salt substitutes that contain potassium. The correct answer is option C, because hypertension requires lifelong medication, and stopping suddenly can cause rebound hypertension. Now we will discuss hemodynamic shock, a life-threatening condition where tissues do not receive enough blood supply. If left untreated, this condition can quickly lead to multiple organ failure and death. Hemodynamic shock is classified into 4 main types: cardiogenic shock, hypovolemic shock, obstructive shock, and distributive shock, which includes septic, neurogenic, and anaphylactic shock. Each type has its own distinct causes, symptoms, and management strategies. Let's start with cardiogenic shock. This type of shock occurs when the heart cannot pump effectively due to reasons such as a heart attack, known as myocardial infarction, heart failure, or abnormal heart rhythms, dysrhythmias. Some key findings include elevated cardiac enzymes such as troponin and CKMB, low blood pressure, hypotension, rapid heart rate, tachycardia, weak pulses, lung congestion with crackles, distended neck veins known as jugular vein distension, JVD, and decreased hemoglobin and hematocrit levels. The treatment involves giving medications like vasopressors such as dobutamine and norepinephrine and nitroprusside, which helps reduce pressure in the vessels around the heart. Oxygen therapy or mechanical ventilation might also be needed, and continuous monitoring of ECG for abnormal heart rhythms is crucial. For nursing priorities related to NCLEX, nurses must continuously monitor cardiac enzymes and ECG, carefully administer fluids to avoid overloading the patient, and closely watch urine output, which should always be greater than 30 milliliters per hour to ensure good tissue perfusion. Next, we have hypovolemic shock. This type occurs due to excessive fluid loss from the body, which might happen due to bleeding, hemorrhage, severe vomiting, diarrhea, burns, trauma, or surgery. Important signs include low blood pressure, hypotension, rapid heart rate, tachycardia, weak pulses, decreased skin turgor, dry mucous membranes, and reduced hemoglobin and hematocrit levels. Treatment involves quickly restoring fluids using isotonic crystalloid solutions like normal saline or lactated ringers, and blood products if the patient is bleeding heavily. Medications such as dopamine or norepinephrine may also be used to support blood pressure. NCLEX nursing priorities include closely monitoring urine output and reporting immediately if it falls below 30 milliliters per hour, placing the patient flat with legs elevated, known as the Trendelenburg position, to improve blood return to the heart, and continuously checking for signs of fluid overload like crackles in the lungs, difficulty breathing, and swelling, edema. Thirdly, we have obstructive shock. This happens when blood flow is physically blocked, commonly due to conditions such as pulmonary embolism, tension pneumothorax, or cardiac tamponade. Key symptoms include sudden low blood pressure, hypotension, rapid heartbeat, tachycardia, distended neck veins, and reduced or absent breath sounds if there is a pneumothorax. Treatment focuses on correcting the underlying issue, for example, inserting a chest tube for a collapsed lung, pneumothorax, performing pericardiocentesis to relieve cardiac tamponade, or giving thrombolytic medications for a pulmonary embolism. NCLEX nursing priorities include preparing immediately for emergency interventions such as needle decompression, pericardiocentesis, or surgery, administering oxygen, and monitoring for worsening respiratory distress. Finally, we discuss distributive shock, which occurs due to widespread vasodilation and increased capillary permeability. It includes three subtypes: septic, neurogenic, and anaphylactic shock. First, septic shock. This occurs due to severe infections, typically caused by gram-negative bacteria or conditions like urosepsis, especially common in the elderly. Symptoms initially include low blood pressure, hypotension, rapid heart rate, tachycardia, and fever, with skin appearing warm and flushed initially but becoming cool and mottled in later stages. Lab findings typically show elevated lactic acid levels and positive blood cultures. Treatment involves administering large amounts of isotonic fluids, antibiotics such as vancomycin and piperacillin tazobactam, and vasopressors if fluids alone are ineffective. NCLEX nursing priorities include drawing blood cultures before starting antibiotics and continuously monitoring for signs of organ dysfunction such as decreased urine output, oliguria, confusion, and increased lactic acid levels. Next is neurogenic shock, caused by spinal cord injury, such as trauma leading to paraplegia or quadriplegia. Unique symptoms here include low blood pressure, hypotension, combined with a slow heart rate, bradycardia, and the patient's skin typically appears warm and dry. Treatment involves first giving fluids, followed by vasopressors such as norepinephrine or dopamine, and atropine to treat slow heart rate. Nursing priorities include closely monitoring for loss of the body's ability to regulate temperature and raising the head of the bed slowly to prevent sudden drops in blood pressure, orthostatic hypotension. Then we have anaphylactic shock, which is a severe allergic reaction. Key signs are low blood pressure, hypotension, wheezing, swelling known as angioedema, hives, and significant breathing difficulties. Immediate treatment includes giving intramuscular epinephrine, antihistamines like diphenhydramine, corticosteroids, intravenous fluids, and oxygen therapy. Nursing priorities include maintaining a clear airway, preparing for potential intubation if necessary, and educating the patient about using an EpiPen for future allergic reactions. Lastly, a major complication of any type of shock is multiple organ dysfunction syndrome, abbreviated as MODS. In MODS, organs progressively fail, including kidneys, lungs, liver, and the heart. Important signs include rapid heartbeat, tachycardia, fast breathing, tachypnea, and worsening organ function. Management primarily includes supportive care measures such as mechanical ventilation, dialysis, and careful monitoring for signs of further deterioration. Now, let's discuss disseminated intravascular coagulation. In DIC, widespread clot formation happens first, and this is quickly followed by excessive bleeding. Patients may show signs such as bruising, small pinpoint red spots called petechiae, blood in the urine known as hematuria, and gastrointestinal bleeding. Treatment for DIC includes giving blood transfusions, platelets, and clotting factors like fresh frozen plasma. Nurses must closely monitor lab values such as prothrombin time, partial thromboplastin time, and international normalized ratio. For the exam, nursing priorities include closely monitoring for any signs of bleeding from the gums, urine, stool, or intravenous sites. Additionally, nurses should avoid intramuscular injections and unnecessary venipunctures to prevent additional bleeding. Next, we will talk about aneurysms, An aneurysm is an abnormal widening or ballooning of a blood vessel due to weakness in the vessel wall. Risk factors for aneurysms include being male, smoking, high blood pressure, hypertension, atherosclerosis, and aging. The first type we'll cover is an abdominal aortic aneurysm. Key signs include flank or back pain and a pulsating abdominal mass. It's important not to palpate this mass because it can cause the aneurysm to rupture. Treatment involves surgery if the aneurysm is greater than 6 centimeters or symptomatic. Nurses need to closely monitor the patient's blood pressure, aiming for a range of 100 to 120 millimeters of mercury, and always be prepared for emergency surgery in case of rupture. Next is a thoracic aortic aneurysm found in the chest area. Patients often experience severe back pain, coughing, shortness of breath, and difficulty swallowing. Diagnosis is typically made using X-rays or a CT scan. Another critical condition is an aortic dissection. Here, patients will have sudden, severe, tearing, or ripping pain in the chest or back. They may quickly enter hypovolemic shock, showing signs such as low blood pressure, hypotension, rapid heart rate, tachycardia, and absent pulses. Treatment requires immediate emergency surgery. Nursing priorities include keeping blood pressure controlled using beta blockers or antihypertensive medications, and closely monitoring for signs of rupture such as sudden severe pain and hypotension. Now, let's move on to blood and blood product transfusions, a crucial area in patient care and commonly tested on the NCLEX exam. We'll start with autologous transfusions. This process involves patients donating their own blood ahead of time, usually between 6 weeks and 72 hours before surgery. Doing this helps ensure blood availability and prevents complications. Understanding blood types and their compatibility is essential to prevent life-threatening transfusion reactions. Let's simplify this. Type A, blood has A antigens and B antibodies, and these patients can safely receive blood types A and O. Type B blood has B antigens and A antibodies, making it safe to receive blood types B and O. Type AB blood has both A and B antigens but no antibodies, which allows these patients to receive blood from types A, B, AB, and O. This type is called the universal recipient. Type O blood has no antigens but has A and B antibodies. Therefore, patients with type O can only receive type O blood, but type O is known as the universal donor type. Another critical factor is the Rh factor. Rh positive blood can only be given to Rh positive patients. Rh negative patients must never receive Rh positive blood to avoid severe hemolytic reactions. Finally, let's mention RhoGAM. RhoGAM is administered to Rh-negative mothers at 28 weeks of pregnancy and again within 72 hours after delivery if the newborn is Rh positive. This helps prevent hemolytic disease of the newborn. Let's now understand the blood transfusion procedure along with the key nursing responsibilities involved. First, there are important pre-transfusion steps to follow carefully. Obtain informed consent from the patient before beginning the procedure. Establish intravenous access using a large bore needle, typically an 18 to 20 gauge needle. 2 licensed registered nurses must together verify the patient's identity, the compatibility of the blood product, and its expiration date. Before starting, prime the blood administration tubing with 0.9% sodium chloride solution, which is also known as normal saline. Never use other fluids like lactated ringers or any dextrose-containing solutions for this step. Next, let's see what happens during the transfusion itself. Start the transfusion slowly, usually at a rate of 2 milliliters per minute for the first 15 minutes. Stay with the patient for at least 15 to 30 minutes to closely monitor them for any transfusion reactions. Carefully check and document the patient's vital signs immediately before starting the transfusion, again 15 minutes after initiating it, and finally at the completion of the transfusion. Now let's talk about potential transfusion reactions and how to manage each type. First, there is the acute hemolytic reaction, which is life-threatening. Symptoms include chills, fever, low back pain, rapid heart rate, also called tachycardia, flushing of the skin, low blood pressure, known as hypotension, and blood in the urine, hematuria. The nursing action here is to stop the transfusion immediately, administer normal saline through a separate intravenous line, notify the healthcare provider immediately, and closely monitor the patient for signs of shock. Second is the febrile non-hemolytic reaction, which is less severe. Symptoms include fever greater than a 1 degree Celsius increase, chills, headache, muscle stiffness, and nervousness. The nursing action in this case is to stop the transfusion and administer an antipyretic medication such as acetaminophen to lower the fever. Third, a mild allergic reaction can occur. Symptoms are itching, hives, also known as urticaria, and skin flushing. The nurse should stop the transfusion and administer an antihistamine medication, such as diphenhydramine, commonly known as Benadryl. Fourth is the anaphylactic reaction, a serious and immediate allergic response. Symptoms include bronchospasm, swelling in the throat, known as laryngeal edema, severe drop in blood pressure, hypotension, and signs of shock. Immediately stop the transfusion, administer epinephrine, also known as adrenaline, give oxygen therapy, intravenous fluids, and vasopressor medications to stabilize blood pressure. Lastly, circulatory overload can happen, especially in patients with congestive heart failure. Symptoms include difficulty breathing, known as dyspnea, rapid heartbeat, tachycardia, high blood pressure, hypertension, visible neck veins, jugular vein distension, crackling sounds in the lungs and swelling in the extremities, peripheral edema. Nursing actions include slowing down the transfusion rate, placing the patient in a high Fowler's position to help breathing, and administering diuretic medications if ordered by the healthcare provider. Before we dive into next topic, here's something important. You don't have to struggle with NCLEX prep anymore. We have a proven shortcut to pass the NCLEX, and that is our complete NCLEX review course. With a 99% passing rate and over 5,000 nurses passing the NCLEX in the last 5 years, this course is built to deliver results. You'll get 100 hours of animated crash course content that can help you pass in just 1 week, over 300 recorded lectures based on NCLEX-tested topics, 5,000 real past NCLEX questions, 15 full-length mock tests, a complete ebook, and 1 year full access. And here's the best part. It's now 70% off for a limited time. Seats are filling up fast, so enroll now by visiting our website. The link is in the description below. Now let's discuss anemia, which is a condition characterized by inadequate red blood cells or hemoglobin, or both. Because of this, tissues and organs do not receive enough oxygen. Anemia can occur due to blood loss, decreased production of red blood cells, increased destruction of these cells, or nutritional deficiencies. Let's first talk about the causes of anemia. Number 1, blood loss. This can happen from trauma, surgery, gastrointestinal bleeding such as ulcers or colorectal cancer, or heavy menstrual bleeding, also known as menorrhagia. Number 2, decreased production of red blood cells. This can result from bone marrow suppression caused by chemotherapy, radiation, leukemia, or a condition called aplastic anemia. Nutritional deficiencies of iron, vitamin B12, or folic acid can also reduce red blood cell production. Number 3, increased destruction of red blood cells, known as hemolysis. This occurs in conditions such as sickle cell disease, where abnormal cells block blood vessels, autoimmune hemolytic anemia, certain infections, or reactions to some medications. Number 4, nutritional deficiencies, specifically affecting blood cells. Iron deficiency anemia is most common in children due to excessive milk intake and in pregnant women. Vitamin B12 deficiency might be due to poor intake or the lack of intrinsic factor, causing pernicious anemia. Folic acid deficiency is critical, especially during pregnancy, because it can lead to birth defects involving the brain and spine. Number 5, chronic conditions. Diseases like chronic kidney disease decrease erythropoietin production, reducing red blood cell production. Chronic inflammatory diseases, such as rheumatoid arthritis or HIV infection, can also cause anemia. Next, let's look at signs and symptoms you might see in anemia. Generally, people experience fatigue, pale skin known as pallor, weakness, dizziness, and sometimes fainting. Cardiovascular symptoms include increased heart rate, known as tachycardia, palpitations, and low blood pressure in severe cases. Respiratory symptoms often involve shortness of breath during activity. Neurologically, patients might feel numbness or tingling, especially in vitamin B12 deficiency, or have headaches. Skin and nail signs include brittle nails, spoon-shaped nails called koilonychia, inflammation of the tongue called glossitis, and cracks at the corners of the mouth, known as cheilitis. Now, nursing care and key responsibilities you should know for exams like the NCLEX include: for iron deficiency anemia, administer oral iron, usually ferrous sulfate, with vitamin C to increase absorption. Avoid giving iron with dairy products, caffeine, or antacids within 1 hour because these reduce absorption. Educate patients about black-colored stools, a normal side effect of iron supplements. In severe cases, intravenous iron dextran can be given using the Z-Track method to avoid skin staining. In cases of vitamin B12 deficiency or pernicious anemia, first identify if intrinsic factor is missing. If absent, lifelong monthly B12 injections called cyanocobalamin are necessary. If dietary, patients should consume foods high in B12, such as meat, eggs, and dairy products. For folic acid deficiency, supplementing with folic acid is crucial, especially during pregnancy. An important NCLEX fact is that high doses of folic acid can hide symptoms of a B12 deficiency, leading to neurological problems. In anemia associated with chronic kidney disease or cancer, erythropoiesis-stimulating agents such as epoetin alpha are given. It's vital to monitor hemoglobin and hematocrit levels twice weekly to avoid polycythemia, a condition of excessive red blood cells increasing clotting risks. Stop epoetin alpha if hemoglobin rises above 11 grams per deciliter to prevent clotting complications. Blood transfusions are reserved for severe anemia cases. Monitor closely for transfusion reactions like fever, chills, rash, back pain, rapid heart rate, or low blood pressure. Always flush intravenous lines using normal saline to prevent red blood cell breakdown. Administer transfusion slowly, frequently checking vital signs. If anemia goes untreated, it can lead to serious complications like heart failure due to increased strain on the heart from chronic oxygen shortage, developmental delays in children, or pregnancy complications such as neural tube defects or premature birth. Next, let's discuss essential gastrointestinal diagnostic procedures which help identify problems in the liver, pancreas, intestines, and other digestive organs. Liver function tests measure enzymes such as ALT and AST, normally below 40 units per liter. Bilirubin levels should remain below 1 milligram per deciliter. High levels indicate liver problems or bile obstruction. Albumin, normally between 3.5 to 5 grams per deciliter, indicates nutrition status or liver disease if low. Ammonia should be below 100 micrograms per deciliter. Higher levels occur in liver failure, causing hepatic encephalopathy. Pancreatic function tests include amylase and lipase, both typically below 100 units per liter. Elevated levels indicate pancreatitis, with lipase being more specific. A fecal occult blood test checks stool samples for hidden blood, which can signal ulcers, colitis, or colorectal cancer. Endoscopy procedures are valuable diagnostic tools. Colonoscopy examines the colon via the anus under sedation, with the patient positioned on their left side with knees drawn toward the chest. Preparation involves bowel cleansing, a clear liquid diet avoiding red, purple, or orange fluids, and no food or drink after midnight. An esophago-gastroduodenoscopy examines the esophagus, stomach, and duodenum through the mouth, requiring no food or drink for 6 to 8 hours prior. Sigmoidoscopy examines the sigmoid colon without sedation, positioned similarly to colonoscopy, with bowel preparation and a clear liquid diet 24 hours before and fasting after midnight. Complications from endoscopy include bleeding, indicated by rapid heart rate, rapid breathing, or low blood pressure, and aspiration risks like difficulty breathing or fever. Finally, a gastrointestinal series uses contrast agents like barium swallowed or given by enema. Before the test, patients follow a clear liquid or low-residue diet, fasting after midnight, and avoid smoking or gum chewing, which increases digestive activity. Afterward, patients should drink fluids to clear the contrast, expecting white stools for 1 to 3 days until the barium fully clears from the system. Now, we will discuss important therapeutic procedures used to treat gastrointestinal disorders and their nursing responsibilities. The first procedure is enteral feedings, which are indicated for patients who are comatose, intubated, or have difficulty swallowing, known as dysphagia. Nursing responsibilities for enteral feedings include checking the residual volume every 4 to 6 hours. If the residual volume is greater than 100 to 200 milliliters, feedings should be temporarily held to prevent complications. Next, we have total parenteral nutrition, also known as TPN, which is administered through a central intravenous line. It is given to patients experiencing malnutrition or hypermetabolic states. Nurses must perform daily laboratory monitoring, change the tubing and solution every 24 hours, and use filtered tubing to remove any particles. Blood glucose levels must be checked every 4 to 6 hours for the first 24 hours. Always keep a solution of dextrose 10% in water at the bedside to prevent low blood sugar if the TPN is disrupted. Complications of TPN include air embolism and infection. If an air embolism occurs, immediately clamp the catheter, position the patient on the left side in Trendelenburg, head down, feet up, administer oxygen, and notify the healthcare provider. For infections, monitor the central line site carefully for redness, tenderness, or discharge, and avoid using the TPN line for other intravenous fluids or medications. Another procedure is paracentesis, which involves inserting a needle into the peritoneal cavity to relieve pressure from excess fluid, known as ascites. Before this procedure, verify informed consent, have the patient empty their bladder to prevent injury, position them upright, and record vital signs, weight, and abdominal girth. After the procedure, continue monitoring vital signs, weight, and abdominal girth, and administer intravenous fluids or albumin as ordered to prevent low blood pressure. Bariatric surgery, such as gastric bypass, requires careful postoperative nursing care. Initially, fluids should be resumed slowly, starting with about 30 milliliters per intake, gradually increasing as tolerated. Patients should eat 6 small meals daily. Nurses must watch for dumping syndrome, a complication characterized by cramps, diarrhea, rapid heartbeat, dizziness, and fatigue. Nasogastric decompression is used in cases of intestinal obstruction to relieve abdominal pressure. Indications for this include vomiting, absence of bowel sounds, also called paralytic ileus, high-pitched bowel sounds indicating obstruction, abdominal pain, and distension. Nursing responsibilities include regularly assessing bowel sounds, measuring abdominal girth after placement, and monitoring for signs of tube displacement, such as decreased drainage, increased nausea, vomiting, or abdominal distension. Ostomies are surgical openings created to bypass certain gastrointestinal regions. An ileostomy involves the ileum and produces frequent liquid stools, whereas a colostomy involves the large intestine and produces more formed stools. Nurses must ensure that the stoma appears pink and moist and empty. The ostomy bag when it is 1/4 to 1/2 full. Potential complications include ischemia, indicated by a pale pink or bluish-purple dry stoma, requiring immediate medical attention. Patients with ostomies are also at risk for dehydration, so adequate fluid intake should be encouraged. Now, let's highlight NCLEX-focused nursing priorities. Before any gastrointestinal procedure, ensure the patient maintains nothing by mouth status, assess for allergies, especially to contrast dye or anesthesia, and confirm informed consent. After invasive procedures, closely monitor for signs of bleeding, perforation indicated by a rigid abdomen, severe pain or fever, aspiration, and infection. For enteral feedings, always check residual volumes, maintain the head of the bed at 30 degrees or higher, and take steps to prevent aspiration pneumonia. For TPN, monitor glucose levels closely, change tubing every 24 hours, and follow strict sterile technique. For paracentesis, watch closely for low blood pressure and fluid shifts, regularly check vital signs, and monitor albumin levels. For patients with ostomies, educate them on proper stoma care, protecting surrounding skin, and recognizing complications. Finally, we will discuss esophageal disorders, specifically gastroesophageal reflux disease, known as GERD, and esophageal varices, both important topics on the NCLEX exam. GERD occurs when stomach contents, including acid and digestive enzymes, flow back into the esophagus, causing irritation and inflammation. Risk factors include dietary triggers like fatty or fried foods, chocolate, caffeine, peppermint, spicy foods, tomatoes, citrus fruits, and alcohol. Physiological factors include obesity, pregnancy, and increased abdominal pressure, such as from ascites or bending at the waist. Lifestyle factors like smoking, delayed stomach emptying, and hiatal hernia also contribute. Clinical symptoms of GERD include heartburn, worsening when lying down or bending over, regurgitation with a sour or bitter taste, chronic cough, hoarseness, sore throat, difficulty swallowing, and chest pain similar to angina that improves when sitting up, drinking water, or taking antacids. Diagnostics include esophagogastroduodenoscopy to identify Barrett's esophagus, a premalignant condition, and pH monitoring to confirm acid reflux. Medications include proton pump inhibitors such as pantoprazole or omeprazole, antacids like aluminum hydroxide or magnesium hydroxide taken 1 to 3 hours after meals and separately from other medications. Histamine 2 receptor antagonists like ranitidine or famotidine, and prokinetics such as metoclopramide, which enhance esophageal and stomach motility. Monitor carefully for extrapyramidal symptoms with prokinetics. Therapeutic management includes lifestyle changes such as avoiding trigger foods and large meals, waiting 2 to 3 hours after eating before lying down, elevating the head of the bed 6 to 8 inches, weight loss, and wearing loose clothing. In severe cases, surgical intervention known as fundoplication may be required where the stomach is wrapped around the esophagus to prevent reflux. Now, let's discuss some key nursing responsibilities you need to remember for the NCLEX exam. First, when caring for patients with esophageal issues, it's crucial to monitor closely for complications such as Barrett's esophagus, which is a precancerous condition, esophagitis, and strictures. Additionally, educating patients on dietary changes, strict medication adherence, and proper positioning after meals is very important. In severe cases, always assess the patient's risk for aspiration. Also, keep a close eye on side effects of medications, particularly proton pump inhibitors, which can increase the risk of fractures and Clostridium difficile infection. Next, let's talk about esophageal varices. These are dilated, fragile blood vessels in the esophagus that occur due to increased pressure in the portal vein, commonly caused by liver cirrhosis. Bleeding from these vessels is a medical emergency. Key risk factors include liver cirrhosis, alcoholism, hepatitis, and portal vein thrombosis. Patients typically present with sudden massive vomiting of blood, known as hematemesis, black tarry stools called melena, low blood pressure, rapid heartbeat indicating shock, abdominal swelling, and jaundice. For diagnosis, endoscopy is considered the gold standard. Laboratory tests usually show decreased hemoglobin and hematocrit, along with elevated ammonia levels, indicating liver dysfunction. In emergency management, establishing intravenous access with a large bore needle is essential for fluid resuscitation. Administer medications like octreotide or vasopressin to constrict blood vessels and reduce portal pressure. Endoscopic procedures like band ligation or sclerotherapy may be necessary, and balloon tamponade is used for life-threatening bleeding. As a nurse, monitor closely for signs of shock, including rapid heartbeat, low blood pressure, and changes in consciousness. Maintain the airway to prevent aspiration in patients vomiting blood. Prepare for possible blood transfusions, and educate patients on the importance of alcohol cessation to prevent recurrence. Before we get started, let's talk real. Many students struggle with NCLEX prep not because they aren't smart, but because they lack the right strategy. That's why we created a complete NCLEX review course that's helped more than 5,000 nurses pass over the last 5 years, with a 99% passing rate. Inside, you'll find 100 hours of animated crash course content, 300-plus video lectures, 5,000 real NCLEX questions, 15 mock CAT tests, a complete e-book, and 12 months of access. And here's your golden moment. It's 70% off right now, but only for a short time. Visit the link in the description and get started today. All right, let's jump into today's lesson. Now let's move to peptic ulcer disease. This condition involves erosion of the stomach, esophagus, or duodenal lining. Common causes include Helicobacter pylori infection, use of NSAIDs and corticosteroids, which weaken protective mucosal barriers, stress, smoking, alcohol use, and conditions like Zollinger-Ellison syndrome, characterized by excessive acid production. Symptoms usually involve burning or gnawing stomach pain, heartburn, bloating, nausea, vomiting, and the presence of red blood or black tarry stools. It's important to differentiate between types of ulcers. Gastric ulcers typically cause pain 30 to 60 minutes after meals, worsening when eating. Duodenal ulcers cause pain 1.5 to 3 hours after meals and at night, often relieved by eating or taking antacids. Serious complications include perforation and hemorrhage, characterized by severe sharp stomach pain, a rigid abdomen, and signs of shock like rapid heartbeat and low blood pressure. Another complication is dumping syndrome, occurring after stomach surgery, causing dizziness, rapid heartbeat, sweating, nausea, and diarrhea. Dietary modifications include small frequent meals, avoiding fluids during meals, and adopting a high-protein, high-fat, low-carbohydrate diet. Medications include antibiotics like metronidazole, amoxicillin, clarithromycin, and tetracycline for H. pylori infection. Acid reducers like ranitidine and famotidine, PPI like pantoprazole, antacids like magnesium hydroxide, and mucosal protectants such as sucralfate. Nursing responsibilities involve monitoring for signs of bleeding, assessing for perforation, encouraging complete antibiotic courses, and educating patients on dietary changes and avoiding NSAIDs. Moving forward, let's discuss gastritis, which involves inflammation of the stomach lining. It can be acute or chronic, with chronic gastritis potentially leading to pernicious anemia and Helicobacter pylori infection. Risk factors include H. pylori infections, NSAIDs, corticosteroids, alcohol, smoking, caffeine, stress, and autoimmune conditions. Symptoms include upper abdominal pain, bloating, nausea, vomiting blood, and black stools. Endoscopy with biopsy is the gold standard for diagnosis, along with testing for H. pylori and checking for anemia. Management involves dietary changes like small, frequent meals, stress reduction techniques, and careful monitoring for signs of gastric bleeding. Medications used are histamine 2 receptor antagonists, such as famotidine, PPIs like pantoprazole, antacids taken separately from other medications, prostaglandin analogs like misoprostol, not safe in pregnancy, mucosal protectants like sucralfate, and antibiotics for H. pylori. Monitor patients closely for complications such as gastric bleeding, dehydration, and pernicious anemia, requiring monthly vitamin B12 injections. Finally, let's talk about non-inflammatory bowel disorders. A hernia occurs when bowel contents push through weakened abdominal muscles. Risks include being male, elderly, and having increased intra-abdominal pressure from pregnancy, obesity, or heavy lifting. Patients may notice a lump or discomfort at the site and should avoid heavy lifting or straining. Irritable bowel syndrome, or IBS, is characterized by cramping, changes in bowel habits, bloating, belching, and mucus in stools. Management includes increasing fluids, fiber intake, avoiding stress triggers, and eliminating irritants like gas-producing foods, caffeine, and alcohol. Medications such as allocetrone for IBS with diarrhea and lubiprostone for IBS with constipation may also be used. Now, let's discuss intestinal obstruction. An intestinal obstruction prevents the normal flow of contents through the intestines. There are two types of intestinal obstructions we need to know about. First is mechanical obstruction, which can be caused by physical issues like tumors, adhesions, hernias, or diverticulitis. Second is non-mechanical obstruction, which occurs due to problems like paralytic ileus, vascular or neurogenic disorders, or electrolyte imbalances. When assessing a patient with intestinal obstruction, findings differ depending on the location. If the small bowel is obstructed, the patient will present with sudden projectile vomiting that often has a fecal odor. But if the obstruction occurs in the large bowel, you might see diarrhea or ribbon-like stools moving around a blockage. On auscultation, or listening with a stethoscope, you'll hear high-pitched sounds above the site of obstruction and hypoactive or quieter sounds below it. The management and nursing responsibilities for intestinal obstruction include keeping the patient nothing by mouth, placing a nasogastric tube to decompress the stomach, and providing intravenous fluids to maintain hydration. Oral hygiene should be performed every 2 hours to ensure comfort. Surgical interventions may be necessary, such as colon resection or the creation of a colostomy. After surgery, nurses must clamp the NG tube before removing it and carefully assess the patient's tolerance when clear liquids are reintroduced. Next, we move on to inflammatory bowel disease, also known as IBD. Two main types are important here: ulcerative colitis and Crohn's disease. Starting with ulcerative colitis, this is chronic inflammation specifically affecting the mucosa and submucosa of the rectum and colon. Typical findings include pain in the lower left quadrant, and patients might have 15 to 20 stools per day containing blood, mucus, or pus. They also commonly experience abdominal distension and fever. Diagnostic lab tests will show decreased hematocrit and hemoglobin, increased erythrocyte sedimentation rate, elevated white blood cells, and low albumin levels. Imaging methods for diagnosis include colonoscopy, barium enema, and computed tomography. Management involves dietary changes such as a low-fiber, high-protein, and high-calorie diet. Surgical therapy might include colectomy or ileostomy. Medication therapy includes 5-aminosalicylic acids such as sulfasalazine, used to reduce inflammation, corticosteroids, which carry a risk of infection and high blood sugar or hyperglycemia, immunosuppressants like cyclosporin, which require careful monitoring for infections, immunomodulators such as infliximab, where patients should avoid crowds due to lowered immunity, antidiarrheals like loperamide, which must be used cautiously to prevent toxic megacolon, and antimicrobials such as ciprofloxacin or metronidazole. In comparison, Crohn's disease is another chronic inflammatory condition, but it can affect any part of the gastrointestinal tract, from mouth to anus. Typical findings here include right lower quadrant abdominal pain and around 5 loose stools per day containing mucus or pus. Patients might also experience steatorrhea, which means fatty stools. Management strategies are similar to those for ulcerative colitis. Another important condition is diverticulitis, which is inflammation of diverticula caused by trapped food, feces, or bacteria. Patients typically report lower left quadrant abdominal pain, fever, and chills. Nursing management involves dietary changes, starting with clear liquids and low-fiber foods, gradually increasing fiber intake. Patients should avoid foods such as nuts, seeds, and popcorn, as these can worsen symptoms. It's crucial to monitor patients closely for complications like perforation, indicated by sudden severe pain, fever, and vomiting. One serious complication of diverticulitis is peritonitis, presenting with a rigid, board-like abdomen, nausea and vomiting, rebound tenderness, and rapid heart rate or tachycardia. If peritonitis is suspected, nursing actions include placing the patient in Fowler's position, which means sitting up, administering oxygen, inserting an NG tube, and maintaining NPO status. Finally, let's explore 2 common gallbladder disorders known as cholecystitis and cholelithiasis. Cholecystitis is inflammation of the gallbladder wall, typically caused by gallstones blocking bile ducts, leading to bile backup and inflammation. Cholelithiasis refers simply to the presence of gallstones within the gallbladder. Common risk factors include being female, obesity, a high-fat diet, genetic factors, older age, rapid weight loss, pregnancy, hormone replacement therapy, and diabetes. Clinically, patients will experience sharp pain in the right upper quadrant, often radiating to the right shoulder or back, especially after high-fat meals. They may also report digestive issues such as dyspepsia, burping, also known as eructation, flatulence, nausea, and vomiting. Stool and urine changes include clay-colored stools due to blocked bile flow, fatty stools, steatorrhea, dark-colored urine, and itchy skin, or pruritus, due to bile salts accumulation. Systemic signs often involve fever and increased heart rate, or tachycardia. Lab tests usually show elevated white blood cells due to inflammation, increased bilirubin levels due to bile blockage, and elevated amylase and lipase if the pancreas is involved. Diagnostic methods include an ultrasound as the first-line test, abdominal X-ray or CT scans to detect calcified stones, and a hepatobiliary scan to assess gallbladder function. Treatment options include lithotripsy, a shockwave therapy suitable for small cholesterol-based stones in patients who cannot undergo surgery, cholecystectomy, or gallbladder removal, performed laparoscopically with a short hospital stay, or through open surgery requiring T-tube placement. Nursing responsibilities after open cholecystectomy with T-tube placement include elevating the T-tube above abdomen level, monitoring and recording the drainage's color and amount, clamping the tube 1 hour before and after meals, and assessing stool color. Initially, stools may appear clay-colored but should return to normal within a week. Postoperative diarrhea is also common. Dietary management post-surgery includes a low-fat diet and avoiding gas-producing foods like beans, cabbage, cauliflower, and broccoli. A critical complication to watch for is peritonitis, a life-threatening infection resulting from gallbladder rupture. For NCLEX purposes, nurses must closely assess patients for signs of bile duct obstruction, monitor for complications like infection or peritonitis after surgery, and educate patients clearly on post-operative care, dietary changes, and symptom management. Let's begin with pancreatitis, which is a serious condition that can cause severe complications if left untreated. First, we'll look at its pathophysiology. Normally, the pancreas secretes digestive enzymes that break down carbohydrates, proteins, and fats. However, in pancreatitis, these enzymes activate prematurely inside the pancreas, causing autodigestion and inflammation. Chronic pancreatitis eventually leads to fibrosis and loss of pancreatic function. The risk factors for pancreatitis include biliary tract diseases such as gallstones, alcohol use, gastrointestinal surgery, hyperlipidemia, high fat levels in the blood, hyperparathyroidism, trauma, penetrating ulcers, and medication toxicity. Patients with pancreatitis often present with severe epigastric pain that radiates to the back, left flank, or left shoulder. This pain typically worsens when lying down, but can be relieved by curling into a fetal position. Other gastrointestinal symptoms include nausea, vomiting, and weight loss. Additionally, there are notable skin signs, such as Turner's sign, which is bruising on the flanks, and Cullen's sign, which is bruising around the belly button area, Patients may also have jaundice, ascites, fruity smelling breath due to ketoacidosis, and signs of low calcium, such as tetany indicated by positive Trousseau's and Chvostek's signs. Laboratory tests for pancreatitis typically show elevated amylase and lipase levels, elevated white blood cell counts indicating inflammation or infection, decreased calcium and magnesium levels due to the saponification process, elevated liver enzymes and bilirubin, and hyperglycemia due to damage to insulin-producing cells. Management involves both acute and long-term care. During acute episodes, patients are kept on nothing by mouth status to rest the pancreas, receive total parenteral nutrition intravenously, are provided pain relief with opioids, and have fluid and electrolyte balance closely monitored. Long-term care includes a bland, low-fat diet, avoiding caffeine, alcohol, and smoking, regularly monitoring blood glucose, administering insulin when necessary, and taking pancreatic enzyme supplements with meals and snacks. Complications of pancreatitis can include pseudocysts from fluid leakage and type 1 diabetes mellitus due to damaged pancreatic cells. Nursing responsibilities for pancreatitis involve monitoring for hypocalcemia symptoms, managing pain effectively, checking blood glucose regularly, and administering insulin if needed, and educating the patient about dietary restrictions and the importance of avoiding alcohol. Next, let's discuss hepatitis and cirrhosis, two significant liver disorders with long-term health effects. Hepatitis is primarily caused by viral infections, although drugs and toxins can also be responsible. There are three main types: hepatitis A, transmitted through the fecal-oral route by contaminated food or water and preventable by vaccination; hepatitis B, spread through blood and body fluids, sexual contact, intravenous drug use, or from mother to child, also vaccine preventable; and hepatitis C, transmitted mainly through blood and body fluids, often from intravenous drug use or sexual activity with no available vaccine. Risk factors for hepatitis include intravenous drug use, unprotected sex, tattoos, piercings, contaminated food or water, travel to areas with poor sanitation, and living in crowded conditions. Symptoms typically include flu-like feelings, fever, vomiting, dark urine, clay-colored stools, and jaundice. Laboratory tests usually reveal elevated liver enzymes, AST and ALT above 40, and bilirubin levels greater than 1. Cirrhosis occurs when chronic inflammation leads to liver scarring. Types of cirrhosis include post-necrotic cirrhosis from viral hepatitis, Lennox cirrhosis resulting from chronic alcohol use, and biliary cirrhosis due to chronic bile duct obstruction or autoimmune diseases. Complications of cirrhosis include hepatic encephalopathy causing confusion, hand tremors called asterixis, and coma; gastrointestinal bleeding from esophageal varices, ascites, jaundice, spider angiomas, severe itching called pruritus, and musty or sweet-smelling breath known as fetor hepaticus. Nursing care includes positioning patients upright at about 30 degrees, elevating the legs to reduce swelling, and recommending a diet high in carbohydrates and protein, but low in fat and sodium. Nurses must monitor closely for signs of encephalopathy, administer lactulose to bind ammonia, and maintain strict intake and output records and daily abdominal measurements. For the NCLEX exam, nurses should frequently assess neurological status, monitor for bleeding and fluid accumulation, educate patients about lifestyle changes, including avoiding alcohol and adhering to dietary guidelines, and ensure compliance with immunosuppressive medications following liver transplantation. Finally, let's examine key renal diagnostic procedures. Laboratory tests include measuring creatinine levels, which are the most specific indicators of kidney function. Normal creatinine ranges from 0.6 to 1.2 milligrams per deciliter in men and 0.5 to 1.1 in women. Elevated creatinine indicates kidney disease, acute kidney injury, chronic kidney disease, or glomerulonephritis. Blood urea nitrogen, abbreviated as BUN, normally ranges between 10 to 20 milligrams per deciliter and can be increased due to dehydration, kidney disease, heart failure, or a high-protein diet. Urinalysis, ideally done with an early morning sample for accuracy, evaluates color, clarity, pH, protein, glucose, ketones, specific gravity, red and white blood cells, and bacteria. Abnormal findings like proteinuria suggest kidney disease. Glucose in urine indicates diabetes, ketones indicate diabetic ketoacidosis, and white blood cells or bacteria suggest urinary tract infections. Red blood cells in urine point toward trauma, infection, or kidney stones. Imaging studies include CT scans with contrast, which carry a risk of contrast-induced kidney injury, so patients should increase fluid intake afterward. If patients are allergic to iodine or shellfish, alternative imaging methods or premedication with antihistamines and corticosteroids are used. Cystoscopy, or cystourethropy, provides direct visualization of the bladder and urethra. Preparation includes nothing by mouth after midnight and bowel cleansing with laxatives or enemas. Post-procedure care involves monitoring for mild bleeding, signs of infection, urinary retention, and bladder perforation. Excretory urography, or intravenous pyelogram, visualizes renal structures. Preparation involves fasting after midnight and bowel cleansing. Post-procedure includes increasing fluid intake to clear the contrast dye and monitoring for allergic reactions or kidney damage. Dialysis, including hemodialysis and peritoneal dialysis, is a life-saving procedure used when kidneys fail. Dialysis helps remove excess fluids, electrolytes, and waste products from the body. It's important to understand the types, complications, and nursing care, especially when preparing for the NCLEX. First, let's talk about hemodialysis. It requires vascular access through an arteriovenous fistula, graft, or central venous catheter. Typically, it's performed 3 times per week, each session lasting around 3 to 5 hours. Nurses have several responsibilities for patients receiving hemodialysis. Before dialysis, it's important to assess the fistula or graft by feeling for a thrill, which is a vibration, and listening for a bruit, which is a whooshing sound. Remember, never use the access arm for taking blood pressure, giving injections, or starting intravenous lines. Prior to dialysis, nurses should monitor vital signs, patient weight, blood urea nitrogen, creatinine, electrolytes, and hematocrit levels. During the dialysis session, watch closely for complications such as low blood pressure, muscle cramps, vomiting, or bleeding. Because heparin is used to prevent clotting during dialysis, nurses should always have protamine sulfate ready as an antidote. After dialysis, comparing pre- and post-dialysis weight helps determine fluid removal. Monitor patients carefully for hypotension and electrolyte imbalances. It's essential to encourage increased protein intake after dialysis, since dietary restrictions from before dialysis no longer apply. Patients should avoid lifting heavy objects, compressing or sleeping on the access arm, and should regularly perform hand exercises to help mature the fistula. Complications of hemodialysis include clotting or infection of the access site, which can be prevented with anticoagulants and strict sterile technique. Another complication is disequilibrium syndrome, caused by rapid fluid and electrolyte shifts leading to cerebral edema. Symptoms include headaches, nausea, vomiting, altered mental status, and seizures. Nurses should slow the dialysis rate and administer anticonvulsants as needed. Hypotension may occur, requiring intravenous fluids, lowering the head of the bed, or slowing the dialysis process. Anemia can happen due to blood loss and reduced erythropoietin production, managed by administering erythropoietin and iron supplements. There is also a risk of infectious diseases like hepatitis B, hepatitis C, and HIV due to blood exposure. Next is peritoneal dialysis, commonly used when vascular access isn't possible, especially in older adults or patients with cardiovascular disease. During this procedure, a hypertonic dialysate solution is instilled into the peritoneal cavity, allowed to dwell, and then drained. It can be done at home as continuous ambulatory peritoneal dialysis or overnight as automated peritoneal dialysis. For nurses, it's important to educate patients before the procedure that feeling fullness or mild discomfort during the dwell phase is normal. During dialysis, monitor inflow versus outflow. Output should be equal or greater. Normal dialysate drainage is clear to slightly yellow. Cloudy drainage signals infection. Keep the drainage bag lower than the abdomen and warm the dialysate to prevent cramping. Complications of peritoneal dialysis include peritonitis, which presents as fever, cloudy dialysate, rigid abdomen, and purulent drainage. Immediate interventions include sterile technique and antibiotics. Protein loss requires increasing dietary protein intake. Hyperglycemia can occur, requiring regular blood sugar monitoring. Poor dialysate flow, caused by obstruction, constipation, or fibrin clots, can be managed by milking the tubing using stool softeners and encouraging a high-fiber diet. Kidney transplantation is the definitive treatment for end-stage kidney disease. Postoperatively, nurses should monitor urine output closely, ensuring it's more than 30 milliliters per hour. An abrupt decrease may indicate rejection or obstruction. Infection prevention is crucial. Regularly assess for fever, difficulty breathing, redness, or drainage at the incision site. Watch carefully for signs of rejection, like fever, high blood pressure, and pain at the graft site, and administer immunosuppressants such as cyclosporin, tacrolimus, basiliximab, or teclizumab as prescribed. Respiratory care, including turning, coughing, and deep breathing, helps prevent pneumonia. Maintaining bladder irrigation is also essential. Patient education after kidney transplant includes following a low-fat diet to control cholesterol, high-fiber intake to prevent constipation, increased protein due to immunosuppressant use, and avoiding concentrated sugars and carbohydrates to prevent diabetes. Patients should avoid contact sports to reduce the risk of kidney trauma. Rejection can be hyperacute, occurring within 48 hours, and irreversible, acute occurring between 1 week to 2 years managed by increasing immunosuppressants, or chronic, occurring over months to years with gradual loss of kidney function requiring supportive care. Polycystic kidney disease is a genetic disorder marked by fluid-filled cysts in the kidneys, progressively impairing kidney function. It can be autosomal dominant, the most common form, or autosomal recessive, which is rare and severe in infancy. Early signs include high blood pressure, blood in the urine from cyst rupture, flank pain, kidney stones, frequent nighttime urination, and changes in urine volume. Kidneys become enlarged and palpable, progressing to end-stage renal disease, typically by ages 50 to 60. Complications include hypertension, cyst rupture, chronic kidney disease, cerebral aneurysms risking hemorrhagic stroke, and cysts in the liver or pancreas. Ultrasound is typically the first-line diagnostic tool, while CT scan can detect cysts more accurately. Nursing management involves controlling blood pressure, ensuring fluid intake of 2 to 3 liters daily, managing pain, preferably with acetaminophen, preventing urinary infections, promoting a low-sodium diet, and considering dialysis or kidney transplantation in end-stage renal disease. Genetic counseling is also advised for family members. Finally, acute kidney injury is a sudden loss of kidney function leading to fluid retention, electrolyte imbalance, and waste buildup. It can be reversed if treated promptly. Acute kidney injury progresses through 3 phases: the oliguric phase lasting 1 to 3 weeks with reduced urine output, fluid overload, and electrolyte disturbances; the diuretic phase lasting 2 to 6 weeks, marked by increased urine output and risks of dehydration and electrolyte imbalances; and the recovery phase lasting up to 12 months, where kidney function gradually normalizes. In this section, we will discuss the types of acute kidney injury, along with their causes and management strategies. First, we have the prerenal type, which is caused by decreased blood flow to the kidneys. Common causes include shock, hypovolemia, which means low blood volume, renal artery stenosis, sepsis, and heart failure. In this case, the nursing role is focused on restoring blood flow and perfusion by administering intravenous fluids and vasopressors, as well as closely monitoring blood pressure. Second, we have the intrarenal type, which involves direct damage to the kidneys. Causes of intrarenal injury include nephrotoxic drugs like non-steroidal anti-inflammatory drugs, aminoglycoside antibiotics, contrast dyes used in imaging, heavy metal exposure, acute glomerulonephritis, and trauma. Nurses play a key role by discontinuing nephrotoxic medications, closely monitoring urine output, and administering corticosteroids if the injury is due to inflammation. Third is the postrenal type, caused by an obstruction of urine flow. This can happen due to kidney stones, tumors, an enlarged prostate, also known as benign prostatic hyperplasia, or a neurogenic bladder. Nurses typically manage this condition by inserting a urinary catheter if needed and facilitating procedures to remove the obstruction, such as surgery or lithotripsy. Now, let's look at laboratory findings and diagnostics associated with acute kidney injury. Creatinine levels will be elevated and serve as the most specific marker. Blood urea nitrogen, or BUN, also increases rapidly, sometimes reaching levels between 80 to 100 within 1 week. Electrolyte disturbances like hyperkalemia, metabolic acidosis, hyponatremia, and hypocalcemia are commonly observed. Urinalysis in intrarenal acute kidney injury often shows casts and proteinuria. Treatment and nursing care involve careful fluid management, either restricting or replenishing fluids depending on the phase of injury. Diuretics such as furosemide may be used if oliguria, meaning very low urine output, persists. Nurses must closely monitor electrolytes, treating high potassium levels with medications like kayexalate or insulin. Dialysis might be necessary in cases of severe electrolyte imbalances or uremia. Dietary management includes a diet low in potassium, phosphate, sodium, and magnesium, along with a high-protein diet to prevent muscle wasting. Next, let's discuss chronic kidney disease, also called CKD. CKD is characterized by progressive and irreversible kidney function loss, frequently caused by diabetes or hypertension, eventually leading to end-stage renal disease or ESRD. Key risk factors for developing CKD include diabetes mellitus, which is the leading cause, followed closely by hypertension. Other risks include a history of acute kidney injury, long-term use of nephrotoxic drugs like NSAIDs, contrast dyes, aminoglycosides, autoimmune conditions such as lupus, and older age due to decreased renal reserve and higher dehydration risk. Chronic kidney disease is classified into 5 stages based on the glomerular filtration rate, or GFR. Stage 1 has a GFR greater than 90, indicating kidney damage, but normal function. Stage 2 ranges from 60 to 89, representing a mild decrease. Stage 3 includes a moderate decrease in function with GFR between 30 and 59, where symptoms typically start to appear. Stage 4 has a severe decrease with GFR between 15 and 29, indicating that dialysis preparation should begin. Finally, Stage 5 is end-stage renal disease with a GFR below 15, requiring dialysis or a kidney transplant. Clinical findings in CKD vary and can involve multiple systems. Neurologically, patients may experience lethargy, confusion, tremors, or jerky movements. Cardiovascular signs include hypertension, jugular vein distension, and heart failure. Respiratory symptoms may present as rapid breathing, crackles in the lungs, or Kussmaul's breathing due to severe acidosis. Gastrointestinal symptoms include nausea, vomiting, and uremic fetor, a urine-like breath odor. Skin issues such as itching, known as pruritus, and uremic frost, white crystal deposits on the skin, are common. Additionally, anemia occurs due to reduced erythropoietin production. Labs and diagnostics for CKD typically show increased BUN and creatinine, electrolyte imbalances like hyperkalemia, hyperphosphatemia, hypocalcemia, and metabolic acidosis. Urinalysis often reveals blood, protein, and diluted urine indicated by low specific gravity. Imaging, such as kidney ureter bladder X-rays, also called KUB, along with CT and MRI scans, assist in diagnosis. Nursing management includes daily weight monitoring, remembering that 1 kilogram of weight gain equals 1 liter of fluid retention. Dietary restrictions of sodium, potassium, phosphate, and magnesium are crucial, while encouraging a high carbohydrate, moderate fat diet. Nurses must monitor for signs of hyperkalemia, like peaked T waves on an EKG and arrhythmias. Administering erythropoietin helps manage anemia, and avoiding nephrotoxic agents like NSAIDs, contrast dyes, and magnesium-containing antacids is essential. Patient education on limiting fluid intake to about 2 liters daily, quitting smoking, and controlling blood pressure and blood glucose is also vital. Common medications used include erythropoietin to stimulate red blood cell production, ferrous sulfate to treat anemia, furosemide to manage fluid overload, phosphate binders like calcium acetate and sevelamer to reduce phosphorus, and antihypertensive medications such as ACE inhibitors and ARBs to protect kidney function. Dialysis is indicated when the GFR drops below 15, or in cases of severe hyperkalemia, metabolic acidosis, or significant fluid overload, leading to conditions like pulmonary edema.